Hello, hello, check 1 2 3, mic check, test 1 2, hello. Hello, test 1 2 3, mic check, hello.
check, hey, check, check, hey, check, check, check.
Check. Mic check. Hello. Hello. Check. Audio. Test. 1, 2, 3. Mic check. Test.
Check. Hey. Check. Hey. Check. Check. Hey. Check.
Okay, good morning. Good morning. We'll start. So I'm supposed to give the introduction. That's the only talk I have in these 2 days. Thank you very much for coming on a Saturday morning to Hyderabad if you're coming from outside Hyderabad, and to Western if you're from Hyderabad. First, I'd like to thank the faculty who have taken time out of their busy schedule to come and join us here. When we started planning this program almost 4 months ago, everybody was asking us, why are you saying preparing the complex recipient? Why don't you start with preparing the standard recipient first? But then the answer is that there's no more standard recipient. Every patient with chronic liver disease has some problem or the other, and the key aspect of managing these patients is actually identifying these problems, assessing their significance, and mitigate them so that they have the best possible outcome after a liver transplant. More and more we are seeing sicker patients, more complicated patients, patients that maybe even a few years ago we would not consider as transplantable. In the UK, they have terms like not fit for a haircut, I wouldn't touch him with a barge pole, for this kind of sick patients. But actually, these are the kind of patients that we are now routinely seeing, and these are the patients actually we are, I must say, we are doing a pretty good job in getting them through, getting them ready for a transplant, and actually getting them better to go on to have a good life. Now the program, it's a 1.5 day program, and it's actually got, the way it's planned is it's got 3 streams intertwined. The first is a series of lectures looking at well-defined problems associated with liver disease. This is like kidney injury or encephalopathy. And what we hope is that each lecture will give us a good idea about a standardized protocol for managing such patients. The second stream is actually called controversies, and these are slightly less recognized or less well-defined problems that we encounter in these patients. It could be patients who need a transplant and who have active tuberculosis, or patients who have a tumor which is beyond your standard transplant criteria. And what we hope is that at the end of each talk, we will have an idea as to how to approach these patients and try and get them better for transplantation in the best possible way. Another important goal, I hope, is each of these lectures will help us in identifying future research goals, because these are all still problems which still need a clear solution. None of them have level 1 evidence, like we like to say in medicine, and there's a lot of work that needs to be done in these areas, and I hope that these lectures will stimulate discussion and research in these areas. And I think the third, probably the most important, is case discussions. And the way these case discussions are planned, each of them is planned to actually highlight the points that have been learned in the lectures of that session. Now, these cases, most of them have been managed by our team over the last 1 year. There are a few cases which my colleagues from other centers have very kindly agreed to share with us. And the interesting thing about any patient is that every patient has a lot of aspects that we can discuss. You have a patient with ACLF needing an emergency ABOi incompatible transplantation and has a colonic tumor. You can discuss any of these 3 things. And what we've done is we've tried to identify 3 or 4 key take-home points and then discuss that so that, again, it can generate discussion. I'll finish now. Again, thank you very much for coming, for the faculty, the delegates. I hope that we learn new things this weekend, learn new ideas, find new research ideas, and hopefully make new friends. Thank you.
Thank you, sir, for that inspiring opening and reminding us of the vision behind this meeting. Today we have 6 sessions. In the first half we have 3 sessions, and in the second half we have 3 sessions. The first session is the basics. The theme of the session is this: before we run to solve the controversies, we have to walk steadily through the fundamentals. In aligning with the theme of the conference, preparing the complex recipient, which means we have a patient who needs to undergo transplant, but they have a condition which needs to be optimized before transplantation. Over the next 1 hour, we have 3 talks. The essential question of who needs to be transplanted and what are the imperfections of the most widely used scoring system. And in the second talk, we have a patient with encephalopathy and what is the prognostic impact it has and how we are going to optimize this patient. And in the third talk, we have a patient with AKI who needs to be optimized. After the 3 talks, we have a case discussion because how, even if the theory sounds elegant, when we face with the real patient in the clinical setting, we face difficulties. So I welcome chairpersons for the first session, Dr. Sarath, consultant in medical gastro from Star Hospitals, Dr. Sethu Babu, senior consultant medical gastroenterology from TIMS, Dr. Ramanjaneyulu, senior consultant medical gastroenterology, Star Hospitals. Dr. G. Srinivas also. We know MELD score is at the heart of organ allocation and prioritization, but many times in clinical practice, we see patients with high MELD score, but clinically stable, roaming around, and patients with low MELD score, but they need early transplantation. So should we rely blindly on the MELD score? To discuss on this, I invite Dr. Mithun Sharma from AIG Hospitals, Hyderabad.
Good morning and thank you everyone. So I'm the opening batsman here today. So the slides. Just change the slides. First one.
Yeah, Dr. Mithun, I'm here.
Yeah.
Yeah, let me welcome you to this session, and I know Dr. Mithun is a good speaker. He's from AIG. I request him to speak on indications for a liver transplant and pitfalls in a MELD scoring. It's over to you, Doctor.
Thank you, sir. Thank you for the kind introduction. And so my job is in this complex scenario, as I have heard, my job is a little simple because I'll be talking about the basic indications of liver transplant, which in this August gathering, I think everyone is aware of it. So this is the outline of my talk. The first is when to refer and list for a transplantation. How are the different types of MELD scores, the MELD, the MELD sodium, the MELD 3 are used? What are the limitations? And can we make the MELD score better to select our patients from getting denied of a transplant? So first of all, when we know that when we talk of referring for a transplant, there are always some triggers as a clinician. So the book says, the first episode of decompensation, please discuss with the patient and try to put him in a center where transplant program is running. The first episode can be either the presence of ascites or a variceal bleed or an encephalopathy. Or if somebody has a rapid increase in the MELD score or a patient who is getting admitted with recurrent episodes of infection, the moment you start diuretics, he is going into renal failure or he has encephalopathy, and if the patient has become very malnourished, frail, or he see that his muscle mass is getting lost, this is a part which we hardly discuss. These are the triggers as the clinicians where we should start thinking of referring to a transplant center. Now we should also keep in mind that you should assess the transplant benefits. It's not the MELD score alone. Sometimes you need to assess the reversible factors like alcohol use, infections which can be treated. And there are many patients, this holds good more in the Western countries than in India. The living donor transplant can be used in situations where MELD is under prioritizing it, but you feel that a transplant is required. So the broad indications of liver transplant are acute liver failure, a patient of cirrhosis who has decompensated, the malignancies, metabolic disorders, and some of the systemic complications of chronic liver disease. Of this, the most common indication still remains as cirrhosis of liver, covering around 57%. When we talk of acute liver failure from India and the acute liver failure from the West is totally different. As you see in the Western countries, it is mostly acetaminophen-related acute liver failure, whereas in India, the majority of the ALF are actually Hep E related, and this is data from the All India Institute, which says that in majority of the patients, of the 40% patients where you don't know the cause of acute liver failure, if you do an E antigen, you might find them positive. It accounts for 5 to 6% of all the transplants that are done in the country. In some countries, it varies between 8 to 10%. The second indication of chronic liver failure, the only thing I like to highlight here is that NASH, that is MELD, is catching up with alcohol-related liver disease, which is becoming one of the very complex cause of doing a transplant, because most of these patients with MELD will have metabolic syndrome, they will have diabetes, they will have chronic kidney disease, and this leads to a very complex scenario pre-transplant as well as managing them post-transplant. The next indication is hepatocellular carcinoma. As the introductory was told that you will be discussing about operating within the criteria and outside the criteria. Most of the time we are familiar with this criteria, but now with more and more complex cases coming, borderline cases are taken up for surgery, and we see that the results are not that bad, but we still stick mostly to the Milan and the UCSF. There are some surgeon-friendly criteria, there are some hepatology-friendly criteria, and the debate goes on. There are other malignancies of the liver where a transplant is indicated. These are rare indications. There are cases where a transplant has happened for hemangioendothelioma, for a neuroendocrine tumor primarily of the liver, which is very rare, and of course in the pediatric population in hepatoblastomas. We also have a very controversial and debatable indication, which is cholangiocarcinoma. We are all aware of the Mayo protocol, where you select a patient who has a lesion of less than 3 centimeters without involvement of a lymph node, give them a neoadjuvant chemoradiation, and then if you do a de novo transplant, you have a 90% survival at 1 year, which boils down to around 50% by 10 years. But we need to think beyond this, whether there is a role of bile acid circulating DNAs which can be helping us in selecting more patients, or whether we can do some post-surgical chemoradiations which can possibly help us in getting better results. The next indication of a liver transplant are the metabolic and the cholestatic disease. Many of these are pediatric patients with biliary atresia. It's done sometimes in many patients with Wilson disease where the results are excellent. And then there are the rare diseases like hyperoxaluria, where we can be cured by transplant. There are some other conditions where transplant may not be curative, but may improve the outcome, like those in some of the glycogen storage diseases. Apart from this, we also know that patients with vascular diseases of the liver, like Budd-Chiari syndrome, where you fail a TIPS or a stent gets blocked and it becomes non-recanalizable, these are the patients who are taken up for transplant. We find in our clinic a lot of time people coming worried about cysts in the liver. We tell them these are benign cysts, but many of the time they have large polycystic liver diseases. If they are very small, you can handle the dominant cyst by an aspiration or a sclerotherapy or by a laparoscopic fenestration. But when there is a massive polycystic liver disease causing malnutrition and causing complications like pain and affecting the quality of life, this is one of the offbeat indications of liver transplant. In a gastro setting, we get a lot of patients sometimes of Caroli's disease who presents with recurrent infections. The smaller infections we can treat with antibiotics and UDCA, but if it's a bilobar disease or if there is any debate about the development of a malignancy, these are the cases we take up for a transplantation. The last two indications are primary biliary cholangitis and the primary sclerosing cholangitis. PBC, we normally try for a transplant when the patient is decompensating with a high bilirubin and with a low albumin, and intractable pruritus is one of the indication. Any patient, young patient of primary sclerosing cholangitis, we need to keep in mind that the MELD score usually do not give them much credit, but the Mayo score can predict the outcome. Finally, I touch upon some rare indications. One of the indications is amyloidosis. Few days back, a patient of renal amyloidosis came to the clinic asking for a liver transplant. So we should understand that amyloidosis liver transplant works only in one variety, that is hereditary transthyretin amyloidosis, and if there is familial amyloid polyneuropathy. But the crunch here is that if the disease has advanced, it doesn't reverse the amyloid deposits. So you have to do it early. Most of the time, it is the neuropathy which reverses, and the 10-year survival in these patients varies between 50 to 70%. There has been reports of transplantation in hepatic sarcoidosis, which is one of very rare indications. Now I move up to the second part of my talk, which is the MELD score. As you know, the MELD score has evolved from the MELD to the including MELD sodium, and then in 2023, they use gender. But there are a lot of things the MELD score doesn't take into consideration. Refractory ascites, GI bleed, all these are considered to be out of the MELD criteria. Neither does it take into consideration the hepatopulmonary syndrome or the portopulmonary hypertension. Also, there are conditions where the MELD score may not be useful, like in cholangiocarcinomas or patients with Budd-Chiari syndrome, in patients with polycystic disease. These are conditions where the liver function remains well preserved and the MELD score won't help us. So what has changed from MELD to MELD sodium to MELD 3? As we know, the MELD was initially used to for prediction of outcome of TIPS. It was included bilirubin, INR, and creatinine. The MELD sodium thought that we need to include sodium, and the MELD 3 had included the gender so that it feels that it can change this. The aim was that we have a better mortality prediction, and this policy was adopted by US in 2023. Now I come up to 3 or 4 pitfalls of the MELD score. The fallacy number 1 is creatinine is neutral. That is the biggest fault, because creatinine underestimates the kidney function, particularly in women, because they have a lower muscle mass. So they will have a lower MELD score or a MELD sodium at the same risk. Now the national data has shown that the worst waitlist outcomes for women are similar at the scores, and MELD 3 possibly partially corrects this. The implication is that we should move towards something better like measure GFR or consider it for the height and the body size, and we should advocate earlier transplant in these patients. The fallacy number 2 is that we believe one size fits all. It doesn't. For example, the MELD sodium underestimates the mortality and morbidity in PBC and PSC. These patients may be having recurrent cholangitis, they will be having pruritus, which may be intractable, affecting quality of life, and sarcopenia because of the loss of the fat-soluble vitamins also. So this MELD score will underestimate this. So we find that there is a higher waitlist dropout despite a modest MELD score. So we may need exception pathways for these patients. The most important fallacy that we find here is that ACLF patients' risk is not captured by the MELD score alone. ACLF has much higher short-term mortality than predicted by the MELD sodium. So possibly a CLIF ACLF score will outperforms the MELD score for predicting the 30-day mortality. We can use the ACLF grading or the scores along with the MELD when triaging these patients for liver transplant. Finally, we take the lab parameters. So lab-only prioritization ignores frailty. Frailty or sarcopenia is one of the most major things which is affecting the outcome of this patient. We see most of the patient, by the time they come to our center, their muscle mass are lost, their bellies are out. So we need to include this as an exception, particularly in low mission. So we should incorporate the liver frailty index or the hand grip strength into listing decisions. And finally, there is a lot of interlaboratory variability in the INR which can shift the MELD score and the rank the position. Exception points like ACC may distort the sickest first without, if the policies are not clear. Even a small ACC makes it on the top priority. So we should standardize lab parameters, and we should have a diagnosis-specific exception guidelines and include the patient as a whole. How can we solve these problems? We may try to use MELD-3 for baseline priority. ACLF-specific models like the CLIF score or the ARC score can be used to capture near-term risk. Frailty metrics and sarcopenia measures should be used. And disease-specific modifiers like cholestatic disease, refractory cholangitis should be considered as transplant exceptions to the MELD score. And whenever there is a gap of option of not getting a cadaver liver, a living donor options can be used to overcome these problems. The contraindications of liver transplant now still stands as relative at this point of time, though normally we don't take patients with raised ICP in acute liver failure or with advanced cardiac pulmonary diseases, but this is something this conference will possibly discuss because these are where the controversy lies. And there is no age cutoff which I feel nowadays. There are people who want a transplant at 70 years. So Chairperson, with your permission, the final take-home message is that the indications of transplant remains decompensated cirrhosis, selected ACC within criteria, acute liver failure assessed by the prognostic criteria, and the other diseases we mentioned. MELD is necessary but insufficient. It misses sex, ACLF, frailty, and disease-specific race. We can use MELD-3 plus adjunct scores and use structured exceptions and advocate early transplant for women, ACLF, and cholestatic disease. And whenever feasible, consider living donor liver transplant to avoid a lot of waiting list attrition in the cadaver list that we always see. Thank you so much. I'll be happy to take any questions.
Yeah, thank you, Dr. Mithun, for an excellent and lucid presentation. You were specific to the topic given to you. Yeah, you mentioned some of the rare indications like sarcoidosis, etc. But in them, you feel that liver failure should be a component. That is the one clarification I wanted to know.
Yeah, liver failure should be there, but I said, this is just last week, one patient from, I think, Delhi, he came with an information that if you do a liver transplant, he is a CKD patient. He has been told that his kidney will get normal, so the nephrologist referred to us. But he didn't have the specific type of amyloidosis. So as of now, we have not transplanted any case of non-liver indications where liver failure has not been there in amyloidosis.
Yeah, some of the, of course, a list will be much bigger, but some of the indications where liver transplantation had been done, like a dengue fever with a liver failure, also COVID-19 with a liver failure. Of course, it's a long list, but anyhow, thank you. And some of the limitations which you have told in a MELD, definitely there are some fallacies. The parameters this MELD takes, like creatinine, etc., so many influences, including the way we do it. I think those make a difference. But ultimately, idea is that a sickest patient or a patient who needs it more should get a priority. That is the message I think you wanted to give you. Thank you very much. Dr. Srinivas, you have any comments? Or I will open some of the comments from House. Dr. Sharath?
Yeah, thanks, Mithun. So I think we have to, there are multiple problems with allocation. Srinivas, we talk so much about MELD, and it doesn't really capture the sickest patient. And some countries have moved on, as you might be aware. UK is using NLOS now, liver allocation system, where they take multiple things into account. They take the donor condition into account as well. So people are moving on with MELD, and it needs to be modified. But unfortunately, I think in our state, we are still stuck with a lot of problems. Even getting a MELD exception approved is also a difficulty. I think we're having a lot of practical difficulties. So I think it's good to discuss MELD, but a lot of times there's a lot of sarcopenia, there's encephalopathy. There is a patient who's been admitted several times to the hospital with a pneumonia, for example. It just doesn't get captured anywhere in the MELD. Decreased effort tolerance, so many other things. I think there's so many other things we need to consider in addition to MELD. And ultimately, it comes down to the treating team. There has to be some guideline, I accept that, but within a given range of MELD, maybe 3 or 4 points here or there, there's so many other factors to consider. Quickly about amyloidosis, we actually operated on a patient with amyloid a few years ago. We planned a domino transplant. But unfortunately, due to difficulties and a very prolonged cold ischemia time, we could not use the recipient's liver to do the domino transplant. So there were some technical difficulties with that surgery. But yeah, we did attempt a domino for an amyloid patient.
Thank you, sir. Thank you so much. Yeah.
Thank you, Dr. Mithun. I think that was an excellent talk. I just wanted to extend from what Sharath was saying. Basically, I mean, MELD, the allocation criteria, they're all a way of assessing the relative urgency of transplantation in a cadaveric waiting list. I mean, in India, 80% of transplants are done for living donor. And I think here we need to really look at the patient benefit. You know, what is the risk benefit for the patient rather than just looking at what's the MELD score and related to other patient waiting lists. So just to generate a discussion, I'm asking, do you think we should have separate listing criteria for LD, LT and DDLT?
Yeah, so first of all, I feel even our hospital, individual hospital doesn't have a list which is based on severity. Let us be honest about it. So in India, it's like, it's my relative's liver, it's my money, so you do it. Even if he's 72, he is valuable for me. So we definitely need some criteria for living donor, definitely, because all these criteria are criteria based where the organ is a state organ. So in India, we hardly get a state organ, so it's mostly your personal organ, or the wife or son. So we do think at one point of time, at least at a state level and then at the national level, we need to have some criteria for living donor because we are possibly the highest in the world doing living donor transplants from other 1 or 2 Asian countries. So I agree to that. Thank you so much.
Thank you, sir.
Thank you.
Thank you, sir. Dr. Sharath has joined as a chairperson. Next, I invite Dr. Ashok Chowdhury to give his talk on prognostic impact of pre-transplant encephalopathy and strategies for optimization.
Good morning, sir. Good morning, sir. And it is my privilege to introduce Dr. Ashok Chowdhury, sir. He is my teacher and co-guide in ILBS. And he is very research-oriented and student-oriented. And he is one of the, along with Dr. Sarin, he has invented ARC score in ACLF, which helps in organ-specific mortality. Sir, over to you, sir.
At the outset, thanks whole STAR team. Thanks, Srinivas, for a nice introduction. We quickly go for a relatively topic we need some thoughts, that is hepatic encephalopathy. So we'll cover in few outline this way. So you can see the hepatic encephalopathy, one of the advanced complications, and more often once it develops, likely the another 40% will develop recurrence in 1 year. And if you see a patient once have a hepatic encephalopathy, the readmission is close to 1/3 or 1/4 because of the indications of any liver related, and majority are being hepatic encephalopathy. And once this hepatic encephalopathy happens, the mortality is too high. 1 year mortality is 50% and 3 years in absence of transplant is only 25%. And it is a brain dysfunction because of both liver insufficiency as well as the collaterals causing the toxins injuries. But at same time, we have to rule out the whole basket of neurological psychiatric diseases which are common for any person, and liver patients are not immune to that. So if you think of hepatic encephalopathy, the grading has a big impact. You can see here, if a ACLF person coming with a grade 3, the mortality is close to 80%, and any new onset has a very high in absence of a transplant. So if you think of the hepatic encephalopathy for this, the minimal hepatic encephalopathy also had a reduced survival. As we discussed, the mortality close to 50%, and the diagnosis of hepatic encephalopathy to the duration has shows a significant in relation to the MELD also, because MELD has not taken into account the hepatic encephalopathy. But you can see here, if a MELD is more than 15 and hepatic encephalopathy is long standing, then it is poor outcome. And here is very interesting is each episode, if a person of hepatic encephalopathy you are managing in your clinic lasting for more than 48 hours has a poor outcome than who is getting recovery. We see most of one hepatic encephalopathy recover overnight. And if they have a MELD score more than 15 and even they are admitted for a single episode, the hepatitis lasted for 2 days, they are a very sicker group patient, he should be considered early for the transplant. Then if you think of ascites as a combo, which most often we see, it causes more mortality. You can see it, if you only moderate ascites, the mortality shoots up. When you go for the both ascites and hepatic encephalopathy, even at a score of less than 20, even less than score 20, the ascites and hepatic encephalopathy both are not included in the MELD score, and they increase the mortality high even those than the MELD score than 40. So this is how this MELD score, as rightly discussed by my previous speaker, ascites and hepatic encephalopathy two are additional factors causing poor mortality. So that is not the only thing. When there is a hepatic encephalopathy, it is a disease of affecting the whole surrounding for them. It is surrounding pattern by the, you can see here the family and the caregivers. So when hepatic encephalopathy happened, there is a quality of life compromise that causes more problems than the disease per se. So how this hepatic encephalopathy happens? So before considering hepatic encephalopathy, you can see that this is a disease of brain dysfunction. So these brain dysfunctions can be because of hyperammonemia, because of systemic illnesses. We have to identify what is brain dysfunction, then you move to hepatic encephalopathy. Then if you think it should be a broad that all patients coming to you. So once a person has diagnosed to have a cirrhosis, and hepatic encephalopathy is a diagnosis of exclusion when you rule out other causes, in that you need to think of causes contributing to like liver failure, portosystemic shunts, nutritional related, electrolyte imbalance, precipitating events, drugs, and so a lot of things are there, and the sole purpose of these products is to cause a inflammatory milieu. They cause a gut pathological translocations, there is a inflammatory stress and hyperammonemia, both causing to a development of this disease. And once this disease starts, the majority organ is the dysbiosis, then the systemic inflammation, neuroinflammation and oxidative stress, which leads to cognitive, memory and motor functions. Either they represent as a overt or a covert hepatic encephalopathy. And when you go to the brain, you can see there is astrocytes are the major chunk to receive the burden because of the ammonia and glutamine conversion. Then the neurotransmitters, the GABA is a depressing, that you can say the mood is off, glutamate is got a mood off on. That means these patients can be excitatory or inhibitory neurological complications, which we see often because of this cytokine storm. Then next comes ammonia. We thought most inflammatory ammonia is synonymous to hepatic encephalopathy, is not actually. When ammonia is high, it suggests or it corroborates your diagnosis. But if clinically thinking of hepatic encephalopathy, if ammonia is not in most studies to correlate to the level of hepatic encephalopathy. And at the same time, we have shown from the ACLF, there is a ammonia level cutoff. The sick patients, if ammonia is remaining above more than 175, they are likely to have a poor outcome irrespective of hepatic encephalopathy. If hepatic encephalopathy, that is one. If ammonia more than 175, that persisting on admission day 4, day 7, this is also high thing. So ammonia has to be taken case to case basis. Then how to assess hepatic encephalopathy? I think the house is aware of these minimal and the overt encephalopathies. But here we need to know most important is the psychometric, neurophysiologic and clinical examinations. And most important, the hepatic encephalopathy typing. You can do type A, B, C, that guides you for the treatment. A is acute, where the different treatment, B is for the bypass or the shunt-related cis liver synthetic dysfunctions. And you know, grading calculates your severity, and then overt or covert, that is because most of the covert, nearly 80% converts to the overt. And most important is another one, episodic, recurrent or persistent. If you persistent, has to go for early transplant. Recurrent, you find some other cause of precipitating, but has to go for the transplant. Episodic, you may manage for some time, depends upon the clinical and liver disease parameters. And next important is whether it is spontaneous or it is precipitant. That is, these three things give you guidance for a treatment planning. So if you go for the hepatitis evaluation, we need to know multiple factors. You can see here, this person is having to be considered as a good, bad or more by the combination. Either it is a severity of liver disease, associated comorbidity like we discussed the kidney failure, age more than 65 has a poor outcome, hyperammonemia to some extent is there, if severe inflammatory stress or advanced liver disease can be there, and also type of precipitants that guides you to therapy. As we discussed, nearly hepatic encephalopathy, close to 100% will have some precipitate events. We need to know what are their precipitations. This is a very interesting study. The precipitation like infection, constipation, AKI, drug-induced GI-related hyponatremia, or non-taking the rifaximin or zinc. So when these parameters are commonly we see routinely, and this interestingly they have combined that how many factors are there. If risk factor is 1, 2 or 5, the more is the risk factors, the survival is so poor. So whenever we see a ACLF, hepatic encephalopathy, try to find out the precipitating factors that will guide the therapy, as well as that will prognosticate the number of factors are there. Then another important is the SIRS. Presence of SIRS is associated with a poor outcome in case of hepatic encephalopathy patients. And as you know, the SIRS has 4 components. The more is the number of components, that is also proportionally correlated to the having a severe poor prognosis in case of hepatic encephalopathy. Then you think of, now we discuss the hepatic encephalopathy, its implications, when to go for the transplant. I think if you are aware of this minimal listing criteria, it shows that these patients, if survival chance is less than 1 year, we should go for. So these are the indications we very much aware. However, this minimal listing criteria is applicable to the all cadaveric setting of the patients. And just see a simple way, if you have a cirrhotic patient, his survival, likely median survival is 9 years. Any decompensation, the survival drastically down to 2 years. If SBP, it is less than 1 year. If hepatic encephalopathy, weeks to months. That means it is the disease which decides that how rapidly you should take action. And that is why the global consensus for the early referral for the transplant, be it the ASLD, it is the ESL, they think because the transplant is going to make a life-saving, improving the quality, and has now the improved outcomes. As already I am not going to talk on this, but here the MELD score has added all these factors but negates the hepatic encephalopathy, which are very important factors. That means we have to consider patients with low MELD or beyond MELD. And that is why this is the, which I am lucky to be part of this APASL guideline and liver transplant, where these are the class, taken the MELD indications as exceptions to be considered for the transplant decisions. Then most important is the, what is the challenges. You see here, do we need to see for a patient, the family and the healthcare system. The hepatic encephalopathy is, as much they get delayed, the challenges get more worsened. And there is no support system for them to get a, how they can get prioritized. And because of this, you need a challenge both for the disease, both for the social and for the systemic. And as we need their patient to be transplanted, need a optimization. So I have got quickly. So one of the important correctable factor is the portosystemic shunt. You can see here, if you are able to do a very early, that is child A, MELD is 6 to 9, they have a good outcome, you can offer them a shunt closure. And it is very interesting that this shunt percentage also increases as the severity disease increases. If a child C, you can get 72% having shunt, where you cannot offer any therapies. So, and very interestingly, the more is the number of portosystemic shunts or the collaterals, then the more is the hepatic encephalopathy and poor is the transplant survival. So that is a correlation to them. However, very early stages, they show a good transplant-free survival for this group of patients. But obviously it is not without complications. When you shunt closure, then the varices become increased, they develop worsening of ascites, and I think you have to select a few group of patients who have a low MELD, but transplant evaluation should not be made that is not needed. It should be there and you have to counsel, and also low albumin is one of the poor factors. Then when a patient comes to us in critical care setting for the hepatic encephalopathy, particularly in ACLF or ALF setting, now CRRT and ammonia reduction has shown some improvement in the cerebral hemostasis, cerebral edema, and the hemofiltrations also has been added with filters to reduce the cytokine storm that can indirectly help for the ammonia reductions. And as we discussed, the filters are now changed from hemofiltration DP mass, so they are also giving help to these two patients who are sick. I think everybody is aware of giving the LOLA. LOLA has been verified for the ALF, but now meta-analysis is coming up that it is to some extent helpful for the prevention, particularly those have a recurrent or persistent hepatic encephalopathy. Similarly, now this is a new drug has come up, phase 2, that is SLOPA, just ornithine phenyl acetate. So this is interesting in that the ammonia reverse cycle is blocked when there is a LOLA, there is a channel is open. Hence, complete utilization of ammonia, rebound hyperammonia is poor in this drug, but still it needs to be approved for the FDA. Then important is the rifaximin. We know rifaximin, even we give lactulose as the first line therapy, we have a chance of 75% with rifaximin, close to 1/4. Even with combination, we are getting more of recurrence. So what is the overhead? So this is a very interesting study. What they have done, they have shown those patients who have done the rifaximin and they are responders or non-responders. Their microbial analysis from these two organisms, salivarius and nervous, and they found that when you combine them with the secondary bile acids, like the deoxycholic acid, then you can find it's not UDCA, the deoxycholic is not, few companies are available. So that is a good food for thought. If rifaximin we are giving, still getting a recurrence, we can get secondary bile acid related salts where we can get a clue to benefits. Then next important is comes the gut microbiota, which is the main organ for the hepatic encephalopathy as well as the liver disease complications. The concept is that this is a rough soil, you populate with a good soil. So when soil is good, the results will be good. So hence the concept of having the gut microbiota modulation has come up. And it can be an antimicrobial therapy like rifaximin we are giving as the focused one, probiotics which is just like to empower them, or we can go for the FMT which is like the Hanuman, we taking the whole microbiota to be replaced. So this is the interesting trial come up, the thematic trial, where they have given FMT along with capsules to this group of patients. They found that there is no improvement in death or transplant. However, they found that hepatic encephalopathy recurrence can be reduced, liver related admissions are decreased. So in a patient of cirrhosis, child C, hepatic encephalopathy once, FMT can be given for 5 days, and this has helped in that way. And they have shown the recurrence is on the lower side, particularly when giving both enema as well as the capsule groups. Then probiotics, which is most widely used and few debates. So I just brought a meta-analysis where they have showing that it is not helpful for liver related complications. It is only helpful for the prevention of hepatic encephalopathy in these groups. And recently interesting one that we are very much used to write a PPI. So this PPI has a poor outcome as far as the meta-analysis is concerned. This suggests that these are causing aggravation of the hepatic encephalopathy, because we thought of there is some debates is good or bad, but this meta-analysis is good. I think taken good number of around 12 studies that try to avoid PPIs in your hepatic encephalopathy patients as far as possible to prevent hepatic encephalopathy. Then important is the long-term albumin. I think everybody aware of the established indications for albumin. So this is hepatic encephalopathy, hyponatremia, SBP are coming as the doubtful indications, and obviously ACLF, muscle cramp, these are coming as the emerging indications. The concept is that to totally modulate the albumins where it acts as anti-inflammatory, it helps in the cytokine storm reductions, and also it corrects the hyponatremia. So combining these, it can help the spectrum of hepatic encephalopathy long term. However, the cost benefit analysis needed. Then next is the, what is the challenge? It's a very interesting study across 1400 physicians across the Japan. This shows that the peoples are not able to diagnose hepatic encephalopathy because of lack of a good modality. If you think of the gold standard of hepatic encephalopathy, it takes around 30 minutes, which is difficult to assess them and not able to identify the parameters. And then these peoples need to be treated. Just to conclude my talk, hepatic encephalopathy in a critical ill patient needs to be considered to be admitted to the ICU. They need a speed for the acute insult. They need to manage for the precipitating factors. At the same time, calculate the disease severity scores. Then they need a early transplant listing. And at the same time, you have to give all the therapies, give a response guided therapy so that the critical period, the first week, is the golden window where we should think of a decision how to go for. So just to summarize my talk, cirrhosis needs hepatic encephalopathy associated as to go for LT. Pre-operative operation needs more than rifaximin, albumin, nutrition, muscle mass, gut modulation are needed in multimodal way. Correctable cause like shunt closure, other disease, particularly for the brain related, has to be excluded before considering a case as hepatic encephalopathy. Thank you.
So, excellent discussion, sir. Covered almost pathophysiology and precipitating factors and almost treatment till now. So I have one question, sir. In patients pre-transplant, suppose shunt-related hepatic encephalopathy or episodic encephalopathy because of precipitation by some infections, is there any challenges in post-transplant? Because post-transplant, lot of immunosuppressions and intubation, post-extubation, is there any delay of extubation? Is there drug-to-drug interactions?
Yeah, so very right, because number of slides have not added. So now it is come as a functional MRI concept. So any persons of hepatic encephalopathy pre-transplant, you go by the functional imaging of the functional MRI. You can identify the pick-up areas, metabolite patterns, and they suggest that those having a long-standing hepatic encephalopathy, prolonged or persistent hepatic encephalopathy, recurrent episode of hepatic encephalopathy, a reduction in the frontal and temporal lobe areas, and then I forgot some metabolite changes are also there. If these are there, they are the poorer predictors, and these people are likely to be more in terms of getting therapy related side effects much faster. Tacrolimus related, sodium fluctuation related, they can get more symptoms. Second, even there is not symptoms also, their residual neurological deficit remains nearly around 70% for 5 years, there will be more. So definitely pre-transplant neurological disease has a implication for the post-transplant outcome, and I think now the things is coming up that we should include functional MRI, not a plain CT of the brain, functional MRI, particularly for the hepatic encephalopathy patients. So that will help both the ways for the during peri-transplant period or long transplant for a neurological perspective.
Any questions from audience? Thank you, sir.
Thank you, sir. Next. One of the toughest situations we face is to manage cirrhotics with impaired renal function. How do we optimize those patients and bring them for surgery? To give us insights into this challenging space, I welcome Dr. Joy Varghese.
It's my privilege to welcome Dr. Joy Varghese, HOD of Department of Hepatology, Global Hospitals, Chennai, who is going to present cirrhotics with impaired renal function. Please welcome Dr. Joy Varghese. Over to you, sir.
Respected chairpersons, colleagues, friends, good morning to all. At the outset, my sincere thanks to Dr. Srinivas Reddy for invitation of this Star Liver Talks conference and congratulating all the organizing members of the things. So, if you see the renal dysfunction in cirrhotic background, almost 40% of the individual, whatever day-to-day practice we are seeing, at one point will have the renal dysfunction. Same thing will increase in ICU setting, goes to the 60% of our decompensated chronic liver disease. This renal dysfunction significantly plays a major role in the mortality. That's why in the MELD score also, which the only one organ, the creatinine, has been incorporated in the assessing the short-term mortality. HRS AKI is a unique phenotypes. We will go into a little bit details. Earlier days, type 1 HRS, type 2 HRS, and the definition was based on the serum creatinine more than 1.5. So nowadays, we know the serum creatinine is not a good marker. because earlier Dr. Mithun also quoted that how the serum creatinine will be value less in a female gender and in sarcopenic individual and so many factors. So the baseline of the creatinine, we have to take if there is a rise in more than 0.3 milligram DL within 48 hours, then we can call it as a AKI, acute kidney injury. And at the same time, if you take within a week, last 1 week previous, the patient comes, in the 1 week time, it shows the renal parameter increase more than 50% above the base, then also AKI. Or in the last 6 hours, it is very useful in the ICU setting. Even though creatinine is not that much increased to 0.3 in the 48 hours, if the urine output has reduced less than 0.5 ml per kg body weight, we have to call it as AKI. The AKI, even though it's a broad terminology in the background of cirrhotics, HRS AKI, but we have to classify as a stages just based on the creatinine rise. If the stage 1 AKI means the creatinine value should be 1.5 times to the 2 times higher than the normal range. If the serum creatinine level is 2 to 3 means stage 2, more than 3 of the normal range, the upper limit, that is called stage 3. Because we are seeing in our practice, some patients will see with the serum creatinine of 1.6. Some of the patient, first time we will see the creatinine level, even though it was normal earlier time, within 40 hours, 3.5. So we have to start to write in the stage, HRS AKI, what is the stage? 1, 2, 3. So what is the usage? Because it's a bidirectional way it will work. Some of the individual AKI 1 stage, there is a chances to progress to 2, 3 in the due course. Some of the time, due to the preventive strategy or the treatment strategy, we can bring back to the stage 1 AKI or sometime normal. Whatever say, so if the data from the ILBS Kimeva, so close to 50% of the individual, the AKI will be in the either persistent or progressive nature. Persistent means we can say AKI up to only 7 days. Beyond 7 days, if the AKI persistence, we are not calling it as a HRS AKI, we are calling it as a AKD, acute kidney disease. So that's why we have to write it out in the case summary and follow up, either HRS AKI or if the creatinine level is persistently high, there is AKD, HRS AKD, that time the outcome of the patient will be poor. So this is the normal, the dynamic course. Within the 7 days, based on the definition, either the rise in creatinine more than 0.3 milligram per DL or urine output, or the last 7 days, what about the rise in 50%? But once it crosses more than 7 days, suppose some patients treated outside hospital with the AKI, and if you come to us, that time also it shows the creatinine high, so it is called AKD if it crosses more than 7 days. That time we have to use the formula, the GFR only. The GFR is less than 60%, then we have to write AKD. This AKD, still it's a reversible, we have to revert back, we have to try to attempt, but most of the time, the earlier previous slide I showed, there is a more chances to progress to the CKD. That means if it persists more than 3 months. That time either it may be non-olivuric or olivuric. Non-olivuric means we can manage medically. If it goes to the olivuric stage, that time they might require the renal replacement therapy. So what are the precipitating factor for this, the dramatis, the deterioration by the liver cirrhosis by the AKI? If you take the AKI in any diseases, which all is now here also come into the picture, either hypovolemia or the toxins or sepsis or a combination of this component. But we are dealing a patient with a decompensated chronic liver disease. If you look into that, we have to try to identify which precipitating factor, particular to our decompensated hypovolemia means whether it's a blood loss related hematemesis, or it be due to the large volume paracentesis, or due to laxative induced diuretic. That's why we have to apply our knowledge. And with the toxin means either the nephrotoxic drug, either contrast, we are giving the either CAG, or we are doing CT abdomen, or sometimes due to diuretic induced. So what type of toxin, or sometimes antibiotics. So our sepsis, either is a SBP or non-SBP, even though the patient have a cellulitis or any other infection, that also cause, or combination of the things. These all will be we know the precipitating factors for the HRS in liver cirrhosis. If you look into the pathophysiology, whatever I have showed in that, we have to apply the factors. If you see, some of them will be in the splanchnic vasodilatation, some of them will be in the renal pressure. And if you see the last one, that is important. So earlier they thought HRS is the non-structural damage. Now we are accepting there will be a structural. So initially it will be the normal kidney. That means functionally good, structurally good. At one stage, it is progressing to the structurally good, but functionally not good. Another stage comes both structural damage and the functional damage. So then, based on the duration, if it is a 7 days to 3 months, it is called acute kidney injury. If it progresses to beyond the 30 days, it goes to the chronic kidney disease. So this is the basic picture. We know the liver disease and other, where we have to focus on the patient's susceptibility. Old patient, they are more prone to get the HRS AKI. If the patient gender, so mostly few papers support the female gender. And the patient have the associated comorbidities. So one thing, we know the decompensated chronic liver disease, and another thing, so we have to see the patient's demographic data. This way, we have to try to avoid that precipitating factor that will prevent the AKI. So preventive strategy is not a treatment strategy. So we know that our decompensated disease are vulnerable. We know the AKI is causing the rising the mortality. And the stage also we know how it's progressing and how the mortality rate increasing. So what are the preventive strategy? So whenever the contrast media, so adequate hydration we have to do and withhold the diuretic. And NAC, based on the study, it is not helpful, but in day-to-day practice, we are giving N-acetylcysteine prior to the contrast and all the things. And volume depletion, how we have to avoid. See, the practice, each one of the things we have to, preventive strategy, if you take it, we can somehow control the AKI incidence in the background of chronic liver disease. This all, we all know, but one thing, the variceal bleed, we have to start the antibiotics. Same way, if there is any sepsis, either SBP, we have to give albumin with the antibiotics. And any bacterial infection, again, albumin with antibiotics. The purpose of the albumin here, to keep the MAP at adequate range, more than 85. So this type of preventive strategy, we have to apply in our decompensated chronic liver disease, particularly if they have so much of the comorbidity and other things. And the nephrotoxic medicines, so many, even whatever antibiotic we are using, we have to be careful, particularly all the vancomycin and the augmentin, that kind of amoxicillin groups. Major abdominal surgery, sometimes they are going to take care, again the MAP and so many factors will involve if the patient have the umbilical hernia repair or so. After the surgery, not only the decompensation in the form of the liver disease, they will end up with the AKI and there will be a deteriorations. So how to manage all the things? AKI stage 1. So stage 1 means I have told that the rise in creatinine should be 1.5 to 2 times. If other all, AKI 2 stage, 3 stage, directly we have to give albumin, and if there is no response, we have to use the vasoconstrictor therapy. If still there is no response, we have to go for renal replacement therapy. But in stage 1 alone, we can we have to correct all the factors, and based on we have to wait and watch policy, we can use it. And the management of HRS, quickly we all know, HRS AKI, here it is the HRS AKI, and it is not applicable for the non-HRS AKI. Non-HRS AKI component are the, I already mentioned, AKD and CKD. So in AKD and CKD, this is not applicable. In HRS AKI1, within 7 days, so we are noticing rise in creatinine or urine dropout, everything. That time we can start with the terli with albumin, either the infusion or the, so now most of the centers starting the continuous infusion therapy. In case terli wise there is no response, there is no improvement in the renal function, then we can increase the terlipressin dosage. Similarly, we can increase the albumin dosage even up to the 40 gram of the albumin per day. Still, there is no improvement. We have to go ahead for the renal replacement therapy. The tips and other options, liver transplant, usually with the AKI, if you are going to take, and at that time it is conduct. Even though the recommendation, the paper mentioned ESL practical guideline, but we all know tips is not is a contraindication in the presence of the renal dysfunction, and particularly the liver transplant, emergency liver transplant is not acceptable because that time that's affecting the overall post-operative period. So when we have to discontinue the therapy also we have to know, and alternative to the terli, some of the patient will not tolerate the terlipressin. That time we can use the midodrine with octreotide. The problem with the midodrine, so some of the times along with the beta blocker, that will cause the bradyarrhythmia. So the bradyarrhythmia only, suppose sometime it will go for the atrial fibrillation and all the things, VAF, ventricular flutter and everything. So that alone, while giving the midodrine, we have to be careful about the things. And this already I mentioned. So this paper I just show to that, if the patient going for the RRT due to the AKI therapy, if you see this is the study on 722 patient follow-up, less than 25% only they are recovering. So most of them going for the persistent, that means already CKD. So once the CKD develops, we have to think about the combined liver and kidney transplants. These are the time when to start the RRT. There is no consensus, either early or late, because both the side, there is no much improvement in the mortality benefit. But we should do the RRT, but at the same time, we have to prepare, we have to counsel the family members. There are more chance, 70% of the individual, there is more chances to go for the CKD. And what about if you are going to do the patient, the immediately transplant? That's why I mentioned in non-responders. So AKI groups or AKD groups, if you are going with liver transplant, emergency liver transplant, if they are already responded with the therapy, means that time the chance after liver transplant, they will not get the kidney function revert back. If there is not much partial responder or non-responder groups, they will go for the CKD. That's why some of the patient, even after the liver transplant, we are seeing the elevated renal parameter, and due to the immunosuppressive therapy, whatever the TAC and CNA sparing drug we are using, the renal disease will progress. To summarize this, so cirrhosis, impaired renal dysfunction, poor prognosis, high mortality. We know the spectrums. We have to know what is the AKI 1, 2, 3 based on the assessment. We have to see either with the therapy, whether the reversibility is there or not. Preventive strategy is always better, and also close monitoring. So before to conclude, see this is the pictures, because the biomarkers, it's not much helpful in the patients with the HRS AKI. Biomarkers are useful for the HRS, that particularly AKD, CKD. But routine analysis, suppose urine routine we have to send. If you are seeing the hyaline cost is nothing but the mucoprotein, uromodulin, the protein. It is commonly we see in the HRS, AKI, and all the pre-renal. If you are going to see the WBC, that time it is acute interstitial nephritis. If you are going to see the RBC cost, it associated with the glomerular nephritis. If you are going to see these other, the granular cast. Granular cast also the mucoprotein with the debris. This we will see mostly in the ATI groups. So urine routine is important. That's why we can somehow apply the basic biochemistry knowledge in the further assessment. Thank you so much for everyone and kindness.
It was a very nice presentation, sir. So a small question, sir, like SGLT2 receptor role in HRS prevention. Any emergent data on that SGLT?
It's a SGL2. At present, I have no much knowledge about that one, and whatever the at present recommendation also, it has not been included so far in our HRS.
Any questions from the audience?
Excuse me, sir. Sir, I have a question. In a patient with HRS AKI who shows improvement with terlipressin and albumin volume expansion, but even after the improvement, the creatinine is still high. For the evaluation of transplant workup, is a kidney biopsy indicated to rule out a CKD component?
Kidney biopsy is not indicated now because already most of decompensated chronic liver disease will have all the high coagulopathy, ascites, so many things. So what we should understand, the improvement is complete reversibility. So what you are saying, there is an improvement, but still they are in the renal parameters high range. Whenever the renal parameters is above the normal range in more than 7 days, we have to call it as AKD. So that case is at the time of taking a liver transplant, they have the AKD. That AKD groups, there are the chances to revert back, but they are still, that's why I said, partial responders or the non-responder, there is more chances to progress to the CKD even after liver transplantation.
Thank you, sir.
Thank you. We'll conclude this session and we'll proceed for the next proceedings. Thank you.
Thank you, chairpersons, for your valuable time. Next, we have panel discussion. For the panel discussion, I invite the panelists, Dr. Sridhar Gandhi, nephrologist from Star Hospital, Dr. Gopi Krishna, anesthesiologist from Yashoda Hospital, Dr. Ravichand Siddhachari, surgeon from Apollo Hospital, and Dr. Somashekar Rao, medical gastroenterologist from Yashoda Hospital. Our first case discussion focuses on cirrhotic patient with severe encephalopathy. I invite Dr. Sharath Putta for the talk. Please.
Audio కావాలా సార్ మీకు? I can start now.
So good morning. Thank you, Dr. Srinivas Reddy, for inviting me to this conference. So it's a panel discussion on Okay, sorry about that. So encephalopathy, you already had a talk, so I will try not to discuss the same things over again. So this is a case we dealt with 3-4 years ago, 57-year-old NASH cirrhosis, and he presented to us with a few weeks of chronic progressive inability to carry out tasks of daily living. And his bilirubin was marginally high, albumin, INR were marginally deranged. He had minimal ascites. So my question to Dr. Somashekar. So how will you proceed from here?
So looks like, here he is not able to do his day-to-day activities. And level of consciousness, sir?
Yeah, so the patient was conscious, fully conscious.
Fully conscious. But he has some cognitive defect.
Yeah, so I'll put the slide here. So I think, yeah, you are hinting at this patient having chronic encephalopathy.
Yeah.
So like you said, you are interested in the cognitive changes. So he had a slow decline in his memory.
Oh.
He was unable to, his recall of short-term memory was affected. And we did an MMSC score that was around 20. And so that was the cognitive part. And then you are interested in his motor disability. So basically, so there's significant slowing. I'll just play a video shortly. And he was unable to walk without assistance. He was limited to bed most of the time for the last few weeks. He was pretty sarcopenic. He was almost Parkinsonian. The expression was very slow. There was increased muscle tone and everything. And then he was withdrawn. There was some personality change, and he had these comorbidities.
Yeah. So generally,
so how will you grade?
Yeah. See, traditionally, we talk about West Haven grading, but that applies for episodic hepatic encephalopathy. But here it looks like he's going into chronic hepatic encephalopathy, where we need something else other than our just West Haven grading. So we need to stage these people with other scoring systems other than our West Haven, traditional West Haven and chess scoring system.
Okay. So like you said, the traditional West Haven scoring grades 1 to 4, it is typically for episodic HE. So you have your cirrhotic who is stable, who is now traditionally in hepatic coma. So the mentation has to be depressed. So these don't specifically tell you about this group of patients. This patient has chronic HE. He's fully conscious, fully alert, but then his cognitive abilities are disturbed. So you're looking at these batteries of cognitive tests. 90% of the times you don't have to do this, but this is for the chronic persistent HE types. So these are tests of attention deficit and slow information processing. And then so he was slow in all of these. And then we did a functional impact score. This is activities of daily living. It was significantly impacted. So he was pretty slow. There was cognitive decline, and he was not able to carry out activities of daily living. Just quickly play a video here. So this was a patient. We were trying to do a number connection test with him. I'm sorry, the audio is not coming through. So there's hardly any motor movement happening. We actually asked him to, we wrote a number and asked him to identify the number. It's like 30 seconds and we didn't get an answer from the patient. So that was the state of affairs. He was bedbound. And so basically what we have here is this 57-year-old with significant persistent HE affecting his motor and cognitive ability. So Dr. Sridhar, so we optimized the traditional correctable factors, lactulose, rifaximin, we gave the branch chain amino acids. His sodium was 125. How will you deal with that?
How much sodium is?
125.
Yeah. So like as all the patients with it, one of the factor in this patient with hepatic encephalopathy, probably hyponatremia, which is chronic, mostly hypervolemic, is a contributing factor, not the sole factor. And like ideally, suppose if this patient is on symptoms like apart from your routine therapy of fluid restriction and stopping the diuretic, suppose if the patient is already on diuretics, correcting the hypokalemia if the patient is hypokalemia.
So assuming this patient has hypotonic hyponatremia, he is not on diuretics, how will you now deal with this hyponatremia?
So these patients per se, suppose long-term tolvaptan role is very minimal. Like in this patient, 3% saline is not indicated. Tolvaptan, suppose if the patient is going for transplant in another 2 weeks or 3 weeks, that is the role of tolvaptan. Otherwise, tolvaptan effect is short-lived, and there are some studies where liver dysfunction may be increased. But tolvaptan in a short time, it increases the quality of life, and your after hyponatremia correction, these hepatic encephalopathy symptoms also improves in some patients.
Yeah.
So as of now indicated if the patient is for planning for transplant.
Yeah, sure. So his sodium was right on the cusp, it was 125. There are a couple of cautions about tolvaptan. If you look at the product labeling and if you look at FDA guidelines, you're supposed to give the first dose in hospital, keep them in for 24 hours. Some people can have a jump of 10, 12 milliequivalents in a day. Start slow and avoid it in child C cirrhosis. It's a bit of a paradox, but those are the patients who need it the most, but you have to be very careful when using it in child C cirrhosis. I'll skip the albumin part. Dr. Chowdhury has addressed that. So Dr. Ravi, so what were your concerns with this patient? Because he was the operating surgeon, our transplant surgeon. So we had this patient who was in a pretty neurologically debilitated state.
Yeah. So there are few things we need to look into in these kind of patients. First thing is whether his previous mental health was optimum or not. Whether this is a chronic encephalopathy with a cognitive dysfunction, you're worried that post-transplant, whether his cognitive functions will come back to 100% normal or will partially recover or some residual dysfunction will remain. So that would be one of the main things. So I might ask help of neurologists or
So when you look at this MRI scan with pretty significant atrophy and you look at the patient with neurological debility, so like you said, you're concerned that some of this may not reverse. You might actually, have a patient who had a transplant but remains with significant disability. There's a significant disconnect with the liver function, which is not too bad, and the hepatic encephalopathy, which is pretty severe. So in this scenario, we actually asked, ideally you're supposed to get your neuro colleagues also to see this patient. So we asked our neurology colleagues to review this patient, and we got an MRI done. It shows significant atrophy. We asked, actually this patient was from Mumbai, so we asked him to see a neurologist with special interest in neurodegenerative disorders. So this is a concern. These patients with significant cognitive disturbances and some of them having extrapyramidal effects like increased rigidity, decreased movement, you're concerned about degenerative disorders. But there are some differentiating features when you have the scan showing a lot of atrophy. If you have a neurodegenerative disorder, you're more likely to have midbrain atrophy. If it is PSP, for example, you're more likely to have asymmetric atrophy. If it is multisystem atrophy, you may also expect some pontine changes. And you may have no lenticular changes. If you have hyperintensities in the globus pallidus, that goes more in favor of hepatic encephalopathy. So these are some of the more nuanced changes that you might want your neurologist to look at and tell you how much of this is actually hepatic encephalopathy, how much of this is a neurodegenerative disorder, because you don't want to be transplanting a patient who has significant neurodegeneration. It can get very difficult, and so some of the things I mentioned. A lot of these patients, especially if the etiology is alcohol, and now we're transplanting more and more patients in the advanced middle age group around 60, 65, they're all going to have a bit of cerebral atrophy and white matter changes. That should not deter you from proceeding with transplant, but of course you get a thorough neurological review. And if you have these changes in the hyperintensities in the globus pallidus, for example, these hyperintensities, then that gives you more confidence that you're dealing with hepatic encephalopathy. So he was seen by a neurologist. He was actually started on anti-Parkinson's treatment. Some patients with cirrhosis have significant extrapyramidal symptoms and they might have to go on this Parkinson's therapy. So we did a lot of things to this patient. We put him on albumin infusions. We gave him these medications, and we observed him for a period of 3 months before we committed him to a transplant. So none of these actually made a big difference to the patient. In fact, I mean the lactulose and all, the reducing ammonia, your branch chain amino acids, your rifaxamines, these are generally not very effective in the chronic persistent HE. They're more effective with your episodic HEs. So we looked for these large shunts. We didn't find any of these single large shunts. So if you have a single very big shunt, you might consider embolizing the shunt to see if that reverses the encephalopathy before you subject the patient to a transplant. This has its own problems. It can precipitate worsening portal hypertension and it can push the patient into other problems like bleeds, for example. But our patient did not have this. So Dr. Gopi, so now we have a patient who has significant neurological debility and comorbidities. And we went through the whole process of evaluation. We thought there was no coexistent neurodegenerative disorder. We went through the whole discussion with the family and now we are proceeding with transplant. So what are the things you would want to look at as the anesthetist taking charge?
So most common contributors are hemodynamic instability, rapid fluid shifts and rapid correction of sodium. My priority would be to maintain cerebral perfusion pressure, though autoregulation is fairly maintained in this type of patient, but can have significant derangement during the anhepatic phase and the early neohepatic phase. So hyperperfusion, hypoperfusion, both can cause an issue here. So hemodynamic optimization is very important. Rapid correction of sodium can cause central malignancies.
So more specifically with regard to this patient, our extubation was pretty delayed. Normally we go for ERAS, the early extubation, or for example, they extubate the next day. For this patient, because of his sarcopenia and encephalopathy, he remained intubated for close to a week. And then after that, we had to actually do a tracheostomy for this patient to facilitate extubation. And so how do you manage delirium? Is that a big delirium or an altered neurological state in the post-operative phase? Is that a concern when you're taking these patients up for surgery?
Yes, definitely. In the immediate, so a lot of microembolic events happen during surgery, which right now we are not picking up because we don't use transcranial Doppler routinely. So, and then optimization of metabolic optimization, correcting hemodynamics, and then sedation breaks and frequent monitoring of delirium. I think non-pharmacological methods are more important here.
Sure. So basically, in green, we have this patient who starts off in a pretty poor physiological state. And then going through surgery, you have all the fluid shifts and ischemia, the blood pressure shifts and reperfusion injury, all the dyselectrolytemias. This can add to the neurological problem. And it can be long lasting. If your hypotension is severe, the neurological recovery, you can push it back by several months. And then you have, once you've transplanted your patient, then you have your immunosuppressive drugs, the CNIs, which can add to the problem. So post-transplant, we gave this patient tacrolimus, and he was getting pretty excitable and tremulous. And at one point we were worried if he was getting additional complications like leukencephalopathy. We repeated the MRI, which was okay, and we put him on a very low dose. So what this patient has is the chronic HE variant. So persistently he is in HE. He used to go into grade 3s and then come back to a grade 1 or grade 2 level. not your regular episodic HE, which is a bit more easier to manage if you have known provocating factors. And I think one important thing here is if you actually give yourself some time, see these patients, assess them initially, take the help of your neurologist, give them an interval after all your interventions, and if you repeat a scan, it's interesting that some of these patients can mimic have chronic vascular changes like white matter changes, which can reverse once your encephalopathy reduces. So you can take all these measures before you actually plunge into transplant with these patients. So to summarize, so we went through with the transplant, and then after the transplant you have this problem of accelerated atherosclerosis because he already has the risk factors and now you're adding medications to it, and that is actually what makes cognitive recovery worse after transplantation. So you have to take care of your immunosuppression as well and modify your metabolic risk factors. So this is the patient post-transplant. I hope I can get the audio here. This is the last slide. So actually surprisingly we had pretty rapid neurological recovery. This was 3 weeks post-transplant. So you see that, his eye contact and, the way he's talking. I'm sorry about the audio not coming through, but this was 3 weeks post. So the message I have is, if you have somebody with chronic debilitating hepatic encephalopathy, you don't automatically invalidate them. So Metu wanted a complex preoperative case, so I think this was one of the more complex ones. We had to talk to the family, set their expectations. They need to know that they may not come back to full cognition post-transplant. They may not be useful actually, to put it in a certain way, post-transplantation. I think I have Dharmesh at the mic. Hope it's not a difficult question, Dharmesh.
So you presented a great case, Sharath, but I think the message for the audience should be that somebody who's got a sodium of 125 first to see whether they are edematous or not. And then an electrolyte that we often don't give much attention to, that is chloride. So that's something that we don't give much attention to. That can give you a handle on whether you want to correct your electrolytes, but potassium is extremely important. Hypokalemia, which is long-standing, is a very common cause of this, as is hypermagnesemia. Very poorly studied electrolyte in the context of liver disease. What you described is a classic...
So the hyperintensities in the basal ganglia, that is the...
So that is manganese and magnesium, unpublished work done 25 years ago by us, but it's unpublished. So the description of this patient is a chronic persistent HE. The message to this audience is never send this patient to a neurologist. They will almost invariably start this patient on PD medication, so get an MRS done first. And also, every time you have a discord between the degree of liver dysfunction and encephalopathy, we should do a Doppler or an MRV. That should be the first step in the management of a patient like this. Of course, this is not an uncommon problem.
So we did a carotid and vertebral Dopplers for this guy. So he didn't have obstructive atherosclerotic disease.
Yeah, so MRV because you have good liver functions and bad encephalopathy. Of course, ammonia did not figure in your description. I wish it had.
No, I skipped through the ammonia slide. This person's ammonia was around 65. Everything was just on the cusp.
So these patients need a huge period. So what we do in our program is to have a run-in with them rather than try to tackle them later on. So many of them are deconditioned actually. So if he is not edematous, he is hyponatremic, chloride is normal to low, then you know that you are not dealing with a situation where you want to correct that. So these patients need more of a physio-based input after you've ticked the other boxes, and then that's the time we would want to transplant them.
Yeah, so the 3-month waiting that I was talking about, I think we put him through everything, including neuro rehab and some nutritional fortification. So we went through a lot of things, and I skipped some of the slides because it's very tight doing a panel discussion in 15 minutes.
Thank you, sir. Our second case deals with pre-operative AKI. a situation which we often see. Do we delay surgery to allow kidneys to recover or go ahead and risk post-transplant dialysis? To share this case, I invite Dr. G. Srinivas Reddy, hepatologist at Star Hospital.
So good morning, everyone. So today morning we have discussed presentation by Joy Varghese sir about pre-operative AKI, how to manage, how to evaluate, and post-transplant outcomes, how it will be there. Just we'll go through the case scenario. So this is the patient. He is a case of CLD, likely cryptogenic, diagnosed in 2023. He had prior history of AKI HRS, was treated with albumin and terlipressin. He has recovered. His index presentation like jaundice was treated with medical management. History of upper GI bleed in 2024 on EVL sessions. History of ascites since 6 months, refractory on LVP every 1 month. He had history of AKI with maximum creatinine of 3.54 and history of HE recurrent is there. When he comes to us, he's on examination wise, performance status is good and gross ascites is there. And he had history of abdominal wall cellulitis, was improved with antibiotics. So when he came to us, his hemoglobin is 7.2, counts were 4.36, platelets were 42, and INR is 1.36 with albumin of 2.9, and creatinine of 3.53 with sodium of 131, and potassium is of 4.2. So we done quickly ultrasound IVC to see volume status. His IVC is 1.2. Good volumes, and kidneys wise CMD is maintained, and we done single time aspiration. There is no history of SBP. And quickly we done urine analysis, which was showed albumin plus, and pus cells were 3 to 5, and CAS was nil, and urine PCR is 2.6. So our diagnosis is likely portal hypertension. He has history of bleeder on EVL sessions. CLD likely hepatitis B plus cryptogenic, decompensated in the form of refractory ascites, hepatic encephalopathy, and upper GI bleed, and he had history of AKI, HE, GI bleed, and MELD sodium is 23, and CTP is 10. The reason for AKI likely thinking of HRS likely. So my question to panelist Dr. Somasekhar sir, is a patient with refractory ascites requiring repeated tapping with AKI, HRS, what will we do next line of management in this case?
Are we sure that abdominal wall cellulitis has come down?
Come down. That's
so there is no source of
no
sepsis
source of
anywhere.
infection.
So obviously I will go with HRS component. We would start terlipressin and albumin again at this point of time. We will see for the decrease in creatinine and the urine output.
Okay. So we have started albumin plus terlipressin as a step-up protocol initially with 2 mg per day. And slowly, if you see creat initially 3.57, it came down to 1.79 after giving almost for 1 week. His minimum creat reached to 1.7 at this point of time. So here the acute kidney injury with creat of 1.79 with proteinuria like nephrotic range proteinuria. So in this case, what will be the next step for further evaluation? Is there any biomarkers in this helpful to differentiate in this case, or any role of kidney biopsy in this case? Sridhar sir, nephrology, can you comment on this?
No. Like if you go through the slide of the previous slide, even from the beginning also his GFR is less, 1.42 means, like even without acute deterioration also. Probably because he is a diabetic, he might be, along with the proteinuria, probably he might be having underlying diabetic nephropathy is one possibility. Rarely one possibility of his hepatitis B related.
Yes.
B related, some glomerular involvement in the form of membranous nephropathy is one. Or chronic HRA, sometimes they have proteinuria, if persistent injury is there, that proteinuria is there. So these are the three possibilities. See, suppose if diabetic nephropathy is there and GFR of more than 30 ml per minute, like straight away you can think of, after managing this, planning for liver transplant. And the role of biomarker, instead of single episode of biomarkers, it is the natural history of the disease and the GFR, like persistent decrease in the GFR of less than 25 ml per minute for more than 6 weeks, he qualifies for the criteria of liver plus kidney. But in this patient, his GFR is more than 40 ml. Like if any method roughly you calculate, it is more than 30-40 ml. So probably underlying diabetic nephropathy is there, but GFR of more than 25 and not dialysis dependent. Probably after managing, liver transplant is the only liver transplant is an option, explaining that patient family that future diabetic nephropathy may progress, he may need is one. The second, the role of biomarkers. Most of these biomarkers, see, ultimately whether to differentiate between HRS or acute tubular necrosis, we do. But per se in clinical utility, not much role. And improvement with all your conservative measures, albumin and terlipressin, which gives, and even if it is ATN, significant damage is there, all the markers are elevated. ATN is there. ATN which is not improving over a period of 6 weeks, again qualifies the criteria of going for combined liver and kidney transplant. So they tell us whether structural damage is there or not, but ultimately for making a decision, it is your natural history and GFR whether improved or not.
Sir, any comment, sir, Somasekhar sir, on this? Biomarkers for to differentiate HRS AKI and non-HRS AKI.
Yeah, we have few biomarkers which are available, but practically I don't think we can do for every patient. But definitely when we want to tell the patient about the prognosis and post-transplant only we are doing a liver transplant and we need to explain them the risk of progressing to CKD, we can do some biomarkers initially, like we have something called NGAL, we have urinary IL-18. These things with an upper limit, if they are crossing that, and to give the prognostication, definitely yes, urinary biomarkers definitely helps, is what I feel.
So usually in HRS AKI, the chronicity, this natural history, so they might go into HRS AKI, HRS AKD and HRS CKD. These are all natural history. Initially, previous Dr. Joy sir showed, initially they will have the functional kidney is normal. The progress, slowly the progresses, they may have some underlying structural changes in these patients with HRS AKI. So in this case, should he proceed liver transplant alone or thinking of any simultaneous liver kidney transplant? Dr. Ravichandran sir.
Yeah, so as Dr. Sridhar already explained, this is a tricky case where, I mean, at the moment he doesn't fit into the criteria of SLK, if you go by the criteria. So you have to go for LT alone. So, but my worries are still there, like baseline creatinine is a bit high and he has got nephritic syndrome. So we have to explain to the patient and the family that he may end up with renal issues later on and may need it may recover or may not recover completely and may need a kidney transplant at a later stage.
So next question to you, sir. Induction immunosuppression in this patient, is it standard versus do you think of IL-2 inhibitors at induction?
We do use IL-2 inhibitors in these cases. We have been regularly using it, although there are some centers where there is some apprehension, but we are using and we are having a fairly good result also. What the problem is not the immediately the kidneys will recover partially, they will allow you to give some immunosuppression, but the problem happens little later after 3 months, 6 months when you are going on that nephropathy may trouble you later.
So in this scenario, you do consider intraoperative CRT in these cases, Dr. Gopi sir?
If you see the evidence, there is no single prospective study comparing intraoperative CRT with conservative management. So whatever data we have is only few case series. So when there is not much evidence, my indication will be somebody with severe hypervolemia or hyponatremia when I am expecting severe fluid shifts. metabolic acidosis on full medical management, or hyperkalemia just before reperfusion or in the post-reperfusion phase. Few vulnerable indications like acute onset of right heart failure. Otherwise, no, don't start regularly.
So do you think in intraoperatively if the patient has metabolic acidosis, is there at that time you might start CRRT?
Yes.
Okay. So what we did in this patient has refractory ascites, AKI HRS with minimum creat of 1.79. We explained prognosis and we proceed with liver transplant alone with induction with basiliximab 20 mg at day 0 and day 4, and we given intraoperative CRRT in presence because of metabolic acidosis. If you see by post-op at the time of discharge, post-op day 14 is creat is 0.74 with sodium of 134 and sodium is 4.1. So last question for expert panelists, is there any cutoff for proteinuria or creatinine to proceed liver transplant alone? Sridhar sir, to think.
See, only suppose if you think of proteinuria, we have to think of whether other primary glomerular disorders are there or not.
Yes, sir.
And suppose if proteinuria with normal renal function and diabetes is excluded, most of the, I am talking about in terms of clinical utility. So most of the glomerular proteinurias, either it may be an IgA nephropathy or membranous nephropathy, we use mycophenolate or tacrolimus or steroids. So anyhow in the post-operative you are giving this one. So proteinuria per se, if for the diagnosis point of view, sometimes you may consider biopsy or do PLAR antibodies, some vasculitis workup. If these are not there and diabetes is not there, proteinuria cutoff is not, you can go ahead straight with but explaining the family that primary glomerular disorder, proteinuria is there. Like afterwards, if it is not responding, he may need biopsy in the future, because instead of doing for proteinuria biopsy now with CLD decompensation with coagulation abnormalities, management it is not going to change. Unless you suspect some. So only proteinuria taking for transplant alone and monitoring the proteinuria in the post-operative period that is better option. And cutoff creatinine, definitely it is not the creatinine, it's the GFR. Persistent decrease in the GFR. See, normal isolated kidney transplant, when we consider for kidney transplantation, GFR of less than 15 ml per minute over a period of 3 months, like ESRD, we'll consider. Whereas liver disease with CKD, because up to 20, within less than 30 ml also we should consider for simultaneous, because these are the patients, they require prolonged RRT therapy if their GFR is 20-25. Post-operatively, they require prolonged renal replacement therapy and prolonged CRRT, infection risk are more. So in them, if it is less than 25 ml, you can consider for both combined liver and kidney.
Ravichandran sir, what is your comments on this?
I agree in what Dr. Sridhar said. There is no number cutoff as such for proteinuria or creatinine. Okay. It's the trend we see, the treatment response, and also whether this patient really needs a SLKT or not. So I don't think there is a number where you can put in and say this is the cutoff where I will do SLKT or LT alone.
Somsekhar sir, you are same. Okay. So this is the case scenario in patients with AKI, HRS, who is very progressive, going maybe towards AKD or towards CKD. There is no cutoff for proteinuria. The patients, we need to explain the risk, benefits and progressive RRT, then we should think about liver transplant. But always to discuss with the family members, backup, you might require renal transplant, even post liver transplant also. Thank you.
Thank you, sir. Thank you, panelists. We close this session. Now we have tea break for 10 minutes.
So I think what we talk about HRS is all flicked from the Western literature. Which one of us wants to put a urinary catheter to measure 0.5 ml per kg? So all of that is nonsense. We should just stay away from that, Whatever the Western world does not, as you know now, the fountainhead of all donkeys is the White House. So we should get even more careful.
Yes.
Now, HRS is not a syndrome defined by creatinine. It's a syndrome which is defined by hemodynamics. It is also not defined by the IVC diameter. Again, some studies have happened in some from our part of the world, unfortunately, which are talking about the IVC diameter. It's completely flawed. In your patient, important question is he oliguric, non-oliguric? Is his renal function getting better, not getting better? If his renal function is getting better, and you've seen this patient for a short duration of time, regardless of what the proteinuria is, you only talk to them of a liver transplant alone. SLKT is a huge thing. We talk about it loosely. It's not to be trivialized. Important thing in the post-operative period is, because what you saw was the honeymoon period. This patient will have problems with the kidney later on. So you should check the proteinuria after the transplant also. So again, this is a commonly made mistake that when you have got an acute kidney injury, you start looking at the UPCR. It's a good idea to know that UPCR, but it's a better idea to know what is happening when your renal function is also getting better. So never ever base your decision on labeling somebody as an HRS just based on the creatinine value. Of course, there is an increase in the creatinine from 1.42 to 3 point whatever value, but I can again tell you, if you go back to the charts, those charts will tell you a different number. You cannot have a sodium of 134 or 137, which you projected, with the creatinine having gone up from 1.4 to 3.4. It's impossible. So HRS is a completely different syndrome. It's defined by hemodynamics. It's defined by the cardiac function. It's not defined by the creatinine value.
So usually some of the patients with cirrhosis patients, they might have on diuretics. So these patients, volume status also very important. Sometimes before starting terlipressin, if you give some volumes of albumin, these patients might be improved with, so these patients' volume status also might be important in these cases.
We have done a study on the prior to liver transplant. We took the renal parameter and we assessed the what about the post liver transplant renal dysfunction as well as the overall patient outcome. So the study we did for last 5 years, we are now the full papers write-up is going on. Whenever the patient we are going to take a non-oliguric above the normal range, the creatinine, the post-liver transplant, overall that morbidity was high, and compared with the normal renal function, that this morbidity also statistically high, and over the last 5 years, I mean, if you are going to data, it's going to be more of CKD. So what our observation is the renal parameters on the day of liver transplant, if it is above the normal range, overall the patient's outcome is poorer than the normal renal dysfunction, normal function.
Any other comments, questions? We can have a short tea break. Come back, 5 minutes, 10 minutes, coffee break also, yeah.
నాది కాదు టాక్ నెక్స్ట్ టాక్ ఇది వీడియోస్ కేబుల్ కనెక్టెడ్ లేదు ఆడియో
we welcome you to the session 2. The session 2 is very special because it highlights an important theme, the decisions we as clinicians make at the edge of certainty. In liver transplantation, you always live in a twilight zone where there are no right or wrong decisions. In this session, we have 3 talks. First one is young patient dying of alcoholic hepatitis, where transplantation is the only option. In the second talk, a patient living with relentless ascites, where every option seems imperfect. The third talk, we have a patient ready for transplantation, but carrying an infection. So each scenario forces us to ask, what would I do here? For this session, we welcome the chairpersons, Dr. Rami Reddy, Dr. Rajesh Gupta, Dr. Shravan, Dr. Kondal Reddy, and Dr. Yuktansh. Dr. Yuktansh.
Good morning all. In this session basically we are dealing with critical issues in the liver transplantation, and out of which these are the critical scenarios in the pre-transplant setup, like alcoholic hepatitis, as refractory ascites, and one more thing is a pre-operative infection. These are the 3 important topics for every hepatologist and gastroenterologist. And now I request Dr. Anand Kulkarni to present on liver transplantation for severe alcoholic hepatitis. He is a senior consultant at AIG.
At the outset, I would like to thank Dr. Mettu sir for inviting me here, and Team Star, and my colleagues Srinivas, Sunil, Raghu, all of you. Thank you so much for inviting me here. The topic is a little complex, liver transplantation for alcohol-associated hepatitis. This leading indication probably in India, in our hospital especially, is now alcohol-related ACLF and alcohol-related alcoholic hepatitis, and probably decompensated cirrhosis due to NASH. If you see the epidemiology, the use of alcohol is significantly high. The recent data which is published in BMJ says that although there is reduction in the death due to alcohol and there is increasing deaths due to drug-related abuse, we still see that alcohol contributes to 5% of death and disability-associated life years. It has impact over 200 diseases and types of injuries. In India, this accounts for 22% of the deaths due to liver disease and 20% of deaths due to liver cancer. Alcohol is the main culprit. Why we discuss about alcohol consumption in Telangana? Because we stand number 2 in consumption. We are just 10% away from defeating Arunachal. Arunachal is the highest consumption of alcohol, followed by Telangana, then Sikkim. While in females, it's in Arunachal again, then Sikkim, Assam, and Telangana. 6.7% in Telangana, and in rural areas, we see around 1.6%. We have been doing some rural-based research now, but what we see is 65% of rural area individuals consume alcohol. So alcohol is pretty high, a huge burden. And when we discuss about alcohol-associated hepatitis, this is a severe form of alcohol-related liver disease. The problem with alcohol-associated hepatitis is at least 4 out of 5 will present as ACLF. This was the ARC-based analysis which was published in Hepatology International, and they found out that 30% are only eligible for steroids. So 4 out of 5 of alcoholic hepatitis will present as ACLF, that is they have extrahepatic organ failures, they have infections not suitable for any kind of medical management. We also have no drugs for this alcoholic hepatitis. That's the reason we need transplant for these patients. There is one drug which has shown some benefit for these patients, direct DUR928, but it has shown beneficial only in American settings, not in UK or other settings. There is no animal model for alcohol-associated hepatitis. That is the reason we struggle with developing any drug for this disease. As of now, the medical management is hovered only around steroids. That's the reason we are stuck with only liver transplant as the best therapy for these patients. Currently in US, alcoholic hepatitis is the leading indication for transplant. There is 5 to 8-fold increase in transplant for alcoholic hepatitis. They are doing multiple research to reduce the burden of alcohol-associated hepatitis. And at least this early transplant for this patient costs around $300,000 per patient in US. The burden is pretty high in US as well as in India. But the problem is the differentiation between alcohol-associated hepatitis and alcohol-related ACLF. This is a table which we had recently published in liver transplantation. This may not be true in all extent, but what we usually see is if the patient has large liver, mild ascites, no or grade 1 varices, elevated bilirubin and INR, and EST elevation and more than 200, in less than 400, then we think it is probably just alcoholic hepatitis, not ACLF. If an individual has other gross ascites, grade 3 or more ascites, which large varices, and has bilirubin, modest elevation of bilirubin, and also has enzymes which is not pretty high, but the platelets are low, indicating chronicity in those patients, then the probably patient has ACLF. These kind of patients require upfront transplant. They will not respond to steroids. The response to steroids in them ranges between 38 to 50% in those patients. Well, if the patient has pure alcoholic hepatitis, the response to steroids ranges between 75 to 80% in those patients, and probably transplant, without transplant, they may recover to some certain extent. Coming to transplant, the pivotal study which was published in NEJM, they said that it has excellent survival, but they chose they had very strict criteria for transplanting those patients. It has a very small group of patients, 25 to 30 patients who underwent early transplant. They include only those who were not responding to medical therapy, where severe alcoholic hepatitis was the first liver decompensating event, and there were no coexisting psychiatric disorders, and the patient had a favorable psychosocial profile. These were the individuals who were chosen for early transplant. I will not be talking about only transplant, it is mainly around early liver transplant for these patients. But what actually is early, this definition is very not clear. When we did some review of this definition, early LT for AH is defined as transplant without a prerequisite period of alcohol abstinence. That we have made it as 6 months. So it's actually not 6 months is actually not cutoff which has been defined in any literature. This was based on 1994 study which was published in Hepatology, where Jack Lake was the senior author, where he said that 6 months, if you do a transplant within 6 months, these individuals tend to relapse more. That is the reason we came to a definition of early transplant as less than 6 months, but it is actually just defined as without a prerequisite period of alcohol abstinence. What are the predictors of post-transplant relapse? We see the post-transplant, we see the relapse is in around 20 to 25% of patients, and 8 to 10% will have severe relapse. These are usually young patients who have more than 10 drinks per day, those who do not have family support, those with a history of psychiatric illness, those who have concomitant substance abuse. These are the individuals who have high risk for relapse post-transplant. So it is dependent on abstinence. To transplant or not is dependent on abstinence, liver disease severity, psychosocial aspects, and probably, yes, we need the donor for these patients to undergo transplant. This is our experience which was published in Annals of Hepatology. We had only 25 patients who underwent liver transplant early. The median abstinence day was around 93 days, that is 3 months. MELD at the time of transplant was 28 and DF was 104. Almost 70% survived more than 1 year. The survival for these patients was low because we also used steroids for these patients, and they had most of these patients developed infections post-transplant. 3 died due to fungal sepsis, 2 had bacterial sepsis, and 1 developed COVID. The relapse rate was 20% and severe relapse was around 8 to 10%. When we compared with other transplant centers, it was similar. This is from Dr. Narendra Chaudhary's group, 39 steroid ineligible patients who underwent transplant. Age was 43. This is the critical age where we see around 40 to 45 years alcohol-related ACLFs who come to us planning for transplant. They have an abstinence period of 4 to 6 months in that study. And there was the survival is better compared to non-AH ARLD and alcohol hepatitis related ARLD. Relapse rate again around 12%. Higher infection. This is a struggle in India. We have 70% of MDR bugs in India, which was published in Gastro by Piano study. We have a high burden of MDR bugs in India. So probably that is the reason we have high infection rate. 71% developed infections in alcoholic hepatitis group compared to 50% in non-AH group. Again, in Korea, they have reported around 9 LDLT for these patients. 14 days within listing, they underwent transplant. And third one is the one study which I quoted already. So early transplant has excellent survival, but the problem is availability. In Asia, only 18 to 20% we can offer early transplant. This is a survey-based study which was published in Lancet GastroHep. In Canada, it is 100%, US 97%. So every alcoholic hepatitis is immediately listed for transplant. That is the reason they are doing research to identify patients who will not require transplant early. While in Asia we have only 18%, that is 1 out of 5 we may undergo transplant early for alcohol-associated hepatitis. What happens when the patient relapses post-transplant? How does it impact the survival? This was a study which was published in CGH, Lee BP, which he actually has worked multiple articles on early transplant for alcoholic hepatitis. There they saw 4 patterns of alcohol relapse post-transplant. Most of them were abstinent. Those who were abstinent had significant survival benefit even at 5 years. In pattern 2, these patients who had late non-heavy alcohol use, their survival was also good. That is, patient after 1 year, if he starts drinking and he is not consuming in heavy amounts, only occasional slips, their survival will not be impaired. But those who have early non-heavy and early heavy, their survival is significantly impaired. Although at 1 year the survival may remain same, post 1 year their survival significantly decreases at 2, 3 and 4 years. And in those who have early heavy alcohol use, their survival is hardly 50% at 5 years. In this study, they actually had questionnaire-based assessment of alcohol use. They also monitored through biomarkers, that is PET test was done in certain patients, in 75% of the patients. And they said that early relapse is a significant predictor of poor survival for alcohol-associated hepatitis. And how do we diagnose alcohol use disorder in clinic? That is our common question for patients pre and post-transplant. These are the traditional biomarkers which are already available in, which have been using regularly. What we see is MCV. When the patient comes to us, if the MCV is elevated, it is quite sensitive to identify alcohol use. We also see the AST, ALT elevations. We see the GGT levels. But the one which has come to recently to market is the PET testing, which is a marker of the red blood cell. This gets converted into, phospholipid gets converted into phosphatidylcholine in the presence of alcohol. This is the PET test which have been suggested for alcohol, to identify alcohol use post-transplant on the second right-hand side. If the PET is less than 10, then the patient may not have alcohol consumption. If it is between 10 to 20, there is some alcohol exposure. He may require repeat PET testing. If it is between 20 to 35, there is high risk of alcohol exposure. If it is more than 35, he definitely is consuming alcohol. PET has to be measured by LCMS method, which is a very costly method, very sensitive method. We have started performing ELISA for this, and we find it to be useful in clinical practice. There are certain scores to predict alcohol use post-transplant. The one which has been actually published and recommended by guidelines is the SALT score, which is sustained alcohol use post-liver transplant. A score more than 5 indicates high risk of relapse. These are the comparisons between the two. When I use this score in our clinical practice, most of our patients have a score of 8. So I don't know whether it is relevant to Indian settings. We need more research on this aspect. Last but not least, please identify these patients who have risk of alcohol abuse and treat them with these medications which are available. We have naltrexone, which is freely available, 50 mg per day. We also use acamprosate 333 mg thrice daily. Baclofen, although not approved, but can be used for these patients. And in the use of we need to send them for psychological counseling, but our patients are quite reluctant to undergo psychiatric counseling, and although we have been trying to send them to psychiatric counseling, this is a very poorly conducted systematic review published in CGH, where they said that the combination of CBT and MET, motivational enhancement training and cognitive behavioral therapy, along with medications, will help them remain abstinent from alcohol. To summarize, what we suggest is a proposal which was published recently. If you have a patient who his MELD score is 25 to 35, he has disease severity which is alcoholic hepatitis without AKI or only HRS AKI, good performance status, has no risk of relapse post-transplant and good control of infections, he may be ideal candidate to undergo transplant if there is good family support. If a patient has any of these which is fitting in blue criteria, he may not be ideal candidate, you have to wait and reassess. If the patient has very poor family support and has not been engaging with alcohol, engaged with abstinence and mental health care, he may not be ideal candidate, he should be delisted and should be avoided from providing liver. To summarize, alcohol-associated hepatitis and alcohol-related ACLF is now a major indication for transplant, and early transplant provides excellent survival, at least 70 to 80% in these patients. Indian data shows the feasibility, but there is need for strict infection control and psychosocial support, which we probably lack to some extent. Self-reporting, relapse prediction tools which are there, and biomarkers are essential to identify alcohol use. MAT, that is medication-assisted treatment, and motivational interviewing, that is just spend 5 minutes with them to remain abstinent from alcohol, they will probably quit alcohol. CBT and MAT have to be done by a psychologist. If the patient agrees, then probably you can go ahead with CBT and MAT. I'd like to take this opportunity to invite you all for our liver conclave, which is being held on 26th and 27th of September. Look forward to seeing you all again in next month. Thank you so much.
Thank you, sir. Thank you for lucid presentation. And I have one question for you, sir. Suppose particularly in such cases, if transplant is delayed some or other reason, is there any role of FMT, fecal microbial transplantation?
FMT, we have not seen any great results. We initially tried FMT in our center. We usually prefer to do plasma exchange as a bridging therapy for timing. If the patient is not infected, we do plasma exchange and then probably take them for transplant once they are stabilized.
Questions from audience?
Thank you, Anand. It was a great talk, actually, as usual. What I wanted to know was, I mean, we see more and more these patients who come to us, they've been in another hospital, had steroids, got multiple infections, they have come. In the Indian setting, with the kind of MDR bugs that we're having, are there any clear subset of patients where steroids are actually indicated if your patient presents with alcoholic hepatitis?
So what we usually see is that if the procalcitonin is low, even if he harbors those VREs, which has been routinely done as from all the orifices to identify, they usually respond well. If the patient has frank gross ascites, who has very small liver and very high bilirubins with renal failure, we usually avoid giving steroids. If they have good liver reserve, only elevated bilirubin with mild ascites, no varices, good platelet levels, probably they will respond well to steroids.
Thank you. And I think I was impressed by one slide of yours, the paper from CGH, where you shown that if you remain abstinent after transplantation, your survival is, 5-year survival is nearly 100%.
100%
I mean,
survival.
that just shows that, these are patients who, if they actually stick to the word, then they do very well with transplantation.
And I think that's definitely true over here, but our patients, they tend to relapse whatever said and done. At least they have occasional slips. And PET might be useful in identifying those patients.
Thank you.
Thank you.
Thank you.
Next week, I call Dr. Dinesh Jodhimani for the talk on managing recipient with preoperative infections.
Good morning. My privilege to invite Dr. Dinesh Jyothimani. So he's a senior consultant, hepatologist, working in Chennai, over 18 years of experience. He's actively involved in global health community. I hand over mic to the Dr. Jyothimani.
So Srini, I thought the talk was how to manage ascites before transplantation. I think the next talk is the infection talk, actually. Oh, okay, so yeah, difficult to treat ascites. It's very old. So patients for liver transplantation, when they develop ascites, initially they all respond to diuretics. But by the time they come for liver transplantation, actually, many hepatologists struggle to treat the ascites, actually. I'll be very frank with you, because they're often sarcopenic, They have high creatinine, sodium is on the lower side. It's not an uncommon scenario. It's not an uncommon scenario to see such patients when they come for liver transplantation. When we see patients like that, we need to find out why the ascites is increased. Is this because of disease progression, or is this some other reason why they have increasing ascites, and why we struggle to manage or reduce the ascitic formation or treat this condition. So when these patients walks into the outpatients, in your outpatient department, first question we need to ask is, are they non-compliant with the diet? Or they're not taking the diuretics because they have some side effects and because the prescriptions are not correct? Or the liver disease is progressing. So that's one of the main reasons, because when they started ascites probably 2 years ago, they were responding to diuretics, but by the time they get referred for transplantation, they may not be responding to diuretics. Or there could be other causes not related to the liver directly. They may have cirrhotic cardiomyopathy, they may have pulmonary artery hypertension, where they have increasing ascites. So we need to identify the cause and treat accordingly. WHO recommends low salt diet actually for everybody, not just for liver patients. But in India, we consume double the amount of recommended salt. If you look at the world map here, we are in red. That's quite alarming. I'm sure, and particularly in Telangana, it must be very high because you guys all eat pickle. Is that correct? So, so pickle has almost 1.2 grams of salt in 100 grams of pickle. So you should be careful when we, talk about diet to these chronic liver disease patients, particularly when they have ascites. So when patients, despite having diuretics, when they have increasing ascites, the first thing, the diet should be addressed properly, and we should ensure they are on strict low salt diet, because that's extremely mandatory. So therefore, somebody who on diuretics, on low salt diet, if they still continue to form ascites and struggling, then we'll have other options. So what are the newer options that may be available? Midodrine, it is a weak vasoconstrictor drug. Okay, the other strong is terlipressin, which is intravenous. So there's a study from Virendra Singh's group. So midodrine addition to the standard of care, like with diuretics, has been shown to reduce ascites formation, increase urine volume, increase your mean arterial pressure, increased sodium excretion. So if you add midodrine to diuretics, definitely that's going to help your patients to reduce ascites. And if you continue for 1 year, definitely your survival is better. But these drugs do not treat the underlying cause, that is your chronic liver disease. It only aids excretion of ascites in the urine actually. So therefore, midodrine is probably useful in patients where your diuretics, where we are not using diuretics. Say for example, if they have borderline renal function, you stop the diuretics and then add midodrine for some time, and that actually works for many of our patients, in addition to your dietary salt restriction. What are the other drugs that can be potentially useful? Is 12-aptan, which is aquaretics, V2 receptor antagonist that causes water loss, free water clearance. So there is another study from India that showed midodrine plus 12-aptan actually causes complete resolution. There are more patients who received this combination had better response to better treatment with ascites, in addition to your diuretics. So you have a cocktail of medications here. So diuretics plus midodrine and 12-aptan. So you should be careful in monitoring the side effects. Okay, but the response at 3 months has been better. So if you have somebody who's waiting for transplantation, you may try midodrine or tolvaptan drugs like that. Now, there are a lot of studies. There are at least 4 good studies on the use of albumin in patients with refractory ascites. Now, the 2 studies showed benefit, 2 did not show benefit. But this large retrospective study showed that if you have ascites, particularly grade 3 ascites or grade 2 ascites, and if you give them 40 grams per week, that is 2 albumins per week, 20% albumin, the ascites formation comes down, the grade of ascites reduces. By doing this, you can actually improve the response to diuretics. So if you have somebody with grade 3 ascites and you give them albumin, it may come down to grade 2 and they may respond to diuretics better actually. So this is a possible option in patients, particularly if they are waiting for cadaveric donor transplantation. But again, giving 40 grams per week is very expensive. They may need to come for daycare, and it's not practically feasible in our country. So you may give at least once a week like that. So this is an option. So either you can use midodrine, you can add tolvaptan, or this is another option. You can give albumin and increase your diuretics because your oncotic pressure increases, your renal blood flow improves. With this interesting study done in, I think, SGPGI actually. So what they did was they mixed albumin and furosemide together and then gave slow albumin as an infusion. And they found that patients who received this combination of drug had a better improvement in ascites at day 28. This is particularly useful in patients with acute on chronic liver failure, where the response to diuretics is often not that great because the liver disease severity is quite bad. But once again, these are a small group of studies and single center studies. So therefore, where we may use this combination is, this strategy is useful in those with anasarca, where they not necessarily they have ascites, they are just globally fluid overloaded, where you want to bring down all this extracellular fluid to the intracellular space. So it may be an useful option. Earlier, somebody asked about SGLT2 inhibitors in patients with liver disease. So this receptor works in the proximal tubule. So SGLT co-transporter is nothing but where your sodium is excreted, your glucose is excreted, along with sodium is also excreted. So, that's how it works, the inhibitor, the SGLT2 inhibitor. So this is a dapagliflozin actually. But what happens is when you excrete sodium along with your glucose, the ascites also reduces. But when you have more glucose concentration in the urine, there is a risk of urinary tract infection. So you should be very careful in prescribing these drugs, but generally we don't use it for the ascites purposes. The other modalities are, so these are the pharmacotherapy, how we manage difficult ascites. The other modalities are large volume paracentesis. Personally, I'm not a big fan of this because frequent large volume paracentesis causes acute kidney injury, post-paracentesis circulatory dysfunction, and mainly sarcopenia, and the hepatic encephalopathy, all those complications. So frequent paracentesis is probably not the best idea actually, but maybe once in a month or in patients waiting for transplantation, it's probably okay. What followed in the West may not be applicable for us. In the West, these sort of patients usually go for transjugular intrahepatic portosystemic shunt, the TIPS procedure. But at least 1/3 of patients can develop hepatic encephalopathy. So what happens in the West is where there is more abundant cadaveric transplantation. So if patients develop hepatic encephalopathy, you can internally prioritize this patient and give the next available organ, which is not a practical scenario in our population. So therefore, utility of TIPS may be less in our country actually for such reasons. And if you have a living donor option, you should go for that. And there are contraindications for TIPS procedure as well. There are other modalities like alpha pump and there's something called PICA, which removes the ascites through the urinary bladder. But again, the risk of infection, hyponatremia is quite high and it's not widely used. The newer modalities are long-term ascitic fluid drainage and a peritoneal catheter, it's called PICA. So they have shown to be beneficial. It was used in malignant ascites initially, but subsequently people have tried in patients with chronic liver disease. So home-based peritoneal catheter has been shown to improve survival without any increase in acute kidney injury or spontaneous bacterial peritonitis actually. And these patients were actually, some of them have even undergone liver transplantation. But once again, whether we experiment with these, I don't know. I have not used them. What followed in Japan is concentrated ascitic fluid reperfusion therapy. This may be an attractive option. So when the ascites is removed, it goes through filtration process and cleaning process and then goes back to the patients. So this is something we can use in the future, because what we are doing with large volume paracentesis, we remove so much enriched fluid and give only albumin. Albumin alone doesn't equate to ascitic fluid. Okay, so so much proteins, other important components are there in the ascitic fluid. So this is probably a better option, and it is shown to improve quality of life, and importantly, no need for albumin replacement therapy, and it reduces diuretic resistance, and this may be an option in future in patients who are awaiting liver transplantation. Ultimately, liver transplantation is the only solution for patients with refractory ascites who have acute kidney injury, etc. So how do I manage patients with difficult ascites? First, ensure salt restriction. Make sure they're on a very low salt diet. Make sure inadvertently this salt is not going in the diet. Optimize diuretics. So once you ensure low salt diet, optimize your diuretics. You can increase your diuretics and they may respond very well. In these patients, the creatinine increases. You can temporarily stop diuretics, add midodrine. Once the creatinine improves, then in addition to midodrine, you can restart low dose diuretics. That might work. If sodium decreases, again stop diuretics, add tolvaptan, go for fluid restriction. And if sodium improves, temporarily continue tolvaptan, restart diuretics, and then you can stop tolvaptan once the sodium levels are achieved. But ultimately, liver transplantation remains the only curative therapy in these patients. Thank you very much.
Thank you, doctor, for highlighting various modalities of treatment for refractory, difficult to treat ascites. I have one question. So, how best we can treat for refractory chylous ascites?
Can't hear you.
Chylous ascites. Chylous.
Chylous ascites. Chylous ascites usually in the pre-transplant setting we don't see much. We see sometimes in the post-transplant setting where you have to adjust the diet, and that's why it's important to discuss with the transplant surgeons. Sometimes they say they had a lot to manipulate the small bowel, that may cause chylous leak and ascites. So that is slightly different way of managing. So generally in the pre-transplant setting we don't see much actually.
Questions for audiences?
Sir, is there any role of partial splenic artery embolization if the patient is wait list for liver transplantation? Any comments on this?
Yeah, so there are sporadic case reports on splenic artery embolization to reduce the inflow, thus reducing the formation of ascites. but it's not widely practiced. And if patients opt for liver transplantation, unnecessary manipulating also causes problems, and that may cause splenic abscess and preclude them from having a transplantation, or you may end up doing splenectomy. You know, all these are sort of, you have to take a calculated adventure rather than, you know, going to extremes.
Sir, I have a question. Sir, in patients with this ascites who present with incarcerated umbilical hernia, like in the place where I got trained, along with the anatomical repair of the hernia, we used to do a Denver shunt, which is a peritoneal venous shunt. So is there a role, I mean, in a patient with moderate ascites where the pump is implanted in the subcutaneous, so patient has to manually press every time. So is it done still? Does it have any role?
The question is Denver shunt useful? So Denver shunt is a very old technique. It's a peritoneal venous shunt. It's been used for palliative purposes in patients who are not candidate for TIPS or liver transplantation. We don't use these days because we have good effective drugs for the management of ascites, and also the availability of Denver shunt is not there these days, and it is also invasive actually, and sometimes can get blocked, and risk of spontaneous bacterial peritonitis we don't know. So in clinical practice we don't use Denver shunt. It's more of pharmacotherapy.
Can I just make a comment? Just wanted to add to what Dr. Kondal asked about chylous ascites. I think we do see cloudy ascitic fluid when we do tapping. It's not always chylous ascites, but especially we've seen that in patients with Budd-Chiari syndrome, patients who have extensive portal vein thrombosis, and we always have to rule out tuberculosis, because that can actually cause infiltration of the lymph nodes and cause blockage. And to the second question, I think Denver shunt, Dr. Rela has, we've seen him use it for post-transplant ascites. You know, patients who have persistent ascites post-transplant, it does help in managing these patients.
So sometimes the cloudy ascites, partly treated SBP, tuberculous ascites, they are slightly different entity. They don't come into this category. They won't respond to these treatments. So yeah, and sometimes you can prick the lymphatics during the ascitic tapping. That can also cause chylous. So that's a totally different way of managing them.
Thank you. Any questions?
Thank you, sir. Next topic is managing recipient with preoperative infections. I invite Dr. Dharmesh Kapoor to give his talk.
I invite Dr. Dharmesh Kapoor. He is a senior consultant hepatologist working at Yashod Hospital. He needs no introduction. He is my teacher and mentor. And he is a great author and published more than 50 journals, and is given more than 15 topics in a textbook. Thank you. Hand over to Dr. Dharmesh.
Good morning, everyone. Thanks to Dr. Methu for this invite. So this is one of the most challenging things that we see in people who are waitlisted for liver transplant. Almost forever we are trying to combat infections in this cohort of patients. And actually what you have heard in the earlier talks, whether it's dyselectrolytemia, renal dysfunction, altered cognition, actually the roots of that might all be in a patient who's having a smoldering infection. The important thing, and I could just sum up this talk in a few sentences, that when a patient who's waitlisted for transplant has an infection, there are a few problems. There are some things that we read from literature, and there are some practical problems. The literature tells you that once somebody has an infection, they will have a worsening of cholestasis, worsening of renal function, cognition, acid-base status, hemodynamics. They will be pushed to organ failure, and that would probably tell you that these patients need to be transplanted sooner than later. But of course, you have to contend with the fact that they might still be harboring an active infection. The more practical purposes, points are as to how you manage them. So diagnosis of these infections for a cohort of patients who are already on a number of prophylactic drugs. Then they also have associated dysfunctions, and you heard about that from the previous speakers. How do you culture these patients when they have already received antimicrobials, and some of them might be on ongoing antimicrobial therapy? And most importantly, how do you have a venous access, something that we never ever discuss about. So you've heard about domiciliary albumin, 40 grams per week. So all of those who see these patients at ground zero, we know how difficult it is. This is one of the most compelling commentaries on the global burden of bacterial infections, only bacterial infections, which was published a few years ago in the Gastroenterology Journal. So the sum and substance of this particular study from Sylvester Piano from Italy is that you have patients with cirrhosis who, if they catch infection, in that part of the world it's still mostly community acquired. Mind you, in our country almost 60% is either healthcare associated or hospital acquired. Then the sites of infection are things that are all very well known to us. So it could be a spontaneous bacterial peritonitis, urosepsis, respiratory tract infections, spontaneous bacteremia, skin soft tissue infections, extremely common but often overlooked, and a host of other things like cholangitis, or somebody has got a TIPS, endotipsitis, you name it, any part of the body can get infected. And when these patients get infected, there is a worsening of their liver scores, and oftentimes they will be pushed into organ failure. The biggest problem and the main reason for this particular article was the burden of the multi-drug resistant bugs. And this is something that we all are faced with on a day-to-day basis. So just the top sentence of this slide. If somebody has been exposed to antimicrobials, that itself predisposes you to a multi-drug resistant bug. So oftentimes these patients will be coming into the hospital either for large volume paracentesis, albumin infusions, or just for any other reason, and you would find that they already have been exposed to the healthcare associated bugs. So please remember, the bulk of the infections which occur in cirrhotics are actually HCA. The definition for HCA for cirrhotics is very different from the HCA in the common practice. And oftentimes you might have to do an invasive procedure. So like I said, you will run out of venous accesses for them sooner or later, especially those patients who've been on prolonged periods of time on the deceased donor waiting list. And then you would spend so much time, energy, effort and money on just trying to sample various body parts. And the algorithm which is given by various societies is extremely detailed. So you have to sample each and every part of the body. And when you think that somebody with cirrhosis who's waitlisted for transplant is having an infection. So what are the downsides when you compare it with the other critically ill patients? So is WBC a good marker? The answer is no. Is lactate a good marker? The answer is no. Is the cognition a good marker? The answer is no. Are the biomarkers a good marker? You heard a little while ago the role of procalcitonin. Actually in decompensated, especially child CEPU cirrhotics, procalcitonin levels are increased even if they do not have an infection. So you talk of anything and you would find that it's probably a big zero when it comes to managing these patients. So important thing is the clinical sense. So if you've been seeing this patient for a fair length of time, it would not be very difficult for you to tell that this patient is infected or not. So what about beta blockers? So if you were to use the quick SOFA score, my colleague left a little while ago, they published recently saying that quick SOFA score is good. So quick SOFA score has got potential problems because many of these patients are on non-selective beta blockers. So therein comes that you've ruled out at least one of the 3 parameters that you would use in that score. So there are challenges, and other than clinical sense, there is nothing that will come to your rescue. The most important thing that we must remember is then when we are treating these patients for the primary infection, at least a quarter of them will go on to develop a secondary infection. The secondary infection, 3/4 of the times or even more than that could be with a different bug. So just because this patient is in the hospital for his primary infection, you are actually again subjecting him to another infectious exposure, and that is going to be a bigger challenge. And if it is a different bug, then obviously your antimicrobial repertoire is also going to increase. So you can see that if you have got a secondary infection, then the chances of the MDR and the XDR also increase. So therein, the potential problems of dealing with the patient who's waitlisted and who's got infections. The important message from the NACSELD. So when NACSELD was first formed in the second decade of this century, it was actually called the iNACSELD. So that means these were the infections which were pushing the patients into organ failure. So the North American Consortium for Study of Liver Disease, actually their first publications were all on I-NAXL. That means it was an infection as a trigger. And most of these patients actually needed organ support. So as you can see on this slide, these patients would be pushed to organ failure, needing some kind of an organ support. So it is one thing to be pushed into organ failure, and it is another thing to have organ failure which requires organ support. And that just makes the situation that more dramatic and difficult to manage for these patients. So many of these patients would either need ventilation or they would be on RRT, and then you would be hard pressed whether to justify transplant for this cohort of patients or not. So most studies have shown that the predictors of hospital mortality, and mind you, these are also predictors of the 28-day mortality. So in most clinical trials, these are the two paradigms that you use. They are based on the severity of underlying liver disease score. Those who are not at least on non-selective beta blockers, you could still use the Q-SOFA. Mind you, Q-SOFA is a very good score to tell you that this patient should be on the radar. He should either be on a step-down unit or this patient should be in the intensive care unit. It does not really tell you that you are on your mark, set, go. So go is still not there. On your marks, get set, definitely yes. Those patients who get pushed into organ failure, and then the efficacy of empiric antimicrobial therapy. Again, extremely important. So please remember that just because somebody received, say, a third-generation cephalosporin for the treatment of a primary infection does not mean that this patient cannot be treated with a third-generation cephalosporin again. So please remember that empiric antimicrobial therapy is extremely relevant even in this cohort of patient as it is in the other ICU practice. The only other difference for 28-day mortality is if you have this wait-listed patient develop an MDR bug. So if this patient develops an MDR bug, then their 28-day mortality is also extremely high. So again, in the same publication, and I would like to draw your attention to this bar. So look at the far right of these slides. So the top one is carbapenems. So these are the healthcare associated bugs. And like I said, that almost 40 to 45% of healthcare associated infections are seen in this cohort of patients. And look at the bar with the carbapenem. So you've got just about 50%. And if you look at the hospital acquired, or what we used to call nosocomial infections in yesteryears, so this deep blue bar is now not only a carbapenem, it is a carbapenem with glycopeptide. So you are faring miserably when it comes to the number of antimicrobials that you would use in this cohort of patients just to fight infections. And mind you, this is extremely different from other parts of the world. So Dr. Piano's commentary was also very telling in one respect, which is that most of the MDR bugs, they come from the Asian continent. So is only the medical practice responsible for that? The probable answer is no, and this is something that can be discussed. So what happens to patients who are waitlisted and when they catch an infection? So you can see that the resolution of infections is much higher when you do not have an MDR bug. Whereas in all other situations, at least in this study, this was not statistically significant. Mind you, these are small numbers. This is the cohort which defined the canonic cohort, which was 2013 to 2014. And about 1,200 patients were registered into this cohort, and only about 1/3 of them presented with acute and chronic liver failure. So this is a glossary of terms that we must all get very well used to. And our ID consultants actually will have an acronym for all of them. There is one which is not figuring in this slide, which is also extremely good favorite of mine, which is Acromobacter xylosicistens. So these are all tongue twisters and tongue rollers, but these bugs are extremely important because these bugs at times will need lower order antimicrobials. For example, Stenotrophus maltophilia. So again, a very commonly recognized bug in the cirrhotic population, but it comes from venous accesses. So that is something to bear in mind. So it is not that every time a patient comes to you, you have to hit them with the carbapenem. So the drug sensitivity is extremely important. So these are the guidelines from the EASL, some years old. Nowadays, I know that most of the centers are using or hitting these patients hard, even with the new line of drugs, but I know that there is a session on infections and cirrhotics subsequently, and therefore probably these issues can be discussed at that moment in time. Now these are key slides which are of practical use for the audience present here. If you have a urosepsis and this patient gets an organ call, do you treat this, do you take this patient up for surgery or not? And this is what we have incorporated into the LTSI guidelines also. They will be published very soon. So I think this slide set will be available and you can go through all of them. Important message is that the common infections are urosepsis. This is probably that should not refrain you from taking these patients for transplant. SVP, even if the patient is responsive, 48 hours later you show a decline in the white cell count, you can take them up for transplant. Bacteremia needs to be treated differently because you will have to prove that there is a negative blood culture. Pneumonitis is extremely difficult to treat, so you must have at least 7 days of antimicrobials on board, especially it was a hospital-acquired infection. But mind you, don't look for the radiologic improvement. So if white cell is coming down, lactates are coming down, oxygenation is coming down, PF2 ratios are getting better, you can take up this patient for transplant even if the radiological imaging is not clear. The spontaneous bacteremia needs much longer period of treatment than spontaneous bacterial peritonitis. Fungemia, SFP, again probably needs a lot of discussion because many of these patients have been in the hospital and have been hit with antimicrobials in the past. That itself is a precursor to produce these two syndromes. Please remember that the management of SFP is very different from that of SBP, and you must always rule out secondary causes. So wait for the patient's renal function to improve. Make sure that there is no secondary peritonitis in this cohort of patients. Otherwise, you will have egg on your face when the surgeons open the abdomen for transplant. C. difficile, not very common in our part of the world, but if you start looking for it, it is there. So all these years we have been saying that Europe and Asia does not see C. diff. In recent times when we have started to look for it, it is definitely there. Oftentimes Turley-induced diarrhea we always say is because of bowel ischemia. That is certainly not the case. Message for all of you in the audience, start sending the C. diff toxin assay and you will be surprised. So these patients have to be treated for a significant length of time. If they have a recurrence, then they have to be treated for much longer. So what happens to the patients who are waitlisted, say on the deceased donor side? So this is the experience from University of Padua. Again, similar to what I have been alluding to in the previous 7 to 10 minutes, that these patients would often have a second infection and they might even need a readmission. So mind you, these are patients on the deceased donor liver transplant list. So what you must understand is that if you have got bacterial infections present, the probability of death at least in the first 6 months and probability of not getting a transplant in the first 6 months is pretty high. So that is something to remember. And if your bacterial infection has resolved, then your chance of getting a liver transplant touches again your control value. So what to expect post-transplant, because that is something which is extremely relevant to this audience. So if you have had a bacterial infection pre-transplant, new infections post-liver transplant, fungal infections and septic shock are extremely common, statistically far more common than patients who have not had an infection. However, this is important. The survival at 1 year and survival at 5 years is not different. So the message is, if you have been able to treat the infection satisfactorily and based on the guidelines that I just mentioned earlier, then these patients will have an outcome measure which is no different from the control group. This was the recent publication. Again, something that you can go to. This is available on the net. This is a multi-center Spanish study where again the focus of attention was the MDR bugs. So selectively the MDR bugs and how do these patients do after transplant. So please remember, use of organ support. So it is not just organ failure, use of organ support. And whatever antimicrobials you have used in the past, that is going to decide whether these patients are going to get better or not. But again, when you have overall risk of infection in these patients, the lower respiratory tract infections are the commonest. And when you have got the MDRO bugs, then urosepsis. So mind you, in our country, we often treat urosepsis very shabbily, but that might not be the true case. So try to get rid of the catheters very quickly. So there is an ever-going fight between the physician and the ICU colleagues and surgeons whether to remove the Foley's or not. So all depends on who's the dominant force. So try to get rid of the foreign bodies ASAP. The bugs are again gram-negative mainly, but because there is an intervention that has happened, so you see the gram-positives too, including Enterococcus faecium. But the mortality rate remains high if you have got an MDR infection. If you had an infection with a susceptible bug or no bug, then the mortality remains pretty much the same. So this is a huge topic and you can have a day-long seminar on this. And the things that I have not discussed are again things which are of extreme relevance to all of us in this audience. So all of us have read papers on patients with cirrhosis and waitlisted being colonized. Does it have any relevance? So there are so many publications on that, but this data is not granular. Biomarkers, there isn't one. CRP, procalcitonin, presepsin, you name it and they all have got their problems. Rapid diagnosis comes to your aid, but mind you, still the culture-based diagnosis, they cannot be undermined because the drug susceptibility would not be known unless you have a culture-based diagnosis. Invasive fungal infections, I did not allude to, extremely relevant in two cohorts of patients, patients with severe ALK-HEP who present with acute on chronic liver failure and undergo transplant, and those patients in whom you have a reactivation of autoimmune or an autoimmune hepatitis related acute liver failure, wherein you want to transplant them and they have been pre-treated with steroids. So IFI is extremely important in the steroid exposed patients. Tuberculosis, I think there's going to be a talk on that. Viruses, there is information that now, just like the bacterial sepsis, there is also an entity called viral sepsis in patients who have end-stage liver disease and who are waitlisted, protozoans in some other parts of the world, and intangibles. So intangibles is for all my surgical colleagues. So skin to skin time, anesthesia colleagues, what are you using? Fluids or pressors, what are you treating your patients with? We still haven't gotten or wrapped our heads around whether we should be giving steroids to patients who undergo transplants or not. And of course, immunosuppression. So please continue to do what you are most experienced with, and do not try any flamboyance when you manage these patients. If the patient goes on organ support post-transplant, that is the time when you have to switch gears. Low immunosuppression almost never kills. So again, there is always a debate, a raging debate in the post-operative period that the enzymes are going high and the physicians did not start the patient on immunosuppression. I can tell you 10 out of 10 times whosoever is telling you that is wrong. Thank you so much for your attention, and I'll be very happy to take any questions.
Any questions from audience?
Sir, one question, sir. The patients who has difficulty to SBP, so after 5 days with treatment with sensitive antibiotics, after 5 days we tapped again, but still there is no resolution of ascites. So what we do we change antibiotics or to add any GM-CSF role in these settings?
So what you are saying is that you repeated the tap
Resolution after
and
5
you found
days.
that there was no decline in the
decline.
polymorphonuclear counts. Most of these patients would have been exposed to antimicrobials earlier. So again, what should come to your aid is 5 days is too long a period of time. Probably you should be testing after 48 hours itself. So if this patient has got creeping renal parameters, lactates are going up, white cell count is going up, the urine output is tailing, or his cognition is impaired, then I would definitely switch gears. But you should probably do it sooner than later. So waitlisted patients are always on our radar. The threshold to tap them again, especially when, see on the living donor side, you have the advantage that things can be optimized. The slide that I showed on the various infections are more relevant to an organ call being available for a patient who's on top of the deceased donor list. So you have somebody whom you are treating for SBP, and 72 hours later they say that he was on top of the list and there is an organ of the same blood group available. Do you take this patient up for surgery or not? So those are more difficult to take decisions.
Is there any role of GM-CSF in these cases, sir?
None. It has been used, but that data is all over the place.
What is the best time to vaccinate, sir, when CLD patients? Best time to vaccinate with a preventable disease?
Right. Difficult question. So I still vaccinate them only against hepatitis B. I vaccinate for the newer, more fanciful and expensive vaccines only if there are other comorbidities. Most of our patients are anti-HIV total positive. Response to hepatitis B vaccine is not very good, but always test for the anti-core total. So before you initiate vaccination against hepatitis B, always look for the anti-core total. So if anti-core total positivity is there, you can do an anti-HBS, but you don't really need to vaccinate them. So if you have a patient who's stable, you could just give them one shot if the anti-HBS was not detectable and look for an anamnestic response. As regards the influenza, pneumococcal, shingles, so on and so forth, I don't do that in my practice, unless somebody has got other comorbidities, either from the cardiovascular side or the respiratory side.
Any questions? Thank you.
Good morning, sir. Nice talk. One doubt, sir. If at all the patient is improving after starting the drugs, and the timeline that you have given is like suppose 5 days or the 7 days, and he's responding, and the call comes in between, like after 48 hours you have seen a response. So whether in that scenario, will you proceed for the surgery or you will still give that specified time for that patient?
We should proceed for the surgery. So timing is of essence. Especially in high acuity patients, the timing is of essence. So if you have been able to show a decline in the parameters, white cell count, lactates, improvement in renal function, and you must demonstrate. So the commonest call comes for SBP. So if you have tapped them and you have shown a decline in the white cell count, then yes, surely you should consider them for surgery.
Sir, will you look any specific parameter, or as such the clinical improvement whole you will take into consideration?
Nothing to beat the clinical improvement. So demonstrate objectively that the white cell count has come down, and if there is clinical improvement, we go with it. If the white cell count has come down, but you are seeing the other parameters that this patient is now on inotropes or the blood gases are all over the place, hold back.
Oh, thank you, sir.
Thank you. Thank you, sir. Thank you, chairpersons. Next, we have panel discussion. For the panel, I invite Dr. Sharath Putta, Dr. Sukanya, Dr. Sachin Daga, and Dr. Chandana Reddy. Our first case is on pre-operative infections. These are exactly the same situations where the transplant teams will differ. Some would say, I would like to go ahead with surgery. Some would say, we have to wait. To present the case, I invite Dr. Shushmita, anesthetist from Star Hospitals.
Good morning, everyone. I'm Dr. Sushmita, consultant liver transplant anesthetist, Star Hospital. So my case is a 48-year-old male presented to our hospital with jaundice of 2 months and ascites of 1 month. He was diagnosed with chronic liver disease, ethanol-related, and was on medical management. He was abstinence for 3 months, and he had past history of HE grade 1 to 2, AKI grade 1, which was resolved, and he had history of steroid usage for alcoholic hepatitis. And is a known case of diabetic type 2 mellitus and on oral hypoglycemic agents. On examination, he had icterus and bilateral pitting pedal edema, grossly distended tense ascites, and right basal entry was decreased. On labs, the platelets were 38,000, INR was 2.92, total bilirubin of 15.4, albumin of 1.9, and sodium of 125. The MELD score was 34. The diagnosis was acute and chronic liver failure. He had portal hypertension and was a non-bleeder with small esophageal varices, alcoholic hepatitis with underlying alcoholic liver disease, and organ dysfunction being AKI grade 1, which was resolved. The need for liver transplantation was explained. On routine workup, we found that CMV IgG was positive and IgM was also positive. So my first question to Sachin sir, so what is the significance of CMV IgM positive?
CMV IgG positive along with IgM means it has been little bit old infection. It means it has been more than a duration, and in such cases we need to see the viral load, and probability of going ahead with this status will be a better. Only issue will be when if it is only IgM positive and IgG is negative, and if there is any associated transaminitis along with it, then it will have a significance.
Okay, sir. So we had done CMV DNA qualitative PCR, and we found that the viral load was 7,700 per ml. So my next question is to Sukanya ma'am, should we treat this, how do we proceed?
So Dr. Sushmita, I'd like to know, did the patient have any symptoms, any
No
clinical
ma'am, patient was
scenario
completely asymptomatic.
So I think CMV PCR below 10,000, 1,000 to 10,000 is a very uncertain range. You cannot, in the presence of a proper clinical scenario or symptoms, you should definitely treat. Otherwise, the guidelines are very vague on treating somebody with a viral load less than 10,000. So I would probably look for, other evidence, say something on the lungs, on the CT, HRCT chest, something which shows some subtle infection or something, and only then think of it treating pre-transplant. Post-transplant, definitely one would have to treat prophylactic.
My next question is to Sharad Putta, sir. Sir, how do we monitor the viral load and how long do we have to wait before transplant? Like, what are the endpoints before taking up a transplant?
Yeah, I think just a bit of background. So this is a youngish patient, around 40.
So 48.
Yeah, 40, and so he's had steroids.
Yes, sir.
So that's the background, and so it is unusual to have a CMV infection pre-transplant. To come across a CMV infection is a little unusual, but now that you have these copies, but there's no evidence of any infection, right? No retinitis,
Yes, sir. No
pneumonitis.
retinitis.
So there's no end organ involvement as such. So we're just treating a viral load.
Yes, sir.
I think couple of weeks and then you check your DNA again. That should come down to undetectable levels because the levels are not very high. And if there's no evidence of any end organ infection as such, you could possibly wait for 2 to 4 weeks and then go ahead with your transplant. But again, how long you wait is determined by the patient's condition. We're not going to just wait because one number is high, because you're anyway going to go through the transplant with the antivirals on board.
Thank you. So we treated the patient with tab, valgan, cyclovir, 900 mg BD pre-transplant for 3 weeks and then repeated the CMV DNA qualitative PCR, which showed the viral load was not detected. And we found, we had done a CT abdomen and with lower chest sections, and we found these lesions. So Kanya ma'am, what do you think is the finding of the CT? And
yeah, though this is only the lower cuts, but what we can see, what we can see there is actually cavitating nodules. At least 2 we are able to see, 3 we are able to see. One is in the perihilar area and remaining in the, it's probably in the lower lobes, lower segments. We see 3 or 4 we can see, even one on the right side also, right lung also we can see. So in a differential diagnosis in a patient with chronic liver disease who's immunocompromised, has received steroids in the past for this thing, and he has a CMV infection. So they are all risk factors for a fungal infection. So first possibility will be a fungal infection in the form of invasive pulmonary aspergillosis. Other differential diagnosis for such a cavitating nodules, multiple bilaterally seen, will be septic emboli, but they are more predominant in the basis and more towards the periphery. So we definitely need to do blood cultures and rote endocarditis in such patients. So third thing will be, of course, tuberculosis in our country, but one thing odd for tuberculosis is, again, the lower lobes are predominantly seen here, at least I can't see the upper cuts. And second thing is the intervening parenchyma is normal, which is usually not the case in case of tuberculosis. You'll have more coalescent lesions with the consolidations between. Other things, of course, in a non-CLD patient will be vasculitis conditions, like anchor vasculitis will be other differential for cavitating nodules. But first, high on the list will be invasive aspergillosis because of the history of CMV, steroid use, CLD, which are all risk factors for invasive aspergillosis.
Dr. Chanda, may I ask, do you think that is a fungal ball?
It's not a fungal ball. It's
in
a
the cavity?
No, it's not a fungal ball. That's not no. It is mainly a cavitating nodule, which because of the central necrosis, the necrotic element falls towards one side. So you see a crescent sign. It's typically a crescent sign, but it's not a fungal ball. Fungal ball is in the previous cavity you have a fungal colonization. That's called a fungal ball. This is not a fungal ball. It's the invasive aspergillosis. Typically it presents like this with a crescent sign.
And how do we have to evaluate it, ma'am? Like, how do we go next? How do we proceed?
Yeah, so there are different criteria. Actually, for the routine criteria which are given by the EORTC or mycosis study group of the European Society, they basically give the criteria for the neutropenic patients, like post-bone marrow transplant or post-immunosuppression patients. But now there are criteria for patients who are in the ICU and who have other non-hematological or non-malignancy related risk factors like CLD and steroid use and COPD patients. So we have what's called the Aspergillus ICU criteria, which take into consideration 4 factors. First is, of course, the clinical factors, that is the signs and symptoms suggestive of a respiratory infection, where there is no response to after 3-4 days of antibiotics, the patient continues to have hemoptysis, cough, expectoration, breathlessness. Second is the radiological criteria, where you have typical features suggestive of a aspergillosis infection. Third will be the mycological criteria, where you have either a lower respiratory tract cultures positive for aspergillus, or you have the biomarkers positive in the form of galactomannan. And the fourth, you either can have host factors, or you can have a semi-quantitative cultures of this thing. So the aspergillus ICU criteria are more used for this group of non-neutropenic patients. And non-neutropenic patients, usually serum galactomannan is not very sensitive because the neutrophils in the blood will eat away the galactomannan. So the sensitivity comes down. So the cutoff in the serum galactomannan for non-neutropenic patients they have decreased it to 0.5. So any serum galactomannan more than 0.5 is considered to be significant, that increases sensitivity. Whereas the ball galactomannan is much more sensitive, picks up, and the sensitivity is around 80 to 80% with a specificity of more than 90%. So we should, ideally, this patient should undergo a serum galactomannan test and also bronchoscopy with a ball from that area, from the segment, and send it for appropriate investigation, including the fungal stain, fungal cultures, and also because in our country we need to know tuberculosis, so AFB stain and the TB PCR or a gene expert, and of course ball galactomannan. So this is what I would do for this patient. Yeah.
Yes, ma'am. So we have done, we had proceeded with bronchoscopy as you had said. We had also sent serum and ball galactomannan test, and ball, AFB, fungal, gram stain, biophy, TB PCR and cultures, everything have come negative. Pine viral PCR had also come negative. The ball galactomannan was weakly positive, but the serum galactomannan initially was 0.83. After 48 hours we had repeated and it was quite significant, it was 1.74. You have already answered this question, so serum galactomannan positivity. And what is the choice of antifungal agents in child C patients, ma'am?
So I think the drug of choice otherwise would be, last one indication is for voriconazole. Is a drug of choice for azole, is a drug of choice for invasive aspergillosis. But because it's child C, I would go for probably isavuconazole, which has a lesser hepatotoxicity in this patient. So isavuconazole will be the drug of choice in this patient, child C. If we cannot still use isavuconazole, it still has around 10% chance of hepatotoxicity, even in isavuconazole. So maybe second drug of choice would be liposomal amphotericin.
And what are the treatment endpoints? Is this clinical recovery or biochemical or radiological resolution?
I think it's a combination of all. So he hadn't have much clinical features.
Yes,
so here we would definitely, we can do a serum galactomannan, serial galactomannan or ball galactomannan. If it's decreasing in amount, it indicates that the patient is improving. Second, the radiological improvement. So CT improvement is important also, or radiological improvement. So probably biochemical and radiological improvement is what I would say.
So with strong clinical suspicion for a fungal infection, we get started tablet isavuconazole 200 mg TID for 2 days followed by OD. It was given 2 weeks prior to transplant and there was clinical improvement. During the course, patient had spontaneous pneumothorax for which ICD was placed and managed before surgery. Condition at transplant, he had improved quite well. The platelets had improved, INR had decreased, bilirubin had decreased and sodium had improved. So MELD had decreased from 34 to 28. So Sachin sir, is there any role of change of antifungal agents recommended preoperatively?
As this patient has responded, probably no. But just before a day of surgery, we will shift to amphotericin and continue in the post-operative period.
Okay. We had added injection amphotericin B from day 0 of transplant and continued for 5 days along with tablet isavuconazole 200 mg OD for 10 weeks in total. Patient was stable and was doing well post-op. This is his post-op labs, which shows platelets have improved, bilirubin had decreased and albumin has improved. And there was complete radiological resolution, which was taken 8 weeks after transplant. So my summary is active CMV infections present preoperatively should be treated. Preoperative fungal infections in CLD patients have very high mortalities. So high index of suspicion, prompt treatment is necessary to optimize patient overall outcomes.
Hello, can I make a comment? So I think Dr. Chandna has made some very important points in her narration of the CMV viremia. So pretty much as you see in the post-transplant period, when you are seeing an odd organism having grown, you should always look for the other members of in the hooligan group. So these are the MDR bugs, the CMV, the invasive fungal infection. So your patient has the right phenotype for developing an IFI. And it is well known, as it happens in the post-transplant period, that when you find a particular bug, in this case a virus, look for the others. Maybe to make the narrative more audience-friendly, you made the CMV DNA narrative first, followed by the CT scan. But obviously the CT scan probably would have made this patient far more symptomatic. So the same thing holds for the post-transplant period also. So if you are seeing, say, an IFI, always look for the CMV. And we should all remember that CMV drug resistance is also on the rise. So we might think that valganciclovir always comes to a rescue. but in published literature from other SOTs actually says something to the contrary.
Thank you, sir.
Our next case is on hepatitis B with high viral load. I invite Dr. J. Srinivas Reddy, a star hepatologist.
So, moving to case 4, this is routinely we used to see in cirrhosis with hepatitis B, usually with patients with cirrhosis and ascites or cirrhosis with HCC cases who requires transplant with high viral load, how to manage and in this case scenarios. So this is the case of hepatitis B viral cirrhosis with HCC. He has diagnosed as hepatitis B virus underlying cirrhosis 20 years back, took treatment for 10 years, then after that he took CAM, and history of jaundice 6 months ago, and history of pain abdomen 3 months back. He was evaluated and diagnosed to have HCC with 5 into 4 centimeters lesions and no decompensation in past, evaluated for liver transplant, came to us. Examination wise, no other specific findings. So his LFT bilirubin is 1.3 with AST is 85 and ALT is 47, albumin is 3.7 and hemoglobin is 12.2 and counts for 7,000 with platelets are good, and AFP is 90 and PUCA is normal, and his viral load is almost log 8.3, and if you see CT scan, there is a lesion in segment 6 which is almost 5 into 4 centimeters. Along with that there are some 2 lesions with 1 centimeter. So my diagnosis is hepatitis B related cirrhosis with well compensated, with underlying portal hypertension, with non-bleeder, grade 1 varices, with CTP5, with MELD of 12, the BCLC B HCC, multifocal, with the largest lesion 5 into 4 centimeter, with SUV is 2.94. And there is no involvement of portal vein and there is no distant metastasis. So what will be the next line of management, and in this case what will be the significance of high viral load in liver transplant settings? Dr. Sharath sir.
So the first question is, what is the next line of management? Obviously you have to address the cancer and as well as the virus. So I got the part that the largest is 5 centimeters. How many other lesions you said there were?
Total 3 lesions are there.
Okay.
And the next 2 lesions are 1 centimeters and third lesion is 5 into 4 centimeters.
Okay. So in terms of treating I'm assuming this patient is going to be waitlisted for transplantation, and you might want to bridge the patient while he is on the waiting list.
Yes.
So the bigger lesion may be amenable to treatment. So you might want to do TACE, which is very well compensated. There's no portal hypertension as well. So, and it depends on the socioeconomic setting as well. So you could do a TACE as well as a microwave combination to the bigger lesion, because it's around 4 to 5 centimeters. It may be amenable to that combination therapy. And in terms of high viral load and the significance in the transplant setting, so at the time of transplant, if you have an aviremic patient, if you've instituted antivirals and your patient is aviremic, you may be able to avoid giving hepatitis B immunoglobulin through your transplant, as compared to a patient who has detectable viremia, where you might have to give some amount of immunoglobulin in the anhepatic phase, if not for a few more doses later on. So yes, you would discuss about transplantation, waitlist the patient, maybe talk about the options for bridging therapies, and start him on antiviral agents.
Yeah. So for this case, because of high viral load and multifocal SCC, we explained to the patient to wait for transplant for time being. So we started on dual antiviral drugs, tenofovir plus entecavir, and for largest lesion we have done TACE to that lesion. After 1.5 months, we have repeated DNA, which was log 4, and repeat PET CT showed complete response for the lesion, and there is no new lesions were not there. And AFP from 2090, it has come down to 12.3 nanograms. So this case, how long to wait for HBV DNA levels to come down for liver transplant? And second question, in this scenario, ideal cutoff for HBV DNA levels in setting of underlying multifocal HCC background. Dr. Sukanya, ma'am.
Since this patient after 6 weeks of therapy has complete remission, I would wait for the DNA to come down to not detectable levels.
Okay.
There is no hurry to transplant at that point. But otherwise, at least a 10 power 3 is what we should aim for to go for a transplant. But
So
in this patient, I would wait till it becomes undetectable.
So
for the same reason as what Dr. Sharath said, you can avoid immunoglobulin. Not just that, you can avoid a reinfection and so many other things subsequent to that. And then you also increase the chance of patient becoming HBsAg negative post-transplant, responding to vaccination post-transplant if you go with undetectable viral load.
So this patient is already underlying multifocal HCC, maybe chances of...
But then we have seen that the other two lesions are 1 centimeters. You know, 1 centimeter lesions do not get any BCLC, any exceptions. So not BCLC, so they don't get any MELD exception points. They should be at this, treated the same way as a patient without HCC. And the bigger lesion has gone into complete remission. In 3 weeks, if the viral load has come down from 10 power 8 to 10 power 4, then it's quite, in 6 weeks, it's quite likely by 12 weeks it would be undetectable.
You could argue that this is outside the conventional criteria, right? So instead of rushing into a transplant for the fear of the cancer recovering during waiting, instead you might actually want to wait because you've bridged the patient, you want to uncover the biological behavior.
Yes.
So if your patient is recurring that fast, then your prognosis post-transplant may not be good. So it is paradoxical, but because it's outside the criteria and now you've bridged the patient, you might actually want to wait and see the biological behavior.
And also another thing, when we downsize patient tumors, it is expected that you follow them up for a finite length before you can take them for transplant without significant chances of a recurrence of tumor. So for 2 reasons, obvious. One is for the viral load and the other is to uncover the biology of the tumor.
So in these settings, we explain the patient that to become HBV DNA to go for undetectable levels, but family are little hesitant to stay. So in this case, HBV DNA is log 4, post-test it showed complete response. AFP is 12.3, waited for almost 1.5 months. So option now is wait till for HBV DNA to go for undetectable or liver transplant with the support of immunoglobulins in this criteria. Sachin sir?
Actually, when we decided to downstage, that time only we would like to see whether patient is going to be for a living donor or a cadaveric transplant. Suppose if he is for a living donor transplant and we have identified the donor, we would like to do some fast vaccination for him so that he has antibodies in him prepared by the time they go ahead with donation. And we will definitely like to go ahead with transplant if patient is willing and they have a donor immediately. Suppose if he is for cadaver, anyway we have to wait for HBV DNA to come down and even organ is not available. So in those cases we would like to wait. But if living donor is there, we will definitely like to go ahead. And even immunoglobulins, we usually give low dose immunoglobulin to these patients and then follow only with antivirals.
So in this case, he is evaluated for LDLT, his donor is there. So we proceed with liver donor transplant. So with continuing dual antivirals, along with that we have given intraoperatively anahepatic phase almost 10,000 international units given, followed by daily 1,000 units for 7 days, and then weekly once for 1 month. So we kept his anti-HBs titers almost 230 at 1 month after transplant. So in this case, how long to continue immunoglobulins in this case? Dr. Sharath sir?
I think that's a difficult question to answer. So we could say that at the time of transplant, the viral load is not high, it's in the intermediate range, right? So you've treated the patient for a week. If you went back to traditional protocols, we used to treat them for a few months, in fact for a few years. Some of these patients used to get HBIG. So I think for this patient, at least for the first 3 months, I would maintain a serum Hbig level more than 100 at least, and while maintaining the patient on antivirals. End of 3 months, again you could argue, do you go once a week with your Hbig? How much do you go? How many units do you go? So it's a bit hit and miss, but you continue the antivirals and check your surface antigen. And if your surface antigen remains negative and your titers are above 100, I would maintain that for maybe 2 to 3 months and then switch over to the antivirals after that.
Sukanya ma'am, any comments on this?
I think from Asia Pacific, the subcontinent, HBIG is very rarely being used. But since this patient was viremic at transplant, I would give him HBIG for maybe a year to keep anti-HBs levels at more than 100, and then antivirals forever.
So our plan is to keep immunoglobulins 1000 units monthly once to keep at least for 1 year, along with to continue antivirals. So second question, how long to continue antivirals in post-liver transplant setting and how to monitor in these cases?
You need to continue it.
Yes.
You just need to continue it. You could monitor the HBsAg yearly.
Okay.
It's every 3 months for first year and then yearly. And then if you're vaccinating the patient after a year, you could check the anti-HBs levels also. But then they have, there are periods, transplant patients, there are periods when they are HBsAg negative, and then that alternates with periods where they are positive. So it's a very fluid situation. I don't think any of us would like to stop antiviral even if the patient is HBsAg negative.
Any comments, sir?
Yeah, at the moment, I just practice continuous antivirals, but I'm aware of studies, particularly from the Oriental countries, where after a few years post-transplant, if your HBsAg is persistently negative, then you could consider, and if your immunosuppression has come down to a lowish level, if your core antibody is negative, you could consider vaccinating these patients. And if you're able to build up their anti-HBs titers, a few years down the line, you could consider getting the patients off antivirals. I've been able to do this for a couple of patients, but that was serendipity because the patients were complaining about severe muscle pains with tenofovir, and so they were reluctant to continue with that, and they had a bit of renal dysfunction. They happened to slowly try this on these patients and take it off, but I practice just continuous antivirals.
So it's a last question. In patients, routinely sometimes we used to see reactivation of hepatitis B or acute liver failure maybe due to hepatitis B. So we were preparing for liver transplant. So these cases, how to prepare for pre-op and intra-op and post-op? Sachin sir, is any comment on this?
In this scenario, means if they are for living donor, we will definitely give 1 shot of vaccine to the donor, and then definitely these patients will be started on dual antivirals, and depending on level of HBV DNA, they will be treated with intraoperatively. We are a follower of a low dose immunoglobulin in such situations, and even on occasions we don't even give immunoglobulins.
Any comments, sir? Sukanya ma'am. In these cases, reactivation of hepatitis B, if DNA is very high, is waiting for going for transplant, LDLT.
I think if patient is in ALF, there is a donor available, whatever, regardless of the viral load, start the antivirals and then take the patient up for transplant. Since it is ALF due to hepatitis B, a non-immunocompromised patient would have a good chance of becoming HBsAg negative, but this patient may not become. Health will need to be continued on antivirals.
Sir, any comments, sir?
Just digressing a little bit, but I think a lot of healthcare professionals who are not adequately vaccinated against hepatitis B. I'm sure some of them in this hall would not know what their anti-HBs titers are. So I think, and if you're a surgeon, you're handling a patient with ACLF, you're going to have very high viral loads. So you're better off checking your vaccination status as well.
So ideally in patients with hepatitis B, the DNA levels should be undetectable levels before transplant, but it might be depending upon the case basis because of underlying liver tumors where there is chance of metastasis. These cases we can, in setting of LDLT, their immunoglobulins can be helpful to decrease the post-transplant recurrence of hepatitis B. So thank you, ma'am. Thank you so much. Any questions from audience? Next. Sir.
I wanted to know from any of the audience or the experts here, has anybody encountered a situation where the anti-HBs level is high in post-transplant, more than 100, and still you have a patient who's HBsAg positive?
Yeah, I mean, when it was a couple of decades ago when I was training in hepatology in the West, there was a lot of use of HBIG. Sometimes, the schedule of HBIG also was dependent on a little dependent on the titers and the viral loads. So sometimes you had a situation where the patient was on HBIG, the titers were up and down, and when the titers were down, you had a surface antigen positivity and also a bit of anti-surface antibody. But it's not a situation I've encountered lately, and most, I would say, more than 95% of the times, the transplants we are doing currently are with the highly potent antivirals in a situation where the patient is aviremic. So not something I've faced recently.
Thank you, sir. Thank you, ma'am.
Thank you, panelists. Now we enter into session 3. In the next hour, we'll challenge some of the widely accepted boundaries in transplantation, whether it's expanding criteria for HCC, considering transplantation with an active non-hepatic cancer, or dealing with tumors that invade the portal vein. So these are the areas where opinions diverge sharply, and that's exactly why we are calling this session Controversies and Challenges. So now I call upon the chairpersons, Dr. Venumadhav, Dr. Aditya, Dr. Adit Mishra, and Dr. Naeem, sir. There's a small announcement. We are running 1 hour late, so please kindly stick to the timeline. Thank you. First talk is by Prashant sir on hepatocellular carcinoma beyond UCSF criteria. Over to you, sir.
So thank you very much, chairperson, sirs, ladies and gentlemen. I was told it will be 10 minutes plus 5 minutes of discussion, so I'll try to stick to that. So I've been asked to speak on liver transplant for HCC beyond UCSF criteria, and of course this would come under the controversies and challenges heading of this conference. What I tried to address today is I tried to go into and tell you how we are managing patients today with HCC in an era of transplant oncology. This is how we are thinking of patients today. And in this, there are two aspects that I still would like to stress on. One is to still say that what is old is gold, and second, to look at what is new and what has evolved over a period of time. Now, what I think still remains, or old is still gold, is that the only curative treatment for HCC beyond very early stage or some early stage tumors which can be managed by the intervention radiologist is surgery. And that surgery can either be resection or liver transplantation. And therefore, when you look at a patient with HCC, the goal should define your means. So you're looking at a curative treatment and you're looking at an intention to treat sort of curative treatment to take them to surgery. The second aspect is that liver transplant is usually the best option in patients with HCC. Why is that? It's because when you have a cancer, the only thing that you're looking for is an R0 resection. And in HCC, more often than not, you're going to have multicentric disease. So although you believe before transplant that these may be within UCSF patients, on pathology, there are actually many more who are beyond UCSF. And therefore, if you want to get an oncologically curative surgery in these patients, the only option probably is a transplant. So if you look at before 2022, this is the BCLC staging system that we were using for more than 2 decades. Transplant and resection were completely out of this beyond UCSF patients. That means intermediate stage and advanced stage. And we were looking at only palliative treatment in terms of TACE and sorafenib with a 3-year survival of 10 to 40% in these patients. However, you look at the 2022 update, and this is for the first time that transplant comes into the domain for intermediate stage HCC. And why has that come and how has that evolved? We all know these criteria, the Milan and UCSF criteria, and we have all been following it, and we know they are the best criteria. However, there have been multiple series, both in the DDLT as well as in the LDLT setting, where these criteria have been expanded. And when you expand these criteria, they were found to give outcomes which are comparable to Milan. Especially in the Asian countries where DDLT is not very frequent, it was the LDLT centers that expanded these criteria, and the main impetus now was on no extrahepatic disease, no gross vascular invasion, and not so much on number and size. And what was important was the use of tumor markers to tell you about tumor biology. And therefore, mantra number 3 is we now know that tumor biology is the key. And it's not just size and numbers, and you'll see that in all the criteria across the world, this is what has been incorporated. And that's where BCLC 2022 tells you that you can actually go to extended liver criteria, transplant criteria, and what you use primarily there is the size and the alpha-fetoprotein or tumor biology in other words. There is another aspect in BCLC 2022, and that is about stage migration. What does that tell you? It tells you that if you have a tumor which is beyond your criteria, and you are able to successfully downstage these tumors, you can actually get them into your transplant criteria and go ahead and transplant them. So this is the UNOS protocol now. It was initially the UCSF downstaging protocol. This is now incorporated by the whole of UNOS. And if you are able to downstage these patients and get them into your acceptable criteria, you can get a 5-year survival of more than 70% in these patients. This UNOS downstaging criteria has now been even further expanded, and this is what is called as the all-comers criteria. This is through what is known as the Merit LT Consortium, and this was published in 2025, August, in hepatology. And you will see in this group also, if you have a patient who is beyond all criteria, that means he's got large number of tumors with large sizes, and he even has portal vein tumor thrombosis, and you were able to downstage these patients. About 63% of these patients were downstage, and you look at the 5-year survival, overall survival, as well as the recurrence-free survival in these patients, it is considerably high if you were to downstage these patients. So that means any patient, if you are able to successfully downstage and bring him into criteria, then you can get good results in these patients. And the salient points of this publication that has just come out in hepatology is that in these patients, probably TARE is better as compared to TACE. Number 2, if the all-comers can actually be brought down by downstaging into acceptable criteria, you get an overall survival of more than 70%. And who are the best people for these all-comer criteria? It is patients who have a sum of tumor number and largest tumor diameter less than 12. You exclude those patients who have an alpha-fetoprotein of more than 100, and exclude those patients who are Child's B and C. So in all comers, if you have a Child's A patient with a low alpha-fetoprotein and sum of tumor number and largest diameter less than 12, if you are able to downstage them, you're going to get very good long-term results. And it is this concept that we have imbibed for many years now, and we published this in 2021, where we were actually able to divide patients with HCC based on a competing risk regression model into low risk, moderate risk, and high risk. And these patients had a recurrence of 9%, 25%, and 46%, and this was based upon 3: alpha-fetoprotein, UCSF, and FDG18 PET. And this is the algorithm that we now follow. Based on AFP, UCSF, and FDG18 PET, if you have a low-risk individual, that means he has no risk factors, or he has only one of the risk factors, then you go for upfront living donor liver transplant. If you have a moderate risk individual, that means you have 2 risk factors which are present, you would downstage them if feasible. And in this, we prefer more and more TARE as compared to TACE. If he's high risk, no way you can transplant this patient. You need to downstage him, bring him into the low risk category, and only then go ahead and transplant these patients. We have also used immune checkpoint inhibitors. I cannot finish my talk today without talking about immune checkpoint because these are the new kids on the block. And in fact, there have been series now where you have used immune checkpoint inhibitors for all comers to bring them into criteria and then transplant them. And this is something we incorporated in these ILTS guidelines, the consensus guidelines that we published in 2020, where we said that now we are moving towards a composite criteria of tumor biology and response to neoadjuvant treatment and not just UCSF criteria or size and number criteria. We also said that the selection criteria can be slightly different in LDLT as compared to DDLT, but you should have an overall survival of more than 60% at 5 years if you're thinking of expanding your criteria. Inaugural, we've been a part of this, many of us in the audience here, and Inaugural also now has incorporated this where we have divided this is the Puri 3 recommendations which we recently published, intermediate stage divided into B1, B2, B3, and B1 are those extended LT criteria patients who can be downstaged and taken up for transplantation. So mantra number 4 is that stage migration is an actual possibility with downstaging therapy, and if you downstage patients and transplant them, you're going to get excellent long-term outcomes. Let's come to the advanced stage. And if you look even at the BCLC update of 2022, this advanced stage will include both patients who have portal vein thrombosis, tumor thrombosis, and also patients who have extrahepatic disease, and they are clubbed under one single heading of advanced stage disease. Now we all know that 10 to 40% of patients with HCC will present to you with a portal vein tumor thrombosis. And as I said, both of them, whether they have portal vein tumor thrombosis without any extrahepatic disease or they have a combination of both, are clubbed under one heading. Everyone talks about giving them systemic therapy, and they talk about more than 2 years survival, and we all know that this is untrue. The median overall survival in these patients remains very poor, 5 to 19 months, and the time to tumor progression is only around 4.1 months. So the first aspect I think we need to look at is that you cannot club together patients who have only portal vein tumor thrombosis without systemic disease along with patients who have systemic disease. I would prefer to call them as locally advanced hepatocellular carcinoma if they have only portal vein tumor thrombus and they do not have extrahepatic disease. So that's what we did in Inaugural also. We classified stage C into C1 and C2. C1 is portal vein invasion without any extrahepatic spread, whereas C2 is if you have extrahepatic spread. And in C1 we said that you can do things beyond systemic therapy alone. So if I look only at this population, locally advanced HCC with portal vein tumor thrombosis, this is something again we published in 2022. At that point of time, we had only 25 patients with portal vein tumor thrombosis whom we had downstaged using a combination of TARE and SBRT, and we were able to completely take care of the portal vein tumor thrombus and then transplant them. And we were able to get an overall survival of more than 60% in these patients. This is just an example. This is before SBRT. You will see that there is an FDG18 avid right portal vein tumor thrombus. This is post SBRT and before transplant. Similarly, you have a tumor there on the left side, again completely taken care of with SBRT. And then you have a combination of TARE and SBRT. In fact, this is a patient who has a VP4, a main portal vein tumor thrombus. This patient we treated with a combination of TARE and SBRT. We waited for a period of about 1 year in this patient post downstaging. He was transplanted in 2017. We are in 2025 today, and he is alive and disease-free at present. So this is how TARE and SBRT could completely take care of the portal vein tumor thrombus, and then we went ahead and transplanted him. This is updated, but this is updated March 2024. We had 66 patients at that point of time, downstaged using TARE or TACE with or without SBRT. A mean follow-up of 36 months in these patients after downstaging. And you will see there overall survival of 57% at 5 years, 61% recurrence-free survival at 5 years. We had 15 long-term survivors, more than 3 years, and 7 of them were surviving more than 5 years after transplant post-downstaging with portal vein tumor thrombosis. We had 9 recurrences, which was about 20%. 17 of them died, 5 post-op, 4 due to recurrence, and 63% of patients were alive without recurrence at last follow-up. So if you compare a 3-year survival of 10% versus a 5-year survival of 57%, you will see how much transplant benefit these patients had if they were downstaged and they had a transplant. And we were probably the ones who started off, but now you have several series that have published this. And again, I've put it for want of time. I'm not going to go into details of this series, but this is there in a recent review that we published in the Journal of Hepatobiliary Pancreatic Surgery. There are some caveats though. You start with 100 patients with portal vein tumor thrombosis and you try to downstage them and take them to a transplant, you will be able to do it only in 50. So there's a 50% success rate that you will actually be able to take them to transplant. Number 2, your liver function does determine whether you're able to give these downstaging therapies. So you need a good CTPA patient with good amount of non-tumoral volume if you want to give this particular treatment. The third aspect is you have to adequately wait after downstaging to make sure that the chances of recurrence are low. And how effectively you deliver the downstaging therapy is what matters. It needs to be done by an expert intervention radiologist and radiation oncologist, and only then you will actually get the effectiveness. Another point that I have not put there is if you have hepatic vein tumor thrombus, along with the portal vein tumor thrombus, it's a completely different ballgame. Having hepatic vein tumor thrombosis is a bad prognostic factor and you will have a bad outcome with high recurrences. Again, immunotherapy has been used to downstage these patients, and we have now transplanted 6 patients post combination of immunotherapy and TARE or SBRT and had good outcomes in these patients as well. Again, for want of time, I'm not going to go into details of this, but these are all recent publications that we made on this particular aspect, and those interested can go and read these publications. The last 2 slides that I have are talking about transplant benefit, the concept of transplant benefit in locally advanced HCC. And in simple terms, transplant benefit is the gain offered by transplant in comparison to best alternative therapy. That is survival after LT minus survival with best alternative therapy. So if we were to employ that in our own population, we found that in the low risk group, just at 3 years, we had a 27-month transplant benefit. At 60 months, that is at 5 years, we had a 42-month transplant benefit. And even in high-risk group, we had a 25-month benefit of transplant in patients who had multinodular HCC beyond UCSF criteria. And for HCC with portal vein tumor thrombosis, we had a 23-month transplant benefit that means 2-year transplant benefit even at 3 years. So if you look at this, actually the highest survival benefit in patients with HCC is actually in those patients who have advanced HCC as compared to the early HCC. There is a cost of expanding the criteria. Recurrence rate is going to be slightly higher, about 10 to 15% higher, but you are going to give them a huge benefit as compared to just palliative therapy with a TACE. So to conclude, ladies and gentlemen, I think that in a day and age of transplant oncology, we cannot make rules for every single patient. There cannot be one rule for every patient. We have to sit together, all of us who are involved in the care of those patients, in a tumor board, decide what is best for that particular individual and take a decision based on that. Thank you very much for your patient listening.
Thanks, Prashant. Good, nice talk. Just wanted to know, most of your patients with portal vein tumor thrombus, they were VP2 and VP3. Only 3 patients had VP4. So what was the outcome in those patients, and what would you recommend for these kind of patients? Like we should routinely do SBRT and tear and take up these patients, and what are your criteria?
So thanks for that question. So I think that the proportion of VP2, VP3 and VP4 itself tell you that these patients are very difficult to downstage and actually take to a transplant. So the chances of downstaging these patients with VP4 tumor thrombus are much lower as compared to those where you have VP2 or VP3. As I said, in that one patient whom we had transplanted, in most of our VP4 patients, the waiting period has been almost 6 months to 1 year after actually downstaging these patients, because you need to look how the natural biology of the tumor is progressing. So that waiting period is absolutely essential. But after a prolonged waiting period post downstaging, if you find that the tumor thrombus is inactive on FDG18 PET as well as on a triphasic CT, you have tumor markers which have come down and you have a very good delta AFP. That means the first AFP versus the last AFP. And you have had a good waiting period. I think they deserve a transplant. But the chances are lower that you will be able to downstage them and maintain them there. But in those selected few patients with a good tumor biology, you should transplant them. In all these cases of VP3 and VP4, now we again follow a rule that in order to make sure that you are going beyond, that means proximal to the portal vein tumor thrombus, most of these patients we would put in an extension graft from the SMV-SV confluence as a surgical procedure to make sure that you are taking a good margin beyond this particular tumor thrombus before you actually transplant these patients.
Right. And you said you have done about 6 patients after immunotherapy.
Yes.
Right. So you use CTLA4 antagonist along with PD-L1 inhibitors, or you just use PD-L1 inhibitors, atezolizumab with basis?
So we've used in these patients a combination of local ablative therapy along with systemic therapy. So in all these patients, the use of systemic therapy has been primarily atezobev, and the local therapy has been either a combination of TARE SBRT, or it has been TARE alone, or it has been TACE. Again, the important point in these patients is these patients have been on therapy for 2 years and have shown evidence that there is no extrahepatic disease and there is no progression of disease. So they've had stable disease or downstage disease, and only then we have transplanted them with a very prolonged waiting period. So I would say probably maybe around 100 patients have received immunotherapy. I think the last time that our hepatologist looked at it with HCC, but out of that we've transplanted only 6. So that means we've really selectively chosen, we've been very, very selective in choosing these patients.
So out of these 6 patients, any of them had TARE also, or only TACE or SBRT?
Did they have, sorry?
TARE procedure along
Yes,
with
yes,
it.
I said TARE or TARE plus SBRT, or they had TACE plus SBRT along with immunotherapy.
Hi Prashant, nice talk. Regarding hepatic vein thrombus, how is your approach different in this patient? Do you still, with portal vein tumor thrombosis, how is it different? Because it's a systemic disease, it's more of a systemic once hepatic veins is there.
Yeah, so I said that again, that one of the caveats is presence of venous thrombosis, hepatic vein tumor thrombus. And I think these are completely different patients. Patients with portal vein tumor thrombus are different from those who have both. Hepatic vein tumor thrombus is closer to systemic disease as compared to portal vein tumor thrombus, I feel. And those have been our results. So initially we did transplant some with very good response to the HVTT as well. But then many of them had very early recurrence. So now we are very selective. I think over the last 2.5, 3 years, we've transplanted probably 2 patients who had hepatic vein tumor thrombus in the right hepatic vein. Again, completely taken care of with TARE SBRT, downward tumor markers, had very stable or downstage disease, waited for around 6 months, and after that we've transplanted. But we are very, very careful about transplanting patients with HVTT. I don't think they are the same group of patients. They are very different.
What is the waiting time for this portal vein thrombus patients after this neoadjuvant therapy?
So I think again it depends upon your level and grade of thrombosis, VP1, VP2, VP3, VP4. VP1, VP2 would be more of segmental portal vein tumor thrombus. So in these patients, we've waited for a period of about 6 weeks after the complete downstaging therapy has been done. In VP3, we have waited for at least a period of 3 months, because once you've given the therapy, you've done scans at 6 or 8 weeks and then again at around 12 weeks, and then you have decided whether you can go ahead with transplanting these patients if it is completely naive. At the same time, in VP3, we have had instances where if there is a residual portal vein tumor thrombus, we have again done SBRT to completely take care of that tumor thrombus. So there has been repeated radiotherapy being done to make sure that there is completely non-arterial enhancing and FDG non-avid tumor thrombus before progressing. So the waiting period has been minimum of 3 months from the time of initiation of the downstaging therapy.
Any more
Thank you,
questions?
Prashant. I think you just once again shown why you are the go-to man for HCC. I just have one, if the patient is stable, yeah, we can put them through all these locoregional therapies and therapies. The problem, the most tricky problem we have is a patient who's got child C cirrhosis, who is not ready for any, who is not fit for any local therapy, and they have this tumor, maybe VP1, VP2. So what is your, how do you go about managing pain? Because if you're talking about transplant benefit, definitely they'll be benefited by transplantation over, palliative care.
Yep.
But how do you do that in your unit?
So, in the very early days, I think in 2014 or 15, I presented a paper from our group where we had transplanted patients with VP1 and VP2 tumor thrombus. We had 13 patients like that whom we had transplanted without any sort of therapy. Why did we transplant them? Because they were so sick, exactly the scenario that you are telling us. Patient would have died of liver failure, and there was no other option for those patients to save those patients. So we transplanted them, went ahead and transplanted them. Interestingly, we found a 3-year survival of 57% in them, overall survival of 57% without doing any sort of therapy. So I think I also put it in that algorithm of mine that if feasible, you can downstage patients with moderate risk. Why is it not feasible in them? Those patients who have more than 3 bilirubin, those who have child C cirrhosis, who cannot undergo either a TACE or an SBRT or a TARE. So the risk of recurrence there is 25% in our study. So I think if you are pushed to the line there are other things that you have to employ when you are doing this particular thing. Number one, first of all, you would, during your surgery, employ techniques that have been shown by groups like ASAN to be useful. For example, completely divide the porta first, don't mobilize the liver, and mobilize the liver only after complete division of the porta, and they have shown very significant benefit in recurrence in this, if this particular thing is done. So porta division first, before mobilization. The second thing is post-operative period. So in the post-operative period, very early switch to mTOR inhibitors with reduced tacrolimus. I think that is very important. Don't give them too much immunosuppression. Number 3 comes the role of prophylactic use of, say, lenvatinib. And I think till today, there is no literature or there is no published study, and I don't think they're going to have it in the future also, which tells you that you should prophylactically use lenvatinib in these patients post-operatively. What you can do is you can do increased surveillance and catch the recurrence early. So instead of doing a 6-monthly CT scan in these patients, we do a 3-monthly CT scan, which may be either a PET or it may be a CT triphasic, along with tumor markers, and catch it early. Because in our another paper, we have shown in 100 recurrences, if you were to catch these patients early and treat them with a multimodality treatment, you can get longer survivals in them also. So I think when you are completely lost at options, these are the things that you can follow in these patients. Yes, I would consider transplant if they are going to die of liver failure and they have a tumor which is with a VP1, VP2. I would consider VP3, VP4 completely differently. VP3, VP4, I think we would not do it.
Hey, can I make a quick comment?
Yeah,
hey, how are you? Abhishek Mathur, just to sort of preface my comment, my context comes from working in the US for the last 8 years. But I think your last point is really important about, which goes into defining success. As you mentioned, like your recurrence is going to be slightly higher, your survival is going to be slightly lower. And defining success is important for, for the institution and for the, the entire community. Because part of the challenge in the US is you're competing against for deceased donor organs as opposed to LDs. So you've got to have success and recurrence rates that result in appropriate utilization. But, sorry. But I think this is really important because you have to talk about this more so that we can redefine success as a community so this is more normalized everywhere, even where DDLT is more common.
Sure, sure. Thank you.
Just one last question. What was your average cooling off period in these 6 patients after stopping immunotherapy and transplant? And
So
any severe rejection you had?
Yeah. So I think we did a ILTS consensus conference last year in Valencia, where we looked at this, because now immunotherapy is going to be used more and more. So it is now proven, and there are recent studies now, that you have to wait for 2 half-lives after the immunotherapy has been completed before you actually go for transplant. So 2 half-lives would translate into around 6 weeks. So I would say you have to wait for a period of 2 months before you actually go ahead with the transplant. So that's what we have followed, and there is very good data now to show that, 2 half-lives of the drug is what you have to wait for, and generally it comes down to around 45 to 60 days. So 2 months waiting after the immunotherapy is completed, last dose of Atezobev.
No severe rejection post-operative?
No, we've not had severe rejection at all. I think most of the studies that were published were with nivolumab mainly, and with Atezobev, with that cooling period and waiting period that we are talking about, the rejection or the, the graft necrosis that was all defined in the UR, we've not had that.
Thanks, Prashant.
Okay. Thank you.
Thank you, sir. Now we have Soin sir for the next talk, that is liver transplantation and setting of active non-liver malignancy.
Thank you very much for inviting me, Dr. Srinivas Reddy and team. So I'm going to talk about liver transplantation in a setting of active non-liver malignancy. Can this be sorted out? It was okay earlier, right? It will be connected to This is for the control. Hello. Finally, yeah. So basically, when you decide on accepting a patient with pre-existing extrahepatic malignancy that has existed before, treated before, or just been discovered during liver transplant evaluation, there are several factors that you have to consider, and they could be associated with organ failure. This is from the AST and ASTS consensus opinion that was published in 2021. So they were talking about all of solid organ transplantation and malignancies. So it depends on organ failure. That means whether it's going to be a life-saving transplant or is there an alternative like a left ventricular assist device for the heart or dialysis for the kidney. But for liver transplantation, there is no such alternative. So then, of course, patient factors, that means whether you will improve their quality of life or it will be life-saving for them. and whether they have any modifiable or non-modifiable cancer risk factors. And then factors associated with the cancer, which means that is there favorable response to previous treatment or known favorable response to simple excisional surgery? What's the natural history of that cancer? And if the treatment has been done, then the time elapsed since treatment, and so on. And then, of course, there are immunosuppression factors, which means does specific types of immunosuppression influence recurrence rates in that cancer? So, so these guys put forward these guidelines saying that for selected tumors like breast, renal cell cancer, thyroid, bladder, it's perfectly okay to transplant them even while there is early disease, that's T1, in some cases T2, as long as that is treated. And while the consensus does not really specify that treatment can be done simultaneously, but those doing living donor liver transplantation will know that simultaneous treatment of these cancers in the early stage works very well, both in terms of saving the patient's life from liver failure or whatever the indication for transplant is, and also treating the cancer. So specifically for breast cancer, if you have DCIS stage 1, there is no wait after treatment. If it is stage 2 and 3, then 1 to 2 years or 3 to 5 years is recommended. And of course, none of the advanced cancers with metastasis, one should consider a transplant. So we're talking about non-metastatic, locally, either early or advanced cancer. Now, colon, generally people have shied away from in transplanting them early. So if you have stage 1, then you're looking at 1-year interval between curative treatment and transplant. Stage 2, T3 stage, 2 years, and stage 3, that's T4, is 3 to 5 years, if at all. But you know, what's not dealt with here is if you have a colonoscopy done on the patient pre-operatively, pre-transplant for whatever reason, and you discover a polyp, which turns out to have a cancer, which is not invading the muscularis, then what do? You just excise the polyp and wait for a year? Possibly not. I would just go ahead with transplant. So there are some gray areas even in colorectal cancer. Now in rectal cancer, if you have stage 1, which has been resected, 1-year wait is recommended. In renal cell cancer, if you have T1A or T1B with Fuhrman grade 1 or 2, that's considered good prognosis, good biology, early cancer, so there is no wait needed as long as you've treated that cancer. But for higher Fuhrman grades, or T1B, T2, there is 1 to 2 to more than 2 years of wait recommended. In bladder cancer, again, low, intermediate risk, you wait up to 6 months, and there is 2 years wait for a high-risk cancer. For thyroid, which is T1, T2 cured, that means thyroidectomy is done, with or without lymph node dissection, then you can actually go ahead and do it in 6 months, is what the recommendation is. Now, for prostate and gynecologic cancers, for very low risk and low risk cancers, there is no wait recommended, and surveillance is acceptable. For high-risk cancers, there are nomograms which tell you the probability of survival, and you use them, and then you make your informed clinical decision whether to go ahead with a life-saving transplant, considering how long these patients are going to live. And again, Prashant's concept of transplant benefit really comes into play here as well. Although the benefit is now to be counted over treatment for an extrahepatic malignancy rather than a non-transplant treatment of a cancer of the liver. And then gynecologic cancers, endometrial cancer, again, low risk, no wait at all. And intermediate risk, 2 to 3 years wait, and high risk, 3 to 5 years. And very high risk, you exclude. Now, what does EASL say? EASL says that the basic principles are that you obviously have to do a multidisciplinary team meeting. That's a given anyway for all cancers. You capture the tumor type, the histology, the exact stage, the known treatments, the response to treatments, the remission duration. So all these have to be factored in as per the cartoon I showed you in the first slide, all the factors that influence selection of these patients. So you consider all those in your MBT. And then you do a balanced projection of the liver transplant benefit versus recurrence risk, which is what I just said. And there are actually AI models developed on this that you put in all the factors and then you see what the expected survival is. And then you plan therapy if there's a recurrence post-transplant. So you have to do all that before selecting the patient and accepting the patient for a transplant. And of course, they do not recommend any transplant for active malignancies, which is understood. We would not transplant any patient with an active malignancy which is not already treated or simultaneously treated. So there is no specific weight for very low-grade cancers with negligible recurrence risk according to the EASL guidelines, like a superficial non-melanoma skin cancer, in situ breast cancer, superficial bladder cancer, similar to the ASTS and AST recommendations, and prostate cancer, Gleason less than 6, incidental renal tumor less than 1 centimeters. Now, they don't separate Furman grades of tumors, renal tumors. And they have advised to look at modeled cure probabilities after solid organ transplantation. And when lung and breast are compared to colorectal, testicular, and thyroid, basically the system should get more permissive for colorectal cancer, thyroid, and testicular cancer compared to lung and breast, because the probability of those cancers in an advanced stage recurring after transplant are higher. So what is our experience? We've transplanted 20 patients with extrahepatic malignancies out of a total of nearly 5,000. And of the breakup was hematological malignancies. There were 5, Langerhans cell histiocytosis 2, leukemia 1, multiple myeloma 1, Hodgkin's lymphoma 1. All of these were previously treated, at least a year or more prior to transplant. Renal cell cancer, we had 4 cases. 2 of them underwent simultaneous. So we did 15 simultaneous extrahepatic malignancy curative surgeries along with living donor liver transplants. 4 were for renal cell cancer, 2 radical nephrectomies and 2 partial nephrectomies. Obviously, the kidney specialists, our colleagues, did that. And then breast cancer, we did 4 surgeries, 3 wide local excision, 1 mastectomy. Thyroid cancer, total thyroidectomy, 5 cases. The last one was done last week. Endometrial cancer, 1. So this was a patient who had total abdominal hysterectomy and bilateral salpingo-oophorectomy along with the transplant. And then squamous cell cancer, wide local excision 1. So our protocol is you accept these patients if they are curable at or before transplantation or in complete remission. Simple rule. Not always practical to biopsy these patients, but you should biopsy the extrahepatic malignancy if possible, because then you can understand the grade and also consider tumor biology. We are especially getting into that now because we've had 1 renal cell carcinoma recur, although long term. So what are the outcomes? We lost 1 patient early and 1 died 11 months later from a cardiac cause. 1 is alive with late RCC recurrence at 5 years, and 18 out of 20 are alive at a mean follow-up of 52 months. 90% of them are alive. So obviously, if these guys were denied a transplant, they would have all been dead at this time. So the conclusion is that strict selection and simultaneous curative surgery enables safe living donor liver transplantation in patients with prior or pre-transplant extrahepatic malignancy. What's the experience elsewhere? There are small case series, one by Desai et al. Over about 10 years ago. So they had 16 odd cases with lymphoma 4, breast 3, and 1 each of the others listed there. And then cancer recurrence was seen, 1 in melanoma, 1 in leiomyosarcoma. Leiomyosarcoma is a bad tumor to do a transplant in. I would not touch that patient. And then they said that you could achieve good outcomes with proper selection and good tumor biology, which is correct. And then another series of 14 where 9 were detected during evaluation and 5 were known before. And they all did surgeries prior to transplant. The oncologic surgeries were done prior to transplant, average about 70 days prior. And they had 100% 5-year survival. So again, they demonstrated feasibility of this approach with rigorous selection. And there is this small series of 3 cases of renal cell cancer who also had simultaneous nephrectomy and good results, but they also selected early tumors. So to summarize, a mere diagnosis of extrahepatic malignancy does not contraindicate liver transplantation, but advanced metastatic cancer is a contraindication. So according to ASTS guidelines, stage and cancer-specific waiting intervals have to be devised and followed. So early cancers of thyroid, breast, renal, that's kidneys, bladder, prostate, and uterus, no wait is needed. Later stages, if they're cured, would generally say 1 to 2 years or more remission periods before transplant. EASL says the same thing, cancer-specific, no-wait categories, plus they would do cure probability modeling. We and others have found excellent outcomes with strict selection on above guidelines, plus documented remission in cases they've been treated before, or curative simultaneous surgery in case they've been discovered during liver transplant evaluation. And one always needs to individualize by biology, kinetics, remission duration, plan the immunosuppression, plan the tumor surveillance, and also plan the post-recurrence therapy should they recur after transplantation. This presentation was prepared by AI and me together. Thank you.
Thank you, Dr. Swain. How do you deal patients who are decompensated cirrhosis being evaluated for transplant and then simultaneously you discover...
Sorry, I didn't get the first part.
Patients who have decompensated cirrhosis who are being evaluated for liver transplant.
Patients who have?
Decompensated cirrhosis.
Decompensated cirrhosis, yeah.
Who are being evaluated for transplant, and then you have a breast, thyroid, or endometrial or colonic malignancy. And these patients cannot be subjected to surgery, breast surgery or colonic surgery, and then you have, they can't even be given chemotherapy. So would you do in the same setting both transplant and...
So, I mean, obviously, if they have decompensated cirrhosis, they will not tolerate major surgery under general anesthesia. That's understood, which is why majority of our patients in this situation have had simultaneous curative surgeries. But if you're thinking colorectal, then I think you're in a difficult situation, especially if it's a big lesion, if it's a, established muscularis invasion or a T2 or a more lesion with nodes, then you're really in trouble. Then you can't really be treating. We would not like to do intestinal or colorectal surgery along with transplantation. But like I've shown you, we've done breast, thyroid, and kidneys and skin. So that can be done along with transplantation.
Sir, for how many colorectal malignancies did you manage?
We don't have any colorectal in our series, no.
No, nothing. No.
We have done 2 cases where we excised polyps. One later turned out to have cancer, but we didn't actually know that at the time of doing the transplant.
I think colonic tumors are different from rectal tumors. So colonic maybe we can do in a same setting, just a resection and anastomosis. But tumors which require anti-resection or low anti-resection probably should...
I don't know, I can't hear your question properly. There's some muffling of the...
I said colonic tumors are different from rectal tumors. Colonic tumors probably you can deal in the same setting, but rectal tumors which require anterior resection or low anterior resection, probably they should not be dealt with.
So you're saying colon and rectal tumors are different?
Colonic are different from rectal.
Colonic is more?
Are different from rectal.
Yes, of course they are different.
Yeah,
to
so
rectal.
colonic may be dealt with in the same setting along with transplant, but rectal tumors which require anterior resection or low anterior resection, they are different.
Yeah. So there is a difference, and I think that that's what I said in the guidelines. That's what the ASTS guidelines also say, that you generally have to wait a year after treating colonic cancer. And if you're in a situation where where the recipient is not going to live for that much time, then I think that's a decision that you have to make at that time. But I don't think it's worth saving someone's life to live a year, but it's certainly worth saving their life to live 3 to 5 years. But that's, it's not something that you and I can decide. You have to talk to the family and decide. But we haven't done any colorectal cases.
One question, sir. Suppose there is a young patient, relatively young patient, less than 40 years patient, decompensated CLT, and there is a simultaneous...
Compensated or decompensated?
Decompensated CLD. He needs transplant, obviously. And there is a simultaneous tumor like colon or renal. Simultaneous surgery is not possible, as you said, because especially colonic tumors. So is there any possibility to give a chance, do the transplant, don't touch the tumor? Once the patient comes out of, like after 2-3 weeks, is it possible? A theoretical question. Considering the age of the patient.
So yes, that is possible. We have discussed this option for kidney and thyroid cancers in the cases that we actually did along with the transplant. We've discussed these with the kidney surgeon and the thyroid surgeon, and they have also given that option that once you do the liver transplant, we can operate on them afterwards, 4 weeks, 6 weeks later. Colon, we've not really considered. I've told you this before. But I think that somehow we rationalize that because you give significant amount of immunosuppression in the first month, then you may already do some of the harm that is immunosuppression related by waiting for a month to treat these tumors. So with that logic, we've gone ahead simultaneously.
Dr. Soin, a really nice, thought-provoking talk.
Hi.
I had a question about the breast cancers, which you're doing concurrently with liver transplant. Say you do the sentinel node biopsy and you find like 3 nodes that are positive, then do you still go ahead with the transplant, or what do you do then?
Well, I think that this hasn't happened to us, but if that were the case, then I guess they would have the lymph node dissection done at the same time and would still go ahead. Yeah.
I see. And then just post-op.
Yeah, I think if the a priori plan was to go ahead with simultaneous surgery, we would stick with the plan.
Thank you, Dr. Soin, and thanks for taking up this challenging talk, actually. Just wanted to say that I did a random survey of some of the units, and a lot of centers are doing this. Thyroids, kidneys, and we've done a colon. So, in fact, we're trying to do like a survey study across all the big centers in the country. Because I'm sure it's happening, but it's not there out in the literature, and this is one area I think we need to look at and maybe create some guidelines on the line of what you suggested in your talk. Thank you.
It'll be interesting to actually put this data into our registry and see where we get.
Yeah. Thank you.
Thank you, sir. Now I call upon, thank you, chairpersons. Now I call upon the panelists for our case presentations. I request Naeem sir to stay back as a panelist. And I welcome Dr. Naveen sir, Dr. Shantan sir, and Sainath sir to come onto the dais. Dr. Naeem sir as a panelist. And after quick case discussion, we'll break for lunch.
Can we just stick to 10 minutes per case so that we can quickly finish off, because a lot of this stuff already been discussed by Prashant and Dr. Soin, so we'll just have the case itself and finished off. Thank you.
Yeah, I got the message that I have to quickly conclude. So in advance, I'm sorry. I'll be running the slides. It has been already been discussed, immunotherapy, cooling period and all. So please bear with me. I will be running now. Okay. So thank you, esteemed panelists. Our index patient is a 55-year male with HCV CLD. He had pulmonary tuberculosis, was treated 10 years ago. And after 5 years, he presented with constitutional symptoms, and on evaluation, his alpha-fetoprotein was more than 50,000. It was child A. On triple phase MR, that was an HCC, large HCC, 10 centimeter HCC involving anterior sector and portal vein tumor thrombosis of right anterior portal vein, right posterior portal vein, and entire main portal vein. As I said, is CLD child A. Okay, this is the arterial phase MRI. I'm not running through the videos. This is the arterial phase involving the portal vein, enhancing tumor thrombus in the portal vein. This is the portal venous phase. So, our challenges are in the background cirrhosis, a large tumor with main portal vein tumor thrombosis, and alpha-fetoprotein above 50,000. So, questions to the panelists. Dr. Sainath, what comes to your mind with such a large tumor, alpha-fetoprotein more than 50,000, and tumor PVTT in main portal vein? What comes to your mind? Is it like curative or palliative?
From a practical point of view, most of these patients end up with palliative care. But again, with the newer drugs, immunotherapy drugs, there is some hope. The reason why I'm saying this is we still don't know what is a perfect marker, who will respond. So you have to treat all them and keep an eye who is the exceptional responder. So, but without that, if you have to look at the hard data, most of these patients, 3/4 of these patients, or more than that, in fact, would end up being palliative.
Okay. Naeem, as a surgeon, when you come across such patient to begin with such a large tumor, what would be your thought process initially?
At the outset, it looks like a very bad tumor. It's a diffuse infiltrative pattern of tumor, the VP4 tumor thrombus, and AFP more than 1 lakh. So first thing comes to my mind is it's probably a metastatic disease. So I would like to rule out a metastatic disease, and probably do a if you're planning anything, then you should also probably do a biopsy to see if it's a poorly differentiated tumor or anything else.
Dr. Naveen, triphasic CT was done, MR was done, PET CT was also done. They said no distant metastasis, alpha-fetoprotein. So do you want to consider any other investigations apart from this at this stage?
I think looking at the MRI and the CT definitely looks like a very infiltrated tumor. So as Naeem says, it's a pretty bad disease. It's a very high chance of metastatic disease. So yes, PET would definitely help us to understand what is going on in terms of extent of the disease. With high AFP, infiltrated disease, VP4, poor prognosis for this patient. In previous days, we would have actually said immunotherapy, especially if the patient has got good performance status, we would have said immunotherapy and wait and watch. But I think now we're talking about downstaging, so we'll probably discuss about it. I think any other investigations probably won't add any more value. I would not do PIVCA here because it's not going to add any more value. So I think we got enough investigations to tell what the stage of the disease is.
Yeah, great. Dr. Shantan, so roll-up biopsy we have discussed, all the investigations have been discussed.
Yes.
So at this stage, when that anti-treatment armamentarium is there, what do you want to consider first?
Yes, now with a well-established diagnosis of hepatocellular carcinoma with VP4 tumor thrombosis, so if you're going for BCLC, if you're saying the inacil modification, it's coming into C1. So still there's a chance of downstaging, so I would definitely consider downstaging followed by the possibility of liver transplantation, saying into the context that he is well preserved and he is in child A. Now, out of the possible options we're given, we are ruling out TACE, we are ruling out currently which are as a second line medications. So coming into possibility of
tear or immunotherapy. There are two issues. Now we deal with the VP4 tumor thrombus and we deal with the liver lesion. Being it the infiltrative lesion, large lesion, possibility of tear followed by decompensations is higher, and the liver reserve is currently unknown. So I would definitely go for starting with the immunotherapy, see how he responds, and add on SBRT for the VP4 tumor thrombosis, and I won't touch the SBRT for the lesion itself currently.
Yeah, thank you. So our medical oncologist, Dr. Sainath, is there. They were treating this patient. Probably they have taken the right decision. Of course, they offered tear also, both immunotherapy and tear, but patient family was not that willing for tear since it is an invasive procedure, and they consulted multiple doctors. So considering this AFP of more than 15, they started immunotherapy as a palliative intent. So,
sorry, sir. Do you do any ICG-15 retention? Indocyanine, because now with the retention, we don't know the quantitative assessment, qualitative assessment. So
okay,
normally
functional status.
Functional status.
Functional
Yes,
studies.
yes, yes.
So as for this patient, for this index patient, it was not performed. Okay. Maybe it can be considered in future. We do functional studies in nuclear medicine.
So only my concern with the large lesion and with infiltrative, with the introduction of tear, if the patient decompensates, then the problem arises. So that is a reason which I was asking.
True. We are doing functional studies for resection patients and as well as for living donors, but not exactly before considering for tear. So coming to the treatment our medical oncologist started, they started with lenvatinib, they gave for 10 days. And by the time the family has decided and they're not willing for tear and both options were given immunotherapy, immunotherapy was started by Dr. Sainath and Dr. Santosh, and they gave 3 cycles. So question to Dr. Sainath, at what stage or after how many cycles you want to reassess for this index patient as well as in general for any other patient?
So generally, I mean, just to add to one of your previous questions, in any patient whom we are trying to do atezolizumab and bevacizumab, we will always look for the varices, because the risk of variceal bleed for a grade 3 varices after bev is very high. So after setting that, assessment will be dependent. Most of the times what we have seen is, I mean, not from the downstaging liver transplant point of view, but if the fall of AFP's fall is good in the first 4 to 6 weeks, it is ideally we do it after 3 cycles. But sometimes the fall is slow, and we do know some segment of these patients take a longer time to respond to immunotherapy. In those patients, preferentially it is 4, but most of the trials have done generally after 2 to 3 cycles. 3 would be ideal.
Okay. So that's what our team did, reassessed after 3 cycles. There was a partial response that was very motivating, and the team continued with the rest of the cycles. So at index presentation, alpha-fetoprotein was more than 50,000, and after 3 cycles, it was again more or less same, but there was some reduction in the size and some reduction in FDG avidity. So continued 3 more cycles of same combination. And after 6 cycles, when they did PET-CT, the tumor has really shrunk, and FDG avidity was also reduced. And there was, of course, faint FDG avidity in the main portal vein, suggested was some viable tumor, probable viable tumor in the main portal vein. You can compare with PET-CT done at 3 cycles and after 6 cycles. So at this time, after 6 cycles, alpha-fetoprotein has nicely come down to 5. And at this point, so my question to Dr. Naeem, so alpha-fetoprotein is normal, almost the intrahepatic tumor has, the metabolic response is complete, but there is a faint FDG avidity in the main portal vein, suggestive of probable viable tumor in the main portal vein. So what do you want to consider now?
Since the tumor has shown a remarkable response, and there is some avidity in the portal vein, I would like to treat the portal vein tumor thrombus with SBRT. So,
Dr. Naveen, what about your comments considering faint avidity in the main portal vein and alpha-fetoprotein is normal? So, do you suggest any loco-regional therapies at this point to target main portal vein?
Yeah. So I think just coming back to the point about the atezolizumab bevacizumab, although the study says 3 cycles, generally we give for 6 cycles and then reassess is what my practice has been. And after 6 cycles as well, we reassess, and then based on the response, we'll continue with the cycles. Now, I think coming to this case here in particular, main portal vein thrombosis, middle portal vein thrombosis is there. So, so what I would suggest here is definitely SBRT, as been discussed, because mind you, this patient has got well preserved. We're looking at curative intent now rather than being just a palliative treatment. So I think definitely SBRT followed by reassessment is what I would also suggest.
So
my only other question is whether we continue with any other TKIs along with it. I probably wouldn't. Just give SBRT and then wait and watch.
That's what, very nice, Dr. Naveen. And our team, at this point, to be honest, actually, since it was very encouraging, we primed the family for probable liver transplant, considering the huge response with immunotherapy after 6 cycles. So at this point, we informed the family that probably we can contemplate for liver transplant. Dr. Srinivas is also here, our hepatologist. We did this when I was in my previous organization. Then we added SBRT to sterilize the main portal vein. So after 6 cycles and after SBRT we did 4 weeks ahead of planned liver transplant. This is the PET CT just before liver transplant. There was complete metabolic response, both intrahepatic tumor and as well as in the main portal vein. And alpha-fetoprotein was consistently less than 2 or 3. So patient, this is the serial PET CTs. The last row is just before the transplant. There was no FDG avidity at all, both in intrahepatic and also in the main portal vein. So, Dr. Naeem, would you like to consider for transplant now? Since the tumor has been completely sterilized, there is a complete metabolic response both in the liver as well as in the main portal vein, and alpha-fetoprotein is also normal.
Yes, because the patient has shown a very good response after immunotherapy and SBRT. Starting with, didn't look like the patient would go for a transplant, but the kind of response he has shown, I think we could offer him transplant after the cooling period.
That was the time, it was like 2.5 years back. So we had to discuss with few centers in Mumbai and Bangalore, Mumbai Global and Bangalore Global had performed 2-3 transplants. We had to discuss with them about the cooling period. Daughter donated and patient underwent uneventful liver transplant. Coming to the interval between the last cycle of immunotherapy and actual transplant was 11 weeks. Dr. Shantan, what about cooling period? Are you okay with this 11 weeks?
Yes, I think previously Dr. Prashant has already informed that we need for 2 half-life of the drug to be eliminated. So that would make up to almost 6 weeks. So there was a meta-analysis in 2022 which showed the average time of 4 weeks. But that was more of nivolumab related, whose half-life is less than the atibeva. So when we see atibeva, half-life is coming up to almost 3 to 4 weeks, so ideal time would be more than 6 weeks. So that's fine.
Yeah, this was the pre-operative CT image just before the transplant. There was complete portal cavernoma, and we put a jump graft to take inflow from the superior mesenteric vein. Post-operatively, he did very well, and he received standard triple regimen immunosuppression. There was no episodes of rejection. So this is the pathology, histopathology specimen. There was radiologically and as well also pathologically, there was a complete tumor response. There was no viable tumor in the specimen. So follow-up, every 3 months, patient underwent either PET CT or CT. Alpha-fetoproteins were consistently less than 3 for the last 2 years. And this is since it was the jump graft, it's a distorted image. I just wanted to show the patency of the jump graft from the superior mesenteric vein. Now we followed for 2 years. It's exactly 2 years now. And alpha-fetoprotein is less than 2 and no recurrence. He's leading normal life. Of course, we had to stent him for biliary stricture. So my question to Dr. Naveen, This was a decision taken by our oncologists, to be honest. They were in the front line in managing this patient till we contemplate transplant. I really congratulate them. This was like 2 years back. After that, many such transplants have happened. So, suppose if you come across such kind of patient, do you want to give the same regimen of ICIs, Beva and Atejo given? Do you also consider the same regimen now, or you want to change?
I think the Atezo and Bevacizumab has become the first-line therapy for most of our HCC patients. So definitely, yes, we have seen similar kind of results with our case series as well, where we're able to downstage them. Of course, to liver transplant to certain people were able to downstage to local regional therapies, we're able to prolong their life. So I think times have changed where we're downstaging, stage migration is definitely possible for these patients. Even for metastatic disease also, for we had patients where we had bone mets as well, we're able to downstage to where we were actually able to do a transplant. So definitely immunotherapy, particularly atezolizumab, definitely has been a wonder drug.
Thank you. My question to Dr. Sainath, as Shantan also said, there are some unfavorable factors to consider for tear, like in this case is an infiltrative tumor, and also if biopsy was done, if it is a poorly differentiated tumor, they may not be responding for tear, and also main portal vein involvement. If it is a necrotic tumor, they won't respond for tear. It's a general consensus like. So my question to Dr. Sainath, what are the predictors of responsibility to immunotherapy? Before starting immunotherapy, are there any subtle factors so that we can happily start immunotherapy instead of tear or TACE?
So now the recommended immunotherapy regimens, apart from Atezo-Bev, which we had 2 years ago, the only regimen, now we are spoiled for choices. We have Durva-Trem and also Nivo-EP. Nivo-EP is awaiting approval in this segment. The first thing is we always look at what is the etiology of the background liver disease. So most of the cases where it is because of the viral, where it is viral cause, they are likely to have a better response with immunotherapy as compared to the NASH. And there is subtle data coming up, when you use a dual checkpoint inhibitor, durvalumab with tremelimumab, they do better. The NASH patients do better with that dual checkpoint inhibitors as compared to Atezo and Bev, which is an angiogenic inhibitor. So these are the subtle considerations we have to take. But when, in the previous talk and what we are seeing, the upcoming data, the systemic analysis, the vitality analysis, what we have seen is there is definitely certain segment of patients where downstaging and transplant can be done, especially with portal vein thrombosis without extrahepatic disease. When we see if it's because of wider etiology, no extrahepatic disease and this thing, the choice would preferably be Atezo-Bev, because most of the transplant post-IO has been with this regimen. We don't know how dual checkpoint inhibitors do, because the risk of graft rejections when you are using a CTLA-4 inhibitor is theoretically high. We need to see how it does. Even after the cooling period, we have to see, because a lot of the CTLA inhibitors might actually take longer time. And most of the experience, is the case series and the retrospective analysis, is with Atezo-Bev. So if it is extrahepatic, no extrahepatic disease, viral etiology, there is a good scope of downstaging, it is Atezo-Bev. If it is NASH or hepatic, extrahepatic disease, where these are the ones who don't do so well, probably even a dual checkpoint inhibitor is also an option.
Yeah, thank you. I hope we got the take-home message. I'm skipping this slide. This was the previous team. When I was in my previous organization, we did this transplant. Let me congratulate all our previous team members. Thank you from Apollo. Thank you. Any questions from audience? Dr. Prashant is a master in HCC from India. No HCC session gets complete without any comment of Dr. Prashant, and also I need some comment of Dr. Srinivas Reddy also.
Raghu, I think they are short on time, so
yeah,
I don't want to make any elaborate comments. Only one comment. Once a metastatic disease, it's a no for liver transplant for me. Even if it is downstaged, even if you would wait for 1 year, I would not transplant the patient who has had metastatic disease already. And for me, a patient who's got an infiltrative tumor, apart from the fact that, if there was less of function and the risk of decompensation from tear, infiltrative tumors per se are bad for tear. The responsiveness of tear in large infiltrative tumors is bad. So I think I won't make elaborate comments more.
Thank you. No, thank you. Thank you, Dr.
This patient was probably lucky. He responded very well. Of course, we can't draw any concern. Dr. Reddy. Yeah.
No, I think this is an excellent case. I wanted Dr. Ravan to present it because it just shows that, times have changed. These are cases, we can't say no to any patient now. There are options that we should try. The patient comes through, that's good. That's good for the patient, that's good for us. I mean, if it doesn't come through, then we tried our best. I think that's what message I wanted to give. Thank you. Thank you.
Thank you, panelists, for all your comments, suggestions. Thank you. Yeah.
Thank you, panelists. We are closing this session as we are running late. We'll now have... Okay, next session we are having by Dr. Prasanna on subacute liver failure with colonic malignancy.
Thank you, sir. So I welcome the panelists again. So our case, 53-year-old female, presented with jaundice for 3 months, fresh blood in the stools on and off. She also had history of treatment for arthritis with tofacitinib and methotrexate for 1 year. She also had jaundice, pedal edema, and ascites. On evaluation, her bilirubin was 20, INR of 1.24, creatinine 0.64, sodium 131, platelets 19,400. She underwent Plex twice. She underwent USG-guided liver biopsy, which showed drug-induced cholestasis with hepatitis. She underwent the routine CT scan, abdomen, which showed thickening in the sigmoid colon. Dr. Naeem, would you evaluate this further? She had a thickening in the sigmoid colon on routine evaluation. Would you evaluate this further? Yeah. So there is a thickening in the sigmoid colon. Should we evaluate this further?
Should we?
Evaluate this further.
Yes, this has to be evaluated with CEA and colonoscopy, full colonoscopy, to see and take a biopsy. We cannot ignore such kind of a thickening.
Yes, sir. We did CEA, and CEA is around 9.04. Also, we did colonoscopy. Colonoscopy showed a growth at 20 centimeter. And biopsy showed moderately differentiated adenocarcinoma. Should we do anything else further now?
We need to stage the disease, so patient would need a PET scan and stage the disease.
Yes, sir. We did PET scan. PET scan showed no metastasis. So we now have a patient with subacute liver failure with coexisting colonic malignancy. Guidelines says that patients with active liver cancer should be excluded from liver transplantation, except those with selected, indolent, or very low-grade cancers. So, Dr. Sainath, what is the 5-year survival for a patient with stage 2 or stage 3 colonic cancer?
So, for a stage 2 and for stage 2, it is definitely more than 80-85%. Yes. And for stage 3, it's somewhere, even the recent IDEA meta-analysis where the trials were done to see whether 3 months adjuvant was 6 month adjuvant. The data showed it was more than 80% in most of the garden variety. In younger patients, it's still around 76 to 78%.
Okay. Dr. Naveen, considering the 5-year survival of more than 60%, what are the treatment options at this stage? Should we palliate or offer transplant? So very good 5-year cancer-specific survival, but she's suffering from subacute liver failure.
So I didn't get why subacute liver failure in this case, sorry.
She has jaundice and she also had encephalopathy.
INR is normal, right?
INR is normal.
There's no ascites.
She underwent Plex twice.
Okay, so and reason for the jaundice, reason for the...
Drug-induced. So the team has decided to go for transplant in this case, and we found that there is a coexisting malignancy.
Okay, so I think first we need to understand a bit more about the liver disease, what is going on, where we stand in terms of the liver disease. Based on that, if there is obviously malignancy, based on liver disease itself will dictate on whether we should go for resection or for the transplant or the palliation. But I think looking at this, probably palliation is what I would think about this at this point of time.
Okay. Dr. Naeem, would you like to differ?
Yeah, with a decompensated disease, I don't think chemotherapy or any form of surgery would help. So I would consider stage the disease and think of transplant along with simultaneous treatment of the tumor or treatment of the tumor just after transplant.
Yes, sir. We also decided to go ahead with transplant. So, Dr. Shantan, what will be the sequence of treatment? The patient is with subacute liver failure, would not tolerate chemotherapy, would not tolerate any major surgery.
So definitely we are ruling out first surgery of the sigmoid colon because of the bad liver.
Yes.
So the other options remaining the sequential, or whether you do transplant followed by the surgery of the colon. If you do the simultaneous transplant and colon resection, the possibility of delayed healing or leakage and sepsis with the contamination of the peritoneum will be higher in terms of colonic resection. So if we have decided to go for the transplant, will be transplant followed by colonic, the third one.
Yes, that's exactly what we did, because simultaneous transplant and colonic resection would risk of leakage and infections in the post-op. So we plan to do transplant followed by colonic resection. Dr. Naveen, would your decision differ if your patient does not have a family donor? Yes.
So if we don't have a family donor?
Yes.
Then obviously the DDLT is the only option then, but...
would you offer a DDLT organ for a patient with a coexisting liver?
That's a difficult choice, to be honest. I know if we would push for LDLT, if there is no LDLT, then I think getting a DDLT will be very difficult for this patient.
Yes. So, Dr. Naeem, is there a role for recipient first and then do a diagnostic laparoscopy before taking the donor if you are planning an LDLT operation?
Not for colonic tumors. I would directly do a laparotomy and do a staging lab after doing a laparotomy.
Yes,
not a diagnostic lab.
Yes, sir. Dr. Sainath, is there a role for mutation testing? Mutation testing, is there a role?
No. I think it's a localized disease.
Yes.
Localized colon cancer. It's always the surgeon first.
So the surgery.
And whatever molecular testing which we do is only to optimize which patient would benefit from an adjuvant or not.
Yes, sir. Thank you. So what we did is, in the first stage, we did ABOi incompatible living donor liver transplantation, A220. There was no desensitization. Left lobe graft, GRWR of 0.92. She had a longer hospital stay because of the subacute liver failure. 3 months she stayed in the hospital. So we did second stage, 6 months after the transplantation, lap sigmoidectomy. Now she is 22 months post-op. She is in follow-up with no recurrence. Summary is that coexisting malignancy need not be an absolute contraindication for transplant. Complete detailed assessment for tumor and potential for cure is necessary. Sequence of treatment depends on urgency and tumor characteristics. Thank you.
Thank you, Prasanna sir, and I thank the panelists. Any comments, please?
Any comments from the audience?
I think everybody is waiting for lunch.
Any immunosuppression you change, sir, for these patients post-op?
No, we gave the standard immunosuppression.
Standard immunosuppression.
Yes.
If it's a right colonic lesion, would you still want to do it stage-wise?
No, we would have done a simultaneous resection.
You would have done a
also, it depends on the intra-op hemodynamics.
Yeah.
Yes.
It was a sigmoid lesion requiring anti-resection, so you did.
Yes, sir.
No, it was a difficult decision actually. Everything about this patient was very difficult. She was managed outside for nearly a month and a half. She came very sick, and then we suddenly find this tumor. We did actually think of not doing the transplant, but then colorectal cancers, they do have a very good outcome, like Dr. Sainath said. And we felt if you say 50 or 5 year survival is your benchmark for transplantation, then why shouldn't we consider transplantation in somebody who's got an 80% 5 year survival with colorectal cancer? And that's the reason why we went ahead and did the transplant. And we actually wanted to see if we can do one stage or maybe immediately after transplant. But she was so sick, there was no way we could have. She was in the ICU for almost a month
Almost
actually
1.5
after
months.
transplant because she was so sick. So we had to delay until 6 months for the resection.
Yes.
I mean, ideally, we would have liked to do that, within a month of transplant, just to reduce the risk of spread. But that was how the patient. That was the time the patient took to recover.
Sir, simultaneous sigmoid resection and colostomy is also an option, no, sir? I mean, without doing an anastomosis.
Yes, it is an option. Initially, we thought of doing that, but the introp patient was on inotrope, so we decided we'll do it later. Thank you.
Right, thank you, Professor.
Thank you, panelists. Now we have lunch break for 45 minutes.
We'll try to assemble by 3:15 maximum.
తీసుకో.
Huh?
We will be resuming back after lunch now. There are 3 more sessions to go. And the session 4 is about medical and critical care by Dr. Selva Kumar. And this topic is on fluid status estimation and optimization. And the chairpersons are Dr. Ashok Chaudhary, Dr. Shantan, Dr. Uma Devi, and Dr. Shravan.
Good afternoon, everyone. So I would like to thank Dr. Srini and the Star Liver team for giving me this opportunity. So the topic for the discussion is fluid management in a liver transplant recipient who is sick. As such, fluid management is not an ideal topic post-lunch, but what I will do is I will try to integrate some data points and physiology so that it remains a bit engaging. So the 3 parts of this talk are why fluid is important, why fluid should be given, why excess fluid should not be given, and then the second part is if we decide to give fluid, what fluid we are going to give, and third part is how much fluid we are going to give. So fluid, as we know, is not just a supplement, it's a drug. It has dose-dependent side effects, and the idea is to just maintain perfusion without causing secondary damage. So the requirements of liver transplant recipient, fluid requirements are quite common actually. Many times we have patients, cirrhotic patients coming preoperatively with shock, renal dysfunctions, and poor intake. So they might require some fluids. And then intraoperatively we know that there will be blood loss replacement, there might be cable clamps or technical things which need further volume boluses. And post-operatively also, if there is a flow graft, there is drains, if there is intake is poor, or if the patient develops shock, we will end up giving some amount of fluids. So why it matters for a sick recipient is that the high MELDers and ACLF patients have very fragile hemodynamics, and any attempt to replace or correct the hemodynamics using only fluids can lead to pulmonary congestion, and most importantly for us, RV dysfunction. So the RV dysfunction is quite important for us because when there is a sick recipient with a small graft, the RV dysfunction is going to congest the graft and then lead to further downhill problems. And then if we decide to restrict the fluids, we also have to remember that these patients are at risk of renal dysfunction, and AKI has been one of the major factors which determines the outcomes, perioperative outcomes in a liver transplant. So again, that also is a bit of a concern. So it's obvious that fluid status is a key factor in the survival. So some data points regarding the perioperative fluid balance. So this is one thing which has been repeatedly studied, the cumulative fluid balance in the post-operative state. So the 48-hour cumulative fluid balance of more than a liter has been studied. Right? This is one of the topics which has some decent data. So most of the studies have shown that when there is an increased more than a liter of cumulative fluid balance at 48 hours, that leads to poor outcomes, especially poor respiratory outcomes. And then the poor weaning post-operatively, again, this is something which has been studied. This has been indirectly studied for the weaning by doing a passive leg raising maneuver. So when there is a fluid responsiveness as per passive leg raising maneuver, the patients had 100% successful resuscitation, extubation, and when the patients had a overload, there is only 33% success in the extubation. So there was a goal-directed trial. So ERAS, the enhanced recovery after surgery, and goal-directed fluid therapy is a mainstream in many of the abdominal surgeries or colonic surgeries. But when it was tried to extrapolate to the liver transplant situation, that was not very conclusive. The goal-directed fluid therapy did not, demonstrate superiority in the liver transplant population. If you look at the systematic reviews and consensus guidelines. The general idea is that the evidence is heterogeneous, but generally a restrictive to moderately restrictive regimens seem to be the safest approach. The recent data is again same thing. 48-hour cumulative fluid balance more than a liter is always a problem, and moderate fluid strategy restriction is better than a complete fluid restriction or a liberal fluid regimen. So, so fluids, if we decide to give fluids, we know that too much fluids are a problem, too little fluids are a problem. What fluids are the solutions in the perioperative solution? So the ideal fluid would be that which gives only intravascular volume, which does not leak into the extravascular space, and has little side effects and is cost effective. So the options we have are either crystalloids, colloids, obviously the blood products, and albumin. The factors which play a role in deciding this are two things actually here. One is that regarding the fluids, there are three major components. One is the tonicity of the fluids, the composition of the fluids, and the oncotic pressure of the fluids. The tonicity is predominantly dependent on the sodium component of the fluids. The composition depends upon the buffers, something like lactate or gluconate or acetate. The oncotic pressure is predominantly dependent on the albumin content of the fluids. And CLT patients obviously have not always a low intravascular volume. Sometimes patients can also have a high intravascular volume, and inevitably they have a low SVR, and all this leads to renin-angiotensin activation and fluid retention. So just a quick review of this. So we need to understand the fluid volume distribution so that we can select the fluids appropriately. Out of all the fluids, majority of the fluid is in the intracellular component, 2/3 of it in the intracellular component, and only a small component is in the intravascular component, which is where we are targeting actually. So whatever fluid we are giving is targeted at this intravascular component, but the major components are either interstitial and intracellular. So any fluid which doesn't have sodium, if you give, it's going to bloat up the body. So D5 is out of the question. Whenever you give D5, it's going to go into intracellular, plasma, interstitial spaces, so that's out of the question. The other option is to give isotonic fluids like normal saline. The balanced salt solutions are not actually isotonic. They are usually a little bit hypotonic, but almost near isotonic. So when you give that, the fluids can leak from the plasma into the interstitium, but not usually into the intracellular component. But the problem is the sodium load. We already know that the renin-angiotensin activation in the cirrhotics are a problem, so the sodium load is a problem. So we think of giving a off-normal saline. But the problem with giving hypotonic fluid is that all this fluid leads to a lot of fluid seepage into the tissues. So we have options of giving a balanced salt solution. The balanced salt solutions can be either plasmolate or ringer lactate. Ringer lactate obviously we don't use because the lactate confounds our graft recovery and measurement. With the borderline graft function, the lactate metabolism is also affected. So we generally use plasmolate in case of a balanced salt solution. The volume effect, if you look at 100 ml of volume, if you give 100 ml of ringer lactate, the intravascular volume effect is only 18% in ringer lactate. It goes up to 85% in 5% albumin. If you give 20% albumin, it's almost doubles basically. It doesn't give us 4 times the volume, but at least it doubles the volume. So the problem with using saline or sodium-based fluid is that it increases the sodium. And even if you don't have an osmotic demyelination, just the increase of sodium can lead to poor outcomes, such as prolonged intubation, prolonged ICU stay. And we also have to think about hyperchloremic metabolic acidosis. What happens is the sodium and the chloride levels increase. It goes to the macula densa, causes afferent arterial constriction, and causes low fall in GFR. And we hardly use gelatins and starch nowadays because there's a big concern of acute kidney injury and coagulopathy. So even though they have a good intravascular retainership, but the side effects have a big problems. Albumin is an option, but it has its own set of issues. We will discuss the albumin later on. So once we decided what fluid to give, how much to give, the options are the hemodynamic monitorings, the POCUS monitorings, and then the cardiac output monitoring. So the primary option of using CVP and PCWP is not really useful. That's out of the question because the intravascular pressure, the intrathoracic pressure, the intra-abdominal pressure, all this is going to affect the CVP. So the better options would be to use something like a stroke volume variation or a pulse pressure variation. And if there is a leaky capillary, you can actually use PICO, which has global end-diastolic volume and extravascular lung water index. So those things will also give us an idea about the amount of capillary leak which is happening. And especially if there is a perioperative hemodynamic change and you have TE in place, that avoids a lot of unnecessary volume, such as when you have a LVOT obstruction, when you have a thrombus, when you have a cardiac dysfunction, it gives you real-time values and real-time pictures and avoids you giving too much fluid for an indication which doesn't need a fluid. So if you look at the cardiac output monitoring, generally our indications are usually significant CADs, renal dysfunction, shocks, hyperlactatemia, especially patients if there is more than 2 organ failures. So post-operatively, POCUS has come up in a big way. The point-of-care ultrasounds, it can be a lung ultrasound to see for A profile or B profile, or you can see the IVC collapsibility index, which is quite useful. Sometimes it can be just a simple matter of looking at the IJV. That will also give us a sort of a surrogate values of an IVC index. And then if you go into the details, you can look at VTI, LVOT VTI. This can be either static or dynamic. The dynamic means you can give a volume challenge and see the improvement in the LVOT VTI, or you can just do a straight leg raising and see the response to the LVOT VTI. So the idea of this is you before giving volume, you basically demonstrate that the patient needs volume. So the entire point of all this test is to demonstrate the volume responsiveness of the patient. So in specific to the sick recipients, in addition to this, we need to have additional strategies in place, something like a endogenous volume bolus. So how do we give an endogenous volume bolus? Meaning you just recruit it from the splanchnic circulation. This is something which happens in the cirrhotic patients. There is a lot of splanchnic pooling of the blood. There is a lot of blood which gets sequestrated in the mesenteric circulation. So by some means, if we can push that volume in the intravascular space, we can avoid giving a lot of fluids. We can avoid all the complications of the volume. So this is where the terlipressin and the vasopressin analogs come into the picture. This was a study which was again done by Dr. Shini only. So this basically showed that if you give terlipressin perioperatively, even for a living donor LDLT situation, there was less AKI and drain output significantly than the control group. The second part is we should not be afraid of offloading these patients. Post-operatively, once the volume is okay, once the hemodynamics are better, we need to intensively offload these patients. And we need to understand that the fluid which is given before surgery and after surgery is going to come back into the circulation, and we have to be quickly getting the fluid out of these patients, because these patients will have very, very poor lung compliance, and if they become chest congested, then that becomes an issue. The options for offloading are 2 things. One is diuresis, the other is RRT. Diuresis is a sort of a safer option, simpler option. But the bigger problem is when the patient has a hyponatremia, when the patient has a AKI, it's very difficult to coordinate this. The changes of sodium and the creatinine can be quite unpredictable. You can always combine with terlipressin, so that's an option. This can be used even pre-op and post-operatively. But SCUF, something like SCUF or CVH gives us better control in removing the fluids, but obviously it has better control in maintaining the sodium levels. It doesn't lead to uncontrolled rise in sodium and osmotic demyelination issues. But the problem is, because it's extracorporeal circulation, you can have problems of thrombocytopenia, sepsis, and all that. So if you look at specific scenarios, something like a preoperative ACLF patient coming with septic shock, inevitably these patients have high CVP, and misleads us that this CVP patient is volume overloaded. For all we know, the patient is usually intravascularly depleted. It's a real challenge to give a volume to this patient. But so the idea would be to have a better monitor and have a better intervention. Better monitor includes dynamic testings like passive leg raising, focus monitors, and then better intervention would be to, instead of giving fluid, give albumin-based fluids, some fluids, and mainly vasopressor-based therapy. And PICOs and advanced cardiac output will also help. Again, small size grafts also have a very little margin on either side. If you have a hypotension or a post-operative fluid requirement, if you load the volume, that's going to congest the graft and lead to further issues. So we need to know better. The TE and the transthoracic echoes might help, and predominantly a vasopressor-based approach and albumin supplemented approach will help. This is a specific situation where we can't use more of vasopressors. Here we need inodilators, something like a portopulmonary hypertension where we have increase in the CVP and hypertension. This is where we have a big role of TE and the actual visualization of focus. So here we can use inodilators and vasopressors and completely avoid the fluids. So if you look at the evidence behind the perioperative fluid management, one thing is very clear: cumulative fluid balance more than a liter at 48 hours is always bad. In fact, it not only leads to poor chest outcomes, it also leads to poor kidney outcomes, predominantly because, contrary to the general belief, the high CVP can actually cause more kidney injury because of the back pressure. So it's not that high fluids always lead to only chest issues, it can lead to kidney issues also. And restrictive intraoperative fluids lead to better outcomes by reducing the pulmonary complication and blood loss. As of now, goal-directed fluid therapy is still not, fully supported by data. And if we want to restrict the volume, moderate restriction is always better, and the dynamic assessments will help us in making the decisions easier. Intraoperatively, the main focus should be the dissection phase should have a comparatively lower CVP and go for vasopressors more than the fluids. And post-operative and anticipate the reperfusion. Again, here also vasopressor-based therapy, and see what's happening before you do anything. So TE or PICO might be helpful. Post-operatively, again, the cumulative fluid balance is something which we need to keep in mind always, and be very aggressive about offloading this patient in the post-operatively once the hemodynamics are better, and have a better monitoring in place. So other than this, if you look at the sick recipients, so it's about monitoring. Monitoring includes something like POCUS, the SVVs, PPVs, and then intraoperatively we use low CVP and vasopressors, and then post-operatively we de-resuscitate. That's the main thing here. And always be on the lookout for specific situations like small grafts or sepsis or RV dysfunctions. And the idea is to have euvolemia and not really having any sort of hypervolemia at any point of time. And the idea is to balance the functions of graft and the kidneys. So generally, our idea is our primary fluid is, due to the multiple reasons we discussed, it's usually a combination of RNS and plasmalyte. And as much as possible, cellular blood products. For example, if there is a blood loss, we try to replace with PRC only, not with anything else. And we completely avoid the plasma, use the ROTAM-based algorithms. And those things actually lead to a lot of reduction in the fluid requirement, and most of the time we end up giving cryoprecipitate and fibrinogen concentrate most of the time, and if needed, sometimes PCCs. But the FFP requirement is completely reduced. If you use albumin, the situations where we use albumin is when there is post-operative drains, when there is when there is oral volume requirement, which is quite significant, we can use it to reduce the oral volume requirement. Acute volume challenge, we use a 5% albumin, but generally we don't chase up the serum albumin levels. Have a low threshold for vasopressors instead of giving lots of fluids. And once the patient is ready, be ready to intensively de-resuscitate and offload the patient, and have a low threshold for perioperative RRT also, because it gives you better control over the overall picture. So the idea should be that once you see the patient perioperatively, we have to have a mental plan of how to go about during and after surgery, continuously monitor, have good monitors in place, and then keep evolving, and always remember the physiology so that it's easier to manage these patients. Thank you.
Very nice lucid talk, Dr. Selvakumar. Thank you. What about the post-transplant polyuria? If it occurs, how long it will stay, and how do you approach for that polyuria scenario?
So post-liver transplant polyuria is not a very common feature which we generally have. Most of the time we have oligurias, unlike a kidney transplant. But if it happens, the problems which we might face is, because most of the time this polyuria could be a part of the recovering AKI, recovering ATN type situation. In that situation, we might be losing a lot of free water, so we might have rapid uncontrolled rise in the sodium levels. That is something we have to keep in mind. And obviously, the intravascular volume has to be kept in mind. And if you have the monitors and either the hemodynamic monitors or a lactate, we can continue chasing up. What we generally do is, if the polyuria is a real problem, we continue fluids with off-NS, which we generally don't give for other patients. We continue with off-NS, have a bit of sodium restriction, and as much as possible go enterally, if possible, and then maintain the tonicity of the fluids with a background infusion of albumin.
And one more question. How do we assess graft perfusion? Can we translate the general body perfusion to graft perfusion, or any other extra lab investigation? Or of course we do Doppler ultrasounds and all those things, but can we really translate the body perfusion to graft perfusion, or we have to do any other extra lab investigations like?
Generally, the liver graft perfusion is generally not something which gets it's not the first thing which gets affected when you have a perfusion issue. But having said that, if you want to measure, obviously the portal flows will be a good point to measure in Doppler. The lactate is something which always helps us if there is any fall in the graft flow. But there is not a specific focus on graft perfusion. Most of the time, it's the overall perfusion, mainly the renal perfusion, which gets affected first, because graft gets its flow from the portal vein, and most of the time these patients will have hyperflow rather than low flow.
Thank you. Audience, any questions?
Thanks for the talk. Sir, are you using this passive leg raising in your setup?
Yeah, we are not fully using the passive. What we are using is we are using passive leg raising and seeing the response in the hemodynamics. We are not actually using the passive leg raising with the LVOT VTI measurement, which is the classical way of doing this. So if you have a LVOT VTI measurement on place, and then with the echo probe in place, if you raise the leg and you can see the VTI improvement, that's a proper way of doing that actually. That is something which can be done.
Usually we take a cutoff of 10 to 12% change after doing a passive leg raising. So if at all that the same thing you are applying for these patients also, or any change that you are keeping, like the threshold is being changed for them?
So the thing is, basically passive leg raising, just like any other dynamic variable, shows that there is a volume responsiveness for the patient. It doesn't mean that patient needs volume. Sometimes the patient might be just having volume responsiveness, and if the perfusion is okay, we might sometimes accept a slightly lower volume. So we don't treat all the passive leg raising positive patients. But if there is hypotension or a borderline perfusion, low urine output, and you have passive leg raising positive, we give volume boluses.
Last one, sir. Both in ventilated population as well as the normal population you're doing, or any specific this thing?
Yeah, ventilated patients, most of the time, if you're going to look at volume, it's usually a cardiac output monitor. This is usually where we have come down the line, actually, meaning when the patients are already weaned off and everything. If you have ventilated patients, PPV is a very good marker. The PPV, the accuracy falls when there is ventilated patient is off ventilator, because you need a 8 ml per kg tidal volume, proper ventilation for the PPV to be fully effective. So that group of patients will have a different set of monitors compared to extubated patients.
Thank you, sir.
Thank you.
Next, I would like to invite Dr. Sanjay Sehgal, sir, to talk about on ABOi incompatible liver transplantation strategies in high-risk MELD patients.
Thank you very much. Thanks, Metu, Rajgopal, and the entire STAR team for inviting me for this session. How do I get the slides? Right. Thank you very much. So this is an interesting talk actually, and was initially thinking of speaking about optimizing outcomes in ABOi. Then I think I got a message that let's look at high MELD. I said fine. So I will take you to this very interesting, for those youngsters, the young fellows and all, you may be interested to know that the first ABOi liver transplant which was held in this country was way back in 2013, and this was one of the paper cuttings in Times of India. A very exciting thing that it was done first time. It was in Medanta, Dr. Soin, and I was there actually. And this was quite a big event that we were doing ABOi at the time. And I happened to be actually involved as a hepatologist. So that was very, very initial learning days, and it was constantly in my mind whether this is going to work out in our country or not. Is it the right thing, or we should do something else? From that, now I'm going to speak on ABOi in patients with high MELD. So therefore, it's a huge sea change from the initial starting point where we started. And today we are looking at patients who are sick, MELD which is high, perhaps more than 30, 35, and trying to do a transplant for them. This would include patients who have got ACLF, who are sick in ICU and are having multiple problems. So we are going to face a lot of problems: immunological barriers, infectious problems, hemodynamic fragility, biliary vascular complications. There's a hugely important concern of limited time for desensitization and outcomes which may not be as good. So if you look at these points one by one, those who are sick, well, there are immunological barriers. There may be high preformed titers, and in this situation, well, it's not proven that those who are sick have high titers, but if you have a high titer and a patient who's very sick, this is a bad combination. And if you're not able to do a desensitization in these patients, then their tolerance to any complication in the post-transplant period may not be as good. There would be more endothelial injury, more chance of biliary as well as vascular complications. Sepsis will be a concomitant part. We know cirrhotic patients, ACLF, are already immune compromised. They have immune dysfunction. And when we desensitize them, if we try to desensitize them with plasmapheresis, rituximab and all, they'll be further compromised and more prone to infections. So sepsis would be the most important concern for us at all times. There would be a lot of hemodynamic and organ dysfunction problems, renal dysfunction, hyponatremia, circulatory collapse, coagulopathy, and the added insult of any AMR would be poorly tolerated by these patients, and certainly a combination of severe coagulopathy in the presence of plasmapheresis and sepsis would exacerbate the entire concern. I have seen that perhaps these patients who are sick and septic are having ABOi, they have higher vascular issues. I've seen it, I just think that they might be having high risk of vascular thrombosis, HAT. We have to be very careful. And also, once the problem happens, if it's a clean surgery, everything is fine, you're okay. But something happens, then I realize that their chances of recovery from that insult is actually very poor. And this, I think, I'll talk about the standard protocol of desensitization, and then we will see, can we do a rapid desensitization in these patients? Is it worth doing it? Because we have a very short duration of window at in some patients. And we generally say that the outcomes of ABOi incompatible and incompatible. If the patients are good and stable, you are doing an elective way, you may have comparable outcome. Although I personally feel that still the outcomes in ABOi incompatible are lower than what we get in the compatible transplants. But certainly those who are sick with high MELD, who have got a lot of other complications, septic state and all, in them I think there is a chance that you might be ending up with poorer outcomes, and majority of centers are very much hesitant in taking these very sick patients. I particularly am very, although we have done a lot of ABOi transplants, believe me, in ACLF and all, I still tell Subhash Mr. that we should not be doing ABOi in ACLF. We are not so good in that status. ACLF 3 and all is completely, I think, no for ABOi at this stage. Well, we all do such cases. I'm not telling that we don't do. We have done these sicker patients, and you may be lucky to have a good outcome at certain stage. But the overall thing is that sicker patients like this are very challenging. Now, when we are managing them, we have these early post-op issues, immunosuppression, antifungals, antibiotics. They're always standard, and a concern for graft dysfunction AMR. Now, my interest in ABOi actually grew more and more in the COVID times, and then I wrote this, review article in JCH. What are we doing in ABOi in comparative liver transplant in our own country? I took help from the IGABA to actually learn a lot of these things from him, right, when I was meeting about almost 2 decades back. With that interest, we saw that the early concerns, we all would agree, whoever is doing ABOi transplants, we know that sepsis, SFS, vascular thrombosis, bile leak strictures, AMR, and rejection per se, they are the concerns which determine the outcome of a ABOi incompatible liver transplant. I mean, a lot of intra-op issues are there. I think this is okay. Most of us would accept that in such a patient, ABOi incompatible, one would like to have a graft volume which is good, something which is more than 0.8, more than 1, and try and have minimal surgical complications, MHE thrombosis, as little as surgical complications as we have. Again, one thing I've seen that those patients who have, post-operatively in the early part, day 2, day 3, have got some MHE thrombosis, some hematomas, bile leaks. Invariably, they are not able to tolerate the hit in an ABOi incompatible as compared to a compatible transplant. So clean surgery in a sick patient is acceptable, and you can have a good outcome. We look at all these, on day 1 and, standard practice, we all would know that. Only thing I would highlight is that I practice doing a titer twice daily for the first, 2 weeks, definitely for the first week. And doubling of titer is a significant entity in my understanding, and I will not wait for LFTs to change. Even if titers are increasing, I would take action on them. And a daily Doppler is absolutely essential. We must have to do it. Now, the standard protocol still remains standard. We will not change it even if it's a sicker patient, except in some situations where we bypass that. We'll come to that subsequently. The standard protocol, I'm sure somebody is going to speak on this, the desensitization protocols is a talk later on, but we all agree that we give rituximab in day -14 and try and institute the plasmapheresis if the titers are more than 1:16, 32 or 34. Our aim is to make it less than 1:16 as far as possible. Some centers would start tacrolimus or MMF before the transplant per se, but we don't follow that. And steroids would taper over the next 3 months. So this is a standard protocol. So what we did was we did a survey, a national survey of practice of ABOi incompatible transplants, LDLT, in our country. This was in 2023, just very recently. Couple of things I found from this very short but interesting survey. Most centers would not do ABOi for high-risk ACLF, ALF during this survey when I conducted this. Most of the centers would consider giving rituximab at least 2 weeks, which is the red one, prior to the elective date of surgery. Some would do 1 week, but certainly the longer the duration, the better it is. And the titer was the crucial question. Most centers would like to have a titer less than 1:16 when they're doing the transplant. So this is the practice in India. So now, if you are doing a high MELD patient, sick patient, ACLF, you cannot have this opportunity. You cannot have the opportunity of giving rituximab 2 weeks prior to that. You may not have the option of, having the ideal titer. So we need to define what is a sick patient and then, go accordingly. But certainly, there would be some exceptions. I'll come to an algorithm later on in the later part of the talk. And we need to understand in the post-operative status, AMR versus sepsis, a very close call. We may not be able to sometimes pick it up carefully, but we should be very careful. Any patient who's having rise in titers, rise in LFTs, falling platelets, and persistent graft dysfunction, you have ruled out vascular, everything biliary, then it is a situation for AMR to be there. There is some, evidence that like those who receive a lower dose of rituximab may have higher AMR, but I'm aware that some centers, I think probably have to talk to Mr. Srinivas Reddy. I think you were using a lower dose of rituximab, but those things we can discuss subsequently. And also that the pre-transplant titers, do they impact the AMR post-transplant? Well, as for this study from Professor Igawa, yes, in the pre-op phase, the IgG may not bother much, but yes, of course, if you're having an AMR, then your titers would certainly rise majorly, and you have to be careful about that. And then, of course, some strategies to handle this AMR, which I think is a very standard. I'll skip this slide. And okay. Now, I come to this study which is actually published from China. A very elegant study, but I'm not sure how much is it replicable in our setup. They had sicker patients, ALF patients, 101 ALF retrospective data analysis, compared 66 compatible versus 35 incompatible, and they had a quadruple immunosuppression regimen. Very interesting. Basiliximab, steroids, tacrolimus, and MMF, and they would give IVIG from day 0 to day 10, and rituximab on the day of transplant, a single dose 375. Interestingly, this was a protocol, so all patients will receive IVIG day 1 to day 10, and what they found was the pre-LT antibody titer did not matter. They did at a higher titer of 1:192 actually, which decreased by less than 1:16 on day 1 itself, and they could actually show that a single dose of rituximab has its impact up to 3 months, which is true fact that it really has an impact for 3 to 4 months. And the survival of these patients between those incompatible and compatible was almost similar, 86 and 83%. I don't think anybody else would have repeated or replicated such a data. And in our setup, we have seen many times. I know a couple of my colleagues have done ABOi in ALF also. I was talking to Dr. Anand, I think he has also done. But we don't think that ABOi incompatible is something which we can do in our practice as of now in ALF patients. So the standard protocol would determine 2 weeks before transplant a rituximab dose, 40 to 70 hours prior to transplant. We would like to do the plasmapheresis to reduce the ABO titers to less than 1:16 as far as possible. Sometimes I would take 1:32, but yes, ideally is 1:16 or less. And on day of transplant, we give IV intravenous methylprednisolone bolus in the anaphylactic phase and standard post-op concerns for infection, immunosuppression and all. Now, those who are sicker patients, just try and develop an algorithm for these patients. Somebody like a sick patient, more than 30 MELD, which is quite common in our ICU these days. In fact, it is more common to see sicker patients than the stable patients who are coming to us for liver transplant. So in the first step, we would try to identify, can they have a donor which is compatible? Well, if they don't have one, then we need to look at their titers carefully. Low titer, things are okay, favorable, whereas the high titer, which is 1:64, then we are in trouble, and we have to see, can this patient tolerate a desensitization with rituximab or plasmapheresis or IVIG? So somebody who's septic, sick, culture positive, hemodynamically unstable, I don't think we can use these modalities, but a stable patient in a selected one, perhaps we can do. So if we can do and we have time, which is an ideal, but if we don't have the time and we have to proceed, then we have to take it for an urgent, or at a very high risk case, and then do a case by case, selection of these patients, and then try and see if we can have an outcome which is optimal in these very sick patients with high MELD. So to conclude, high MELD, especially ACLF, which I think pose significant challenges, and these patients are, as of now, especially ACLF3 and all, are not the ideal candidates for ABO incompatible liver transplants. Graft dysfunction is very, very critical part of the entire thing, and we have to differentiate between AMR and sepsis with very good judgment, and a rising antibody titer post-transplant is sufficient reason to actually do an action, maybe plasmapheresis or whatever you want to do is your practice. ALF, again I say, perhaps is not suitable for ABO incompatible at this stage, and we need to have a collaborative experience. We had done survey earlier 2 years back, and I think it was very, very useful, but I think that we can actually, as part of our societies, do a collaborative survey across all the centers in North and South, have a common registry, and try and see what our experience is, which I think would be very productive. Thank you very much.
Yeah, thanks. It is open to the house first. Yeah, please.
Yeah, thank you, sir, and a nice talk. Charles here. Hi. Doing ABO incompatible for ACLF patients, do you think there's any advantage of using a hemoabsorption column to a TPI? Does it reduce the risk of infections in such patients?
You're not clear actually, a lot of echo. Tell again. Okay, the type of plasmapheresis. Okay, yeah, if I am getting your question. So I've seen that the standard plasmapheresis which we do is reasonably good enough. But if in some situations we are not able to get the titers down, then we do the immune adsorption actually, where we have seen, interestingly, we have seen that some patients are not responding to the standard TPE, and when you do the immune adsorption, actually you can actually achieve that. So I think there is a significant role, but I don't use it as first line. There was an abstract presented on this from our Max team in one of the recent ILTs. There is no difference in only thing which was different was that some patients who were not responding to the standard exchange TPE did actually respond to the immune absorption, and we could take them for transplant. I don't think there was a risk of infection which was different. I don't think so. This is again very interesting. Upfront, no, I don't think I have an experience. No, but also I think that upfront nobody would have used it. For AMR which is not responding, and you have used plasmapheresis and you have IVIG, there bortezomib has a role because it is a plasma cell, attacks on plasma cells. And I know my colleagues in hematology, in myeloma and all, they use it a lot. So bortezomib is an excellent drug, but I have not used it personally.
Hi. You were very negative about ALF, but not so negative about ACLF. But don't you think ACLF are probably patients who are at worse situation for sepsis than ALF, who are actually in a good physical state until they became unwell? And you showed that study where they give it on the day, rituximab on the day of the transplant. But that may be so for hyperacute patients. There are many ALF which don't need a transplant. You wait for 72 hours, 2-3 days or 4 days. You might get time for 2-3 days to give rituximab. I think you've done that, haven't you? The reason you feel more comfortable for ACLF generally, I think, is because you think you can get away waiting for a week. But in that week, they could get septic, and therefore you preemptively do the transplant, even though you can't wait for that 2 weeks. Sometimes you can't wait for the 1 week. So personally, I would think ALF is probably even more suitable than ACLF. I don't know what you feel.
I think very, very, right comments, Professor. I totally, get the sentiment you're telling. But in real life, what I've seen is that if an ALF is there, who's needing a transplant, and sick in ICU, we still have that mental, block that we need to have some time frame
I think it is a mental block.
Yeah, I'm telling. So that needs
Truly,
a level.
I don't rush to do a transplant even in ALF until unless they've grade 3-4 encephalopathy. A lot of the ALFs actually don't fall into that category.
Right.
There is time to think about it.
So I think that, like in one of the previous meetings, I remember one of my colleagues, surgeons from here, somebody who was telling that in ALF they did 3 patients upfront without any no rituximab, nothing. Straightway they did ABOi incompatible and patients survived. So it is very difficult to have a message from that, and to do ALF, well, it is very challenging. And as I agree with you that this is a block. We want to really have some time, and doing somebody if an ALF is there and the titer is 1 is to 256 or 512, I would be very hesitant doing an upfront transplant in ABOi incompatible. ACLF, right? I actually said that ACLF 3 and above are very bad candidates. They are the worst actually. You are totally right. They have more sepsis, more infections. But yes, psychologically you have some time to think. You have some 1 or 2 weeks which you can buy. And if you're lucky, patients have improved on your medical measures, you may be there. So between the two, yes, I cannot say as of now, but I don't know, we need more experience on ALF definitely. I don't have that experience on ALF.
Just one comment.
Yeah.
So like what Dr. Ella said, at least in our experience, what we've seen is patient with ALF, whatever ABO incompatible we've done, we've given rituximab, usually at the time of surgery or immediately after surgery. And for one patient, we've done a splenectomy also. Patients with ALF actually do very well with ABO incompatible, at least in our limited, it's a small experiment, it's just some 6 or 7 patients. It's the patients with ACLF which struggle because they've already been sick for a long time, they're very depleted, and then they drag on, and we really need to manage these patients very carefully post-op. In fact, we did a multi-center study through ILD-LT. So we divided them into ALF and ACLF group. The outcome for ABO incompatible ACLF was around 50 to 60%. The outcome for ABOi incompatible ALF was more than 90%. Of course, there are probably more children in the ALF category from Japan. But
children is also, Dr. Rila, an important point because they have a much better profile for ABOi compared to adults.
I think to some extent ALF patients are better preserved, they can tolerate the little bit of insults, and the risk of infection is lesser also. And we're not giving a lot of time between rituximab and transplant, so they get a new liver which is working, so they can tolerate this. Whereas the ACLF patient, they're sicker before. I think maybe that's something that we can think of. In fact, sometimes I think even ACLF patients, no point in giving 1 week, 10 days, just give the day before transplant, give the rituximab, and we've not done that. But, because when you see ALF patients do so well, have that. In fact, we are discussing one patient who underwent an emergency ABO incompatible for PNF today in this session. So again, we can discuss that in that after that case. Thank you.
Okay, thank you. We'll go to the next.
Thank you very much.
Next, I would like to invite Dr. Uday Zakaria, sir, to speak on role of plasma exchange in sick ACLF and cirrhotic patients.
Thank you, chairpersons. Thank you, Dr. Reddy and team for the kind invite. My mandate is to talk to you about plasma exchange in the setting of ACLF, and I'll try and share our experience. Looks like the slides have changed. Before I start with our experience, it all started with the ARC database and Ashok Chowdhury and Raki Maiwal's group, where plasma exchange, the first set of results were looked at. But when we look carefully at that database, it's important to realize that the patients chosen for plasma exchange, the exclusion was active sepsis, hemodynamic instability, or multi-organ failure. Most of these patients were managed in the ICU and some of them in the wards. And 94 of them underwent PLEX, and about 25 did other therapies. Most of these patients were alcohol, and none of these patients, at least in the PLEX group, had steroids. They were able to show that there was a reduced mortality at day 30, and there was an amelioration of the systemic inflammatory response and prevention to multi-organ failure. With that, I go to our initial experience, small experience, where we looked at low volume plasma exchange with low dose steroids in alcohol ACLF. And in this group as well, the exclusion included active infections, those who had bleeds, and hypotension. So again, these were very sick patients. You can see the Madry's discriminant was high, but what we followed was a low volume, that's half plasma volume, minimum sessions, and low dose steroids, which was at that point 10 to 20 milligrams a day. And we were able to show that there was a better 30 and 90-day survival when compared to a standard medical treatment group. With that, we looked further and looked specifically at using the centrifugal technique. along with low-dose steroid. So it's a busy slide, but if you look at the bottom, it was a centrifugal technique compared to a standard medical arm and a centrifugal technique compared with a membranous plasma exchange technique. Now, again, these were all sick patients, as you can see from the discriminant function and the MELD score. For both, when you look at, this is the C-plex versus SMT, and this is the C-plex versus the M-plex, that's the membranous group. As could be expected, the centrifugal technique had a low flow rate, about 25 to 35 mils per minute, as opposed to 125 mils per minute for the membranous plex. The processed volume again was much lower in the centrifugal plex group. The duration of plex, because it was low volume, was not too different. That's interesting. And as expected, the plasma removal efficiency with centrifugal is higher. And we were able to show in this small series that when compared to standard medical therapy and when C-plex was compared to M-plex, there was a difference in the mortality at day 90, and that continued when followed up for 1 year, but these were small numbers. So at that point, we proposed that in ACLF, the higher grades of ACLF obviously are very sick patients, likelihood of hypotension, multi-organ failure, sepsis is higher, and they must be referred and considered for urgent liver transplant. However, in the earlier grades, you could consider starting with plasma exchange, and in those who don't sort of, or who develop further and go on to a greater level of sickness, would obviously then be considered for liver transplant. With that, I go to a recent meta-analysis, and again, Dr. Ashok was kindly there on this paper. These were overall about 5,000 ACLF patients, of which about half of them had plasma exchange, 23 studies, 4 of them were RCTs. In the flow diagram, it's more to show that of these 23 odd studies, about 14 of them were from China and 4 of them were from India. So this is the forest plot showing that at 30 days, there was an improvement in mortality and favored plasma exchange when we compared it to an SMT. Remember that in this entire group, only about 2% of them underwent liver transplant. So essentially, you were looking at native liver survival as opposed to transplant-free survival. The same result, a 30-day result, was seen at 90 days. And when you looked at the 4 RCTs, these were the Chinese RCTs, again you favored plex at 90 days. If you looked at 1 year, these were about 15 studies, again there was a in favor of plex. When you compared the techniques, the plasma exchange is on the top and the other alternate liver support systems below, again in this meta-analysis there was no difference. And whatever definition you took for ACLF, this is before Kyoto, so whether it is Arapacil or ECIL, there was no difference, and again it favored plex. What were the side effects or adverse effects reported? As expected, on the top were allergic reactions, probably related to albumin or FFP, sepsis and new infection, 2.4 and 3.4% was noted. Hypotension was noted, but that's probably likely related to the technique used. And TRALI, or transfusion-associated acute lung injury, was seen in 1.4%. In the ALF setting, our group has shown that TRALI is not an issue with low volume plasma exchange. So the key points are that plasma exchange improved survival at 30 days, 90 days, and probably at 1 year. It was seen across all definitions of ACLF, any etiology of ACLF, remember this was mainly alcohol and there was hepatitis B, but from the Chinese groups, irrespective of the technique of plex and the volume of plex. However, the quality of data as seen is restricted, as the majority, there were not enough RCTs, and most of the studies, or almost entirely, it was from Asia and 4 from India. This is just a small sample to say of what we are working on. How do we know when to give up and when not to proceed further with continuing plex? In the ALF setting with rodenticide, we have shown that a 20% delta drop of bilirubin is highly determines outcome. Here was some preliminary work which we are still working on, showing that a delta decline in bilirubin associated with the INR may have a role, and hopefully we will have more data on this, because that is then becomes important in helping us decide when can we continue with plasma exchange, when should we stop, when should we not even consider it. Similar data has been shown earlier by other groups in ACLF with regard to plasma exchange, and I was able to find this showing the similar result in the pediatric population as well. Just one line to remind ourselves, if you look on the left of your screen, in health, we all have physiological plasma exchange going on every second within the liver. And when there is an endothelial injury and the endothelium puffs up, blocks, then you have a congestion, and with the congestion there's ischemia to the hepatocytes. And a little bit of that is shown in this EM picture here, where you can see the deformed RBCs blocking the sinusoidal lumen, and indeed a macrophage trying to eat up an RBC. So in a nutshell, what seems to have worked for us in a select group of patients is that we used a centrifugal technique. We depended on low volume. We tried and did as less sessions as possible, and the flow rates by the centrifugal technique were low, and we used low dose steroids as an anti-inflammatory mechanism. Thank you.
Thank you, sir. It's a wonderful talk. For your paper on low volume plasma exchange plus low volume steroid, is there any difference in your group that you have seen between low volume or the normal volume in ACLF?
So I'm unable to give you that data. I think Anand Kulkarni's group has looked as high volume versus standard volume.
That is in ALF. That is in ALF. I'm discussing about the ACLF.
Since we have used only low volume, I'm unable to truthfully tell you that. I don't think that there is data. I hope it comes out.
Any questions from the audience?
Sir, very nice talk. Do you have any experience regarding plasma exchange in scrub typhus induced ALF or dengue fever associated ALF?
So that's an excellent question, and I wish my boss, Dr. Eapen, was there. He would have been smiling and given you a prize for that. So while again we don't have published data from our side, there are, as you know, case reports showing that in the setting of scrub typhus or indeed in dengue, that there is a role for plasma exchange. I would only say that the concept of the traffic jam, anything that ameliorates that and helps the liver regenerate, the native liver regenerate, that would be good.
In the last couple of months, we have treated almost 4 patients, sir. All are scrub typhus induced ALF. Out of them, 3 survived very well with only 1 session, but 1 patient succumbed to death. So just I want to know regarding, have you ever used low volume or high volume or membrane or centrifugal type?
Yeah, so again, I can't answer that truthfully. Okay. I'm sure a few cases may have been done by our medical units, but we have not analyzed it. Maybe Ashok can add on.
Supplement. The plasmax is mostly now preferred is centrifugal, like membrane is less favored now. And 2, it is irrespective of etiology, because it is scrub typhus or dengue, that does not make any difference if you are going to go for. So that's why I think, and then second is the patient hemodynamic status. What we see the ACLF patients, we do normal or low volume, because high volume, as described, most of the Indian patients don't tolerate. So it is a normal volume or the low volume plaques we go for, centrifugal, and irrespective of the etiology. That is a routine program. If no more questions, yeah.
Hi, Dr. Uday. Thank you for the talk. Just for our understanding, can you tell us why there is a difference between membranous and centrifugal plasma exchange? What is the difference and why is one better than the other?
It's hypothetical at this point, and we were able to show that for alcohol ACLF, though we were not able to show that for our rodenticide ALF. My own personal feeling, and forgive me for saying my own personal feeling, is that a membranous technique, by the fact that it is high flow, causes subtle fluxes which our liver patients, especially the ACLF patients, just don't tolerate. And my ICU colleagues may back me on that. So I have a feeling that is why a centrifugal technique, being very gentle and slow, is more sort of tolerogenic to the body, but it's hypothetical at this point. But we have found that it works, and very strangely we started it only because the centrifugal machine can be wheeled into a ward. You don't need any RO lines, you don't need to bother about it. So it was an extremely easy to do, just connect it, finish it, and then, it's like the Hero Honda ad, fill it, shut it, forget it. Thank
you. Thank you, panelists and chairpersons. And next is case-based discussions. We have 2 ABO incompatible cases, and for that the panelists are Dr. Abhishek Mathur sir, and Dr. Dheeraj sir, Dr. Chandan sir, and Dr. Vijay Challa sir. And the first case would be discussed by Dr. Rajgopal Acharya, difficult desensitization in ABO incompatible transplants.
It's not moving. So good evening, everyone, and welcome to the panelists. So we have a surgeon, 2 hepatologists, and critical care anesthesia specialists for this session. So a 56 years male, blood group O positive, weight 71 kg with a BMI of 28 kg per meter square, diagnosed as CLD with decompensation as refractory ascites, encephalopathy, grade 2 varices, non-bleeder. So was evaluated for transplant. Etiology showed hereditary hemochromatosis. MELD sodium was 29 with a bili of 12, INR 3, sodium 139, and create of 0.8. So family had no blood group compatible donor. So we offered. So my first question would be, would you consider ABO incompatible transplant for such a patient where MELD sodium is 29? So the question is open to everyone. I would like Dr. Abhishek Mathur, can you please comment on this question? Would you consider ABO incompatible for a patient with MELD sodium of 29?
Yeah, so, my experience is, again, like I'm going to just preface it, I've been in the US for the last 20 years, so a MELD of 29 would probably get a deceased donor pretty quickly. So with that in mind, I think the point that Dr. Rella made is really important. I've probably only done one ACL or one ABO incompatible in the last 10 years, and it was an ACLF which was going down quickly. And so those are probably, those higher MELD patients might be the one which they're actually required.
Okay. So
to add up on this, with the blood group barrier, we essentially have only 3 options. Either keep waiting on a DDLT list, or to go ahead with the ABO incompatible LDLT, or for a liver paired exchange. Again, he's a blood group O positive, who are disadvantaged for liver pair exchange. So there should be a shared decision making between the patients and the doctors.
So in this regard, so is there any cutoff for antibody titers beyond which ABOi compatible should not be offered to such sick patients? Dr. Chandan sir, can you please comment? Is there any cutoff for the MELD score, and is there any cutoff for antibody titers?
If it is ACLF, high MELD, like how Dr. Sanjeev Sehgal said, more than 20, 22, 25, then better avoid ABOi compatible in ACLF. Secondly, if they have kidney injury, recent in sepsis episodes, then better avoid. And third, if titers are more than 500, better avoid.
Okay.
512.
So coming to this patient, we also follow a policy where we have a cutoff for titers. Coming to this patient, his IgG was 1:2048, which is way beyond our cutoff, and IgM 1:256. But there are a lot of centers which don't give much importance to pre-rituximab titers. So the donor was a son with a good graft GRWR of 0.8, LAI plus 14, and suitable for right lobe. CD19-20 to start with were less than 1%. So next question would be, what kind of desensitization do you practice in your setup? Means, do you consider rituximab as an essential thing for everyone? If yes, what is the dose and how long do you wait?
Yeah, so this is the case of LDLT where we have some time to plan this surgery. So like we have discussed earlier, Dr. Sehgal has said, we give this rituximab 2 to 3 weeks before the transplant, and then we do the titers. If the titers are still high, then we do plasma exchange or immunoabsorption. And once the titers are in acceptable range, then we proceed with the transplant. Okay. And then post-transplant, again, we do a standard triple immunosuppression, but then we aim for a slightly higher TAC values of 10 to 12 nanogram per dl.
Okay. And what is the dose that you prefer to give? Is it a standard dose, or does it vary depending upon the thickness of the recipient?
Absolutely. So the house is divided about this dose of rituximab. Some say 200 mg per meter square, or some other people say 375. However, when the donor, the recipient is sick, like he's a high MELD or ACLF, in all such places we will tend to give slightly lower dose of rituximab.
Okay. Probably 100.
Okay. So basically, I think the purpose of rituximab here is to deplete the B cells, and once we achieve it through a low CD19-20% in the blood, I think the dose really doesn't matter. So we gave 200 mg to this patient considering his sick status. The 10 days after, so we follow a protocol where we give at least a gap of 2 weeks after rituximab. So we evaluate the titers after 10 days, and remaining 3 to 4 days when we start Plex or other techniques to lower the titers. So the IgG was 1024, IgM 128, CD19-20 was 0. So at this stage, what are the methods you practice to reduce antibody titers before going for transplant? So whether you prefer Plex, whether you prefer immunoabsorption columns, or you decide depending upon the titers?
See, in this patient, usually Plex is better than adsorption columns, but in this patient with titers of more than 1000, even after retux, after 2 weeks, better do adsorption columns, I think.
You know, I'll just make one point that all of this is the caveat is how the patient's doing, right? A MELD of 29 and a sick patient, you don't want to like drag it along and then you're dealing with other issues as you're going along. So you've got to figure out that balance of tolerating risk with ABOi incompatible.
Okay. So just before this session, we had a talk on ABOi incompatible where a question was asked whether there is a risk of infection is different between Plex versus immunoabsorption column. So can anybody comment on that, whether means the number of sessions of Plex required to bring down titers should be at least 3 to 4 with this titers 1024. So whether giving immunoabsorption in the first place itself is a good option?
No, actually, there is dearth of evidence in between Plex and adsorption columns. But if you look at the titers, and as my panelist has said, it's about trying to reduce the titers in the shortest time possible. And usually these patients will have occult sepsis with high MELD, already given rituximab. So better do adsorption columns, reduce the titers quickly, and take up for surgery.
I have a different understanding about this thing. So this Plex, in my opinion, is slightly non-selective one. And when you say immunoadsorption, that is slightly more selective for removal of anti-A or anti-B antibodies. So whenever a patient is septic or sick and the titers are high, I will like to go ahead with the immunoadsorption.
I think the cost also comes into play in this in a big way. So what is the target titer before you proceed for transplant? There are various centers which have different cutoffs of the titer.
Preferably less than 1:16.
1:16. Yeah. Does everybody agree on it, or there is a difference of opinion? Or anybody has an experience of doing it at 1:64 or 1:32 with good outcomes?
As low as possible, lesser than 16 maybe.
That is the desired thing, as low as possible. But many times we are unable to reach to that thing. So
it depends on how you communicate with the family, I think that's
okay. So, so this is the titers to start with were 1024 and 128. So we did plex because of various logistic reasons, and so 5 sessions of plex, as you can see in the graph. The titers slowly they came down, and after the 5th session of plex, the lowest titer was 64. IgG was 1:64 and IgM was 1:2. So would you consider transplanting at this titer level on 9th of Jan when the titers were at the lowest possible? And
yeah, I think so, because it's a high MELD patient, so better proceed.
okay. And any difference of opinion from anyone?
Initially began with the high titers to begin with, and he was a high MELD ACLF. We should reconsider at this stage about going ahead with the transplant this way.
Yeah, so we had a similar plan. So on 9th, after the plex, the titer were 1:64:2. As a policy, we do send titers on the early morning before doing transplants. On 10th morning, the titers are rebounded to 1:256 and 1:4, which was strictly against what we think is a good option to go ahead. So what could be the reason for rebound titers or refractory titers? So these are actually 2 questions. What would be the reason where the titers are not coming down in spite of repeated plex or immunoabsorption? And once they come down, what could be the potential reason for going up again?
I think we started with the high titers and we gave 200 mg of rituximab because of the high MELD status. I think we should hit harder at the first place. When we don't, we are a little conservative with rituximab, then this happens and we are wondering why the titers are not coming down. Because all other things are temporary. Plex will only remove whatever antibodies are there in the plasma or serum.
Yeah, but the B cell depletion was adequate as per the CD1920. So again, is CD1920 a good representation of B cell depletion, or are there other sources of B cell which can say put cells in B cells into the stream after transplant? Are there other sources of other lymphoid organs?
Maybe the patient has received products before the transplant or before we contemplated transplant on some other center. So that can be a reason. Or is actually from baseline is immunologically active with the high titers. So that's also possible.
So how many of you would prefer to give a repeat dose of rituximab?
I think it's better to give in this patient repeat.
Okay. So, and coming to this question again, if there is a chance of giving a repeat dose of rituximab, would giving a higher dose of rituximab in the first place itself is a better option?
I think you give 200 mg, it's a good dose actually. For the high MELD, 200 mg is a good.
The house itself is open for any questions right now. So, and how many of would you prefer bortezomib when the titers are not coming down or basically rebounded after coming down? Any experience with bortezomib?
Pre-transplant high MELD bortezomib, I am very scared.
There are good reasons to be scared. I will come up. So we actually gave bortezomib, as you can see from the graph, on 2 days after stopping plex, and patient tolerated it well, and all infective workup was negative before we gave bortezomib in form of cultures and procal. And we repeated a second dose. Our plan was to give 3 doses. We repeated a second dose. Unfortunately, after 14th patient developed severe sepsis. So coming to the plex, Dr. Vijay, what is the replacement fluid of choice in plex when done for reducing titer? Is it the same when you do it for other causes like ALF, or does the choice of fluid have any role in depleting the titers? The choice of fluid that we have is albumin versus FFP.
Yeah, so we don't fully replace the FFP, right? We exchange to 1:1 to 1.5 times the plasma is what we generally replace during the plex. So we don't fully replace the FFP because we don't want to do a fluid overload. We do give albumin along with FFP. That will be the safer choice.
Okay, and another question, like when doing plex, there is, what do you prefer? a combination of like 60-40 or 80-20 of albumin FFP or plain albumin plasmapheresis and transfusing FFP over and above it separately.
The experience for me is usually FFP with albumin is what we generally use.
Always in the this plex thing, the most of the volume is with FFPs only. If at all we have to use albumin, like in ACLF status, when the albumin can be dysfunctional, in that case we can use up to 20% of volume with albumin, but it should never exceed 30% of volume. Whether this giving only FFP has any role in sensitization, that needs to be checked.
Generally, the FFP used is AB positive. Generally, that what is used in AB incompatible. Okay. So again, the take-home message is open-ended. Can we consider that AB incompatible liver transplant should be offered or can be offered to sick recipients only if the antibody titers are low? Can we make a statement like that? AB incompatible transplant for sick recipients or for ACLF, can it be done only if the starting titers are low? Should we have a cutoff?
I think that first point is very valid. Okay. If it is low,
I can remove the query mark from there.
Yeah, definitely.
Okay. So, and
you can have a survey actually.
Yes. There is a lot of debate in ABO incompatible. Different centers have different protocols. And failure to reduce titers or rebound in titers, should it be considered as a contraindication for liver transplant? As an absolute
that's very valid.
contraindication?
Yeah.
Okay. So, any questions from the audience?
I just wanted to make a couple of comments about this case. Thanks, Raj. We wanted to discuss this case because there were so many things which we felt were not what we normally see in the setting of ABO incompatible transplant. Yeah, he was a sick patient. In an ideal world, he should get an early cadaveric transplantation. It doesn't have ABO compatible donor. That's what we need. But unfortunately, we don't live in an ideal world, and this was the only option. The donor looked good. The interesting things were the titers were high, but the CD19 and 20 count even before in desensitization was 0%. So there was actually no, on paper, there were no B cells in this patient at all. So that's the reason why we felt that if we give some desensitization and quickly bring the titers down with plasma exchange, we should be able to do a safe ABO. That was the thinking behind giving the low dose and then doing the plasma exchange. Now, to our surprise, the rebound was much more than what we normally see. Normally, what happens, we do plasma, it comes down to 16. Next day morning, it will be 32 or maybe 64. This was from, I think, went to 256. It actually went up to 1,000. And that's when we just didn't understand what is happening. There are no B cells both before and after rituximab. But having titers jumping like never seen before. That's when I spoke to Abhijit. And then we got we did the plasma cell counts. Okay. And we found that the plasma cell counts were actually very high compared to, so this patient actually had a lot of plasma cells, very little B cells. And unfortunately, rituximab doesn't work on plasma cells. It only works on B cells. And we felt that maybe this is the source for this relapsing titers. And that was the point we decided to give bortezomib. Because we thought, okay, these are the plasma cells which are actually causing this rebound. Maybe if we deal with these plasma cells, hopefully the titers will start coming down. Unfortunately, we could never get to the point where we could bring the titers down. So so this was we've done over 60 ABO incompatible transplants, but we never had a challenge like this before. And I felt that this is something that we discussed, because first of all, no B cells before itself, and a huge rebound, and a large plasma cell pool, which could have caused the rebound. And like I said, like the panel said, I think high titers or rebound titers, probably it is not a good idea to do a transplant. Thank you.
Would doing the plasma cell marker and giving bortezomib in the initial phase make a difference?
No. So what happens is, when you give rituximab, most of the centers, what they do is they check CD19 baseline. You should start checking CD38 or 138, whatever is available as well. Because in the cycle of maturity of cells, from pre-B to B to plasma cells, when you are giving rituximab, at that time, there might be some transition which is happening from B to plasma cells. So some of the cells which have CD20 expression, you block those cells. But the cells which has already matured towards plasma cells, they are left unattacked. And these are the ones which are the responsible factors for rebound antibodies and where the role of bortezomib comes. Now, whatever I've seen in last 10 years in ABO incompatible is the worst possible thing is rebound. You can start with a higher titer, but if once you do a plasmapheresis, never say that, okay, I have reached a titer of 16, tomorrow I'm going to do the transplant. We have stopped doing transplants next day after the plasmapheresis. We give at least 24 hours of cooling period to see if the rebound is happening. Those are the worst performing patients. If you're seeing rebound, don't go forward. Look at all these things. If you have to add bortezomib, there was a question about pre-bortezomib. It works well when you see these CD38 positivity, and you can even look at comparing the percentage and absolute number of cells. If it is increasing, then definitely there are B cells and that is going to cause trouble. And these are the patients, you'll 100% have biliary problems in the coming times if you do these transplants. So bortezomib, 3 to 4 doses, that's what we normally do if we see this CD38 positivity and a rebound happening. And even after bortezomib, the rebound still happens. These are the patients we should exclude, because whatever we are doing, it is like kind of doing a medical splenectomy. The lymph nodes are still creating, working, and it is not working in favor of ABO incompatible transplant.
There is some literature which says that the rituximab will work only on the circulating B cells, and the secondary lymphoid organs can be a source of rebound in titers. How practical is that? Can the second dose, repeat dose of rituximab target that?
So there is a paper by Professor Igawa which talks about it. Repeated dosing are actually more dangerous than a high single dose. So if you have to do it, it's better to give a higher single dose rather than doing a repeated dosing.
Okay. Thank you. Thank you, sir.
We actually did a case with very low titers to start with, which was only 1:8. Even post-transplant also, the titers were always 1:8, and we started triple immunosuppression immediately after transplant. But on day 6 post-transplant, the patient started developing severe rejection. We then supplemented with IVIG, second dose of rituximab, and we started plasmapheresis. But unfortunately, the patient developed secondary sepsis and severe CMV viremia, because of which we could not venture bortezomib in that case. So I would like to say that even though the titers were only 1:8 post-transplant, even then there is a chance of him going into very severe rejection post-operatively.
So, I mean, one thing that we should keep in mind is we are doing ABO incompatible transplant. That does not mean all the rejections are because of those antibodies. I mean, the patient can have a ACR, like compatible transplant as well. So it is not that if you're doing ABO incompatible transplant, you just have to think about antibody-mediated rejection. And antibody-mediated rejection in ABO incompatible is also different from ABO compatible transplant as well. So we have to keep all those things in mind while doing that. And think about plasmapheresis. If we are doing conventional plasmapheresis, I mean, my thought is we should use only plasma and avoid albumin in that situation. And personally, I would want to avoid albumin whenever we are preparing a patient for ABO incompatible, because we are not checking the antibody titers in the albumin levels, so in the albumin which we are giving. So it's better to use a AB plasma in the entire scenario.
Sumna has a question.
When we have this rebound titers, rise in titers, the thought process should also be to look at infections at this point of time, because that itself can precipitate rebound of these titers. What is your take on that?
So the infections.
Like say your titers are coming down and again it keeps rising. At that point, would you really look at if there is infection which is actually precipitating these things, or?
Generally the patient was checked for these infections, because at that point we decided to give bortezomib. So that was the time when we sent cultures and procal, and everything was negative for that case. But we have seen cases where the rebound happens, or I should not say rebound, the titers are found increased in cases of sepsis as well, but it is never so marked. It may be 1 log or 2 log, never like 3 logs or 4 logs. What we saw in this case was almost 4 logs increase from 64 to 256. So I don't think infection if the infection is so significant to cause such a rebound, it would be very apparent from the clinical setting itself.
No, I mean, again, it's not written anywhere, but I feel that when there is a rebound of titers, there may be some subtle thing going on which is not evident on your cultures, or it can be a viral infection which can precipitate these rebound titers. I think that's a thought that should go into our minds
the
when it's happening.
infections can actually mask the rejection. I mean, it can actually coincide with the rejection episode. So high spikes of fever can actually be mistaken to be sepsis along with an ongoing AMR.
Especially when we are talking about these ACLFs with a bilirubin of 29.
Sorry? Thank you.
Next, I would like to invite Dr. Pradeep Krishna to discuss about emergency ABO incompatible disease donor liver transplant.
I thank Dr. Srinivas Reddy and his team for inviting me and giving me the opportunity to present our work here. So, Dr. Saigal and Dr. Rajgopal has made my job easier here. There will be multiple repetitions. I hope, bear with me on that. So, moving on to the patient details. So, our patient was a 38-year-old male, ethanol-related decompensated cirrhotic liver disease with ascites, jaundice, and hepatic encephalopathy. MELD score was 20 and he was blood group O positive. He was evaluated for liver transplantation. His wife was found to be a suitable liver donor. She was O positive, 21-year-old female, BMI of 21. And the right lobe graph 608 grams and the expected GRWR was 0.75. Anatomy was straightforward with a single artery, single portal vein and one V5 and V8. So he underwent right lobe LDLT. The GRWR was 0.70. HTK solution was used to flush the graft. V5 and V8 reconstructed on 8 mm PTFE with a common outflow. So cold ischemia time was 133 minutes and the warm ischemia time was 27 minutes. He received 6 units of PRBC transfusions. So he was reasonably stable through the surgery with moderate requirement of inotropes. Urine output was good, but the lactate clearance was poor. The end lactate at the end of surgery was 15. Intraoperative Dopplers were normal. So in view of inotropic requirement and the high lactate, he was shifted on ventilator into the ICU. So on post-op day 0, so he was worsening with increased inotropic support, hypotension. He was sensorium was poor, and urine output was dipping with 40 ml per hour. Peak lactate went up to 17, and INR serially increased to 8.84, and the peak enzymes AST of 2052 and the ALT of 1984. Dr. Vijay, your comments at this point, what do you think and what would be your approach to?
So this patient is going in towards PNF. So once we diagnose PNF and once we make sure that there is no vascular etiology for the cause of the PNF, then we have to plan a retransplant first, and then we have to, if possible, do an emergent graft explant. And we have to change the disrupted physiology, starting from we have to support the synthetic function of the liver. We have to maintain sugars. Then we have to change the NR based on the point of care test. Then we have to also supplement the metabolic function of liver, by removing ammonia and urea, so that we avoid any cerebral edema. We maintain sodium on the higher side to avoid cerebral edema. Then we also we do start CRRT to actually maintain the acid-base status as such, and coagulopathy.
Sure. At this point of time, what is the Doppler for?
Most important is we actually we have to maintain normothermia, near normothermia, so that we don't have any the adverse effects of hypothermia.
This is the POD1 of the surgery. So what was the Doppler like at this point of time?
So Doppler both
artery, portal vein, UMHV.
Yeah, intraoperative as well as the postoperative day 1 Dopplers were normals. So Dopplers were normal, like Dr. Vijay mentioned, all the supportive measures were initiated. He was started on CRRT. So he continued to deteriorate through the day, but post CRRT, the lactate came down to 9.9. So patient, we just sent blood cultures and other, viral markers. Everything came out to be negative, and patient continued to be unconscious with worsening lactate, persistent acidosis, hypotension with high inotropic support, liver enzymes were high, INR was high, and there was decreasing urine output with rising creatinine. So as we discussed earlier, so with this picture, we considered it as primary non-function of the graft and decided to list him for retransplantation under super urgent category. We had a discussion with the family and there was no compatible, suitable donor available. So we had to wait for the deceased donor organ.
Can I just make a quick question? You know, it's fairly unusual to have like a PNF on day one without a technical issue. It's also like worrying to go for another graft if you don't know why the first graft failed. So I just wanted to figure out, like, was there anything else you were thinking?
So we did, whatever we had in our hand was imaging. Doppler was normal. He was very unstable.
The
so we
CTA?
shifted to the CT.
Okay.
And he was on high inotropic supports. Probably, yes, we could have considered CT on the night of the transplant when lactate was going up. Unfortunately, we missed that window. We went on high inotropic support to be shifted to the CT. So other than that, we couldn't find anything else that could be, any correctable cause. So he was deteriorating fast, so we considered it as primary non-function. And post listing him for super urgent listing, we had an A positive organ, in-house organ. They were A positive patient. Brain dead declaration was there. So Dr. Chandan, your thoughts? Suspected PNF.
Super urgent listing, A group. I think it's still we should proceed. We can do the ABOi incompatible.
Yeah. So we did look at the A1 versus A2 debate. So unfortunately, it was again A1. So our thoughts was to go ahead and look at the other data in terms of, we already discussed the importance of baseline anti-A titers that would make our job easier in kind of desensitization protocols. So we went back and looked at his pre-operative samples that were collected before the right lobe transplant. So the baseline pre-operative anti-A titers were 1:128, and the titers at that point after the right lobe transplant were 1:64, probably secondary to the bleeding and the blood transfusions he had received during the initial procedure. So it was 1:64. So this was encouraging, and we also looked at the baseline CD19 count. It was 21%. So with all this data, we decided to go ahead and consider this organ, as there was no other organ available and patient was deteriorating. So, Dr. Dheeraj, what's your policy in Andhra Pradesh? Or do you have the organ allocation policy that across the blood group deceased donor organs are allocated in your state? Or?
So this definitely needs super urgent listing and needs a transplant. But then the policies are there in US and UK. They have a well-defined criteria for PNF and listing criteria. Enzymes more than 5,000, high INR, high lactates, and acidosis. This is a criteria for them. But for in India, I'm not aware, and we have different practices across state.
Yeah. So
I don't think we have any cross-listing criteria in our state as of now for super urgent.
Sorry.
I don't think we have any cross-listing criteria as of now for super urgent where we can cross-list for a patient with different blood group in super urgent.
Yeah. No, so it's not. We don't even. Nowhere, I don't think in India anywhere it's a policy. Even in our state, this is not the policy. But then we had discussions with the liver advisory committee. I think Dr. Sonal is here. He was heading the liver advisory committee at that time. So we had discussions with them and explained them the situation. And this organ was from in-house. It was from our own hospital. So this was not affecting the rota. So considering it as one-off situation, they gave us permission to go ahead with the transplant. So we decided for going ahead with ABOi incompatible deceased donor liver transplantation. Now coming to the desensitization protocol, what would be your approach at this point? What would be the desensitization protocol?
This is a case of primary non-function and then retransplant and then ABOi incompatible DDLT. These are all very intriguous factors. Okay, and we don't have enough time to desensitize now because on one end the patient is rapidly deteriorating. So what we do is that we can give rituximab on day 0 and Before that, we can start plasmapheresis, because with plasmapheresis, rituximab can get drained off. So first do plasmapheresis and then give the shot of rituximab.
Agree, sir. This was we thought on the similar lines. So we went ahead with double volume plasma exchange and achieved target anti-A titers of 1:8 prior to the transplantation. So if we look at the various protocols that's been practiced across the world in emergency ABO incompatible transplants, including both LDLTs and DDLTs. So the commonest thing you see across the various teams is rituximab, whether it is 48 hours prior to the transplant or on day 0 post-liver transplant, and perioperative plasmapheresis to bring down the anti-A titers, and post-operative triple immunosuppression. So considering basiliximab and IVIG, this varies from team to team. Few teams have considered basiliximab and IVIG, but it is not uniform across various teams, even in emergency situations. Dr. Mathur, your thoughts on splenectomy in this scenario?
I mean, your patient is like high pressure, is unstable. I probably would just like go roll the dice with rituximab, IVIG, and triple immunosuppression and see where we go.
This is exactly how we thought actually. He was on high inotropes and high inotropic support. He was unstable and he had large splenorenal collaterals. So in view of this, we just went ahead with deceased donor retransplantation with caval replacement technique. So the right lobe graft appeared pale, it was fatty and shrunken. The hepatic artery, portal vein and hepatic venous anastomosis were patent. But the V5 reconstructed on the PTFE graft was thrombosed. Apart from that, rest of the things were normal. The histopathology of this right lobe graft showed multifocal confluent and submassive necrosis with around 60% microvesicular and macrovesicular fatty change. The C4D staining for this was negative. So post-operatively, I mean, there was no significant reperfusion syndrome intraoperatively. Patient was improving, the inotropic supports were coming down, and urine output was better, the lactate was decreasing. And he received, post-reperfusion, we gave him a dose of 3.5 mg of bortezomib. And after the surgery, 6 hours post-surgery, we gave him rituximab of 300 mg. I think we have discussed enough about the role of bortezomib in the previous discussion. So basically, this approach was influenced by a publication by Chen Li et al., wherein they had a quick preparation for ABO incompatible transplants. This was primarily for living donor transplants, but we followed this protocol wherein it consisted of bortezomib of 3.5 mg injection to deplete the plasma cells, and the plasma exchange to achieve isoagglutinin titers of less than 1:64 prior to transplantation, followed by rituximab of 375 mg per meter square on post-operative day 1. So this was the basis for our the desensitization protocol what we followed.
Yeah, but then if I can ask, like the donor parameters, the BMI was 21 for this donor, the first transplant that happened, and also the GRWR was 0.7. Yes. So yeah, GRW was slightly less, and the donor looked lean. I don't know about the graft, but the biopsy shows small, the 60% of microsteatosis and small for size syndrome. So like, although patient was behaving like PNF, should waiting for some more time would have helped us if this was small for size syndrome or IRI.
Yeah, I mean, small for size syndrome on day, basically, see, to begin with, the graft never appeared to be functioning from the intraoperative period, actually, increasing inotropes, increasing INR, moving on for even renal dysfunction, poor sensorium, all these things were there, and probably, yes, if there was no organ offer, it could have given us a time to assess, and see where it goes, but then with this critical picture there, and with the organ available, we actually didn't get time to, give it that much time and assess what about the organ functions. But regarding the steatotic change, what we have seen is like what we see in acute liver failures. The liver dysfunctions, they usually lead to severe steatosis. Even we have seen this in even other severe allograft dysfunction as well.
I'll just make a comment on that. Microvascular steatosis is not uncommon when you have like some liver injury. It usually doesn't have any impact on the liver function. There's a lot of DDLTs that have, the donors have a bunch of microvascular steatosis. I've used up to like 95% microvascular steatosis grafts to find. It's not an indication of function at all.
Agree. But anyway, this was the finding that's seen in the histopathology post removal of the graft. So So post-retransplantation, first 2 days were good, the graft functions were good, and day 3, patient became conscious and oriented. He was, inotropes were tapered off, he was hemodynamically stable, he was extubated, and urine output was good. So day 3, his titers jumped to 1:16. So we did a plasma exchange in that, and day 4, even on plasma exchange, titers jumped to 1:64. So we repeated a dose of bortezomib of 3 mg on day 4. So all well until now, and then post-op day 5, there is derangement in liver function test with bilirubin jumping up to 13, AST of 139 and ALT of 146. The titers were 1:128. Dr. Chandan, any comments at this point?
I think we should continue plex.
Sorry?
Reduce the titers to less than 1:16. We should continue.
Yeah, so this was an issue, with liver dysfunction, titers going up to 1:128. So we suspected it to be an AMR, although we didn't do a biopsy. We immediately switched from plasma exchange to column immunoabsorption. Glycosorb column immunoabsorption was used. And we also started him on IVIG at a dose of 0.4 gram per kg for 3 days. And pulse steroids were also given. Dr. Mathur, is there any role of splenectomy as a salvage at this point?
I think it would still be like a little bit challenging. You could try like just a splenic artery embolization and see what that does, rather than going for a surgical.
No, you could have done splenectomy during the transplant, no? Retransplant.
During the transplant.
Yeah,
So during the transplant, like Dr. Mathur mentioned, he was very unstable hemodynamically, and there was a lot of splenorenal collaterals. We thought that might add on to the morbidity. And,
No, during the second transplant, maybe splenectomy could have been done at that time, intra-op.
During the retransplant.
During the
retransplant also, he was very much unstable, sir. So we did not consider at that time. And now at this point, so the role of splenectomy did cross our minds, but then we went back and repeated the CD19 counts, but it was 0.26% on post-operative day 6. So the target CD19 counts were achieved, and we waited for next 2 days wherein, luckily for us, the titers came down and the graft functions improved. So titers gradually reduced to 1:32, and the liver function test gradually settled. On post-operative day 9, we had to repeat a plasma exchange, and by day 14, the titers were 1:4, and graft functions had settled. So the patient was discharged on post-operative day 16. Regarding the splenectomy as a salvage, I have an experience in my past institution where we had done an A2 to O transplant without desensitization protocols, but then unfortunately the patient did develop rebound titers post-operatively, and he also had liver dysfunction of the graft, so did not respond to column adsorptions and all that. So on post-operative day 10, we had to go in and do an emergency splenectomy, post which his graft functions settled. So there is a role for splenectomy as a rescue therapy, provided our CD19 counts are not, we hadn't achieved target CD19 counts, or if still despite of CD19 counts of less than 1% if the graft functions are not settling. But luckily for us, the graft functions settled, so we did not consider that. So this is the timeline of various events of management in this patient. So this 20 months post-op, he is doing well with good graft functions. The recent LFTs are normal with a bilirubin of 0.8 and enzymes AST of 24 and ALT of 28. So it's a brief review of literature on the emergency ABOi incompatible deceased donor transplants. Quickly, I'll just finish quickly. So ABOi deceased donor transplants, the Western world has reported this from 1990. 2.6% of adult liver transplants done in US were ABOi incompatible emergency transplants, and but the outcomes were not up to the mark that time. Although the pediatric transplants were okay, the graft functions were comparable between the compatible and incompatible transplants. When it came to adults, the graft survival was poor in ABOi incompatible transplants. In the emergency category I'm speaking about. So the reason behind this was most of the teams did not follow a uniform protocol, and mostly they didn't use rituximab or splenectomy as a part of their protocol. So the teams which just depended upon the plasmapheresis pre-operatively and post-operatively to achieve the anti-antibody titers. But then they had the rebound of titers post-operatively. So the first successful publication on emergency ABOi deceased donor transplants were from Hanto et al. And group in 2003. So they had pre-transplantation and post-transplantation plasma exchange and splenectomy and quadruple immunosuppression as their protocols. So the 1 and 5 year patient survival and graft survival rates were 71% and 61%. So they were comparable to the ABO identical groups. There was no incidence of AMRs in this in this set of patients. So this, again, there was an editorial by Mayo Clinic in Transplantation Journal where they assessed the data published by the successful ABOi DDLTs, and they also concluded that this should be considered when the blood group compatible donors are not available in critically ill patients with fulminant hepatic failure. This was another publication from Newcastle. I think Dr. Srinivas Reddy is the author of this paper, where they did this in 2007 with the desensitization protocol of perioperative plasma exchanges, and they also used rituximab, splenectomy, IVIG, and basiliximab. With this, I think this patient also did well. This was in 2007, and recently in 2022, the Scandinavian Journal of Gastroenterology, they published 20 cases of ABO incompatible deceased donor transplants using rituximab and basiliximab as the desensitization protocol with perioperative plasma exchanges. They did not consider splenectomy. Most of the centers, splenectomy is off the protocol now, and even they had very good outcomes with 1 and 5 year patient and graft survival rates of 85 and 78%. So with this experience from the Western literature on ABO incompatible DDLTs, multiple Indian centers are coming up with emergency ABO incompatible LDLTs in pulmonary acute liver failure settings. This is one publication from Dr. Reddy sir and team, and Dr. Vivek Vid's team has published a case series of 3 cases wherein they did an emergency ABOi LDLTs, one following ALF and other 2 following, one following PNF also on the after LDLT. So there's a lot of literature coming up on ABO incompatible LDLTs in emergency settings. And there's enough literature in the Western world regarding the ABO incompatible DDLTs in the emergency settings for this thing. I couldn't find any published literature in the Indian centers on ABO incompatible DDLTs. So I think it's a time where ABO incompatible DDLTs can be considered with a reduced risk of antibody mediated rejection. So the perioperative double volume plasma exchanges, rituximab with or without splenectomy, and triple immunosuppression reduces the risk of AMR. ABO incompatible DDLTs can be an option in critically ill acute liver failure patients. So is it the time, can we reconsider our policy for organ allocation in super urgent listing? That needs to be discussed, and that's a food for thought to look at our organ allocation policy in ABO incompatible in acute liver failure settings. Thank you.
I would say Herculean effort and miraculous escape. It was a Herculean effort and a miraculous escape of this patient.
Thank you.
You made the right decision on day 1.
Thank you.
Next section will be on controversies and challenges. I would like to invite the chairpersons, Dr. Mokka Pranit, Dr. Lata Prasad, Dr. B. Sukanya, and Dr. Manasa. I would like to invite the speaker, Dr. Kaushal Madan, and he will be speaking about tuberculosis in a potential recipient.
Good evening, everyone, and thanks to Dr. Mittu and Dr. Rajgopal for inviting me for this particular meeting. So like the title of the session, controversies, this is a controversial issue, one, because we have very limited data, and second, different centers have been following different policies when managing these patients. So TB in a liver transplant recipient.
So let's look at the burden. This was the WHO 2024 Global TB report. So these are the countries which have more than 1 lakh incident cases, and this is in 2023, with India having more than 2 million cases. And the entire South Asia, you can look, the entire burden of TB lies here. If you look at how the burden has been changing over the last 15 years, there was a definite dip during COVID time, and then there was a rapid uptick, possibly because of under-reporting, during which time all of these cases were missed and then reported later, and a rise in burden of tuberculosis because of that. What about burden in decompensated CLD? That is what we are here to discuss. So a common disease in our part of the world, and when a patient of cirrhosis who's a bit immunocompromised also develops tuberculosis on top. So this was a Danish cohort of more than 22,000 patients over almost 20 years, and they looked at an incidence of 168 per 100,000 person years, and it was found to be highest in men more than 65 years of age. What about Indian studies? I could find this one Indian study of 667 patients who were diagnosed with cirrhosis and subsequently diagnosed with tuberculosis, giving a prevalence rate of 7.3%. And the maximum prevalence was found to be in alcoholics for obvious reasons, followed by viral and followed by cryptogenic and other causes of cirrhosis. Another issue which we deal with frequently is a patient of cirrhosis who has difficult to treat ascites or refractory ascites, and a number of times we are in a dilemma whether patient has a superadded tubercular ascites along with it. So on this particular issue, there was a study from PGI Chandigarh, which was a case control study, where they looked at 20 patients of cirrhosis who had either peritoneal or pleural TB, compared them with 20 patients who had cirrhosis with SBP. And they found that obviously in peritoneal tuberculosis, the SAG was slightly lower, lymphocytosis was higher, polymorphonuclear leukocytosis was lower, total protein was higher in these patients, and ADA was obviously higher. But as compared to general population, the ADA in a cirrhotic patient who develops tubercular ascites is lower. The cutoff has been defined to be lower, and this was the cutoff they defined, and the ADA of more than 26 had a OROC of 93 to be able to diagnose tubercular ascites. And gene expert, which is considered to be the gold standard in patients with extrapulmonary fluid tuberculosis, was found to be positive only in 36%. So a combination of high clinical suspicion along with high ADA and high protein tells us that possibly we are dealing with a superadded tubercular ascites. The second issue which we deal with in these patients, or the challenge, is treating with ATT prior to transplant, because the 3 most important drugs which are required to treat these patients are hepatotoxic. So this is what has been recommended, that in CTP-A or compensated patients, 2 hepatotoxic drugs can be given. We need to avoid pyrazimnide, duration of 6 to 9 months. CTP-B, only 1 hepatotoxic drug should be given, either rifampicin or INH, and duration increased to 9 to 12 months. And in completely decompensated patients, avoid all hepatotoxic drugs, increase duration to, and add modified ATT and increase duration to 18 to 24 months. But there is a controversy here. For example, I usually in a compensated patient give all RHEZ, all 4 drugs, all 3 hepatotoxic drugs, and most of the times you are able to get away without hepatotoxicity. So there are some studies to suggest, to support this practice. So this is a study from Gangaram Hospital of 67 patients of cirrhosis with TB. The regimen they used were CTP-A patient. They started on all 4 drugs. Other combination were RHEO, HEO or REO. And ATT-induced hepatitis developed in 35%, and equally in all groups, whether it were RHEZ or without the hepatotoxic drugs. And in this particular group, none of the patients developed hepatotoxicity. The same study which I quoted earlier from PGI Chandigarh, 27 patients with TB and cirrhosis, 5 patients were given HRZE, and these were the ones who eventually developed ATT-induced hepatitis, but many of them were child's B. So a child's A patient, well compensated, you may still get away by treating with 4 drugs, including 3 hepatotoxic agents. Another issue where we have a lot of controversy is many physicians, hepatologists believe that INH is more hepatotoxic. Some say rifampicin is more hepatotoxic. So what is it? So this was a study I found, a Cochrane meta-analysis of 10,000 patients, adults and children, non-HIV, where they compared different prophylactic regimens where alone rifampicin was used or alone INH was used, rifampicin plus INH versus INH and the other regimens. And they found that when comparing arsin and INH alone, it favored the use of rifampicin, suggesting that rifampicin is possibly less hepatotoxic than INH. But again, it is controversial. Different physicians use different combinations, and some would still prefer to use INH. Third important issue is tuberculosis in a recipient in the post-transplant setting. So these are the routes of infection in the post-transplant. One, the most common being the reactivation of latent tuberculosis. Second being de novo infection in the post-transplant period. Third is donor-derived infection, which is the least common of all. What is the incidence? What is the burden? This was a meta-analysis of 2,000 solid organ transplant. 253 of them were liver. Median incidence rate of 2.37% per year, they would develop tuberculosis. Most of them were extrapulmonary, or a lot of them were extrapulmonary and disseminated as compared to non-transplant patient and associated with high mortality. Another recent meta-analysis, the pooled prevalence of post-transplant TB was about 1% in liver transplant patient, obviously highest in the lungs because you get fibrosed lungs after tuberculosis. And again, a significant proportion of them had extrapulmonary or disseminated tuberculosis. This was one study from Dr. Olet Selvan's group from South India, a retrospective study of 214 patients, 5 developed TB. Interestingly, the presence of unexplained granulomas in the explant liver, especially if they were necrotizing granuloma, appeared to be the only risk factor when they compared with matched controls without TB. So if you look at, if you find granulomas in patients in the explant liver, there is a high risk of developing tuberculosis in these patients. Then I think a very controversial issue of latent tuberculosis in recipient, the issue of to treat or not to treat. This is what happens in the course of mycobacterial infection. There is a mycobacterium TB exposure, 30% get infected. 90% of them are able, by virtue of cell-mediated immunity, to control the disease, form granulomas, healed lesions. What you find on X-ray as fibrotic lesions, some of them are harboring live bacteria but well controlled by the body. This is what is latent TB. 10% develop active disease, and once they develop immunosuppression, either induced or, for example, HIV, these latent tuberculosis patients may form active tuberculosis. So most societies recommend that potential recipients should be tested for latent tuberculosis infection and treated whenever possible. And IGRA, or the interferon gamma release assay, also known as quantiferon gold, is a test of choice for the same. So the question, since we do not have voting pads, I'll just ask for a raise of hands. Do you test for latent TB in all your recipients and give prophylaxis? How many say yes? So no one says yes, so answer obviously is no. So in a high prevalence area, like high endemicity area like India, I think it is very difficult to offer prophylaxis to all these patients, and I'll give you more reasons why it should not be done. One is poor performance of IGRA in these patients. So this is a study from Korea. 21 patients, recipients developed TB between 2008-2017, highest in the first year post-transplant. And then they looked at whether the image positivity was responsible or the IGRA was responsible for development of TB post-operatively. So whether the IGRA was positive or negative, there was no difference in post-liver transplant TB. What was important is whether the imaging showed a positive lesion. Those were the patients who were more likely to develop post-liver transplant TB. So another study, again, 148 liver transplant recipients, 13.5% found to be positive. Active TB developed in 1,100 out of 100,000 recipients, and none with active TB had a preoperative positive IGRA. So it has a poor performance especially in high endemicity area. So it's not fine to depend on this and treat your patients with latent TB. Second, many are not even able to receive adequate prophylaxis. Again, this study suggested that almost 1/3 of these patients discontinued, and the major reason for discontinuation was liver transplantation among all solid organ transplant. And over 4.57 years of post-transplant, none of these patients developed TB, whether they discontinued or continued prophylaxis. So it did not matter. Third, obviously prophylaxis leads to adverse events because these are hepatotoxic drugs. In this systematic review, 2.1% developed reactivation, but 10 times more developed adverse events, and 50% of them were due to INH. So this was a survey from 16 Indian liver transplant centers, and only one center reported treating latent TB infection, and still reported no increase in active TB post-transplant in those with positive IGRA. And the final issue is transplant and treat instead of treat and transplant. So in which situations does this happen? This happens in patients who have ATT-induced DILI and acute liver failure. 70% mortality rate once these patients have developed ATT-induced liver failure. So you have to transplant first and treat with ATT later. Similar issue with ATT-induced acute on chronic liver failure. These are all studies from India which suggested that these form 5 to 11% of patients of all drug-induced ACLFs. So I'll just skip because of want of time. So these are the results of patients transplanted in emergency for ATT-induced liver failure and then treated subsequently. And as you can see that most of these patients were able to have good survival post-operatively. This was a study from India in which 71% patient had a survival once they were transplanted for ATT-induced acute liver failure. In the post-transplant setup, I think again a challenge is drug-drug interactions. Deranged LFTs during the post-op period, you are called upon to differentiate between DILI and other causes of deranged LFT during the post-op period, and management of extrahepatic sites of TB. So again, a question for the audience. For treating TB in the post-liver transplant setting, what is your go-to strategy of choice? A, standard regimen in which you use all 4 drugs to begin with. How many? I think one, and I think one more I'll say. I had a word with Dharmesh. I think he also uses that. Second, rifampicin free. I think most would raise their hand on this. Rifabutin in place of rifampicin. But issue is rifabutin is usually not available, and obviously this is not an option. I'll just finish in next 2-3 slides. So these are the important drug interactions. Rifampicin is a very potent inducer of CYP3A4, of which all these immunosuppressant drugs are substrates, and their levels come down very significantly. So if you are giving rifampicin, you have to increase the doses by about 2 to 5 times the usual doses. Including steroids, you increase by 1.5 times. Rifabutin is also an inducer of CYP3A4, but a less potent inducer. You may have to increase the dose by 1 to 2 times. And pyrazinamide has been shown to reduce the levels of cyclosporin. This is a study which suggested that rifampicin, rifabutin have similar TB clearance rates when compared with each other. So these are my final take-home messages. Managing TB in a decompensated cirrhotic is a challenging issue because mainly of hepatotoxicity with first-line drug. You give 0, 1, or 2 liver toxic agent depending on the stage of the disease. ATT-induced ACLF and ALF are best treated post-liver transplant. You transplant and treat later. Post-transplant challenges, the main challenge is to give rifampicin-free regimen for which you require longer duration, higher risk of graft failures, and higher mortality. Pre-op testing and treating for latent tuberculosis infection, especially in a high endemicity area, is neither protective nor cost-effective and may even be dangerous. Thank you for a patient hearing. And we cordially invite you to this year's LTSI Con, along with debates and controversies in liver disease in November. I think something wrong with the mic.
Hello?
Yeah.
So There's a patient in which everything has been done to evaluate the tuberculosis pre-op, but nothing was found. During operation, you found tubercle on the peritoneum. So when will you start ATT and what will be your regimen?
So I think obviously these tubercles, you would take histopathology, and if they are necrotizing granulomas, you would start with modified, I would start with modified ATT early.
When, sir? Which post-op day?
So maybe within a week.
Within a week?
Yeah.
And
as soon as the patient has been started orally, maybe after a week we can start him on modified ATT. You can start with ethambutol, levofloxacin, ethambutol, ofloxacin, and subsequently add INH, and maybe later, few months, maybe 2 or 3 months down the line, even rifampicin.
One more question, sir. So if we start ATT post-transplant, should we start all the 4 drugs at one go, or has it to be sequential sort of thing?
So that's why I said, that's what I said, that you start with modified ATT to begin with and slowly add.
Sorry, sir, not this patient, sir, generally. Not this patient, any patient.
Post-transplant period?
Tuberculosis. Should we start all 4 drugs at a time if we want to start, or should we be sequential, like one medicine at a time and check the LFTs, then add the second one, and then check the LFTs?
You're talking about post-transplant period?
Yes, post-transplant.
So what I would do is start with at least 3 drugs, which would include either rifampicin or INH, along with 2 other non-hepatotoxic drugs, and subsequently add the 4th one.
Okay, sir, thank you.
Very nice talk, Dr. Kaushal. Any experience on flare of tuberculosis in a partially treated patient after transplantation?
Personal experience, no, but yes, any partially treated patient in an immunosuppressed state can have a flare.
Because we have very less data in the Indian setting in this context.
Right.
If you have no other questions, we'll move on to our next talk.
Thank you.
Our next talk, I would like to invite Dr. Charles Frankel to talk about on strategies for optimizing severe frailty in transplant recipients.
Good evening, chairpersons, and thank you, Dr. Srini and team, for the kind invite. And it's an honor to be here today. I'll be talking on strategies to optimize severe frailty in cirrhosis. Can I have my slides, please? So in next 12 minutes, I'll be talking on how to define frailty in your 6 cirrhotics and how to measure frailty in your practice, and what are the strategies to optimize severe frailty in your cirrhotics. So coming to the definition of frailty in cirrhosis, global frailty is defined as a distinct physiological syndrome of decreased physiological reserve. And here, your patient has got a reduced physiological reserve, and that makes him increasingly vulnerable to the health stressors, and there is adverse health-related outcomes. So when your cirrhotic is robust or when he is frail, and he gets an acute insult and decompensation, in a frail cirrhotic, it leads to a situation where there is adverse outcomes It leads to a situation where the patient goes on to get recurrent infections and patient goes on to get recurrent decompensations till death or transplant. Whereas in a robust cirrhotic acute decompensations, many of the time these patients will recover to a state, to a recompensated state where they recover spontaneously. And when you talk about definitions of frailty in cirrhosis, it's mainly phenotypic definitions. And we know that there's an interplay of malnutrition, sarcopenia, and frailty in your cirrhotics. The malnutrition is defined as an imbalance of nutrients, and it along with immobility can lead to sarcopenia. And sarcopenia, the phenotypic manifestation is as impaired muscle mass. So a sarcopenic cirrhotic with malnutrition and immobility can lead to frailty. And frailty in a cirrhotic is phenotypically defined as an impaired muscle function. So your patients with malnutrition and sarcopenia can have frailty, and frailty is defined in cirrhotics as an impaired muscle function. And why should we be worried about frailty in your cirrhotics? Because it is associated with twofold increased risk of waiting mortality. There's an increased risk of hospitalizations and mortality in your patients on the waiting list. There's a poor quality of life in your cirrhotics, and it leads to higher mortality and poor recovery after liver transplant. I'm sorry, the slides are somehow outside the... And these are two studies from the UCSF group by Jennifer Lai. And the first study, you can see that patients with the frailty has got an increased mortality independent of the presence of decompensating events like hepatic encephalopathy or ascites. So any patient with hepatic encephalopathy or ascites, if they are frail, they've got a twofold increased risk of mortality compared to patients who are not frail. And in the second study, they showed that if we can improve the frailty, by 1 point, then there's an improvement in the mortality in the waiting list. And this is a study by the same group in post-transplant patients that showed that frailty was associated with a twofold increased risk of mortality in your post-transplant patients. And there was an increased incidence of prolonged hospital stay, prolonged ICU stay, and prolonged utilization of hospital resources in patients who are frail. What causes frailty in your cirrhotics? The frailty in cirrhotics can be due to hepatic causes and non-hepatic causes. And we know that we are seeing more and more patients who are elderly in our waiting list, more and more patients who are NASH or metabolic dysfunction related cirrhosis with comorbidities. And we are seeing more and more patients who are very sick in our waiting list. So advanced age, the comorbidities and advanced liver disease, all this predisposed to a very sick, frail patient in our waiting list. And associated with that, it has got the liver-related factors like the presence of DAMPs and PAMs leading to systemic inflammation, leading to a catabolic state. And you have got alcohol-related cirrhosis where alcohol per se can lead to sarcopenia and frailty. And there is decreased testosterone in most of your patients, and there are got multiple endocrine and metabolic dysfunctions in your cirrhotics that can lead to sarcopenia and frailty. So how do you measure frailty in your patients? The classical it has been the eyeball test, but it's highly subjective. There's inter-observer variability, and it's not reproducible. So we need some objective tests, and for assessing global frailty and physical frailty and sarcopenia, there are a whole lot of tests that has been described in the literature. And the American Society of Transplant, they have a expert committee on frailty in liver transplant and small intestine transplant. And they have come up with 4 tests that can be used in clinical practice. And 2 are subjective and 2 are objective. The subjective tests include the Karnofsky performance status and activities of daily living. And the objective tests are the 6-minute walk test and the liver frailty index. Both the Karnofsky performance status and activities of daily living has been validated in inpatient settings to predict waiting list mortality as well as mortality after liver transplant. And these are subjective tests, but these are the only 2 tests that are validated in the inpatient setting for predicting mortality in the waiting list and post-transplant mortality. And 2 objective tests are, one is a 6-minute walk test where you look at the distance that a patient can walk in 6 minutes, and if it's less than 250, it's a severely frail patient, and more than 350 meters, the patient is robust. The most validated test in the outpatient setting is a liver frailty index. It has got 3 components. One is the hand grip that looks at the nutrition. The second is the chair stance that looks at the muscle strength. And third is the balance, where you look at the neuromuscular coordination. And based on these numbers, and you have an online calculator where it gives you the score. The score is more than 4.4, then your patient is frail, whereas the score is less than 3.2, your patient is robust. And the study by Jennifer Lau using liver frailty index has shown that for the same MELD, if you have two patients with a MELD score of 14, and one is frail and one is robust, the patient who is frail will have a twofold higher mortality than patient who is robust. So any patient with, when the patient with same MELD score, the mortality varies if they are frail or robust. So coming to the classification of frailty, again, in your clinic, you can classify it into mild, moderate, or severe based on these 4 scores. And if the ADL, you can use either ADL, KF, Karnofsky performance status in your sick ICU patients who cannot do objective scoring, and in your outpatient, you can use the 6-minute walk test or your liver frailty index. And based on the scores, you can classify them into mild, moderate, and severe. And how do you, coming to the question of how do you optimize your patients with severe frailty, we come to a concept of rehabilitation where it's initially came in surgery, where the process of enhancing functional capacity prior to surgery to improve tolerance of the to the upcoming physiological stressor. So by rehabilitation, you are trying to improve the physiological reserve of the patient so that you can improve the physiological reserve of the patient so that he can overcome the acute stresses of acute decompensation and as well as the liver transplant. And in a context of cirrhosis, we are looking at, by rehabilitation, we are looking at improving the nutrition status, the muscle function, and the muscle mass, so that we can improve the outcomes on the waiting list, we can improve the post-operative outcomes, as well as improve the quality of life of the patient, both pre and post-transplant. And the main pillars of rehabilitation are exercise training, nutrition, and the physiological support. But in addition, in cirrhotics, as I said, you need to prevent and treat the decompensating event, because decompensating events like hepatic encephalopathy can lead to reduced nutrition intake. The high ammonias can lead to further muscle loss. So, and ascites, again, if you have got gross ascites, the nutrition will be poor. So you have to prevent and treat the decompensating events in your patients with cirrhosis. And also you have to optimize the extrahepatic organ functions, as well as you have to take care of the endocrine and metabolic derangements. You have to correct the diabetes, you have to correct the thyroid, you have to correct his hypogonadism, and you have to treat the metabolic derangements like the hypophosphatemia and hypomagnesemia in your cirrhotic. So all these should be tailored to an individual patient. So you have to tailor, you can't just have one size fits all approach. It has to be tailored to an individual patient so that it's feasible, a patient is adherent to it, and the patient has a good outcome. So coming to management of frailty in our practice, so first is the lifestyle interventions. You ask the patient cease smoking, cease alcohol, then psychological support, as well as increase of physical activity. Then you try to restore the liver health. That's the most important. And you treat the underlying etiology, ask the patient stop alcohol, treat your hepatitis B and C, treat your autoimmune hepatitis, treat all the comorbidities, control your diabetes, ask the patient to lose weight if possible, and optimize the management or prevent the decompensating events. You have to prevent decompensating events, so you have to try and manage the decompensating events early, and try to time the tips and transplant before the patient becomes very frail and deconditions. So in your patients with refractory ascites, try to plan the tips early so that they are not in a severely frail state when they go for a tips, and you time the transplant early in your patients so that they are not frail when they go into the transplant. Now coming to the 3 main pillars, first is nutrition. You have to prescribe nutrition to all your patients with cirrhosis, irrespective of whether they are for transplant or not, and you have to get the help of a dietitian in your clinic. Normally in our clinic, we don't measure the indirect calorimetry or direct calorimetry. We go by subjective measures. Like in non-obese, we give around 35 kilocalories per kilogram per day. It may range from 28 kilocalories to 37 kilocalories per kg per day, and that's a usual resting energy expenditure for your cirrhotics, average cirrhotics. But now that we have seen more and more of metabolic syndrome, we are seeing more and more of sarcopenic obesity, and so you might need to get the patient to lose some weight here. If the BMI is between 35 to 40, then you can ask a patient to take 25 to 35 kilocalories per day. And if the BMI is more than 40, then again the calorie intake can be reduced to 20 to 25 kilocalories per kg per day. But mind you, when you're doing a calorie restriction, always get your dietitian on board. Make sure that patient is on adequate amount of protein so that he doesn't lose mass, muscle mass, and always ensure that patient is doing a resistance and a aerobic exercise. So you have to have your physiatrist and your dietitian on board when you are dealing with sarcopenic obesity. The protein intake is normally around 1.2 to 1.5 gram per kg per day. And in critically ill patients, it may be increased up to 2 gram per kg per day. Don't restrict proteins even in your cirrhotics who have got hepatic encephalopathy, grade 3, 4 hepatic encephalopathy. And always time the feeds because cirrhosis is a state of accelerated catabolism. So don't make the patient starve more than 4 hours. You can either have an early breakfast or a late night snack. So depending on what the patient chooses, he can either have a late night snack or an early breakfast. And always take some small snack every 4 to 6 hours to prevent prolonged fasting. The role of BCCA and L-carnitine is controversial. Even though there's good pathophysiological basis and animal studies to show that they benefit sarcopenia, large systematic reviews and meta-analysis don't show any benefit for BCCA and L-carnitine in your patients with severe sarcopenia. You can use them in patients who are on are not maintaining weight in spite of protein supplements and who are not achieving the targets of muscle mass in spite of good protein supplements. Always prescribe the exercise. Don't just say to your patient that do some exercise. Always prescribe the exercise and make sure, look at the safety whether the patient can actually do it and assess the safety before you prescribe exercise. And in your outpatient, you should always prescribe exercise and you should prescribe the frequency, intensity, type and time of exercise so that you can follow it up later and see if the patient is achieving the targets that you have set and whether you need to increase the targets. And if possible, always get a trained physiatrist involved in the exercise prescriptions. And some of the, other than exercise and nutrition, some of the features, hormonal and metabolic targets that are being tried. One is L-leucine and L-citrulline supplements. Again, these are under trial and there are no guidelines to use leucine or citrulline in your transplant, in your cirrhotic patients. And supplementation of testosterone, a single study by Sinclair that showed that supplementing testosterone in patients with cirrhosis who have got low testosterone levels in their blood. The study showed that there was improvement in the muscle mass as well as reduction in the fat mass in patients who were given testosterone. But routine use of testosterone is not recommended because of the increased risk of HCC as well as increased risk of thrombosis in your patients. So finally, we need to, coming to your 6 cirrhotics in the waiting list, we need to have objective frailty tool tests that are incorporated in your pre-transplant evaluation. And based on the objective tests, you classify the patient into not frail, moderately frail, or severely frail, and plan the management accordingly. And most of your severely frail patients, most of these patients are admitted to your floor or to ICU. And all what I said about prescribing exercise would not be possible in these patients. The exercise pattern, that exercise prescription that we discussed are mainly for outpatients and not for your very sick, frail patients in the ICU or in the wards. And what is possible would be to get the physiatrists involved and get them to have active and passive mobilizations, get them mobilized early out of bed and then have chest physios. And some of these patients might need tube feeds because they are not, your targets of nutrition are not achieved by oral feeds. And at times when there's gut failure, you might need a parenteral nutrition. And we might use some of these patients, very sick patients, we might use IV, BCCA or LOLA supplements to improve the muscle mass. And always, in very sick cirrhotics, the rehabilitation has to be continued post-transplant till the patient gets discharged. To summarize, the frailty is common and we need to incorporate tools to objectively measure frailty in your pre-transplant evaluation protocols. And we need to have a plan to have a multidisciplinary approach that includes a dietitian and physiatrists to improve the frailty in your very sick, frail patients. Thank you.
Thank you, Dr. Charles. In a severely frail patient, would you consider that patient for liver transplantation? And if yes, how long do we wait for optimization?
When you talk about very frail patients, most of these patients are ACLF patients who are very sick in our wards. And frailty alone would not be a criteria by which we say no. So we take everything into consideration before we say no. Because most of these patients, ACLFs in your ICUs or in your wards, they can't wait for 2 to 4 weeks for the frailty to improve. And most of the time, whatever said and done, they don't achieve the improvement that you need. But
very nice talk, Dr. Charles. Do you have a sort of, priority for the protein supplement? What kind of, like should be a supplement which is commercially available or the natural one?
I did not get your question.
See, when we are asking them to take proteins, what form? Like, would you like to add the supplements which are available, or we should go for a natural products?
No, normally if the patient can achieve the protein intake by the natural foods, that would be the best. And if they can't achieve only, then we supplement it.
But we should be keeping a tab of it.
Yeah, we should be. That's why we should always, any patient on the waiting list, we normally get the dietitian involved and keep a tab of it.
So the patient with ascites, so you said that we should manage the ascites. So does it include giving albumin periodically and doing a ascitic LVP also? Or just medical management will be enough?
No, the problem with large volume, if the patient's got a gross ascites, most of the patients can't take food. They will have nausea, anorexia. So the nutrition intake will be very poor. So a large volume paracentesis always helps. And there are some studies that have shown that large volume paracentesis reduces the resting energy expenditure also. And there's some controversy about furosemide. That's saying that it increases the muscle loss. And so the dose should...
it is individualistic for each patient. You have to decide, depending upon his clinical situation, how to manage ascites.
Pardon?
Like, it should be individualistic.
Yeah. It should be individualized, but see, most of the patients, I think patients are getting recurrent ascites. I should go for early tips or a transplant before they develop severe sarcopenia.
Okay. And salt restriction?
Yeah, 4 grams salt for all patients. Salt to improve the palatability, because restricting too much salt also will lead to reduced intake. So salt to improve the palatability, the albumin, your diuretics. At times we admit the patient and then put them on terlipressin and albumin infusions to get the ascites under control. But if the patient is not getting controlled or patient getting recurrent, you don't have to wait for refractory ascites. If the patient is getting recurrent ascites more than 3 times a month, then such patients should undergo at least early tips or a transplant.
Thank you.
Charles, that was a nice talk. But have you ever used testosterone in your clinical practice?
No, we don't. We are given it for patients severely cachexic who are not for transplant, and for patients with hepatocellular carcinoma who are severely cachexic. And oral androgens are being used in patients, severely cachexic patients who are for HCC, because I've seen our oncologists use it a lot. Thank you.
Thank you.
Thank you, Chairpersons. And next, for case-based discussions, I invite the panelists, Dr. Krishna Chaitanya, and Dr. Raghavendra Babu, Dr. Shweta Singh ma'am, and Dr. Manas. And I would like to invite the speaker, Dr. Chandan Kumar, to discuss about the case of severe sarcopenia.
Good evening, everyone. At the outset, I want to thank Dr. Reddy, Dr. Rajgopal, and the team for giving me this invite. I also want to congratulate Dr. Charles for the wonderful presentation. He made the job of this case presentation very easy. So on that foundation, I want to present this case. It's a big challenge for all of us. So this is a patient of a 49-year-old gentleman presented with history of fluctuating non-cholestatic painless jaundice of 8 months duration and abdominal distension for 7 months. He was evaluated elsewhere and found to have liver disease. Abdominal distension was incidence and onset gradually progressive, associated with pedal edema. No history of fever, decreased urine output, hematemesis or altered sensorium in the history. History of blood transfusion for anemia for 5 months before. He was a chronic ethanol consumer with last intake 8 months before. No history of any CAM, no history of childhood jaundice, no significant family history. Comorbidities, he was a known case of hypothyroidism on 50 microgram per day. So these were the labs at presentation in our institution. HB of 7.7, total count 6,400, platelet count 98,000, bilirubin 1.7, albumin 2.3, sodium 122. Etiological workup was negative. Room air ABG showed PO2 of 157. Tumor markers were negative. Endoscopy showed small varices, mild PHE. Ultrasound showed shrunken liver, no SOL, gross ascites. 25 urine creatinine clearance was 60. Thyroid functions was 9.16, so it was on the higher side, so the dose was increased to 75. Acidic fluid showed high SAG, low protein, no SBP. Coming to the anthropometry, this was the patient. He was grossly sarcopenic with a distended abdomen. His hand grip strength was only 15 kgs. His liver frailty score was 5.5. He was severely frail. And his psoas muscle index, if you see here on the right side, it was very thin psoas muscle. The psoas muscle index was 2.69. The normative value for this age group comes around 4.7. So diagnosis was a case of portal hypertension, non-bleeders, small varices, cirrhotic, ethanol related, decomposition with ascites, refractory, diuretic intolerant, acute kidney injury, HRS, AKI, severely frail and sarcopenic with a hand grip strength of 15, for psoas muscle index of only 2.69 and liver frailty index of 5.5. So coming to the panel, can you consider transplant in this patient?
So in this patient who is cirrhotic with refractory ascites and complications in the form of AKI, HRS, definitely transplant is indicated. However, the challenges remain in the form of severe frailty and sarcopenia, which is again associated with poor transplant outcomes. However, even in frailty and sarcopenia, waitlist mortality is very high, almost around 50 to 20%. And hence, with good rehabilitation and nutritional optimization, I would definitely offer the patient liver transplantation, explaining the risks of prolonged stay, risk of infections post-transplant, poor recovery, etc.
Dr. Chaitanya?
Even I agree to that, what Dr. Manasa was saying. I think once we have considered this patient as severely frail, it is better to prehabilitate him and then take him to at least admit him in the hospital, do a prehabilitation, and then improve his muscle power as well as the nutrition, and then only consider for transplant. Since we know that the risk of mortality is high, if you take these kind of patients for transplants.
So you prefer to list him for DDLT?
Yes, I would actually, and I'm not sure whether tips will help in this patients to, since it's a refractory ascites and no history of HE, so we didn't find any shunts also. So maybe tips will stabilize him a little, and then the nutrition also can improve a little more in the meantime.
Okay. I have a slightly different opinion. Tips, I would be a little skeptical in this patient with severe frailty and sarcopenia, considering high risk of post-tips encephalopathy in a severely sarcopenic patient. So I would consider also upfront liver transplantation while optimizing the patient.
Absolutely. I'll not go into this, already covered by Dr. Charles. So Dr. Shweta, this is your study. If you can educate the audience on the normative values in the Indian population.
Yeah, so we did a study to see how the cutoffs were different or were they the same, because it was there was literature to suggest that the patients, there was a study from ILBS, and I was a part of that also, in which we used Western cutoffs, and so a huge number of our patients who were going for transplant had sarcopenia. So we thought that, you know, Indian patients having a different muscle mass and different dietary practice, generally we are not so well built. So we should look at our cutoffs. And so we recruited our population from the hospital, the employed people, as well as the donors who were going for, who were getting evaluated for transplant. So we included 500 odd people for assessment of hand grip and functional tests, and for skeletal muscle assessment, we included the healthy donors, and we...
And the liver frailty index also.
Yeah.
So this is an important study for everyone to read.
Yeah, and we found that the cutoffs were quite low, and
Yes.
these corroborate with
Compared
the
to the
others.
Western data, it was lower in the Indian population.
Yeah.
Coming to the pre-op assessment, Dr. Shweta, you want to give any inputs, how to assess these patients for transplant? When, like
If this patient is going for a living donor transplant, I think the maximum confidence comes from looking at the donor. Because this patient is so debilitated. If the surgeons feel that they are getting a very good graft, I think that actually you know, decides in favor of proceeding for transplant. And deceased donor, I think being not, since it's not a split graft, perhaps the same.
So as alluded by Dr. Charles, so this is it's a vicious cycle. So, and as the patient increases sarcopenia, increased frailty, they have more symptoms of more symptoms of portal hypertension, and as the symptoms of portal hypertension increase, the sarcopenia also worsens. So in this patient, during our hospitalization, he presented with AKHRS, and then he developed hepatic encephalopathy. He had refractory ascites, diuretic intolerant. He was so sarcopenic with frail that he was not able to converse and tell his name also during the hospitalization. So, do you think it is futile for transplant, Dr. Chaitanya?
Definitely. I think at this point of time, so I think there is a lot of risk after the transplant also. Post-operative complications in frail patients, in a study has been said that almost like 59% to 35% in frail versus non-frail patients, as well as the liver failure rates are also, graft failure rates are also high, come somewhere around between 21.5% to 4.9%, a lot of difference between them. So considering these things, even the mortality, HR index which suggests the mortality of these patients also are significantly high. So I think considering transplant at this point of time is not a great idea as my concern is.
Dr. Shweta, what do you contemplate issues intra-op and post-op in this patient if we proceed with transplant?
Actually, you're asking me about intra-op, but I think pre-operatively I'm more afraid of hepatic encephalopathy, and you know, this patient waking up as it is, you're saying he's not able to even tell his name, and post-operatively, of course, weaning from the ventilator, perhaps.
So this was the palliative care. I think this patient should be in palliative care. If it is in a DDLT setting, this patient should have been palliative care because, as rightly said by the panel, it's unfit for DDLT listing. So preoperatively, he was severely sarcopenic and frail, refractory ascites. He had chronic portosystemic encephalopathy, acute kidney injury with HRS, prolonged hypotension needing low-dose inotrope. Because he was so frail, he was not able to feed. So he was placed on NJ because RT was not tolerated, and daily chest and limb physio also was done. Now here, there is some new data coming up. Even Dr. Kaushal Madan also asked about this, about role of giving testosterone supplements in these severely frail patients. So this recent data published in Clinical Gastroenterology Hepatology, whereby giving testosterone in these patients, cirrhotics with hypogonadism, it has shown to improve, reduce mortality, reduce the risk of new onset, new decompensation events without increased risk of HCC. There's also some data about home-based frailty interventions using this home exercise equipment and remote frailty assessments, wherein by these interventions, that is by physical rehabilitation, the liver frailty score also improved in these patients. So this was our patient's chart during the hospitalization. You can see here the creatinine increased to 2.6 and then it gradually improved on low dose inotrope, but patient was continued on low dose inotrope because of the low mean arterial pressure. So we explained, we had a MDT in the team and we explained the risk of high risk to the family due to the poor functional status and risk of intraop events and prolonged hospital stay and risk of infections, and family consented and we proceeded for living donor liver transplant. His wife was a donor, so this was standard right lobe transplant, but also feeding jejunostomy was done in this patient. So he was shifted to the liver ICU with a support of 40% and NORAD and terlipressin. He also underwent tracheostomy intraoperatively. So do you agree, Dr. Shweta, about early tracheostomy in this patient?
Yes, it does help in suctioning, and you can assess the patient's response.
And because his his respiratory effort was so poor that we couldn't have extubated him post-operatively.
He was anyways a candidate who might require, and all these surgical complications would prolong the stay.
And as rightly said, he also had post-op bleed, for which he underwent re-exploratory laparotomy and was found to have hemoperitoneum with large intraparenchymal hematoma. After packing, it was after 48 hours, again he was re-explored and the packing was removed. He was started on trickle feeds, FJ feeds, and then increased the feeds. So how do we approach immunosuppression in such patient? This is something very challenging because they're so frail and prolonged hospital stay pre-op. Do we believe in giving delayed immunosuppression or anyone?
I would go with, along with the nutrition rehabilitation, I will also start immunosuppression, but slightly on the lower dosage with regular monitoring and also while monitoring the side effects.
So as rightly said, we delayed the immunosuppression. We gave very low doses. He also had one episode of ACR which he improved with regular chest and limb physiotherapy. Tracheostomy was decannulated and he was discharged on post-op day 20. So this was his blood work. We started with a TAC level of 1 and gradually built up till 7. So take-home message, this was a very challenging case. Sick, severely sarcopenic and frail patient. Preoperatively, he received aggressive feeding with physical rehabilitation. He underwent timely living donor liver transplant with earlier tracheostomy and aggressive physiotherapy, gradual and low immunosuppression. One take-home point here was feeding jejunostomy helped this patient post-operatively, and also he always had a clean chest. There was no chest infection. That was one of the important predictors of this patient's post-op survival. So this is the patient. He recently went to Kumbh Mela also, and he's doing well. He's resumed his work, and his wife was a donor. They are living a normal life. Thank you very much.
I think what I want to emphasize in this case is that early intervention and rehabilitation should be started in cirrhosis patients rather than waiting for intervention until they are severely frail. And also earlier listing for DDLT and liver transplant should be offered at an earlier stage before severe frailty sets in for better outcomes.
Prof.
A very rewarding case, I must say. But I think physiotherapy is extremely important.
Yes.
Pre-operatively, not giving up on these patients, hauling them.
So they were quite motivated. We explained them the risks of intra-op and post-op, and we had to convince our anesthesia team also. They were very worried, but in the end, I think the wife said, "Whatever risk be, I'm ready," because they had twins and young family, small family. So it was more of emotional decision, and actually he improved. It was very learning for us, increased our hope also. Thank you. Thank you.
Since we are running short of time, tea break is now there. People can freely go and take their tea and come in and have that. So, so sir. Session 6, pediatric session. I like to introduce the chairpersons, Dr. Metu Srinivas, Dr. Ramesh, Dr. Nandakishore, Dr. Rajesh, and Dr. Azrar. And I would request Dr. Mohammad Rela sir to talk about challenges of transplanting small infants.
Pardon? What did he say? I didn't get that. Won't come now?
Can I introduce?
Yes, you can. Yes, please.
So it's my absolute honor and privilege to introduce Professor Rela, who doesn't need any introduction. I mean, we all know he's an excellent teacher, clinician, Tamil expert, entrepreneur. But I think at the heart of everything, he's a brilliant surgeon. I think I've not seen anybody who can operate on children with the kind of skill that he does. And so I think he's the best person in my mind who can actually talk about a topic like this, especially transplanting very small children. Thank you, Prof.
Thank you, Srinivas. So the title is Progress Over 30 Years. I think that is something like my career in the field of pediatric transplantation. So I will talk about the progress that I've gone through in the field. So you will see most of the publications are our own publications rather than put everything together, because I've been very much involved in the field of pediatric transplantation. And I have to acknowledge it's King's College Hospital which made me who I am. And I went into transplantation in 1991, that is 34 years ago, and had an opportunity to work with one of the biggest pediatric hepatologists of the time, the only pediatric professor of pediatric hepatology around the world. So we were fortunate. And going back to the earlier days, I think when I first went into King's, we had to wait for a whole organ for children, actually, in 1991. The splits were not being performed, and reduced livers were very rare. Most of them were reduced livers, and we pushed this technique of split liver transplantation. Again, if you see, these are 1998 publications, and showed that we can have good results both for the adults and children with split liver transplantation. I think this is how it came, and again, if 1997 publications for transplanting acute liver failure in children under 1 year of age with 100% survival at that time. But what was a problem in the early days, where really we were doing splits and using left lateral segments into very small babies, closing the abdomen with a silastic mesh, losing a lot of fluid. So when we looked at the first 10 cases of neonates under 3 months of age, the survival figure, if you see here, is only 50%. There was a significant morbidity associated with transplanting very small children under 3 months of age. And they would all be probably 3 to 5 kilograms in weight at that time. And some of them were less than 3 kilograms in weight as well. So this is kind of a situation where you see, where we described the hyper-reduced graphs. This is a newborn child, probably around 20 days of age. And you can see the size of my finger, the size of the abdominal cavity of the child. So very early on, we described what we called monosegment, which really wasn't a monosegment. I don't think it was my idea to describe it as a monosegment, probably. And instantly, when you hyper-reduce a graph, the outcome of liver transplantation for very small children improved. So the next 6 children, only 1 died of a hepatic artery thrombosis. Now, really, we worked at that time, you all know Muriel Kasahara, who's really pushed this field further. And his ideas about these really came from him working with us, basically. And that is him with my colleague Nigel Heaton and Paula Muizan. Paula Muizan is no more. And he's been describing techniques, and we have had constant discussions with him on this field. And one such technique enabled this transplant that you've all heard about, is a transplant in a 5-day-old child. And that's a girl now, 26 years of age now. So she's never had to be admitted in a hospital following her transplant. So I came back to India 15 years ago. You have Dr. Rabindranath responsible for that. And I came here for 1 year, and I was hooked to the system. And this is our pediatric liver transplant numbers from Chennai. This is only the Chennai hospital. And now we are doing more than 100 pediatric transplants a year for the last 3 years. I think this year also we would exceed that number. I think the only time the numbers stagnated was a COVID time, 2020 and 2021. Otherwise, the numbers have been consistently going up. And we have done close to now, I think, 1,000 pediatric liver transplantation in the Chennai center. And this is just accepted the first 700 pediatric liver transplantation done in our center in transplantation. You can see 1 month, 90 day, 1 year, 5 year, 10 year survival of 94%, 90%, 86 and 85%. So the outcome is really comparable to anywhere in the world. Now I'll just give some, I don't know how many of you are surgeons here, put your hands up. So these are, the rest of the talk is just some tips to the surgeons as to, that is what has been given to me, I think, transplanting very small children. Now, when you think about children, the first thing that most people ask you is, oh, the vessels are very small. And that seems to be the challenge, that the artery will be 1 or 2 millimeter. I think the plastic surgeons can do arteries which are 0.5, 0.7 millimeters. So the challenge is not really the blood vessels. It's really the small abdomen, congestion in the gut, in the non-cirrhotic patients, in the metabolic diseases, in acute liver failure, hyperplastic portal vein, completely unpredictable which ones are going to thrombose and which ones are not going to be thrombose. So these are the issues really for transplanting very small children. The first point I want to make is start with an incision. So particularly in the non-cirrhotic ones, if you make a very high incision and you clamp the cava and clamp the portal vein, the gut will become congested. Everybody thinks non-cirrhotic patients are the easiest to do in children. The non-cirrhotic patients are the most difficult to do because they get very rapid congestion of the gut. And if you have made a subcostal incision very high or use an incision which was very high in the biliary atresia operations, the gut congestion pushes everything up, you won't have space to operate. So you make a low incisions like that, just above the 1 centimeter above the umbilicus and transverse, you will see that the gut, even if it is congested, is outside, so you will have room to work on. That's point number 1. Now, cava is not a problem. Sometimes when there is an absent cava, implanting a liver will twist a liver, and if that is a problem, because I don't want to go into the details, because the left hepatic vein is posteriorly draining, not superiorly draining always. Sometimes it can be superiorly draining. If it is posteriorly draining, you may want to replace the retrohepatic IVC, and that once you've replaced with the retrohepatic IVC between the right renal vein and the confluence of the 3 hepatic veins, that makes it a very standard operation subsequently. That is point number 2 for hepatic vein. What about portal vein? I think portal vein problems are a real problem in very small children, particularly in biliary atresia. The preduodenal portal vein congenital anomalies actually are not a problem. The preduodenal portal vein has never been a problem. The real problem is the atretic portal vein that you see. And you see more atretic portal vein in children who have had Kasai operations than I found in those who haven't had the Kasai operation. And here you can see that the artery is actually bigger than the portal vein in this child. And this child, if you don't deal with it properly, will have a portal vein thrombosis. And when you take a cross-sectional image of the portal vein, they've got a very hyperplastic intima, and the intima itself is very irregular, and you don't see it when you're putting bulldogs on them, what is inside the blood vessel. The way to do is, these are just tips. Positioning I should have talked about first. Don't use cautery, because if a small blood vessel, if the burn goes through the wall of the blood vessel, if you have a burn on the inside of the blood vessel, particularly the portal vein, you will get platelet plugs sticking to a point where there is a burn, and you will surely get a portal vein thrombosis in those patients. I put sandbag. I don't know everybody. I always put a sandbag in the back and arch the back, because that brings the porta hepatis forwards, that brings the artery upwards. Particularly in living donor liver transplantation, where the vessels are very short, you have an arched back. The L1 is pushed forward, the celiac is anterior, so the anastomosis becomes easier. And small children, again, hypothermia is a problem, so don't operate. I always find people are operating with wet pads on the abdomen. They never take the wet pads and throw it out and put a dry pad once again. So if you have wet pads on the abdominal wall and on the small bowel all the time, you get cooling from evaporation, and the children will get hypothermic. So that's simple things that you need to think about. I can't move it any further. Portal vein thrombosis in biliary atresia is probably 15% or even more if you count the intraoperative thrombosis. The 15% is probably people report only the post-operative thrombosis while you're doing the operation. Quite often, at the end of the operation, you find that the portal vein is thrombosed. But the only point I want to make is if your portal flow velocity is around or less than 15 centimeters, you have to redo that portal vein. Don't accept a portal vein velocity of less than 15 centimeters, because the next morning you will have to bring the child back. And you will find that artery always protects in biliary atresia. If you've got an artery which is patent, portal vein thrombosis for 24 hours is not a problem. I've never had graft dysfunction because of portal vein thrombosis in these children. We've seen this. Am I going backwards? Yeah. The next problem that you often encounter in small children, particularly biliary atresia, is bowel perforation, probably around 10% in these children. But the only thing, and most of them are not very symptomatic because they are ventilated or they are on steroids. They don't have peritonism when they have bowel perforation. Sometimes you get some murky fluid coming through the drains. You have to have a high index of suspicion. And then when you have operated on them once, the risk of reperforation is almost 50%. So you really have to be very vigilant that you're watching these children for reperforations as well. The common other problem is difficulty in extubating children, very small children. And again, it's a technical issue. We published this many, many years ago. If you look at that image, the right front, so if you really carefully look at it, you can't see it, it's too bright. On the top of the cava, there is a right phrenic nerve, and the right phrenic nerve is here. So when you put a clamp, you get neuropraxia. They always recover, but you get a right diaphragmatic palsy. Right diaphragmatic palsy in small children is very common. So if you can dissect it out or not dissect at all and put a clamp from the left side, you might avoid damaging the right phrenic nerve, or you won't divide it unless you've diathermy burn on that. You might actually divide it completely. And that's one of the common problems in very small children for weaning them off the ventilator. And finally, coming to the large fasciitis, this is probably what Srinivas wanted me to talk about, and I'll finish with that. Ideal volume is really more than 2%. Unlike in adults, it's more than 0.8%. Children need double the volume of the graft. But because most children are under 1 year of age when they are transplanted, most of them will have a GRWR of more than 3. So large fasciitis graft is a bigger problem in children than small fasciitis graft. One of the things that I want to go back really into the history of these things is when we were doing splits, or even now in the deceased donor, we have the luxury of living donor, we have the luxury of doing volumetry on patients. But when you're choosing to do a cadaver organ and a split liver for a child, you can actually work out if the weight difference is 15 times for a child between the donor and the recipient. you probably have to do a hyper-reduced graft. So a 5-kilogram child, if the the donor is more than 75 kilogram, you probably need a hyper-reduction of those grafts. So this is how we used to calculate. I'm just saying it may still be relevant if you're working on diseased donors. And the techniques really, if it is GRWR of greater than 5, I would say, would do a reduced graft. And I just went back and saw, I'm surprised that the first ever paper I wrote, I used the term non-anatomical reduction of liver allografts, actually. This is before the publication that you see here in surgery, where we renamed it monosegment. In fact, it is not monosegment. Subsequently, people have realized what we described is not monosegment. It's a non-anatomical reduction. I still believe non-anatomical reduction is easier and better for most of you to do than the anatomical reduction that Kasahara proposes. And Kasahara proposes GRWR of greater than 4 for a hyperreduction. We propose 5. I think Srinivas Reddy also wrote a paper claiming that's not important. And he said that anatomical reduction is also important, Kasahara, but we believe anatomical reduction is always not necessary. And there is our own, say, the myth of 4. You don't need to actually hyperreduce a graft. Most often, the GRWR is usually between 4 and 5 in these children. Less than 4 is rare to see as well. So majority of them won't require a hyperreduced graft. We moved on to monosegments as well. Robotically, we can actually do this monosegmental graft. I think we have done 7 or 8, but nowadays we prefer to remove the liver and do it because it's, I don't know if the hyperreduction in situ, I don't know. Is that bell asking me to stop? I think it's gone off a few times. No, I just need to know I can stop. I've just about taken 15 minutes. This bell has been going off for the last 5 minutes, I think. 2 more minutes. So I'm just going to show you a video of the first robotic liver transplant in a child. It's not a small child, but this is the first time it's being shown to an audience. I don't know if you'd like to watch it for 2 minutes. How do I start this? I'm clicking on it. Oh, you have to remove the... you have to take the thing off. Take the pointer off. If you take the pointer off and click on the top of it. Yeah. I'll stop after this, Srinivas. You want to watch this or not? So that's a robotic, this is an auxiliary robotic. And I mean, the point of this is that anything can be done robotic. If you do auxiliary robotically, I'm sure you can do others. But still, I think we've been trying recipient operation, both adults and children. It's not as easy as a donor, actually. So that's a common hepatic artery mobilized. Left hepatic artery is ligated there. Sometimes we anastomose directly to the common hepatic artery. That's a left portal vein. And then we do a left hepatectomy. How can I move this? That's the left and middle vein together, slung there. That's the cava, short veins being taken off. I think it's only a 2-minute video anyway, 1 more minute. So the left lobe, including the middle hepatic vein, is removed. And that's left bile duct is divided. I'm doing a duct-to-duct in this child, even though it's an auxiliary. That's the final bit of the hepatectomy. That's the left and middle, liver hanging by the left and middle. So taking the left and middle separately so that I can put a clamp. You can't put a clamp until you open the abdomen and make a fan and steel and then put a clamp. So we are narrowing the portal vein to the right side, removing the liver, fan and steel, and then push it through the fan and steel. Yeah, these are the difficulties in robotic because you have to literally pull it together. The liver falls off. Somebody has to push it up and can easily tear tissues. The anastomosis is not as beautiful as an open operation, I have to say. These are PTFE sutures. The prolines can be damaged very easily by the needle holder. So that is being flushed and completed. The hepatic vein is completed, and that's the portal vein. So robotically, actually, you can actually do the operation even better, particularly the arterial anastomosis, the bile duct anastomosis can be done better robotically than even open, I believe. I mean, keep the suture line quite loose before tying it. And the clamps removed from the left hepatic and the portal. I'm tying it after opening it. And that reperfused really nicely. You can see how the left portal vein looks really nice. Narrowing the portal vein. Actually, the arterial anastomosis and bile duct anastomosis are probably the easiest in a robotic surgery. Microvascular surgery can be done extremely well in robotic. I find, and also the advantage, why I'm saying it's easier is you have all the time to do the arterial and bile duct anastomosis. Unlike portal vein and hepatic vein, you're running out of time, aren't you? You can't take too long to do that because of warm ischemic time. Whereas artery and bile duct, you can take all your time to do it. So I opened and found a small hole and just closed it. And did a duct to duct directly. And that's it actually. And that's the child and that's the scar. And that's the child was discharged on day 7. This child was discharged on day 7. And I leave you with 500 pediatric liver transplantation. A significant number of these children have been funded by the government. I think most of them have been funded by the government. Thank you very much.
Thank you so much, sir. I'd like to mention I'm extremely honored to share this space with one of my mentors. I was in Renal Hospital for my fellowship in pediatric hepatology.
Thank
you. If we need any questions.
I don't think there is time for that. Thank you.
Next, I would like to invite Dr. Prashant Bachchana sir for talking about role and timing of liver transplantation for metabolic liver disease.
In the interest of time, till he loads the presentation, I'll start. So I have only 15 minutes to talk about a vast topic like role and timing of liver transplantation in metabolic liver diseases. To start with, what is an IEM? There are many fancy definitions, but I'll simplify it. It's exactly what it sounds like. An inborn means child is born with it. Error is a loss of function in the metabolic pathway, and metabolism is breakdown of steps from food to create energy. So it is as simple as that. And the overall incidence, we think that metabolic diseases are rare, but if you look at in the perspective of biliary atresia, which is 1 in 20,000, there are some, if you took the collective metabolic load, it is 1 in 800 to 1 in 2,500 live births. The international classification of inherited diseases, metabolic diseases, which they like to call it now rather than inborn errors of metabolism, has included 1,450 disorders, which are categorized into 24 groups and 124 groups. If I show you a pictorial depiction of that thing which I mentioned, it will look pretty overwhelming like this. Coming back to the IEMs, so you have a substrate, you have a cofactor, coenzyme, or a transporter which is supposed to work and conduct with the remaining part of the pathway, and if it doesn't do it, the end product is not delivered. So what it leads to is a substrate excess, toxic metabolites, and a lack of the end product. So what do we have so far in terms of management? We can reduce the substrate load by dietary restrictions. There are some enzyme replacements that can be done, some cofactor replacements. Gene therapy and chaperone therapy is in research mode. So what is left is organ transplant. So today we'll be talking about liver transplant for non-cirrhotic metabolic liver diseases. What is the role of liver transplantation in inborn errors of metabolism? It provides the crucial enzymes to create a metabolic balance, which in turn improves the quality of life, and that means no dietary restrictions and better crisis management, less hospitalizations, and that all leads to being a more cost-effective therapy. So why liver transplantation for metabolic liver diseases? First of all, the diet is very difficult to adhere, not to mention the cost. Even if someone is good at adhering to the diet and affording the cost, you are still liable to get metabolic decompensations from intercurrent illnesses or stressors. And also, diet cannot prevent progression of extrahepatic manifestations like carcinoma in the case of GSD1, adenomas in GSD1. And the most important thing is, it is very difficult to get hold of good metabolic specialists who can monitor these kids on diet, and these kids cannot just be left on a diet. They have to be monitored. Plasma amino acids, organic acids have to be monitored and titrated likewise. So, pediatric liver transplantation, which has been a well-established modality for end-stage liver disease, chronic end-stage liver disease, acute liver failure, is also good for metabolic liver diseases with hepatic consequences and extrahepatic manifestations, with the primary being in the liver, primary source being in the liver, and it helps in prevention of carcinoma as well in the future. So hepatic-based metabolic disorders which are suitable for liver transplantation. Disorders with primary liver consequences, which is alpha-1, Wilson's, Crigler-Najjar, tyrosinemia. Disorders with mainly extrahepatic consequences, the urea cycle defects, organic acidemias, hyperoxalurias, glycogen storage disorders. And there are a set of metabolic disorders which do not do very well after liver transplant, and that is familial hypercholesterolemia, erythropoietic porphyria, organic acidemias partially, and mitochondrial disorders. So now coming to the business end of the talk, which is role and timing of liver transplant in specific IEMs. Maple syrup urine disease is a rare autosomal recessive disorder with a worldwide incidence of 1 in 185,000 live births. In the Mennonites, it is almost 1 in 380. In the Portuguese Romani population, it's 1 in 70, and in India, it is 1 in 100,000. It's caused by a deficiency of an enzyme called branched amino acid dehydrogenase. There are four varieties of MSUDs, and the classical one is one which presents with fatal neonatal encephalopathy. I can skip this. So emergency liver transplant is not indicated. On the contrary, it is dangerous to do an emergency liver transplant because you will increase the metabolic and catabolic stress on the patient. Elective transplant is recommended in children with recurrent crisis or at risk of neurological injury, despite optimal medical management. Earlier transplantation is recommended for better neurocognitive outcomes and considered around early childhood if crises are frequent and control is poor. So if you have a stable patient, you can continue diet, monitoring the patient, and liver transplant should be offered electively if the quality of life is poor and you find that there's a risk of developmental delay or developmental damage. Unstable patients will go for direct listing for liver transplant. Family counseling is very crucial, saying that, okay, liver transplant will eliminate the dietary restrictions, but it also carries the risk of surgery and the long-term immunosuppression side effects will come along with it. Then comes the urea cycle defects. These are a set of 4 enzyme deficiencies which can cause life-threatening hyperammonemia. Management of the urea cycle defects includes protein-restricted diet, supplementation of amino acids like arginine, amino acid scavengers, and like we all know that liver plays a primary role in ammonia detoxification, and hence liver transplant has been successful in treating urea cycle defects. So what does liver transplant do to urea cycle defects? It provides a permanent source of the missing enzyme, which in turn reduces the ammonia, and corrects ammonia metabolism, preventing hyperammonemia, crisis, and neurological damage, improves quality of life, and the best outcomes come when it is performed early before the irreversible brain injury sets in. Emergency liver transplant rarely performed with acute hyperammonemia crisis due to high perioperative risk, stabilization with dialysis and scavengers, and then prevent post for elective liver transplant. What are the indications for elective liver transplant? Recurrent hyperammonemia despite optimal medical therapy, biochemical instability requiring frequent hospitalizations, severe dietary medical therapy limitations causing quality of life restrictions, considered in early childhood, especially less than 2 to 3 years before the school-going age, so that we can control the diet better. I mean, liberalize the diet better, because once they go to school, you never know what they're going to eat. And better performed before the occurrence of neurological injury. So again, the lifelong immunosuppression risk has to be weighed with the metabolic disease, the dietary restrictions that can be removed, and this should be discussed with the family. Glycogen storage disorders. These are a set of disorders of carbohydrate metabolism, can manifest in the muscle and liver. GSD1A is the most commonly transplanted disorder caused by deficiency of glucose 6-phosphatase enzyme. And the medical therapies so far we have are frequent feeds, uncooked cornstarch, high protein diet, and avoiding of fasting. So what are the indications for liver transplant in GSDs? Metabolic complications, which is with uncontrolled by diet, which is significant hypoglycemias. Some can even have seizures, hyperlactatemia, hyperuricemia, hyperlipidemia. Progressive liver disease, cirrhosis, portal hypertension in the case of GSD4 and some GSD3s. Hepatic malignancy, hepatic hepatocellular adenoma common in GSD1, and quality of life issues, especially poor metabolic control, poor growth, and feeding intolerance also are a very common indication for liver transplant in these set of kids. What happens with liver transplant? So you give a liver transplant and you correct the enzyme that gives better glycogen metabolism, better glucose control, prevents hypoglycemia, seizures, and you have a better metabolic control, and in this in turn will improve growth, quality of life, in the long term reduces the risk of malignancy, and certain extrahepatic issues might remain, especially myopathy in GSD3, renal disease in GSD1, they might persist post-liver transplant. Emergency liver transplant is indicated only for GSD4 when they can present like liver failure. And like we discussed, in GSD1, if there is adenomas which can most likely progress to carcinoma, they are the ones who have to be listed for transplant. Early liver transplant improves growth, nutrition, and prevents long-term complications. Then moving on to Crigler-Najjar syndrome. It's a disorder of bilirubin metabolism which is caused by deficiency of UDP glucuronidase transferase. Type 1 is complete absence of the enzyme, and this is the one which is dreaded, causes kernicterus, needs to be managed aggressively. So this is role of liver transplant in Crigler-Najjar is you provide the permanent source of the enzyme, which in turn will liberate you from phototherapy and prevent kernicterus in the long term, and has excellent long-term survival. When bilirubin cannot be controlled by intensive phototherapy and signs of neurological risk are starting to begin, that is when you list them for transplant. Ideally done before the onset of kernicterus, easier said than done. Consider early phototherapy if requiring more than 12 to 16 hours of phototherapy, and that will cause poor quality of life. Liver transplant is rarely required for type 2, and it can be managed by phenobarbital. So with these kids with Crigler-Najjar syndrome, you need regular neurodevelopmental monitoring. Elective liver transplant is planned in stable children before irreversible brain injury sets in. And there are emerging alternatives like hepatocyte transplant and gene therapy. That's why some surgeons prefer doing a auxiliary just in case gene therapy comes in the future. Propionic acidemia, I think we have a case on this. I'll limit myself to not going into details of it. It's just a deficiency of propionyl-CoA carboxylase characterized by recurrent hyperammonemia, and metabolic crises include, metabolic crisis happens with cardiomyopathy, pancreatitis, neurological injury, and sometimes bone marrow also affected with neutropenia and thrombocytopenia. LT supplies the hepatic enzyme activity, but it's only partial metabolic correction. So when liver transplant helps, it is when recurrent metabolic decompensations and poor metabolic control set in despite optimal diet and therapy. End organ involvement with cardiomyopathy, growth failure, kidney injuries, these are other indications when you should go for liver transplant. What does liver transplant change? It drastically reduces the hyperammonemic crisis. There's improved biochemical control. Cardiomyopathy and renal function can get better with time, and it's not a total systemic cure. Avoid transplant during crisis, like I said before, and consider when there are more than 1 or 2 crises in the early life so that you prevent further neurological damage. Primary hyperoxaluria is a rare autosomal recessive disorder of glyoxylate metabolism causing excess oxalate leading to kidney stones, nephrocalcinosis, end-stage renal disease, systemic oxalosis. Type 1 is the most severe one, only type that can be clearly cured by liver transplant. Liver transplant, the role of liver transplant in oxaluria is liver transplant provides the functional enzyme, thereby halts oxalate overproduction. If you do not detect them early, you might end up with a combined liver and kidney transplant because the liver will provide the enzyme, and the end organ which is damaged will be replaced. Isolated liver transplant, occasionally used, especially if you're lucky and you diagnose the patient early, before the renal failure sets in, then there's a scope for doing an isolated liver transplant. Before end-stage renal disease, primary hyperoxaluria type 1, rapidly declining GFR, especially if the GFR is around 50 ml per minute or above, that you consider it, because once you transplant them, they will be on CNIs, which will further damage the kidneys. Hence, do it a bit early before it drops to 30 ml per minute. Combined liver and kidney transplant is preferred for defective liver enzymes and damaged kidneys. Early diagnosis, start conservative therapy, pyridoxine trial, and monitor renal function, oxalate burden, GFRs, and refer to transplant before the systemic oxalosis sets in or irreversible end organ damage happens, kidney damage happens. So there are the conditions where liver transplant has controversial, acute hepatic porphyrias, AIP, definitely there is some role, but in EPP, liver transplant will save the patient, but ultimately you will have to use a stem cell transplant or a hematopoietic stem cell transplant or BMT to cure the underlying condition. The hyperlipidemias, again, people have different opinions about it. It will definitely reduce the need of lipid-reducing substances, but you still have to use lipid-reducing substances, and there is an atherosclerotic risk, especially if the process has set in even prior to the transplant. I think I'm just 30 seconds to summarize. So, what we've learned so far. IEMs do well post-transplant, especially from quality of life perspective. Avoid transplant during metabolic crisis because it's going to increase the catabolic load. Have a OLT protocol to encourage anabolic state during transplant procedure and post-transplant recovery. OLT done earlier in the course of the disease has better outcome and less complications. Transplant offered earlier for kids with IEM with nephropathy is better because of the CNI use, which further damage the kidneys. Many IEMs have specific monitoring needs even post-transplant, like in the propionic acidemias. OLT is still a cost-effective treatment despite the presence of so many alternative therapies. And newer targeted therapies may replace transplant in the future. Thank you very much. So I'm on time.
Thank you so much, sir. Any questions? I think we're done with the session because of shortness of time. Thank you, sir.
We are running short of time, so Professor Patrick Kamath is online. He will give his lecture. Then we are having an inauguration. Sri Chiranjeevi Garu is coming for the inauguration for the conference, and then we'll follow it up with the rest of the pediatric session. Thank you. Professor Kamath, can you hear us?
Yes, I can hear you.
Okay, we can't hear you.
I think you have to share, allow me to share.
Thank you. I know everybody knows Professor Kamath. He's a professor of hepatology at Mayo Clinic. He's the father of the MELD score and now the father of the MELD 3.0 score. I'm proud to say he's from, we share alma mater, PGI Chandigarh. Professor Kamath will talk about assessment of liver disease prognostication from child CTP score to MELD. You can start.
Thank you so much, Srinivas, for inviting me. I see a lot of friends in the audience too. So I'm going to speak on history of prognostication of liver disease from CTP score to MELD 3.0 to beyond. So in this talk, I will go over why we need prognostic scores, what are the simple prognostic variables in cirrhosis, the current prognostic scores, MELD score, and I'll go a little over the history of prognostic scores and MELD scores, and future directions, which I think are really important, and then some take-home messages. So first, why do we need prognostic scores? So anytime we have a risk score or a prognostic score, we're going to use it either as a clinical tool, a research tool, or a policy tool. So for instance, a clinical tool, we're using it to counsel patients, to make management decisions, and to optimize care. So generally, if you're thinking about this, use the original MELD score or the CTP score. You can also use it as a research tool, and that's why entry criteria into studies as an endpoint and to stratify high risk versus low risk. And then you can use it as a policy tool, and that is for liver allocation, and currently it's the MELD 3.0. So when we look at prognostic variables in cirrhosis, we know with liver disease is biochemical dysfunction, portal hypertension, and extrahepatic organ systems are involved. And so we have got multiple variables in here. For instance, ascites, encephalopathy, pressures tell us how much portal hypertension there is. So these are markers of the hemodynamic system, biochemical dysfunction, and extrahepatic organ system. So theoretically, you can use all these in prognostic scores. The problem is every time you add a variable, the model becomes more complex, and the increase in accuracy is very little. But once you need multiple variables for a model, and if you don't have one variable, then you cannot apply. So basic rule number one is if you're creating a model, and many of you can do this, just keep your models as simple as possible. Now, when I see a patient, I have very simple prognostic variables. When I see the patient, I look at their blood pressure. This is a very interesting study. Mean arterial pressure less than 82, no one survived for more than 4 years. So generally I say blood pressure of 100 millimeters of mercury and below, poor prognosis. Systolic blood pressure more than 100 millimeters of mercury, better prognosis. Not a great prognosis, but certainly better. So look at the blood pressure in these patients, simple variable. Look at whether they are compensated or decompensated. Compensated cirrhosis has a very good long-term survival. Decompensated cirrhosis, you're decreasing survival to about 1.5 to 2 years, and that is when you're going to be considering liver transplantation. And then what is now called further decompensated cirrhosis. That is a complication of a complication. So if you have ascites, now you have hepatorenal syndrome. You had variceal bleed, another variceal bleed. You have encephalopathy, now you've got refractory encephalopathy. That drops median survival to 9 months. So simple variables first at the bedside. One of the problems is endpoints are more predictable if progression is unidirectional. That is, all patients are going to get worse. However, increasingly, liver etiology will be treatable, and this will result in reversal of decompensation and regression of fibrosis. And so accurate endpoint prediction will be more difficult in the future. So let's go over the current prognostic scores and a little of the history as I was asked to speak here. You have to consider prognosis at the very first diagnosis of liver disease. You see a patient, you've diagnosed metabolic dysfunction associated liver disease. Very difficult to predict mortality, so you cannot do it at this stage. Once they have decompensated disease, they're getting complications, then that is where the MELD and CTP scores come on. Now, I know there are organ failure scores, but these are very late. So we know an organ failure score is very accurate because accuracy of any score is highest immediately before the endpoint. But organ failure scores describe the dying process. They don't predict mortality. For instance, if you look here, nobody's going to say, I predict Usain Bolt is winning the gold medal. What you're going to say is, he has already won the gold medal. If you've got 28 runs to make and only one ball, you already say they have lost. You don't say, I predict they would lose. So that is the problem with organ failure scores. Now, let's come into the history. That is the talk here. So this is a question. Think about this. There are 3 people on this list who are essentially unrecognized for liver prognostic scoring systems, and they've done the most important work for the prognostic scoring system. Just think about this. I'll give you the answer in a bit. Now, there are 2 on this list who are disproportionately recognized for liver prognostic systems. Is it Wants, Pugh, Child, Roger Williams, or Mary Ann Payne? Think about this. Answers coming up. These are the 3 who are essentially unrecognized. And I think among all of them, the most important were Wants and Mary Ann Payne. And probably Mary Ann Payne. Remember, she's a woman surgeon in the 60s. Women surgeons did not receive any recognition. And I think she did the most important work with George Wantz on prognosis of liver disease. I'm going to show you her paper in a bit. And Roger Williams, of course, is behind the Pew part of the classification. Again, a little more detail coming up. So these are the three who are essentially not recognized, at least their names are not recognized in the scoring systems. Who are disproportionately recognized? Pew and child. You know, child is very prominent. You talk about the child score. But really, he built up on the scores of Wantz and Payne, and Jeremiah Turcott was his fellow who did all the work. Again, a little more detail coming up. So remember this in your prognosis. Look at this, what a superb paper, Wantz and Payne, George Wantz and Mary Ann Payne, New England Journal of Medicine, 1961. This is, child score is essentially a copy of this score. Mary Ann Payne had A, B, and C as a group. She didn't call it class, she called it A, B, and C. Look at the criteria she used, still managed, almost identical. So the child is almost identical to this, the operative mortality. And look at this. They were so clever. They knew muscle wasting is a problem. They thought muscle wasting was a problem. Child thought maybe muscle wasting is not a good term, and they used nutrition instead. Pew was a resident with Roger Williams. Roger Williams had the idea. Pew was the resident. This is the only paper he wrote. After this, he went to do private practice in Saudi Arabia and then in Africa. So Mary Ann Payne and Wantz started the score. Child, but mainly it was Turcott, who changed muscle wasting to nutrition. Roger Williams changed prothrombin time from nutrition. That's all they did, but it's Wantz and Payne. So if you have to remember someone, if you owe prognostication, it's Wantz and Payne. So that is Roger Williams. And Roger Williams always said he wished he had put his name first in this paper, because then it would have been called the Child Turcott Williams classification. And this is the CTP score. Now let's go to the MELD score, okay? And there's a little history here. So fellows ask me, they say, please give me advice for research. And I say, I cannot give you advice. The patient you're looking after is the best person to give you research advice, research ideas. If you look at the problem with a patient, you don't know how to solve it, that is your idea for research. Pick up something that you really like. So here's the MELD story. 1992, we started TIPS at Mayo. I joined Mayo in August 1991. I found that some patients were dying and some patients did not. I didn't really think about this too much. But then I remember this patient. She was a 50-odd year. She had lost her husband the previous year. She had a son, a little over 20 years. So the son and the mother were very worried about the TIPS procedure. And the mother asked, what are my chances of dying? The son asked, my mom die after the procedure. And I took the child score and I said, no, I think she'll do well. And unfortunately, she died 3 months later. So then I realized that whatever system we have of deciding whether they will do well or not was incorrect, or at least was suboptimal. So that is why I started a study to see, can we predict mortality post-TIPS in these patients? And so essentially for all of you, research is easy. Just think of the right question. Don't do research for the sake of research. Think of a question that is going to help patients and which clinicians want an answer to. Then everything follows, and you have to have collaboration. I had many collaborators, in particular Ray Kim, my fellow, my colleague, and one of the smartest people I know. Additional story, never give up, okay? You may have an idea, journals may not think it's a great idea. So here was the MELD paper. I asked my mentor at that time, Sid Phillips, to look at it. I asked him, where should I send it? He said, hey, TIPS is a new procedure. You have found a way to select patients for it. He said, send it to New England Journal of Medicine, they will like it. I sent it to New England Journal of Medicine, rejected without review, came back very quickly. Comment was, great question. We think it's a really important question, but they said this is a medicine journal, your statistics is too complicated, all that modeling is too complicated. I said, okay, fair enough. So I sent it to, in our field, gastroenterology, came back very quickly, reject without review. What they said was exactly the opposite. They said, your statistics is great, the mathematics is great, but we really don't understand why you did the study. They said you have to use TIPS only pre-transplant. I never understood this comment, but for you, I'm an editor of gastroenterology. Just know that we make mistakes, okay? So don't let an editor's mistake spoil your research career. So I sent it to hepatology. They rejected it, this time with review. Got very nasty comments from one of the reviewers. So he said, really, you think you're so smart and you can predict long-term survival? Because this model was for 2 years that we initially sent it to. And he said, by the way, just in case you don't know, hepatocellular carcinoma kills patients, not creatinine. I said, okay. Now I have to think of a way to get hepatocellular carcinoma out of it. So I picked 3 months. 3 months was the median time to transplant in patients on the waiting list. And 3 months I could, hepatocellular carcinoma no longer would come into the equation. So then I changed the paper completely, had an algorithm, and then I sent it to hepatology, and finally it was accepted after 2 revisions. So for all you researchers, never give up on an idea. Remember that. 2, editors make mistakes, okay? They've got other work to do. They may not read it as carefully. They make mistakes. If you think you have a good idea, send it somewhere else. Your paper will ultimately find a home somewhere. So as a result of the MELD score, it's become a metric for severity of liver disease, used for organ allocation, risk stratification in alcohol-related hepatitis, selection of patients for TIPS and surgery, and acute liver failure mortality risk, as well as variceal bleed mortality risk. So we can use it in different ways. Use the original MELD score for most patients only because it's been most validated there. So TIPS, alcohol-associated hepatitis, hepatic decompensation. For prioritizing patients for transplant, use MELD sodium. We've got little more experience with that, and MELD 3.0 is what we're coming up with now. But I want to spend a little more time on MELD from synthetic data, and that's going to be in the future. Now, if you want, you can write this down. This site is free. Anytime you have a patient, you can use this to calculate risks. For instance, post-TIPS mortality. You key in the variables. You can risk of mortality. Talk to the patient about it. Prognosis in alcohol-associated hepatitis. We put in the variables, and we can get 90-day mortality in here. So all this is on our website. For you, who are a lot of surgeons in there, so mortality risk in patients with cirrhosis, we key in the variables in here. Patient's age is important in surgery, INR, and then again, we get mortality risk. So we use this to counsel patients. What about mortality prediction in compensated cirrhosis, which I didn't go into? And you're going to be seeing more and more about these patients. This is a problem. We don't have an accurate score to predict mortality in compensated cirrhosis because at this stage, they're dying either of cardiovascular disease or cancer. But you can use the MELD score to predict risk of hepatic decompensation. Now we come into transplant. This is again part of the history. And many of you know this. Liver transplant initially was experimental, only a last resort procedure, more organs than patients. So there was no need of an allocation system. But then as people got better at transplant, the demand for organs outstripped the supply. So you had to have an allocation system. Initially, it was the UNOS system, which was really based on CTP score and waiting time. And that was changed in 2002 to the MELD system and 2016 to the MELD sodium system. So we're just trying to do better. And the MELD 3.0 and MELD sodium is really, this is the person, this is Ray Kim, my former fellow. No one understands models better than he does. So he has run with MELD and he has really taken it forward. So this is what we found. So this is a JAMA paper. This was found post MELD allocation, when it changed in 2002. Richer people were enriched. So you can see blacks are disadvantage versus whites. Before MELD, 50 times higher risk of mortality, 25% lower risk of transplant. But after MELD, equal chance of dying, equal chance of transplant. So it really helped disadvantaged minorities. The problem was females, and this is the work done by my colleague Alina. Pre-MELD, women had a slightly higher risk of dying, but post-MELD, even higher risk of dying. Unintended consequences. Lower risk of transplant pre-MELD, even lower risk of transplant post-MELD. So that's how Alina and all of us tried to get to work on this to advantage women. We thought one point to MELD would help women, but no one was willing to accept that until we came up with data. And that Ray Kim came up with, and this is a paper in gastroenterology, showing that the MELD 3.0 is a little better than MELD sodium. Perhaps creatinine, which is what gives men an advantage. And let's see how this goes. But the problems, like I said before, no longer one-directional. Improvement in liver function and even regression of fibrosis is possible. And so predictive models are going to become increasingly less accurate in the future. So MELD, as we see it now, is going to become increasingly less accurate because patients are going to get better from reversal of cirrhosis etiology. So now what are we working on? We want simple and cheap AI-based models for accurate prediction of endpoints. So we first worked on AI-guided prediction. What did we want? A cheap tool. Patients should accept it, so possibly even do it at the patient's home. Wearable devices are very active, but extremely expensive, so we cannot use that. So the question was, can we use ECG as a prognostic tool, a simple 12-lead ECG as a prognostic tool in cirrhosis? And so this is the work done by my colleague Joseph Ahn, and he's done some of our other AI work. And he's got San Diego now doing his degree in informatics, and he'll join us back in January. So in cirrhosis, there are hemodynamic alterations, and those result in clinical outcomes. And ECG in patients with cirrhosis has prolonged QTC, low QRS voltage, decreased RR variations, and short TP to T. This is repolarization. So there are ECG abnormalities in patients with cirrhosis. So we developed this, what we call the A score, the AI cirrhosis ECG score. And what did we find? We can use this score at a threshold of 0.17. This is the score that we have. So 0.17 and above, extremely good. So just look at the ECG and you can say this patient has cirrhosis. You don't need anything else to say this patient has cirrhosis. See how accurate it is. Very sensitive and specific, AOC 0.908. This is interesting. As the score goes up, you find that the MELD is increasing. So more sick the patient is, the higher the score. And around MELD of 25 and above, it seems to plateau out. So just an ECG, that's all to prognose for prognosis. Additionally, interesting again, the score keeps going up. Then we transplant the patient. The score comes down to normal. Few years after transplant, starts going up again. Whether it is recurrent mast cell or recurrent disease, we don't know. It starts going up. So we said, okay, now we can diagnose cirrhosis. Can we predict who is going to have complications? Again, extremely good. This time is a threshold of 0.25. So we use just ECG. The AI system will say, okay, this patient is going to have decompensation. When you add on for MELD, it becomes even more accurate, but by itself, very good. So here, look at the score. I told you the score 0.17 to diagnose cirrhosis. If you look at a patient with this score, we'll say 5 years, this patient will be alive. Let's say the score has gone to 0.25 to 0.5. We'll say this patient in 5 years has a 40% risk of mortality. And if the score is 0.75 to 1, we'll say in 1 year, this patient has a 50% chance of dying, and in 5 years is unlikely to be alive. All just from a single 12-lead ECG. So we said we have to validate this. So we work very closely with the University of Barcelona liver group. And in that team, it's not doing that well. It's still good, still a clinical tool, but not as good as in our system. So the AI machine has to learn. So this is what we are working on. So at Mayo, we have this. So when we click on the ECG, this is our cardiology people help us with that. Just on the ECG, we can make various diagnoses. The ECG is extremely accurate. It can give the age within 5 years. It can tell you male or female, 95% accurate, only from the ECG. Interesting in cirrhosis, it makes the patient older than the patient actually is. And so here are some sort of examples in here. Here's a 41-year-old patient who decompensated with autoimmune disease. Score was low. When she decompensated, score went high. This was even more interesting to me. She was a 70-year-old female with cirrhosis. MELD score was only 10, but she was doing badly. And you can see her ECG score was much worse than a MELD score. So ECG is adding on anything. Here's a patient with biliary cirrhosis, 21 years, high score, transplanted, score comes back to normal. So ECG-based scores are impressive. They can predict liver disease severity, complications, and mortality over time. And we're still trying to do a little better before we can use it. Meanwhile, Joseph Ahn is working with us for synthetic data. So synthetic data is a mathematical algorithm which learns the patterns and translates into a real-world data set. So let's look at this. Trying to make it simple here. These are called diffusion models. So here we take a dog, take all the data and destruct the data. We keep adding noise till eventually it's only noise. You take noise and it's called denoising, and we come up with another dog. This dog has all the characteristics of this dog, but it's not identical. So if I have all your pictures, we can come up with a list of people who look almost like you, but not you. So this is called synthetic data. So this is the UNOS data list of 38,000. We came up with a cohort of 38,000. Notice the synthetic data are almost identical, almost identical. Look at the gender, dialysis, wait list. This is synthetic, all de-identified. We find survival patterns of the real data and the synthetic data almost identical again. So UNOS data original, median survival 110 days. In our cohort, it's 101 days. Transplant-free survival 22% at 5 years, 22.8%. So we know this is extremely accurate. It preserves the MELD performance. So why is this important? Why are we making such a big deal out of it? This is why it's important. Currently, let's say you have a patient with MELD 3 of 35, we can predict mortality. But remember, it may be a little different if it is creatinine-driven mortality, sodium-driven mortality, INR, bilirubin. It depends on the age. So all these variations are in there. So for instance, someone my age will have a much higher mortality than someone who's 35, even if they have a higher identical MELD score. So with this synthetic data we have, we can say this patient This is exactly what this patient's survival is. So we can predict the individual patient's mortality now. And this interval is what's called nearest known neighbor, which means patients who look almost identical like this is going to be their mortality. So I think this is the future. So my take-home messages: at bedside, look at the blood pressure, patient compensated or decompensated. For prognosis, if you want broad stratification, use the CTP score. If you want finer stratification, use the MELD score. The MELD sodium and MELD 3.0 for organ allocation. But for the future, I think synthetic data is likely to be the basis for organ allocation. Thank you.
Thank you, Professor Kamath. That was a very interesting talk, actually taking us through the history of prognostication. Any questions from the audience? Dr. Mathur.
Dr. Kamath, this was a wonderful talk, and it's so great to hear the entire history of how this came about, and also important to set the record straight, I think. I had a question about your last point about synthetic data. One of the challenges with AI anywhere is that the outcome is only good as what you're putting into it. So I guess the synthetic data you have is really good based on whatever variables we think are important currently. So how do you make synthetic data smarter than data is right now? How do you make it MELD 4.0?
So I think that's a very important question. So your database has to be perfect. So we have the UNOS database, so our synthetic data is on the UNOS database. We have another large cohort of patients with alcohol-related hepatitis, so we have synthetic data on that. So in the alcohol-related hepatitis, the reason we're using synthetic data is anytime you do a study, you need a control group. The control group may not be identical to the patients being studied, and patients don't want to enter into a study where they might be in a placebo. So the FDA now approves synthetic data. So we have a cohort of patients whom we know what they would survive without treatment. Now we start treatment. We pick what we call nearest known neighbors. If you're doing better than that, then we know the drug is working. If you're doing worse than that, you're having side effects. So for organ allocation, all we can do is work with the UNOS system. What we have to try and do is work even better on the UNOS system. So if the broad question is, can we use the synthetic data for people in India? I don't know. I don't believe so, but it depends on exactly how you do it. So unless you have a very good data set, you cannot. We believe at Mayo we can do this because we have follow-up almost from birth to lifetime, so we can use that. Outside of that, these will be difficult to use. So outside of UNOS, I think we'll have problems. For studies, for trials, maybe. And also, for allocation, one of the problems is it's called synthetic data. No surgeon, when I talk to my surgeons, they say synthetic. They're very skeptical once you say synthetic, okay, because they think it's fake.
Prof, just a question. I mean, how did you decide to use an ECG for getting, to run on AI to predict? I mean, what was the thinking behind using an ECG and not, I mean, I don't know, maybe something else that probably more similar to what liver function is then?
So at Mayo, we have it's a sort of lounge, it's a coffee room where you come down for coffee. So people from different specialties meet there. So we meet a lot of different people. So there were cardiologists. So there's Doug Simonet, who is my fellow and then a consultant. We were talking to the cardiologists who have this ECG model. You take an ECG, they'll say, what's your chance of getting cardiomyopathy in 5 years? What's your chance of atrial fibrillation? Now they do it in every patient who's pregnant. At pregnancy, you do an ECG, you can predict whether they'll get postpartum cardiomyopathy. then you can change things. So we were saying, hey, in cirrhosis, there are a lot of ECG abnormalities. Let's look at it. So they had the algorithm. They had all the devices. Most important, they had the money to do all this research. We didn't. We just gave them the idea. And now it turned out really good. So it's essentially we borrowed somebody's idea. And you need collaboration across things. I think physicians in India are the smartest, the engineers the smartest. If we have IITs, the medical institutions collaborating, we can do all this even better.
Patrick, hi. It's Mohammed Rilla here.
Oh, of course.
How are you?
Good, how are you? I enjoyed your talk, by the way.
Thank you. Oh, fascinating talk. I really enjoyed it. I mean, every time you give
touch, which AI does not have, I think patients like that. Last week's New England Journal of Medicine has a really nice article on AI in education and how we use it. So here's the problem. Let's say we use conventional, we find something went wrong. You looked at all the data points that you did your examination, something went wrong. You can go back. You can see which lab you missed, which x-ray you missed, get the diagnosis. With AI, if you're wrong, we don't have a way of retracting to find out where we made the mistake. So until we can get AI to a level which can go back and tell us where we can do better, I think we'll have a problem. So AI has to help us, it cannot replace us.
Patrick, the time is for inauguration, and we've got the VIPs who have arrived here. Please do stay on, and thank you very much for your wonderful talk. Is that okay? Is there anything else?
No, nothing more from my side. Thank you.
Thank you.
And again, thank you, Srinivas, for inviting me.
Thanks a lot, Rob. Thank you for coming. Thank you for coming online and giving this excellent lecture. Thank you.
Good evening, everyone. It's wonderful to see a hall full of professionals sitting late in the evening, which speaks a lot about the content and the faculty delivering their content. I'm proud of our liver team, both hepatologists and liver transplant surgeons, for making this happen today. And I want to particularly thank all the organizing team for making this a great success story. I want to introduce our beloved chief guest for this evening's inaugural function, Sri Padma Vibhushan Chiranjeevi Garu, but very well known as megastar Chiranjeevi Garu, who is very dear to our heart. I would like to invite Chiranjeevi Garu to come onto the dais. Please, Ravi and Ramesh, please accompany him. I'd also like to invite the chairman of Renal Institute, Mohammed Rela, who's a dear friend, to be accompanied by Srinivas Reddy to come at the dais, please. Thank you. As our custom in India, the first thing that we would do is the lighting of the lamp. So I will invite all the guests on the dais to Thank you very much. Perhaps it's not an exaggeration if I say that Chiranjeevi garu doesn't need any introduction. Telugulo Jagamadi Brahmadiki Janjamela ani oka samit undi. I know a lot of you were outside Telugu states, if you don't understand. He is a household name, it's not an exaggeration. And he has been a very dear friend from the time I came back from England. Between Ravi and me, we enjoy his great friendship. I want to share something today. Very unfortunately, his mother-in-law passed away this morning, early hours. She's 93. She's very, very close to Chiranjeevi garu. And I came back from Bangalore, and when I met him, I thought it is difficult for him to attend today's program. So when I said at 4 o'clock, sir, we understand, you don't have to come. He said, no, Gopi, that is relationship, my responsibility for my mother-in-law. This is responsibility, my responsibility to public at large, to highlight the suffering, to make sure this donation transplant penetrates into the public. And it just overwhelmed me. And I want to thank you, sir, for being this evening, particularly to being this evening. It's a great honor and a privilege, sir. Of course, he's not a stranger for donation. Because of a lack of blood donations in this state, combined state of Andhra Pradesh at the time, he funded a blood bank called Chiranjeevi Blood Bank in 1998, so about a quarter of a century ago, even more than that. As far as I understand, it's something like 25 lakhs of blood bags, products, and all sorts of platelets, everything are donated. His own fans come every day, and particularly on his date of birth also, they come and give so much of donation to the society through their blood banks. And that's a great boon to people who doesn't have access to blood and products. And of course, he also added corneal donations. He established a corneal blood bank within the same premises. I want to thank you, sir. It's a great privilege for us to be associated with you. And with these few words, I'd like Dr. Ravindranath to say a few words about the function and the liver transplant. Thank you.
Respected Chief Guest and all dignitaries in the dais, all the faculty and delegates and ladies and gentlemen, it is indeed a privilege to be here today as the mentor to this liver transplant program at Star Hospital. I can tell you, our chief guest, such a wonderful person, is not new to the liver transplantation. In 2004, when we did a Pakistani child liver transplantation in Hyderabad, our then CM, late Rajshekar Reddy Garu and Chiranjeevi Garu, both came for that press conference. It was televised across the world by international media. And just before that, I think we had a big war with Pakistan, so we did the transplant. It became a big sensation. He came for that meeting. Dr. Rela did that transplant. Just imagine coming from all the way from King's College, London, and said one word, which I still remember. There may be LOCs between the countries, but there is no borders for humanity, and that's what I'm seeing here today. And he's such a great person. Many movie people or non-movie people whom he knew had a liver problem, he always said, Dr. Garu, go ahead. I will take care if they can't pay. That is something I heard several times from him. Very rarely we see that kind of kindness and concern for people who are ill. So that's my experience with him in liver transplantation, I'm telling you. We did several movie artists and all for liver transplantation. He was instrumental in supporting all of them. That is something which is great. So after that, I'll just briefly tell you, I am so happy to see so many of you here, majority trained or progressed in your career from global. I'm so happy. I'm really so happy to see all of you doing so well across the country. And it's a privilege. And of course, for that, Professor Rela is another instrumental person here for training all of you or establishing 4 transplant programs through global. And then, of course, Rela established his own center in Chennai. Literally, Dr. Srinivas Reddy is trained by him and is a brilliant surgeon, I can say. Rela said to me several times, the one person whom I trained so well and so intelligent is Srinivas Reddy. Several times he told me that. So now I'm so happy today to mentor the program under his leadership, and we have a fantastic team. One thing only I told, as long as I'm here, we must build a transplant program which is patient-centric, excellent outcomes, and very ethical practices. And I will support you whatever way I can, having established multiple transplant programs across the country. I have whatever knowledge and experience and goodwill I have, I'll put behind you and your team. And of course, Star Hospital is, Gopi Chand is my dearest friend. If I have one friend, dearest friend, it is him. So I said I'll do whatever best I can. So we started this program, now doing very well, I can say. And there is a lot more to do. We'll do that. And apart from that, we'll also, like global, we also build a lot of transplant training programs, which the next 1-2 years we'll have a very good training programs and academic programs like what we did. And of course, MCLD is our conception between Rela and myself. Then of course, Rela is continuing that. I'm so happy. And with these few words, it's very nice to see each one of you and participating so keenly. I saw the program. Excellent program, very practical, a lot of case records, and that's the way to go. And each one of you should carry home a lot of knowledge and tips how to handle some of the difficult areas like what I saw, so many of the people explaining to you what to do, what not to do, especially I saw the Rela's presentation. It's an excellent presentation, and Patrick Kamath, and many of you presented excellent cases. So this is the way to go. I wish you all the best and great program. Thank you.
Thank you, Ravi. If you look at the medical history and how specialties developed over a period of time, not necessarily just liver or hepatology or cardiac, in general, there are always some torchbearers. If you go back to certain historical perspective, and I have no doubt today, and I'm sure all of you agree, that between Rabindranath and Muhammad Rela has actually transformed the liver transplant, in fact, liver diseases management in this country, and I have no doubt medical history books in India would write them as the pioneers in liver diseases management in this country. I have privilege of watching Muhammad from the day that he came here. He used to come and operate in at Global Hospital. It's a treat to watch, surgical skill and all those things. I mean, I don't have to tell all of this. But I had the privilege of watching him operate on my very close friend in Chennai who had liver cancer, and it's a great treat to watch Muhammad Rela. I would request Muhammad to say a few words on this occasion. Thank you.
I didn't know that I had to say a few words here. And I want to thank Dr. Ravindranath and Dr. Kopichan for being so kind. First of all, I want to pay my respects to Chiranjeevi Garu for being here. And my condolences for your losses. And on a day to be here we are really privileged. And I've shared many times the stage with you, with Dr. Ravindranath bringing me up every time to participate in all of this. And I have to say, you're looking younger and younger. I've seen you 15 years ago. I don't think you look any older. And before you arrived, I was speaking to Dr. Srinivas Reddy. It looks like he's a big fan of yours. And I asked him, who's bigger? Is it Chiranjeevi Garu or Amitabh Bachchan? And he said, Chiranjeevi Garu, of course. As a child, he's grown up watching your movies, he says. I said, Amitabh Bachchan is all Hindi, isn't it? He says, doesn't matter, you're still bigger than Amitabh Bachchan. And I really want to thank Dr. Ravindranath, really. He's been a good friend for many years, and he's the one who brought me to India. You're the one tempting me. He knew I was doing well in King's, and everybody said, why the hell would you want to go to India? And he said, come for 1 year and try it out. And I came for 1 year, and I was hooked, really. I could not go back to England after that. And you all know, you saw what Patrick Kamath's presentation. India produces the best clinicians. India produces the best engineers, he said. And I can tell you, India produces the best surgeons that I've known. I've trained Europeans, I've trained Western English people, but the best surgeons I've had have always been Indians. I can say that, and you can publish that. And I think one among them is Dr. Reddy, actually. I've always, he's an excellent surgeon, but an excellent human being. I've actually quoted this before. I've said that he's a better human being than me. And it's a privilege that I've had the opportunity for him to be my colleague and friend. And thank you, Srinivas, for that. And Dr. Gopi Chand, Thank you for being so kind to me and your colleague as well, Dr. Ramesh. I've met you for the first time. Yeah. I always sit here and notice what's in the background. I don't know how many of you see things which are very obvious. His Star Hospital has got an arrow and a shooting star which goes up. I don't know who designed that, and I hope that your hospital and your venture shoots up like that shooting star. And I wish you the very best for such a shooting star. And I come from Chennai, and look at the background. There is Srinivasa Ramanuja there. I always wonder what the connection is between Ramanuja and Hyderabad. What is it? Any of you know? But why do you have the biggest statue of Ramanuja here? He was from Chennai. He was born in Sri Perumbudur and he lived in Kanjipuram, and he's a Vaishnavite saint and he's from Chennai. And you've got the biggest statue of Srinivas Ramanujan in Hyderabad. And I want to thank all of you from Hyderabad for that, for promoting our saint. Thank you very much.
Thank you, Mohammed. We can adapt Ramanujacharya. His disciple Chinnajiyar Swami made that happen, which is one of the greatest feats that Hyderabad has been achieved. You wanted to know who designed our Star Hospital logo? Narendra, just stand up. I had to work with him in 2008, several iterations. I keep telling him, you need to write this, you need to do this. And then he came back with this. That's it. That stayed like that. He did that. Thank you, Narendra. Now, Hyderabad has obviously, hugely blessed with a lot of talented surgeons, physicians, in fact, across all specialties. We are really blessed. People don't have to look anywhere else to get kind of treatments that we do here. I'm very pleased. It took some time. Ravi, Ramesh, and us, all of us to work on Srinivas Reddy to entice him to come to Hyderabad, and I'm very happy that Srinivas has accepted finally to come here, and he's accomplishing wonders at Star Hospital, and a great addition to talent pool in the city in the medical profession. Srinivas, few words about the conference and the background.
Thank you. Thank you, sir. Chiranjeevi garu. So yeah, I'm a big fan. Actually, I remember when we were kids, the general Telugu movies used to be extremely boring. We would never want to see Telugu movies in theaters. Then I think I was in 6th class or 7th class, I went for summer holidays and we went to a movie called Kaidi. So there was one theater in my village. It's called Ram Gopal, and me and my brother got 2 rupees together. So 1 rupee ticket, you can sit on the ground and watch the screen. And we saw the movie, and then after that, the only thing we'd be waiting for is the next Chiru movie. In fact, when I left Hyderabad to do my MBBS in 1992, I've just lost touch of Telugu movies. So now, when I think of Telugu movies, I only still think of Chiru movies only. And I know a lot of actors have come and gone, and I don't know most of them actually. But it's a huge honor for me to sit next to sir. So I think in terms of liver transplant, I think India is probably now at the top of its game. We're doing thousands of transplants. We are the largest country in terms of number of living donor transplantations being done, and it's all because of pioneers like Professor Rela who started this in our country many years ago. And the reason why we wanted to have this two-day meeting was just to highlight the kind of advances that were made in liver care, not liver transplantation, but actually looking after patients with liver disease, even before they need transplantation, how to identify problems that can create issues for these patients after surgery or during surgery. So the surgery is obviously one thing. What happens after surgery? Even today, I was talking to one of the reporters and they were asking, we keep hearing stories that initially it's successful and then, patients don't do well after transplantation. But actually, that's not fully correct. Most patients who come out of transplantation, who do well after transplantation, actually do very well. Liver doesn't have a life like kidneys, where you say after 10 years after kidney transplant, you need a second transplant. Liver, if it starts working, it works for life. You've seen photographs in Dr. Rela's talk. He did a transplant for a 4-day-old baby, and she's now a lawyer. And that shows that the liver is for life actually. And a lot of times patients do ask us, after transplant, what can we do? Should we do this? Can I go travel? Can I do exercise? And these questions actually are very genuine questions. And I think most of these questions are in the minds of the general public and also patients who might be thinking of a transplant. And that's the reason why we felt that it's important that this knowledge that patients after transplantation can have a normal life. They can work, they can travel, they can have families, and they can eat pretty much everything. I think that message has to go out into the community that transplant does change lives and you can have a completely near normal life after transplantation. And we have actually come up with a booklet as a guide to patients after transplantation, which we hope will actually encourage patients not to worry too much and to go into transplantation with a very positive attitude to their future. So it's my great privilege to request Chiranjeevi Garu to inaugurate this book today. Thank you.
Now I have the privilege of inviting our chief guest for this inaugural function to say a few words, sir.
అందరికీ నమస్కారం. ఇంత గొప్ప డాక్టర్స్ మధ్యలో కూర్చోవాలంటే చిన్న పేషెంట్ లాగా ఉనికి వస్తుంది నాకు. ఒక్కొక్కరు ఒక్కొక్క శాఖలో నిష్ణాతులు, అద్భుతాలు సృష్టించిన వాళ్ళు. ఇక్కడ డాక్టర్ రేలా గారి గురించి ప్రస్తావిస్తే ఆయన గిన్నిస్ బుక్ ఆఫ్ వరల్డ్ రికార్డు ఉంది. 4 రోజుల పసిబిడ్డకి లివర్ ట్రాన్స్ప్లాంట్ చేసి ఇప్పుడు ఆ బిడ్డ ఏం చేస్తుందో ఇంతకుముందే చెప్పుకుంటూ వచ్చారు. అది చాలా అసలు అమేజింగ్. 4 రోజుల బిడ్డ. అది ఉన్నప్పుడు షాక్ తిన్నాను. ఆ తర్వాత చాలా సందర్భాల్లో నేను రేలా గారు కలుసుకున్నాము. చెన్నై వెళ్ళాను, వారి హాస్పిటల్కి వెళ్ళడం కూడా జరిగింది వేరే సందర్భంలో. ఆయనతో చాలాసేపు నేను కూర్చోన్నాను. ఎన్నో విషయాలు అవగాహన నేను తీసుకున్నాను. అలాగే ఇంతమంది డాక్టర్ల మధ్య ఇందాక పేషెంట్ అన్నాను కానీ నేను ఒక డాక్టర్నే అని నాకు ఆ సర్టిఫికేట్ ఇచ్చిన వారు ఎవరో కాదు, నా మిత్రుడు, మా సోదర సమానుడు, మా కుటుంబ సభ్యుడు డాక్టర్ గోపీచంద్ గారు. ఒకరోజు అది ఏంటి అడగకుండా క్లాప్స్ కొట్టేస్తారేంటి, మా అమ్మగారికి మోకాల ఆపరేషన్ జరిగినప్పుడు బాబు పక్కన ఉండాలని అమ్మ కోరిక. సరే అది లోకల్ ఎనస్థీషియా ఎపిడ్యూరల్ ఇచ్చి చేస్తారు కాబట్టి అమ్మతో మాట్లాడుతూ ఉండొచ్చు. నేను లోపలికి వెళ్ళాలంటే మిగతా సర్జన్స్ ఏదైనా ఇబ్బంది, వాళ్ళు ఏదైనా ప్రాబ్లం క్రియేట్ చేస్తారు, ఎందుకు రాకూడదు అంటారేమో చిన్న హెసిటేట్ చేస్తుండగా నన్ను లోపలికి పిలిచి ఆయన సర్జన్స్ తీసుకునే గౌన్ నాకు ఇచ్చేసారు. నౌ యూ కెన్ కమ్. బాగుందండి, మీకు నాకు రిలేషన్ ఉంది కాబట్టి మీరు లోపల రమ్మంటున్నారు, వాళ్ళకి ఏమైనా అభ్యంతరం చెప్తే ఎట్లాగంటే ఒకసారి మీ గుండె వైపు చూసుకోండి అన్నారు. ఇటు చూసుకుంటే డాక్టర్, అఫ్కోర్స్ నాకు డాక్టరేట్ వచ్చిందనుకోండి ఆంధ్ర యూనివర్సిటీ వాళ్ళు, అదే కదా అనుకున్నాను. కాదు, డాక్టర్ చిరంజీవి ఎంబీబీఎస్, డాక్టర్ చిరంజీవి దాదా ఎంబీబీఎస్ అన్నాడు ఆయన. నాకంటే హా అనిపించి సరే అని థియేటర్లోకి వెళ్ళడం జరిగింది. అది ఆ రకంగా నన్ను డాక్టర్ని చేసి సర్టిఫై చేశారు కాబట్టి ఆ అర్హతతోటి నా మిత్రులు, మరొక సోదరుడు, అందరికీ క్లాస్మేట్స్ ఉంటారు, కానీ నాకు మాత్రం నా రోడ్ మేటు డాక్టర్ రవీంద్ర గారు. ఇద్దరం గత 25 ఏళ్ళుగా ఒకే రోడ్లో ఉన్నాం. రోడ్డుకి అటు ఆయన కాపలాగా వస్తున్నారు, రోడ్డుకి ఈచో నేను కాపలాగా వస్తున్నాను. రకంగా ఎప్పుడు టైం దొరికినా సరే కలుసుకుంటుంటాము. జరుగుతున్నటువంటి అప్డేట్స్ కానివ్వండి, ఈ మెడికల్గా ఉన్నటువంటి ఇవన్నీ కూడా మనం చేసుకుంటాం. నాకు ఉండే ఇంట్రెస్ట్ కొద్ది. ఆ తర్వాత హాస్పిటల్కి వెళ్ళినప్పుడు స్టార్కి మన హార్ట్ స్పెషలిస్ట్ రమేష్ గుడపాటి గారిని కూడా కలుసుకుంటుంటాను. ఆయన అంత సౌమ్యుడు, అంత కంపోజ్డ్గా ఉంటారు. అది చూస్తుంటే ఒక మంచి స్నేహితుడు అనే భావం కలుగుతుంటుంది. ఆయన స్మైల్, ఎప్పుడు నవ్వుతారు, ఎక్కువ మాట్లాడరు ఆయన. అది పోతే ఇప్పుడే పరిచయం అయ్యారు శ్రీనివాసరెడ్డి గారు. ఆయన నా అభిమాని అని చెప్పేసరికి నాకు నా గర్వానికి అంతు పొందలేదు. అంత గర్వపడుతున్నాను. ఎందుకంటే ఆయన సాధించినవన్నీ కూడా నాకు చెప్తూ వచ్చారు. ఏమేమి అచీవ్ చేశారు, ఏ ఉద్దేశంతో ఈరోజు ఇక్కడ సర్వీస్ చేయాలి, మరి ఇండియన్స్కి సర్వీస్ చేయాలి అనే ఉద్దేశంతో వచ్చినందుకు నిజంగా మనస్ఫూర్తిగా మన టెక్నికల్గా కానివ్వండి, మీ డాక్టర్ వృత్తిని మరింత ఉన్నత స్థాయికి తీసుకెళ్ళడం కోసంగా, మీరు అవగాహన పొందడం కోసంగా అబ్రాడ్స్ వెళ్ళినా సరే తిరిగి ఇక్కడికి వచ్చి ఇక్కడ సేవ చేయాలని మీ చక్కటి ఆదర్శానికి నా హృదయపూర్వక అభినందనలు తెలియజేస్తున్నాను. మీలాంటి డాక్టర్స్ నా అభిమానం చెప్పుకోవడానికి నాకు మరీ మరీ గర్వకారణం ఉంది. థ్యాంక్ యూ శ్రీనివాసరెడ్డి గారు. ఇక్కడ అవగాహన అనేది చాలా లోపించింది మన ఇండియన్స్లో కానివ్వండి, ఎస్పెషల్లీ మన తెలుగు వాళ్ళలో కానివ్వండి, ఈ ప్రాంతంలో. అంటే ఇక్కడ డాక్టర్స్ కొరత లేదు, ఇక్కడ హాస్పిటల్స్ ఫెసిలిటీస్ తక్కువ కాదు. గొప్ప గొప్ప డాక్టర్స్ ఉన్నారు ఇక్కడ, గొప్ప గొప్ప ఫెసిలిటీస్ ఉన్నాయి, వరల్డ్ క్లాస్ ఎక్విప్మెంట్స్ ఉన్నాయి ఇక్కడ. బట్ ఎందుకని మనకి ఎంతోమంది సమయానికి సరైన వైద్యం అందుకు చనిపోతున్నారు అంటే అది కేవలం వైద్యులు లేక కాదు, ఇక్కడ ఫెసిలిటీస్ లేక కాదు, వాళ్ళకి సరైన సమయంలో ఏదైనా అవయవాలు ఇవ్వాల్సి వస్తే కనుక అవయవాలు దొరకక, అలాంటి ఇచ్చే దాతలు లేక, వాళ్ళకి అవగాహన లేక ఆ రకంగా చనిపోతున్నారు. అంటే పరోక్షంగా ఎవరిని వేలిది చూపించడం కాదు కానీ ఇలా చనిపోతున్నారంటే దానికి కారణం అవగాహన లేని తోటి ప్రజలే అని నా భావన. నిజంగానే ఇది 25 సంవత్సరాల క్రితం పైన బ్లడ్ దొరకక ఎంతోమంది రోడ్ యాక్సిడెంట్స్లో చనిపోతున్నారు. ప్రసవం టైంలో, డెలివరీ టైంలో మహిళలు చనిపోతున్నారు. తలసీమియా వ్యాధి కానీ, ఇంకోటి కానీ, లుకేమియా ఇలాంటివి వచ్చినప్పుడు వాళ్ళకి సరైన సమయంలో బ్లడ్ లేక చూస్తుండగానే ప్రాణాలు పోగొట్టుకుంటున్నారు. ఇది మన ఇండియా పరిస్థితి అని ఒక ఆర్టికల్ చదివిన తర్వాత నాకు ఒకసారి అనిపించింది, మనకి జనసాంద్రత ఉన్న భారతదేశం. అలాగే నా విషయానికి వస్తే నాకు వేలు లక్షల్లో అభిమానులు ఉన్నారు. వీళ్ళంతసేపటికి థియేటర్స్కి వెళ్ళటం, పాలాభిషేకాలు చేయటం, అక్కడ క్లాప్స్ కొట్టడం ఇవి కాదు కదా. వాళ్ళంత పొటెన్షియాలిటీ ఉన్నటువంటి ఆ ఫ్యాన్స్ చేత మనం ఈ సోషల్ సర్వీస్, ఈ రకమైన అవగాహన, ఈ రకమైన డొనేషన్ డ్రైవ్ వైపు, బ్లడ్ డొనేషన్ డ్రైవ్ వైపు మనం గనక వాళ్ళని మళ్లించగలిగితే ఎంతో కొంత మనం ఈ యొక్క చావులకి రాకుండా లేకుండా చేసిన వాళ్ళం అవుతామనే ఉద్దేశంతో నేను అది మొదలుపెట్టినప్పుడు ఐ వాజ్ లిటిల్ స్కెప్టికల్ వెదర్ ఐ కెన్ కంటిన్యూ ఇట్ ఆర్ నాట్. బట్ వాళ్ళకి చిన్న ఆశ చూపించా, ఎవరైతే బ్లడ్ ఇస్తారో వాళ్ళతోటి ఒక ఫోటోగ్రాఫ్ ఇస్తానని. దాంతో చాలా ఉత్సాహంగా వచ్చారు. మళ్ళీ ఇంకో డౌట్ నాకు, ఇచ్చిన తర్వాత ఒక ఫోటోగ్రాఫ్ తీసిన తర్వాత మళ్ళీ ముందుకు రారేమో, ఆగిపోతుందేమో అని. ఆగటానికి వీలు లేదు. ఎందుకంటే అప్పట్లో ఫోటోకి టెంప్టైన అభిమానులు వచ్చారు, కానీ జనరల్ పబ్లిక్ రావటం అనేది చాలా కష్టమైపోయింది. ఎందుకంటే బ్లడ్ ఇస్తే ఎనిమిగ్గా అయిపోతాం మనం, రక్తహీనతతోటి మనం బలహీనపడిపోతాం అంటూ ఎవరు ముందుకు వచ్చేవాళ్ళు కాదు. వాళ్ళందరికీ లేదు, మీరు కనుక బ్లడ్ డొనేట్ చేస్తే విత్ ఇన్ నో టైమ్ ఆ 350 ml ఆఫ్ బ్లడ్ బయటికి వెళితే దానికి తగినంత బ్లడ్ విత్ ఇన్ డేస్ 4-5 days లోపల మళ్ళీ వస్తుంది. కొత్త బ్లడ్, కొత్త సెల్స్ ఆక్సిజన్ పీల్చుకుని మరింత రీజన్యువేషన్ తోటి మరింత శక్తివంతంగా మీరు ఉంటారు, రండి. మన ఒలింపిక్స్కి వెళ్ళేటప్పుడు చాలామంది స్పోర్ట్స్ పర్సన్స్కి ముందస్తుగా పాత బ్లడ్ తీసుకుంటారు, తర్వాత కొత్త బ్లడ్ ఏర్పడుతుంది కాబట్టి మంచి శక్తివంతంగా ఉంటారటు. ఇలాంటివి చిన్న చిన్న క్లిప్పింగ్స్, చిన్న చిన్న వీడియోలు, చిన్న చిన్న ఆడియోలతోటి నా సినిమాలకి లింకప్ చేసి, నా ఆడియో క్యాసెట్స్కి వాటికి లింకప్ చేసి నేను పంపిస్తూ, అలాగా ఒక 5-6 ఏళ్ల తర్వాత ఆ ఉధృతం అందుకుంది. ఈ రోజుకి చాలా గర్వంగా చెప్పగలుగుతున్నాను, ఎక్కడ బ్లడ్ సమయానికి దొరకక చనిపోవటం అని కానీ, అండ్ రక్తదాతలు ముందుకు రాకని కానీ అలాంటి పరిస్థితి 90% లేకుండా పోయిందంటే అందులో ఎంతో కొంత నా పార్ట్ ఉందని చెప్పడానికి చాలా గర్వంగా. అలాగే ఐ డొనేషన్ అంటే కార్నియా ట్రాన్స్ప్లాంట్ కోసంగా, ఆ కార్నియా కోసం అంటే చనిపోయేటప్పుడు మనతో పాటు కాలిపోయే ఆ కార్నియా, ఆ కళ్ళు చనిపోయిన తర్వాత ఇంకొక వ్యక్తికి, ఒక 2 వ్యక్తులకి కంటి చూపు వస్తుందంటే అంతకంటే పుణ్యం మహాకార్యం ఏముంటుంది చెప్పండి. అందుకని ఆ విషయంలో కూడా ఎంతోమందికి అవగాహన కల్పించేలాగా మళ్ళీ ఇదే పద్ధతిలో నేను ప్రమోట్ చేస్తూ ఇదే పనిగా చేస్తుంటే, ఆ తర్వాత ఎన్నో మంది వాళ్ళ చనిపోయిన తర్వాత వాళ్ళ బంధువులు కార్నియా తీసుకొచ్చి నాకు అందించేవాడు. నేను ఎల్వి హాస్పిటల్కి పంపించి, ఎల్వి ప్రసాద్ హాస్పిటల్కి చాలామందికి కంటి చూపు వచ్చేలా చేయగలిగాను. ఈరోజు ఉదయం 2:30-3 గంటలకి మా అత్తగారు ఇక లేరు అన్న వార్త వచ్చిన తర్వాత అరవింద్ గారేమో బెంగళూరు వెళ్ళారు. నేను ఒక్కడిని ముందు వెళ్ళినవాడిని, నేను అక్కడికి వెళ్ళిన తర్వాత ఆవిడ నో మోర్. ఆ సమయంలో గోపి గారు మనం అనుకున్న ఈ ఆర్గాన్ డొనేషన్ గురించి నాకు గుర్తుకొచ్చింది. నా సెల్ ఫోన్ గుర్తుకొచ్చిన తర్వాత అంత మిడ్ నైట్ అంటే 2 o'clock 2:30 ఆ ప్రాంతంలో బ్లడ్ బ్యాంక్ ఫోన్ చేసి స్వామినాయుడిని నిద్రలేపి, మా బ్యాంక్ వచ్చేసుకుని, ఎల్వి ప్రసాద్ హాస్పిటల్ ఎవరైనా టెక్నీషియన్స్ ఉంటారా, నేను ఆవిడ కార్నియా ఐ డొనేషన్కి నేను మిగతా వాళ్ళని ప్రిపేర్ చేస్తాను అంటే, సార్ ఈజీ చేయొచ్చు సార్, వాళ్ళు రెడీగా ఉంటారు స్టాండ్ బై 24/7 అంటే వాళ్ళని తీసుకురా ముందని చెప్పేసి అరవింద్కి ఫోన్ చేసిన. అరవింద్కి తెలిసి ఎయిర్పోర్ట్కి బయలుదేరాడు. అరవింద్లో ఇవ్వాలనుకుంటున్నాను, నాకు అత్తమ్మగారికి మా అమ్మగారికి మధ్య ఒకసారి ఒక కాన్వర్జేషన్ జరిగినప్పుడు మీరు ఇస్తారా అని అడిగాను. అన్నప్పుడు, బాబు కాలి బూడిదైపోయి వస్తాం కదా, అయిపోయే దానికి చచ్చిపోయి ఉంచుకుని ఏం చేస్తాం, అలాగే బాబు నీ ఇష్టం అన్నారు. ఎక్కడ ప్లెడ్జ్ ఫామ్స్ మీద సంతకాలు పెట్టలేదు, కానీ ఆ మాట నాకు ప్లెడ్జ్లాగా అనిపించింది. ఏం చేయమంటావు అరవింద్ అడిగితే, ప్లీజ్ గో హెడ్ అన్నారు. సో ఎర్లీ మార్నింగ్ అది తీసి నేను హాస్పిటల్కి వెంటనే పంపించాను. దానికి సాక్ష్యమే ఇది. సో ఇది చెప్పడమే కాదు, ఆచరించడానికి కానీ మనం ఇలాంటి విషయాల్లో ప్రతి ఒక్కళ్ళు ఒక బాధ్యతగా, మనం తర్వాత ఇవ్వడం పక్కన పెట్టినా ఇచ్చేవాళ్ళు దాతల్ని ప్రతి ఒక్కళ్ళని మనం మోటివేట్ చేసే విధంగా ఉండగలిగితే, ఇప్పుడు ఎంతో కొరత ఉంది. అంటే మనకి ఒక మనిషి చనిపోతే, బ్రెయిన్ డెడ్ అయితే, వాళ్ళ బంధువులు అంగీకరిస్తే, ఆ మనిషి కాటికి వెళ్ళటానికి ముందే, శ్మశానానికి వెళ్ళటానికి ముందే ఒక వ్యక్తి ఎనమండుగురిని ప్రాణం పోసి కాపాడగలడు. అంటే అది హార్ట్ అవనివ్వండి, లంగ్స్ అవనివ్వండి, లివర్ అవనివ్వండి, ప్యాంక్రియాస్ అవనివ్వండి, కిడ్నీస్ అవనివ్వండి, ఇంటెస్టైన్ అవనివ్వండి, ఇలాగా 7-8 రకాలు. అంటే చిన్న అవయవాలైనటువంటి క్రూషియల్ లిగమెంట్ కానివ్వండి, కార్నియా కానివ్వండి, ఇవన్నీ కూడా ఇవ్వచ్చు. ఇంత అంటే భగవంతుడు మనకి ఒక ఇది దేవుడు అని, ఆ దేవుడు అంటాడు, నువ్వు కూడా దేవుళ్ళ ఉండొచ్చు అంటే ఎలా కుదురుతుందంటే, ఇంతమందికి నువ్వు ప్రాణం పోసి బతికించావు అనుకో, ఆ కుటుంబ సభ్యులకి నన్ను పూజించరు, వాళ్ళ బంధువుని బతికించినటువంటి నిన్ను దేవుడిగా పూజిస్తారు, ఆ అవకాశం నువ్వు తీసుకో అని చెప్తున్నాను. అంటే దేవుడు అనేవాడు ఎవరో ఎక్కడో లేదండి, మన మంచి మనసులో ఉంది, మన దాన గుణంలో ఉంది, ఎంతోమందిని మోటివేట్ చేసి మరి ఎంతోమందికి ప్రాణం పోయటంలో ఉంది. ఆ అవకాశం భగవంతుడు మనకి ఇచ్చాడు. భగవంతుడు స్వార్థపరుడు కాదు. నన్ను పూజిస్తేనే, నాకు అష్టోత్తరాలు చదివితేనే, నాకు వ్రతాలు చేస్తేనే, నాకు యాగాలు చేస్తేనే మిమ్మల్ని దీవిస్తానండు. మరి మీరు కూడా భగవంతులా కీర్తించబడతారా? మీరు చేయండి, ఇదిగో ఈ అవయవాలు ఈ విధంగా చేయండి. డాక్టర్స్ మనకు దారి చూపిస్తున్నారు. డాక్టర్స్ మనకి ఇలాంటి అవయవాలు ఇస్తే కనుక మీరు ప్రాణం పోసిన వాడు అవుతారు. ప్రాణం పోసిన వాడు భగవంతుడే కదరా, ప్రాణం పోసే అవకాశం మనిషికి ఉంది, మీరు దేవుళ్ళు అవుతారు అని చెప్పేసి ఆయన చెప్తుంటే ఎంతమంది అర్థం చేసుకుంటున్నాం. కాబట్టి ఇది స్ఫూర్తిగా తీసుకుని ప్రతి ఒక్కళ్ళు ఆలోచించండి. పూర్తి స్థాయిలో బ్లడ్ డోనార్స్గా చాలామంది, లక్షల మందిని, ఇందాక గోపిగా చెప్తున్నట్టుగా 25 lakhs ఆఫ్ యూనిట్స్ బ్లడ్ని కలెక్ట్ చేయగలిగాను. అండ్ ఎంతోమంది లక్షల మందిని నేను ప్రాణం ఇవ్వగలిగాము అంటే కనుక మన అభిమానులకు ఆ క్రెడిట్ దక్కుతుంది, ఆ దాతలకి ఆ క్రెడిట్ దక్కుతుంది. వారిని చూసి ఎప్పుడు నేను గర్విస్తూ ఉంటాను. అలాగే ఇది కూడా ఒక ఊపు అందుకోవాలి, ఇది కూడా ఒక అవగాహన రావాలి. ఈ రోజున మనకి 2 లక్షల దాకా మనకి లివర్ ట్రాన్స్ప్లాంట్కి ఏదో రకంగా మనకు అవసరం ఉంటే బతుకుండి టిష్యూ మ్యాచ్ జరిగి ఆ ఇవ్వటానికి కోసంగా ముందుకు రాని పరిస్థితి. సరే, ఆర్థికంగా వెసులుబాటు లేదంటే అది వేరే విషయం. ఆర్థికంగా అన్నీ ఉండి డోనార్స్ దొరకక ఇవ్వలేని పరిస్థితిలో వాడు అలాగే ప్రాణాలు పోతున్నాయి. ఇందాక డాక్టర్ని అడిగితే 2 లక్షల మంది నెసెసిటీ ఉంటే అందులో దొరకక 1,00,000 మంది చనిపోతున్నారు. ఈ ఉండేవాళ్ళలో కొద్ది మందికే 100,000 సంఖ్యలో మాత్రమే జరుగుతుంది ట్రాన్స్ప్లాంటేషన్. ఆ జరిగిన వాళ్ళు సరైన అవగాహన లేక కొంతమంది కొన్నాళ్ళు ఉండి ఆ తర్వాత మళ్ళీ కావలసిన దాన్ని సప్రెసెంట్స్ ఉంటాయి కదండి, వాటిని వాడాలి, అవి రిజెక్ట్ అవ్వకుండా. అలాంటి వాడక సరైన అవగాహన లేక అలా కొంతమంది పోయి ఉండొచ్చు. కానీ బట్ ఇది మరింత ఎక్కువ మంది ముందుకు వస్తే కనుక, మరింత ఎక్కువ మందికి లబ్ధి చేకూరితే కనుక ఈ లివర్ వ్యాధుల మూలంగా చనిపోయే సంఖ్య గణనీయంగా తగ్గుతుంది అని చెప్తుంటే నిజంగా. ఎందుకంటే మిగతాది చనిపోయిన మరణానంతరం ఇచ్చే ఆర్గాన్స్ వేరు, ఈ లివర్ అన్నది బతికుండగానే ఇవ్వచ్చు. డోనార్ ఎవరైతే ఇస్తారో అతనికి 3 వారాల్లో తిరిగి ఆ పార్టు మళ్ళీ తయారైపోతుంది. లబ్ధి పొందిన రిసిపియంట్కి అయితే కనుక అతనికి 3-4 నెలలు 5 నెలలు, ఇఫ్ ఐఎమ్ కరెక్ట్ డాక్టర్, అతనికి మళ్ళీ తిరిగి లివర్ పూర్తిగా వస్తుంది. అట్లాగా నా మిత్రుడికి డబ్బు లేక చాలా సఫర్ అవుతుంటే ఇందాక చెప్పారు రవీంద్ర గారు, ఆయన దగ్గరికి ఫస్ట్ వెళ్ళాను. రైల్వేస్లో పనిచేస్తుంటాడు. వాడు చాలా పిచ్చిగా బిహేవ్ చేస్తున్నాడు. ఎన్నాళ్ళు బతకడం తెలుస్తుంది, లివర్ సిరోసిస్ వచ్చేస్తుంది, టోటల్గా ఇదైపోయింది అంటే అతను నాన్ ఆల్కహాలిక్ లివర్ ప్రాబ్లం. అతను తాగుడు లేదు, కేవలం ఎందుకు వచ్చిందంటానికి వేరే కారణాలు ఏమి ఉంటుంటాయి. అతని బిహేవియర్ ఉంటే ముందుకు తీసుకొచ్చేయండి. ఇక్కడ ద బెస్ట్ లివర్ సర్జన్ ఉన్నారు రవీంద్ర గారు, ఆయన టీం, ఆయన చేయిద్దామని ముందు తీసుకొచ్చాను. ఎంత ఖర్చు అవుతుంది ఏంటి అని అడిగితే ఖర్చుకు వెనకాడకండి డాక్టర్ గారు, మీరు చేసేయండి అని నాది బాధ్యత అన్నాను. అయితే ఆ తర్వాత అతను రైల్వేస్లో పనిచేయడం మూలంగా నాకున్న ఇన్ఫ్లుయెన్స్కి రైల్వే మినిస్టర్, సెంట్రల్ మినిస్టర్ని నేను అడిగి వాళ్ళ చైర్మన్, ఆ కమిటీ చైర్మన్ చేత అప్పటికప్పుడు తెప్పించి ఆ డబ్బు తీసుకురాగలిగాం. అలా ఎంతమందికి అవకాశం ఉంటుంది, ఎంతమంది సపోర్ట్ చేస్తారు. ఆ డబ్బు రాకపోయినా నేను మరో రకంగా సపోర్ట్ చేసేవాడిని, అది వేరే విషయం. ఇట్లాగా ఇన్ని రకాలు ఉన్నాయి. అట్లీస్ట్ ఈ డిమాండ్ అండ్ సప్లై మధ్య ఇంత గ్యాప్ ఉంది. ఆ గ్యాప్ని తగ్గించగలిగితే ఎంతోమంది ముందుకొచ్చి అది ఎంతో పుణ్యం చేసేవాడు అవుతాం. ఇది ప్రపంచంలో ఎన్నో అడ్వాన్స్గా ఉన్న దేశాలతో పాటు మనం ముందుకు వెళ్ళగలుగుతాం. అండ్ ఈ రోజున మనకి కిడ్నీస్ విషయంలో కూడా ల్యాక్స్లో అవసరం ఉంటే కనుక కేవలం 50,000 ఇంతే జరుగుతుంది. ఉంటే కనుక ఇచ్చేవాళ్ళు కేవలం 90-100 అనిస్తే చాలా ఆశ్చర్యపోయింది డాక్టర్, అంతకంటే లేవంటారు డొనేట్ చేసేవాళ్ళు. అండ్ ఎంతమంది రోడ్ యాక్సిడెంట్స్లో పోతారు, అండ్ బ్రెయిన్ డెడ్ ఉన్న వాళ్ళు ఉంటారు. వాళ్ళ కుటుంబ సభ్యులకి కనుక అవగాహన ఉంటే, అదే పుణ్యం అనుకుంటే, అదే మహాయాగం అనుకుంటే, అదే స్వర్గం అనుకుంటే, అన్నీ అనుకుంటే డెఫినెట్లీ వాళ్ళు కనుక వాళ్ళని మోటివేట్ అయ్యి ఆ ఇవ్వగలిగితే అంతకంటే మహాపుణ్యం ఏమీ లేదు. అండ్ ఒకసారి చాలా భయాలు ఉంటాయి, మతపరంగా చాలామందికి భయాలు ఉంటాయి, ఆ తర్వాత కొన్ని మూఢనమ్మకాలు ఉంటాయి. అట్లాగా నాకు చూడండి, మీరు కార్నియా ట్రాన్స్ప్లాంట్ ఇవ్వాలని ముందన్నప్పుడు కళ్ళు ఇస్తే కనుక, నేత్రాలు ఇస్తే, నేత్రదానం చేస్తే వచ్చే జన్మలో పుట్టు గుడ్డోళ్ళుగా పుడతారనే భావన ఉండేది. అదన్నీ లేదు, అలా జరగదు అని చెప్పేందుకు నేను చేసిన ప్రయత్నం ఎంతో కొంత సఫలీకృతమయ్యాం. అట్లాగే ఒక సరదాగా చెప్పాల్సి వస్తే లైటర్ నోట్లో, నేను బ్లడ్ బ్యాంకు, ఈ ఐ బ్యాంక్ పెట్టినప్పుడు కొత్తలో ఇలాంటి చాలామంది విఐపీస్ సినిమా నుంచి చాలామంది వచ్చారు. అది బాగా చదువుకున్న పెద్ద వ్యక్తి. అండ్ అందరూ ప్లెడ్జ్ ఫామ్స్ సంతకం పెడుతున్నారు. ఒక వ్యక్తి మాత్రం నేను పెట్టను అంటూ తోసేస్తున్నాను. పెట్టండి సార్, పెడితే బాగుంటుంది, అందరికీ మోటివేట్ అవుతారు, ఇన్స్పిరేషన్గా ఉంది అంటే 2 కళ్ళు కన్ను ఇచ్చేసి కానీ ఒక కన్నుతో ఇలా చూసుకున్నాను, నాకు ఏంటో పక్కన కనపట్లేదు, భయంగా ఉందన్నాడు. ఏంటి సార్ అంటున్నారు మీరు? బతికుండగా కాదు సార్, మనం మరణానంతరం తీసుకుంటారనేసరికి నాకు చాలా ఆశ్చర్యం వేస్తుంది. అంటే నేత్రదానం చేయండి, ఐ డొనేషన్ చేయండి అంటే బతికుండగా తీసుకుంటారంటే అంత ఎడ్యుకేటెడ్, అంత అడ్వాన్స్డ్ ఈ సినిమా ఫీల్డ్లో ఉన్న మాకు కూడా సరైన అవగాహన లేదు. అంటే లోపం ఎక్కడుందంటే వాళ్ళని ఎడ్యుకేట్ చేయటంలో ఉంది, వాళ్ళకి అవగాహన కల్పించటంలో ఉంది. కాబట్టి ఈ రోజున ఈ సభకి ఎందుకు నన్ను పిలిచారు అంటే, నాలాంటి వాడితో చెప్పిస్తే ఈ మాట 10 మందికి చేరుతుంది, 10 మంది మోటివేట్ అవుతారు, 10 మంది ఆలోచనలు పడతారు. అది ఖచ్చితంగా వాళ్ళని ఈ ఆర్గాన్ డొనేషన్ వైపు, అలాగే ఈ లివర్ ట్రాన్స్ప్లాంటేషన్ విషయంలోనూ వాళ్ళు ముందుకు వస్తారు అన్నారు. ఇది చాలా అవసరం ఉన్నటువంటి సిచ్యువేషన్ ఇది. కాబట్టి ఈ రోజున యువత కానివ్వండి, ప్రతి ఒక్కళ్ళు కూడా దీని మీద మీరు ఆలోచించగలిగితే, దీని మీద అవగాహన పెంచుకోగలిగితే, దీని మీద మనసు పెద్దది చేసుకోగలిగితే ఖచ్చితంగా ఈ యొక్క ఇదన్నాను ఇందాక, డిమాండ్ అండ్ సప్లై మధ్య ఇది గ్యాప్ తగ్గుతూ వస్తుంది. కాబట్టి మరి ఎంతోమందికి ప్రాణం పోసిన వాళ్ళం అవుతాం. కాబట్టి నా హంబుల్ రిక్వెస్ట్, ఈ విషయంలో ప్రతి ఒక్కళ్ళు కూడా ఆలోచించండి. ఒకళ్ళు ఒక 8 ప్రాణం పోసేలాగా మీరందరూ పునీతులు అవ్వాలి, మీరందరూ ఆ దిశగా ఆలోచించాలి. డాక్టర్ గారు, నేను చెప్తాను, ఈ యొక్క అవకాశం నాకు ఇచ్చినందుకు ఈ ఒక్కరోజుతోనే కాకుండా ఫ్యూచర్లో కూడా నేను ఏం చేయాలి, దీనికి సంబంధించి ఏమేం చేస్తే నాకు సంబంధించిన వరకు నేను దీన్ని ముందుకు తీసుకెళ్ళడానికి ఖచ్చితంగా మీకు నేను ఒక మోడల్ లాగా ఉంటాను, మీ చేతిలో వెపన్ లాగా ఉంటాను. ప్లీజ్ మేక్ యూజ్ ఆఫ్ మీ. అలాగా నాకు ఈ అవకాశం ఇచ్చారు. అండ్ నేను మెడికల్గా నన్ను అవగాహన ఉన్న మనిషిని కాదు కాబట్టి తప్పులు మాట్లాడుంటే క్షమించండి. అండ్ నేను ఈ రోజున కాదు, ఎప్పుడో మనం ఫస్ట్ టైం కలిసినప్పుడే రవీంద్ర గారు, నా అవయవాలన్నీ కూడా నేను ఇవ్వటానికి సంసిద్ధునయ్యాను. అండ్ నాకు తెలిసిన మా వాళ్ళందరి చేత కూడా నేను ఒప్పించి వాళ్ళు కూడా అవయవదానం చేసేలాగా నేను సంసిద్ధునవుతాను. ఆ విషయం మీకు చెప్తూ చాలా గర్వంగా ఫీల్ అవుతున్నాను. నాకు ఈ అవకాశం ఇచ్చినందుకు ప్రతి ఒక్కరికి నా హృదయపూర్వక ధన్యవాదాలు తెలియజేస్తూ అండ్ మీ సెలవు తీసుకుంటున్నాను. జై హింద్.
Thank you very much for that inspiring speech, sir. Especially encouraging everybody, especially general public in the society, to be open to the idea of donation. Chiranjeevi garu blood bank ద్వారా చేసిన ఆ ప్రయత్నంలో 25 లక్షల బ్యాగ్స్ కనుక, అది జస్ట్ అన్బిలీవబుల్ నంబర్. అది అదేవిధంగా వారి ద్వారా ఇటువంటి ప్రజాహితమైన ఒక ఇన్ఫర్మేషన్ పబ్లిక్లకు వెళ్ళగలిగితే మోర్ అండ్ మోర్ పీపుల్, వారు చెప్పినట్లుగా 8 మంది, ఒక మనిషి 8 మందికి సహాయపడే అవకాశం జరుగుతుంది చనిపోయిన తర్వాత. సో దిస్ ఈజ్ ఏ వండర్ఫుల్ వే ఆఫ్ రీపేయింగ్ టు ద సొసైటీ. థ్యాంక్ యూ వెరీ మచ్ సార్ ఫర్ ఇన్స్పిరేషనల్ స్పీచ్. థ్యాంక్ యూ. Ramesh, could you do the vote of thanks, please?
Good evening, everybody. On behalf of Star Hospitals, I would like to thank our chief guest, Chiranjeevi garu, for coming here and honoring our request despite a personal tragedy at home. We are really indebted to you, sir. and your kind words about, and then the way you educated public about organ donation, the importance of that. I think it will go a long way in taking the message to the general public, and that will help in building awareness on organ donation. Thank you very much, sir. And I would like to thank our mentor, Dr. Ravindranath Garu. He's like Lord Krishna to a lot of gastro-GI surgeons. He's instrumental in making a lot of Arjunas, and he's a great visionary and guiding force behind the GI program at Star Hospitals, and of course at the national level also. Thank you very much, sir, for guiding us, and it's a great help for us. And on behalf of Star Hospitals, I would like to thank the distinguished faculty, Dr. Rela, and the other national faculty members who are here for spending their valuable time, sharing their valuable opinions, and educating a lot of young and budding GI surgeons, hepatologists. And thank you very much, sir. And I would like to thank Dr. Srinivas Reddy, who is the visionary behind this conference. And a conference like this will go a long way in sharing the success stories, in sharing complex problems, how they are solved. And it's also putting minds together to have all good clinical practices. And I hope that this conference will go a long way in sharing the academic aspects of liver transplant. And we at Star Hospitals are interested in driving, and we are looking at driving this liver transplant program in a big way in both the Telugu-speaking states. And Dr. Srinivas Reddy is very instrumental in taking it to the general public and doing good work. Thank you very much, and I do hope that over the next couple of days you'll have a good academic and scientific feast. Thank you.
Srinivas Reddy, the hepatologist, please come. We have hepatologist, he's a young guy, big country, he's doing very well. 2 years into the he's done very well. We find it good. Thank you. Thank you very much. Given to me, you can't take it.
Now we are going to today's last session, case discussions. I would like to invite the panelists Upendra Chava, Dr. Parijatram Tripathi, Dr. Radha Ramadevi, madam. To the stage, please. The first case will be presented by Dr. Emma. It's about propionic acidemia.
Good evening, everyone. I am Dr. Hema. I am a fellow in pediatric gastroenterology and hepatology at Rainbow Children's Hospital. So today I'll be presenting a case of propionic acidemia. So the child is 1 year, 6 month old female child born at term with a birth weight of 3.1 kgs. Child was born to a 3rd degree consanguineous couple. There is a family history of previous deaths of a child on day 5 of life. So a brief history about that child. Child had lethargy, poor feeding, metabolic acidosis and hypotensive shock. The newborn screening showed elevated C3 levels. So given the past history, the newborn screening of this child was done proactively, which showed elevated propionyl carnitine levels in the serum, elevated 3-hydroxypropionic acid, propionyl glycine and methyl citric acid. The genetic testing, the whole genome sequencing confirmed propionic acidemia. So here we have a question to the panelists, to Dr. Upender. What is propionic acidemia and what is the metabolic pathway?
Propionic acidemia is one of the important organic acidemias where we come across in clinical practice. So inborn errors of metabolism, though rare, it's very important to know about their presentation, because most of the time, as in this case, metabolic acidosis, it could be some sepsis-like presentation. If you miss the diagnosis at that time, then outcomes are poor. So coming to propionic acidemias, it's autosomal recessive disorder due to deficiency of propionic coenzyme A carboxylase enzyme deficiency, which results in a blockage of the pathway of propionic acid. Actually, propionic acid is converted into methyl malanoic acid, which is an important precursor for succinyl acetone, which is the important role in citric acid cycle, Krebs cycle for energy anabolic pathways. So leading this deficiency of this enzyme leads to excess production of all the products above the level of the block, that is propionic acid. And as this child has exactly all these metabolites in excess in their blood reports, like propionic acid will be here, methyl acetate, methyl citric acid, methyl citrate will be high, propionic glutamate will be high, leading to hyperammonia, and all this leads to toxic manifestations or metabolic crisis in this child.
Thank you, sir. Next question to Dr. Parijatram. What are the presentations of propionic acidemia and what are the diagnostic clues in newborns if there is no past history in the family?
Yep, so propionic acidemia can present classical variety in the neonatal period,
Like as Dr. Upender said, that it can present like it is very difficult to differentiate it from the late onset sepsis. Like after first feed, baby may present with lethargy, vomiting, dehydration, and on investigations you may find acidosis. So that is the classical variety, and child rapidly can go into encephalopathy or develop seizures. Other varieties are also there where onset is a bit late, either in childhood, adolescence, or even late into adulthood also. And these patients may have hypotonia, intellectual disability, maybe history of repeated metabolic crisis, and a history of seizures also. So if we come to the newborns, definitely the making diagnosis at first go is difficult because sepsis is so common, late onset sepsis is so common. So the important clues are first, in history if you can find consanguinity, I think it was there in this patient. There is any history of previous sib death or any other siblings having the similar kind of history. And on investigations, if you find that septic markers are not very high, CRP not very high, procalcitonin is not very high, despite adequate antibiotics, there is no good response. Ammonia is very high and rapid development of encephalopathy. Those can be the early symptoms because your TCMS, GCMS, and as you said, genetics all may take time. So early clues we have to catch so that we can start the treatment early.
Thank you, sir. So this patient had recurrent metabolic crisis with multiple PICU admissions with metabolic acidosis, hyperammonemia, sepsis-like presentation, and also one episode of metabolic stroke. Child also has failure to thrive at 1.5 years. The child weighs only 6.2 kgs and there is global developmental delay as well. Next question again to Dr. Upender. What are the reasons for metabolic crisis and how does it present?
So metabolic crisis most of the time is precipitated by some stressors. So most common stress is infections in younger children. Even slightly older children, prolonged fasting can precipitate the crisis. Sometimes, rarely, some drugs can precipitate the metabolic crisis. Of all these, most important stressor is being sepsis. So it's as previously also we were discussing, it's very difficult to differentiate between plain sepsis and underlying metabolic liver disease. It can precipitate the acute crisis and complicate the diagnosis. So it presents with multiple metabolic derangements, of which most important is metabolic acidosis. So it can have hyperammonemia, hypoglycemia, hyperlactatemia, lactic acids will be elevated, and ketonuria can be seen. So combination of all these should raise the suspicion of some underlying inborn error of metabolism, and we need to work up in that lines.
Yes. Thank you, sir. Next question to Dr. Radha Ramadevi ma'am. Medical and dietary management to avoid metabolic crisis and balancing protein restriction with growth in propionic acidemia.
Yeah, propionic acidemia is, as we know that it is one of the inborn errors recessive disorder. It is because of the absence of the enzyme propionyl-CoA carboxylase. And this is the one that catalyzes 4 amino acids in the food we take, and they are the leucine, isoleucine, and threonine and methionine. So these 4 amino acids are metabolized by this enzyme, and due to the deficiency of the enzyme, there is an accumulation of the byproducts of these 4 amino acids. And so our dietary management during, in these cases, should be divided into 2 groups. One is during acute decompensation phase and then the follow-up period. So during decompensation, that is when the child presents with metabolic crisis, the management should include correction of the metabolic acidosis and the associated complications like hypoglycemia and hyperammonemia. And during this period, for 24 to 48 hours, there should be total stoppage of the proteins and it should not exceed beyond 48 hours. And this is followed by what is called the sick baby regime for the medical diet. And this is followed once the child recovers the typical medical diet available for propionic and methylmalonic acidemia. So this is the diet management, and the diet should be devoid of all these 4 amino acids. And we should not stop all the proteins because the child goes into protein malnutrition. And as you know, methionine is very important for the growth and for the DNA formation. And so when there is a deficiency of methionine, the growth will be delayed. So we need to restrict the normal protein to the extent of 0.8 gram per kilogram body weight. This is the regular protein which we can provide to the infant or the newborn through breast milk. And then the medical diet protein should be given anywhere between 1.5 to 2 grams. We have to give a little more protein because this is an infant. And so more protein needs to be given in the form of medical diet. Medical diet in the sense which doesn't have these 4 amino acids. So the total requirement of the protein is about 2.2 grams per kg per day, and this should be adjusted along with the calories. That is very important because if you don't give calories, there won't be any weight gain. Simple giving medical diet, which I have seen many practitioners are giving, this will make the child malnourished. And then if you don't add calories to this diet, they will not gain weight. So you have to build up with calories with what are called the various types of carbohydrate diets that are available, the low protein supplements. So with that, we need to follow the growth pattern as well as the mental development in the child. And then the monitoring of the renal and other parameters such as the CBP, calcium and vitamin D3. So these should be monitored while giving the diet management in the follow-up period. So here in this particular child which I am following, this is a very interesting case. Initially, the DNA diagnosis was not confirmatory of propionic acidemia. The whole exome sequencing did not reveal any DNA alterations. And because the previous child also had a propionic acidemia picture, then we went with whole genome sequencing. And with whole genome sequencing, we picked up a deep intronic variant in the PCCA gene, and that is the reason why the child developed propionic acidemia. Then we also checked the parents, whether they are carriers, and the parents are also carriers, which also further confirmed the diagnosis of propionic acidemia. So this patient we managed with a low protein diet, and then the special formula diet for propionic acidemia, along with the medical supplementation with carnitine, because carnitine is very important to improve the mitochondrial function. And then we have to give these children high doses of biotin, because biotin is the one which is very important to activate the carboxylase enzymes. And so you need to give biotin also, so that the activity of the enzyme can be improved, so that the metabolic control will be better. So this is how we need to follow the diet.
Thank you, ma'am. We have another question for you. What is the role of gene therapy in the current era for propionic acidemia?
This gene therapy is still not available for propionic acidemia. Although a lot of research is being done, especially with regard to the gene therapy in the mice is successful, but there are no human trials that are done. On the contrary, people are trying to look into other therapies, such as what are called the mRNA-based therapies for these conditions. And it is already proved successful in mice models. And presently, the phase 1 and 2 trials are going on in humans to use the mRNA-based. And in this aspect, we are also developing mRNA therapies for these organic acid disorders. A research program is going on in the Institute of Life Sciences here in Hyderabad under my guidance. And I hope to get these mRNA-based therapies in future for these patients. But gene therapy is, at present, is not available. And even if it is available, it will be very, very expensive. And the other one that is coming up in a few years is the gene editing. And I'm sure you all know about the gene editing treatment that has been given for one of the urea cycle disorders recently to a child in the USA, which worked very well. And here you edit the defect in the SNP in the gene, and so that you correct the gene defect totally, and it will be a total cure. So this is what we are expecting to come up in future, that is the gene editing, which is a promising intervention in many single gene disorders. So once this gene editing comes, I think liver transplantation may take a back seat.
Thank you, ma'am. We have a common question to all the panelists. What are the indications and optimal timing for liver transplantation and outcomes in propionic acidemia?
Well, actually propionic acidemia is a very toxic condition compared to all other organic acid disorders. So propionic acid is very, very toxic, and in my experience, most of my propionic cases, they did not survive in spite of giving them the diet management and others. So, and they also go into mental retardation because of the recurrent impact on the brain as well as development of metabolic crisis. So the prognosis as such is quite poor in propionic acidemia. That's why we need to intervene very early in life in order to save the child. And this is the child who did respond to diet management initially, but later on the child had problems. So to circumvent those problems, we didn't want to take a chance at a bad prognosis. So the reason for the timing of the liver transplant here is the growth failure and recurrent attacks of infections. So this is one of the most important indication to time the transplant. And the other is that the child's mental condition is very, very important. And if the mental status, if the child is retarded, there's no point in doing a transplant.
Thank you, ma'am.
Yeah, so as ma'am said, it should be done as early as possible rather than late. Otherwise, repeated neurological insults may lead to permanent damage and child may not reach to his ultimate potential. So it should be done at earliest before the damage happens.
So our patient underwent liver transplant with mother being the donor. The indication was poor metabolic control despite strict diet and supplements, and repeated hospitalizations for metabolic crisis and risk of irreversible neurocognitive damage, and she also had severe growth failure. So next question to Dr. Parijat sir. What are the precautions to be taken in post-operative period in managing ammonia, acidosis and metabolic crisis in these patients?
So unlike many other inborn errors of metabolism, liver transplant is not the cure for propionic acidemia. There are other organs and tissues which are still producing propionic acid. So we need to be very careful. There are so many papers that post-op management, post-liver transplant, intra-op management of liver propionic acidemia management when the transplant is going on. So after the transplant, immediately, child should not go into stress, otherwise his propionic acid levels will again increase and metabolites. So proper glucose infusion to keep in the anabolic state. Infections has to be controlled. If ammonia is going high, you have to give sodium benzoate and all. And once the acute phase is gone, even in prolonged period, you cannot immediately start normal protein diet. Initially, usually they are kept on a restricted diet. Over the time, different series are showing variable reports. Most of them still keep some control over the, as ma'am said, branch chain amino acids and all to keep them less so that propionic acidemia. Only thing what it does is repeated crisis can decrease, but overall you can't say that the disease is cured. Even these kids, when even in future where long-term follow-ups are, is there some mental disability, some hypotonia still persists. So we need to take care of all those things.
Thank you, sir. Similarly, our patient was managed in the post-operative period with immediate nutrition. We had given by restricting the protein to 0.5 gram per kg per day. Parental lipid was given with 2 gram per kg per day. Ammonia was closely monitored. Sodium benzoate was given. And initially we continued on low protein propionic acidemia diet and slowly started introducing normal diet, which she tolerated well. And she was also continued on biotin and creatinine supplements. carnitine supplements. So this is the latest urine GCMS report of a patient, which shows normal metabolites. The 3-hydroxypropionic acid, propionyl glycine and methyl citrate are all in the normal limits. I think this question was already answered. So take home message would be propionic acidemia condition needs to be diagnosed early with newborn screening or genetic testing if suspected. Medical and dietary management is the key to tide over metabolic crisis. Liver transplant in these subset of patients is challenging, especially in managing the intraoperative and post-operative metabolic crisis. Liver transplant cures the hepatic crisis, but not other systemic involvement like the heart, renal and the pancreatitis. So regular follow-up is advised. Future gene therapy may help these patients immensely. Thank you.
Yeah, it's coming here. It's coming here. This is the child who underwent the transplant, propionic acidemia child. This is 40 days after the transplant.
Thank you. We'll go to the next case, last case of the day. It's about acute presentation in Wilson's disease. We do see Wilson's disease more commonly in our day-to-day clinical practices. And our case is a 13-year-old female. She presented with fever since 1 month, followed by jaundice, and for that she had alternate medicine intake, and she got admitted with us with worsening of jaundice and with altered sensorium, which West Evans HE grade 3. She was, her birth history was uneventful. Our blood test showed low aptoglobin, high reticulocyte count with Coombs negative hemolytic anemia, with hemoglobin of 7.5, and coagulopathy with INR of 6.6, and jaundice with total bilirubin of 14.2, with hyperammonemia of 109, and lactic acidosis of 4.1, with transaminitis, with AST to ALT ratio more than 1. First question to Dr. Upendra, how to approach this ALF in a child?
Yes, this is a young child with a history of jaundice followed by coagulopathy. So by the definition of pediatric liver failure, this child fits into acute liver failure. So coming to approach, basically there is a gross difference of spectrum of diseases when compared to adults and pediatrics. Pediatrics, we have relatively different spectrum of causes for acute liver failure. Most of the time it is infections followed by drugs or for toxins And sometimes even in pediatrics also, depending upon age of the presentation, etiologies are small. In newborns, particularly in neonatal periods, most common causes would be metabolic causes like galactosemia, thyroxemia, even neonatal hemochromatosis, herpes infection. These are the common causes for liver failure in newborn period. Whereas if you come slightly older children, around toddlers, the infections are more, acute viral infections, and even slightly older children around adolescents are 5 to 10 years, then comes common infections along with some chronic liver disease presenting as acute and chronic liver failures. So this is the spectrum of causes for acute liver failure in children. So whenever we deal with the children, we should have background these etiologies and work up according to these etiologies. This is young child, so our clinical possibilities could be either infections, and this child has history of intake of indigenous medicine. So drug-induced viral infection superadded with drug-induced liver injury could be the first possibility. And second possibility, as we are discussing, some of the chronic liver diseases can first time present with acute presentation, like acute and chronic liver failure. So the second possibility could be the some underlying chronic liver disease like autoimmune liver disease or Wilson disease presenting as acute liver failure. This anemia is one of the clue for some underlying chronic diseases like autoimmune can present with anemia and liver failure. Wilson's can present with anemia. Even viral hepatitis, sometimes a small subset of viral hepatitis children can have anemia due to autoimmune triggered by viral hepatitis. So in this case, we should think and investigate in these lines of management.
Like Dr. Upendra said, we did a Talkx panel which showed negative for DILI, and hepatitis viral panel were negative and showed negative for autoimmune diseases. USG showed acute and chronic liver disease with moderate ascites, and our workup showed low ceruloplasmin with ophthalmic examination showed bilateral early KF ring features. So we thought it's acute presentation of Wilson's disease. And then the second question is the role of genetic analysis in pediatric ALF with indeterminate etiology by Dr. Radharam.
The main goal of doing a genetic analysis in acute liver failure is to mainly identify the cause as well as the treatment decisions so that you can have improved outcomes. So if the cause is unknown, especially in children with inherited disorders, the management is difficult. So most of these monogenic disorders, especially in neonates and infants, can present with an acute liver failure, and that's why the genetic analysis is very essential. Especially in acute liver failure, the genetic analysis, since it takes time, you have to go with what is called a fast-track genetic analysis, where you can get the report within 1 week. So common conditions such as Wilson's disease, hereditary fructose intolerance, tyrosine, and bile acid synthesis defects, all these can be identified once you have a genetic analysis. And in addition to that, some of the mitochondrial disorders, such as the Pol-G DNA depletion disorders, especially after exposure to valproate, can present with an acute liver failure, and you have to differentiate from monogenic single gene disorders to the mitochondrial disorders in terms of management. So the mitochondrial genes like MPV 17 and DGUOK is very, very essential because you want to predict the outcome of liver transplant in these cases of acute liver failure. So in recurrent liver failure, it is also found that there is a special gene that is identified, which is called the NBAS gene, and this is a specific gene that causes recurrent liver failure with onset in infancy. So the genetic analysis helps in identifying this particular gene. So infantile liver failure syndrome type 1 due to other genes such as LARS1 gene is also responsible for acute liver failure. So these are all the genes that can be identified by doing a genetic analysis, and that's the reason why we need genetics testing.
Like Madam said, it's important to rule out indeterminate etiology with genetic testing so that mitochondrial disorders we can identify and NBAS gene mutations. Third question is, how does the clinical presentation of acute Wilson's differ from other causes of ALF? To Dr. Parijat.
Yeah. So first time when a Wilson's child is presenting with acute liver failure, most of the times it is almost impossible to differentiate it, because if acute insult has caused the liver failure, even it may mimic like a prodrome kind of picture, but it may be underlying Wilson's. So 2-3 important things in the history, again, as it is a genetic cause, any history of consanguinity, SIP death, any family history of neuropsychiatric illness, even no liver disease, that may give us a clue. And then if you look at the child clinically, if icterus is too deep, if you can find cola color urine history, that IV hemolysis is happening, that we get many of the times in these acute Wilson children, or very deeply high colored urine, because bilirubin levels are very high, 20, 30 it can go, or up to 40 it can go. So those are the important clues on the history, and rapidly child can go into encephalopathy, that can worsen. Along with that, acute renal failure is earlier rather than regular acute liver failure because of the kidney injury, because of the hemolysis. On examination, you can find hepatosplenomegaly, which is very rare in a normal acute liver failure, and in them acute liver necrosis is happening. While in liver Wilson's disease, there can be some underlying liver disease going on, and still you can palpate the liver and spleen. So those are the clinical clues I will take, and of course CBP and your LFT can give important clues. Hemoglobin is rapidly falling, retic count is very high. If you do Coombs test, it can be Coombs negative hemolytic anemia. Liver function test may show very low alkaline phosphatase, like there are so many things, papers are there, like bilirubin to alkaline phosphatase levels more than 4 show around 100% specificity for that. So looking at the bilirubin level, AST levels may be very high, alkaline phosphatase will be very low, and INR of course will be deranged. So those are simple clues which can lead us to the Wilson's disease.
Like Dr. Parija told, there are clinical clues and then laboratory clues like AST-ALT ratio and ALP, bilirubin to ALP ratio, and then Coombs negative hemolytic anemias can be used to differentiate. Coming to the fourth question, what is the mechanism for hemolysis in this patient of acute Wilson's? To Dr. Upendra.
Hemolysis in acute Wilson's, as Dr. Parijat was discussing, very important point, both for diagnosis and prognosis. So hemolysis is mainly due to excess load of copper, due to necrosis, acute necrosis of hepatocytes. Lots of copper is released into intravascular system, and it causes oxidative damage to RBC membranes. So this leads to typical non-immune. So important is sometimes autoimmune liver disease presenting with acute liver failure also has anemia, but most of the time it is immune mediated. So it is non-immune intravascular hemolysis in Wilson's disease. This DCT negative hemolysis is the clue for etiology. So excess copper is causing hemolysis. So this hemolysis is almost seen in around 15% of Wilson's children. So even it is to such extent that a mild DCT negative anemia in adolescents. So one of the possibility could be Wilson's disease. In absence of overt chronic liver disease features, if a child presents with DCT negative anemia and some growth failure, organomegaly, then our suspicion of Wilson's should be one of the possibility. And even in acute Wilson's, it is very severe that it causes renal failure, hemolysis leading to hemocirrhosis and renal failure causing poor prognosis. So hemolysis is an important issue in Wilson's disease.
And fifth, what is the overview of medical management of Wilson's disease? Any role of chelating agents in ALF due to Wilson's disease? To Dr. Parija.
So in acute liver failure due to Wilson's disease, we give out of desperation. But as we know, chelating agents take time, 4 to 6 months time, that we say it takes time to reduce the load and all. So it is too much to think that chelating agents can treat acute liver failure in Wilson's disease. As the next, of course, we give a combination of D-pen or triantin along with the zinc and all. But definitely role in ALF, I will not say it has a very strong role. And then extracorporeal therapies, next what you are showing.
Role of extracorporeal therapies in ALF.
It has definitely a role, because if your child is not stable enough to go for liver transplant upfront, you need to stabilize the kid. High volume plasmapheresis can decrease the copper load. It can reduce the chances of hemolysis. It can reduce your chances of acute kidney injury. Along with the CRRT in stabilizing the kid, and doing high volume plasmapheresis has definitely a role. There are reports, I think you show the next one also, then I'll come to yeah.
What is the success rate of native liver survival with medical management?
There are case reports that they have shown that if you do give chelating agents and do high volume plasmapheresis, you can avoid acute liver failure, but those are just anecdotal reports. If you ask me percentage, I will say less than 5% along with all that. And we have to look very clearly in them. Many of those patients were grade 1 HE. That still has good. New Wilson index was less than 11. Score was less than 11. ARC and ACLF score was less than 12. So those were the patients we need to, patient by patient, we need to take a call rather than just reading a case report that we can save the kid on that. Taking the right decision at right time can save the kid. So we should not delay the liver transplant in these babies.
Our patient was intubated in view of HE grade 3 and she required inotropes in view of hypotension and received 5 sessions of standard volume plasmapheresis, and she was started on a heparin-free low volume CRRT along with plasmapheresis for 5 days, but still her coagulopathy was still there, INR of 4.3 and bilirubin was still high 12 and lactate of 2 and albumin of 1.9. So we child underwent liver transplantation with mother as donor. So the next question is to all the panelists whether MRI brain is necessary as a part of pre-transplant evaluation in an acute Wilson's patient before going for transplant.
So usually in acute presentation before transplant, we routinely will not do it as unless the child has any past history of clinical features suggestive of neurological involvement. Because this here, the main intention of transplant is to save the life of the child.
Yeah, as sir said, if there is, before the acute liver failure, if child was neurologically well, then I don't think just an MRI finding will refute the liver transplant, because after liver transplant, otherwise also copper deposition in the brain is going to stop. Whatever has happened, and still it has not presented clinically. So chances it is not going to decide for the transplant at that moment of time.
Thank you. So utility of prognostic scoring systems, New Wilson disease index and ACLF R score by Dr. Upendra.
Yes, these both of them are useful indices scores for prognosticating the survival of the patient without transplant. This New Wilson's index, they compared to standard Wilson's index score, they have added WBC count and albumin to increase the sensitivity and specificity. They found that new index score is relatively having better sensitivity and specificity in predicting the outcome of the patient without transplant. So, but still some studies say that even New Wilson score is not doing good, because as per data, if score is more than 11, the survival is very poor. But some of the prospective studies show that they even more than 11 also some children survived without transplant, and scores less than 11 children required transplant. So this new index, ACLF ARC index, it included lactate as one of the component which is important in acute critically ill patients, though it is published in adults, and but it was also validated in children. Especially from ILBS, they have studies showing this is also going good with almost 88% of accuracy in predicting the outcome without transplant on particularly in Wilson's children. So these are, both of them are very good prognosticating scores.
Okay. So this child had a New Wilson score index of 15 and ARC ACLF score of 12. Usually they say a New Wilson index greater than 11 requires transplantation, they have good survival. So the last question is, what are the indications and challenges in liver transplant in an ALF patient with Wilson's disease? The main indications are patients having refractory hepatic failure with absence of native liver regeneration and hyperammonemia and persistent coagulopathy even with extracorporeal therapies and persistent hepatic encephalopathy. They form the indications. And coming to the challenges in liver transplantation, pre-operative wise, the challenge is to keep the intracranial pressure under control by neuroprotective measures, and reducing ammonia levels by CRRT is a challenge, and Second is managing the coagulopathy in these patients, because of patients might have an undercuttable INR and can lead to intracranial hemorrhage, and these should be controlled with the FFP. The main challenge, because the copper level takes some 3 to 6 months to come to normal. And the last question is, how do you follow up for neuropsychiatric manifestation after liver transplantation in Wilson's patient?
Yeah.
By Dr. Parul.
So, as I said in the previous slide, that after liver transplant, there is no more copper deposition is going to happen. But what happens many of the times, whatever copper is already deposited, because of the oxidative distress and mitochondrial damage, that can lead to some neurological symptoms which can come. Another factor is the immunosuppressive drugs that we are using, steroids and calcineurin inhibitors, tacrolimus and cyclosporin. Both are known to cause some CNS things, like steroids can cause psychosis, and your cyclosporin and both these can cause dystonias and all. Tone related. So whenever a child is developing any new symptom in a patient of Wilson's disease, CNS symptoms, we have to differentiate it is because of the old damage which was already there in the brain or because of the immunosuppressive medications. So what normally it is suggested it, after transplant within 1 to 3 months, a proper neurological, cognitive and psychological evaluation has to be done. If any new symptom appear or you have doubt about immunosuppressive drug or Wilson related symptom, you can get MRI at that point of time. And 6 monthly to yearly, you should keep on keeping them under the neurological evaluation just for the development of any new symptoms related with either older damage or immunosuppressive medications.
So the conclusion is hemolytic anemia can be an acute presentation of Wilson's disease in 10 to 15% of patients. Hence, in case of acute hemolytic anemia with associated liver failure, one should always suspect Wilson's disease and investigate accordingly. Extracorporeal therapy improves native liver survival and acts as a bridging therapy to liver transplantation. New Wilson's index is highly sensitive in predicting mortality without liver transplantation. Post-LT potential for worsening neurological symptoms exists in 20% of the patients. Thank you. So this is the last session, so everybody can have dinner and...
Can I make a comment?
Yes, sir.
Thank you. So, sorry, I think it was a very good discussion actually. The reason why we wanted to discuss Wilson's is because actually in our practice, that's the most common indication for emergency liver transplantation is acute Wilson's. I mean, a lot of viral hepatitis, they all improve with medical management, but Wilson's, acute Wilson's, most of them need transplantation, and actually they are a big